Bhubaneswar. Team C.
Good morning, I'm Dr. Saransh from AIMS Delhi.
Good morning, I am Dr. Manoj from AIMS New Delhi.
Manoj and Saransh from AIMS Delhi. And Team D.
Good morning, sir. I am Dr. Divya from Patna Medical College and Hospital.
Good morning, everyone. I'm Dr. Zainul from PMCH Patna.
Dr. Divya and Dr. Zainub from PMCH Patna. All right, so Team A is Archikar, Team B is, so I'll announce like this, Kolkata, Bhubaneswar, Delhi and Patna. Okay? So let's begin with the format of the quiz. We'll do it in the infinite bounds format. Some of you might be familiar with the format, but still I'll explain to you. We are not going to have any separate rounds or cycles, as you call it. We will have 32 questions, which will keep on coming one after one. 10 points for correct answer, no negative markings if you do not answer a particular question or you give a wrong answer. Now, suppose you are very sure about one particular question and its answer, you can ask for a bonus. Okay? So if you ask for a bonus, you get it right, you get plus 20. If you ask for a bonus and you give a wrong answer, you get a minus 10. All right? So if you don't ask for a bonus, there is no negatives. If you ask for a bonus and you get it wrong, you get minus 10. All right? At the end, we will have spotters where again plus 10 for correct answer, minus 5 for wrong answer, and there, if you do not attempt a particular question, there is no negative marking. Now, what is the infinite bounds format? This was introduced way back in the 1980s, where a professor named Shankar Balakrishnan, he invented this new type of quizzing, and this was picked up by Indian Institute of Technology, Madras, and it became very popular. So what happens in this format is, just understand this carefully. If there is any confusion, just ask me. Suppose one question goes to Team Bhubaneswar. Team Bhubaneswar answers that correctly, they get plus 10. Simple. Suppose Bhubaneswar gives a wrong answer or they pass it, it goes to Delhi. Delhi gives the correct answer, they again get plus 10. So every passed question gives you full marks, plus 10. All right? Now suppose there is a situation where the first question is asked to say Bhubaneswar, they pass it, it goes to Delhi, from Delhi it goes to Patna, from Patna it goes to Kolkata. Nobody gives correct answer. Question goes to the audience. For the next question, the first chance will be given to the team which is sitting next to Bhubaneswar. Why? Because in the previous question, Bhubaneswar was given the first chance. So in the next question, Delhi gets the first chance to answer. This is clear? Reversal of rounds is not required. So the best thing for this format is, no team can complain at the end of the quiz that I got the most difficult set of questions, and also often it happens now, suppose you have a relatively weaker team sitting next to you, so you get an advantage of getting all the past questions correct. Okay, so that is not going to happen. But the biggest problem is, please be very careful. Unless I ask you to answer a particular question, do not answer, because otherwise there is a confusion. So whenever I tell you, Team Bhubaneswar, please answer, Team Delhi, please answer, then only answer. Otherwise, don't answer. Otherwise, if any team answers a particular question out of his turn, then that question goes disqualified. Please don't do that. And of course, we have to be very careful. Team and Dr. Mubarak will be doing the scoring. Yes, Dr. Mubarak will do the scoring. We have to be very careful regarding the scoring because things get a little bit of haywire if there is any confusion. And so the most important disclaimer is, for the next 1 hour or so, the quiz master is always right. If in any particular question, suppose I am telling herpes is a bacteria, herpes is a bacteria. It is not a virus. Okay? You can argue at the end of the quiz. You can abuse, you can argue, whatever you want you can do, but not during the quiz. After the quiz, you do whatever you want. All right? Yeah, bahar jaake. Yeah. Okay. So this was regarding the introduction of the quiz. And most important thing, we are not here to test your knowledge. Suppose all of you prepare a set of 32 questions and ask us, it is highly possible we may not be able to answer a single question correct. All right? It's just the difference that I'm on this side of the table, you're on that side of the table. So I'll be having the fun. Along with me, Dr. Bhaskar. So this was regarding the introduction. Any confusion, any questions? Just ask right now. One more thing, before you answer, discuss amongst yourselves. Discuss with your team partner and then answer. Please do not give multiple answers. Okay, your first response will be regarded as your last response. Please do not give multiple answers. Discuss amongst yourselves and then answer. Okay? 15 to 20 seconds. Some questions have a long stem. Once we complete reading out the entire question, then the timer starts. We will look into the timer. It is on an average 15 seconds. But for some questions, it's a long stem. Multiple images are there. You have to connect. There, we will give 20 to 25 seconds. When the question passes, the team has to answer immediately. So this was with the format of the quiz. With this, I invite Dr. Bhaskar to start the proceedings with the first set of questions.
Hello. So all the best to all the quiz participants. So I will request everyone to please answer when I end the reading the questions, okay? And please be clear and loud. And we discuss before giving the answer, give one particular participant for each question, okay? So without any further delay, let's begin. So first question is for team A. So you have to identify the spot test which is used to detect the nickel allergy, which is shown in this image. Team A, your time starts now. Team B.
Please switch on your mic and be loud and clear.
Dimethyl glyoxim test.
Yes, absolutely correct. You got 10 points.
Big round of applause for Team B. Team B, yes, they get plus 10.
So the next question will be asked to Team C. So a 17-year-old boy, known case of tuberous sclerosis, have developed this lesion. You have to clinico-pathologically correlate and give the diagnosis. Team C, your time starts now.
Time up.
FCCH.
Can you give the full name?
Folliculocentric comedonal hematoma. Folliculocystic comedonal hematoma.
Question passes to Team D.
Angiofibroma.
Team A. Team B.
Fibrocephalic patch.
No. We are giving this number to Team C. They are giving 10 points, no?
Yeah.
10 points.
Folliculocystic and collagen hematoma
is
was
the
the full
full
name.
name?
We will
But
give
you
you. You mentioned FCCH in the beginning. We'll give it to you. Team C gets plus 10.
So the direct question is for Team D. 22-year-old man developed this lesion following a traumatic injury. You have to tell the diagnosis from the images. Question passes to Team A.
Myxoid cyst.
Can you speak clearly?
Myxoid cyst.
What?
Is it a myxoid cyst?
Passes to Team B.
Pass.
Team C.
Blue nevus.
No. This is graphite granuloma. There is a traumatic injury, okay? Usually after injury or is material with graphite like pencil, it happens, okay? So this is graphite granuloma.
This
So
question
this
will
time-
start with Team A.
Yeah, now it will start with Team A. So you have to connect the images to get the diagnosis. Team B,
All erythema of regions.
full diagnosis. You are totally giving one diagnosis, full diagnosis. I need the full diagnosis, not one.
Noonan syndrome.
What? Passes to Team C.
Folliculotropic MF.
Team D.
Pass.
So the diagnosis is Joe-Willis syndrome. The first person, the image is for Mr. C.C. Joe-Willis. He is known for the research of the sebaceous gland and all. Second is Euler ophrygenes and 18p monotomy. This triad is classical of Joe-Willis syndrome. Okay. the direct question will be of
Team B.
Team B. You have to name the recently approved topical drug for the following condition. Look at the images, and this drug is also used in veterinary medicine under the brand name of Scredalio as a chewable tablet to treat the flea and ticks in dogs and cats.
You have to name the drug, not the diagnosis.
Pass.
Team C.
Lotilines.
Can you be clear?
Lotilenes. Lotilines.
Yeah, absolutely correct. You got 10 points. This is called, what is the condition? Can you tell?
Pediculosis.
Pediculosis in animals, but in this
Animal,
patient,
in this, what is this?
I'm forgetting.
This is demodecosis, no? Oh, we'll give you the number.
yeah.
So,
Lotilaner is the
Loading as the answer. Fine.
team C gets plus 10.
Now the direct question will be for team D. You have to identify the person from the following clues. You have to connect the images and get the name of the person.
It's very simple, just look at the images.
Question passes to team A. Team B. Team C.
Jadison.
From the audience, anyone? So as you can see, there is a drug, Riociguat. This is cyclic GMP agonist. So this is used for Raynaud's phenomenon, okay? And as you can see in the third image, we are showing the sequential changes of the color, okay? So this person is Maurice Raynaud, fine? So now the direct question will be for team A. You have to tell the diagnosis with the eponymous sign as shown in the image. Both the diagnosis and eponymous sign.
Orf and goat size sign.
Very good.
Fine, very good. You got plus 10.
Claps for team A. Team A gets plus 10.
Just a reminder, if you are very sure, you can ask for bonus.
Double.
Then you can
Yes.
get plus 20. Okay. So direct question for team B. Gitaxistat is a promising drug which has shown to improve the MRSA score as well as pulmonary fibrosis in systemic sclerosis. You have to tell about the mechanism of the drug, that is gitaxistat. Team B.
You can ask for double if you are sure.
PT4 inhibitor.
Passes to team C.
TGF beta inhibitor.
Team D.
Phosphodiesterase 4 inhibitor.
Team A. Anyone from the audience? This is direct from the Bologna's textbook of dermatology in the newer edition. It is autotaxin inhibitor. Okay? And it has shown really very much promising result in modified Rodnan score and also in the pulmonary fibrosis. So the next question will be directly to team. Last one was direct question for team B.
Team
so
B.
it will for team C. So a 42-year-old man presents with recurrent episodes of urticaria, abdominal cramping and dizziness occurring several hours after eating meals containing red meats such as beef or pork. His history is notable for frequent outdoor activities, and he recalls multiple tick bites over the past years. Over the clinical scenario, you have to take the diagnosis. Team C. Team D. Team A.
Is it a recluse spider?
Team B.
You want to bounce? You want to bounce? Plus 20 or minus 10?
Plus 20.
Sure? Okay.
Alpha Gal syndrome.
Absolutely correct. Fine. Nice. Great
Claps
answer.
for team B. This is alpha-gal syndrome. Team B gets plus 20.
There is a new article in IGT. When you are entities in dermatology, you should try read this before going to quiz. It's very much important. So
Direct
this is
question
alpha-gal
for
syndrome.
team C.
Connect the images and you have to tell the diagnosis. Just for clarification, the last image is of IHC. These are the markers of IHC markers.
Bonus.
Okay, team C wants a bonus plus 20 or minus 10.
Plasmacytoid dendritic cell neoplasm.
Correct, answer
Big
is
claps
correct.
for team C, they get plus 20.
Plus 20.
Blastic plasmacytoid dendritic cell neoplasm, they get plus 20. Very good answering. Team C gets plus 20.
So this will be direct question for team D. So this is a topical combination drug which acts on mevalonate kinase pathway. It has been found efficacious to halt progression in lesions of disseminated superficial actinic prokaryosis and child syndrome. So you have to name the combination of this topical drug. Your time starts now.
Time up. Team A,
Cholesterol and lovastatin.
Yeah, absolutely correct.
you could have asked for double.
Yeah.
Team A gets plus 10.
So this will be direct question for team B. So 17-year-old male, he is on isotretinoin therapy, develops large irregular pits, which is beginning from lunula, giving a punch-out appearance. This similar nail change has also been described in context of syphilis. So you have to tell the nail finding from the clinical image and the clinical scenario.
Team B.
Question passes to team C.
Elconixis.
Yeah, correct.
Yes. Team B gets plus 10.
Just-
Claps for team B.
So this will be direct question for team C. You have to identify this self-healing congenital condition in child from the clinicopathological image. Team C.
Congenital self-healing reticulocytosis.
Correct, absolutely correct. I think you should have opted for double this time. So this will be a direct question for team D. So these are the Norwegian scientists as shown in the image. They first document the case of Norwegian syphilis while doing their research in leprosy. They also jointly published a historical landmark literature called Spittelskate, which is the Norwegian term of leprosy. So you have to identify these Norwegian scientists. They are highly popular, very much famous for his research in leprosy.
Don't blame me, these are very bad questions put by Dr. Bhaskar. My set will be easier.
Question passes to team A.
Pass, team B.
Von Hebra, Maurice Kaposi.
No. Team C.
Hansen.
No.
No.
So you can see the name is written in the book in the first page. They are Carl William Boeck and Daniel Cornelius Danielson. So
कौन है ये लोग पता नहीं मतलब. Fine.
now the direct question will be for team A. So a 42-year-old female have developed these following lesions. As the investigation has been done, vitriol and acetohide stain is negative. No history suggestive of high-risk sexual behavior. Histopathology is shown as below. So you have to tell the diagnosis. Team A.
If you are sure, ask for a double.
Malakoplapkia.
Team B.
Lipsoj ulcer.
Team C.
Darier's disease.
Team D. Anyone from audience? No, no, no. What is shown in the image is the acantholytic dyskeratosis, no? So this is the papular acantholytic dyskeratosis of vulva, which is a variant of Hailey-Hailey disease, not diarrhea.
Even if you would have told Hailey disease, you would have given
We would
it.
have given that. So now the direct question will be for team B. So another clinical scenario, 50-year-old male, recurrent and recalcitrant oral ulceration. Diet-related contact pemphigus was suspected and the patient was asked to avoid garlic, red chili and tea to avoid the chemical exposure. You have to tell all the chemical exposures for garlic, for red chili and tea. Team B.
Capsaicin.
No, team capsaicin. No. Team C.
Balsam of Peru.
Team D.
So thiol group. Thiol group.
Thiol group for what? Which one?
So garlic.
What?
Garlic.
Thiol for garlic and for red
Ah,
chili
red
and
chili?
tea, you are 1/3 correct, so you get 3. So rest 2 for red chili and tea.
He's,
Team A,
Capsaicin, thiol, and phenoquinone for tea.
Anyone from audience for other two? Okay, I'm showing the answer. So thiol is in garlic, so team D will get 3 points. Phenol for red chili and tannin for tea. These are known
team
for
D and team A both get 3. They also mentioned thiol. Thiol.
They
Tannin
have
and
also
phenol,
been thiol,
nobody
yes.
mentioned. Yeah.
Team A also will get 3 points. So these are very much notorious, known for contact pemphigus. Okay. So now the direct question only for
Team C. Team C. No, now Team C.
Team C.
Now Team C. Fine.
Recurrent history of spontaneous hematoma on hand, and also there is sparing of fingertips. There is clinical image, and the name of the scientist is also the scientist has also been shown here. You have to tell the diagnosis by connecting the images. Team C.
Diamond Gardner syndrome.
Team D.
If anyone is sure, please ask for a double. Team A,
I'll like to bounce.
plus 20 minus 10.
Aschenbach syndrome.
Yeah, absolutely correct. You got the plus 20.
Can you name the scientist? Full name? No, Walter Aschenbach. Okay, you get plus 20.
So now the subsequent questions will be asked by Dr. Anupam. So I'm giving him the stage.
Achha, can we have the scores once? Yeah, Mubarak. It's going pretty close. Team D, that is PMCH Patna, is at 3 points. Claps please for Team D. Then we have Team Bhubaneswar, that is Team B, that is on 40 points. Then we have Team A, that is Arjikor, at 43 points. And as of now, Team Delhi, Team C is leading with 50 points. So 43, 40, 50 and 3. It's very close. Okay. We finished at Team A, now we start with Team B. Team B ready? Of course, I don't want to know the diagnosis. I'm talking of a drug which is used to prevent and treat severe oral mucositis in cancer patients undergoing high-dose chemotherapy. Now, this drug is very special because it binds to keratinocyte growth factor receptors in the skin, which stimulates the rapid proliferation of epithelial cells and keratinocytes, which of course leads to acanthosis nigricans-like lesions. So, I want to know the name of the drug which is used in chemotherapy and it causing acanthosis nigricans.
Bexarotene.
Team C? D? A? Audience? Very good answering. Big claps. Your good name? Dr. Sumit. Big claps for Sumit. Very good answering. This is palifermin. All right. So nobody gets this. We now go to team C. Team C. Now, I'm talking of a very interesting regimen, the BPALM regimen, which is 6-month all oral treatment for multi-drug resistant or rifampicin resistant tuberculosis. This has been approved by the WHO and adopted by many national programs. You have to expand BPALM. I need the full expansion, half answers will not fetch you any marks. Expand BPALM.
Bedaquiline,
Yes.
no, minocycline, linezolid.
C, sorry, team D.
Betaquilirin, protamine, levofloxacin, and moxifloxacin.
Again,
Bedaquiline,
bedaquiline, pretomanate.
Levofloxacin, linezolid, and moxifloxacin.
Very good answering. Team D gets plus 10. You could have asked for a double. Team D gets plus 10. Bedaquiline, pretomanate, linezolid, and moxifloxacin. The standard duration for this regimen is 26 weeks. So they get plus 10. Direct question for team A. Please read the question. Do not answer in a rush. 76-year-old male presents with a vexing persistent skin rash composed of nodules and urticarial lesions. There is high-grade fever, polychondritis. Skin biopsy reveals neutrophilic inflammation with features of vasculitis. So you have a vexing rash, you have fever, you have polychondritis, you have vasculitis. Bone marrow biopsy was done to rule out dyscrasias, which revealed myeloid cell precursors with prominent cytoplasmic vacuoles. I think the diagnosis is clear by now. You have to tell me the name of the gene.
UBA1.
Question passes to team B. Team C.
E1 ubiquitin lesion.
Team D.
Is it Sitzner syndrome?
Team A was right. I was just playing with the teams. This is UBA1 gene only. The diagnosis is Vexus syndrome. All right.
You asked for the
Team A gets plus 10. So everyone is feeling sleepy. I thought of adding a bit of. All right. So Vexus, of course, V stands for vacuoles, E stands for E1 enzyme, X is for X-linked, A for autoinflammatory, S for somatic. Right? So it is very much like Sweet syndrome, but you get myeloid cell precursors on bone marrow biopsy. So the answer is UBA1 gene. Team A gets plus 10. Next direct question is for team B. All right, team B. This is very recent. On 28th April 2025, US FDA approved a first-in-class autologous cell-based gene therapy for treating wounds in patients with recessive dystrophic epidermolysis bullosa. It acts as a permanent single application treatment for chronic RDEB wounds. What is the name of the product? You can tell the brand name or the molecular name. You want to bounce? Okay. Plus 20 or minus 10?
Pratimagine, Jamicatcel, Jevaskin.
Excellent answering. Bhuvneshwar is on fire. Team B gets plus 20. Dr. Bhaskar told me this question will go unanswered. I was sure someone will definitely answer this. So team B gets plus 20. Very good answering. Direct question for team C. Ready? Read the question carefully, don't rush. Okay. I'm talking of a disease. 3 outbreaks globally have been reported. One in Ethiopia, one in Tanzania, one in Rwanda. This is a list of recent outbreaks. It's a severe viral hemorrhagic fever, very high fatality rate ranging from 24 to 88%. The clue is exposure to Rausetus aegypticus is the primary source of infection from animals to human. What is the disease? Recently, lot of was being discussed in BBC, Lancet, everywhere. NDTV, lot of news came up. Just few days back.
Ebola.
No. Team D. If anyone is sure, ask for a double. Team A. Team B. Audience? Sumit, you should have been on stage. This is Marburg virus disease. Very good answering. So this is globally the reports of Marburg virus disease. You can see in Uganda, Angola, Congo, USA, various parts have been reported. So this was very recent, I thought of giving this. All right, nobody gets this. Now the direct question will go to team,
Team C. This was
no,
direct for-
this
direct
will
for
go to team D.
Team D.
Next question will go to team D. Simple one. Team D. I'm sorry, there is an overlap. Okay. This is a promising approach for the treatment of genodermatosis, like epidermolysis bullosa and ichthyosis vulgaris. You have to name the procedure. Even if you tell me the abbreviation, I will take it. This is something very recent going on right now. If you are sure, ask for a double. Name the procedure.
Vector-based gene transfer.
Team A.
CRISPR-Cas9.
This is CRISPR-Cas9. Can you expand?
It's not coming back.
Team A gets plus 10. So this is clustered, regularly interspaced, short palindromic repeats associated protein 9. So CRISPR-Cas9 is the yes. Yeah, that was the googly. It was purposely there in the slide. It was purposely there. The answer was there in the slide. CRISPR-Cas9 technology. It was purposely there. So this is the full form of CRISPR-Cas9. Team A gets plus 10. Direct question for team
Team B.
B. Okay. Team B. You have to give me the diagnosis. This is often linked to EGFR inhibitors like erlotinib and your PD-1 inhibitors, that is programmed death 1 inhibitors. You can see some follicles, some pustules, some infundibular lesions. Now microscopy is showing dilated hair follicle containing, there lies the clue, birefringent crystals often composed of calcium palmitate surrounded by necrotic tissue. What is the diagnosis? If you are sure, ask for a double. Team B.
Pride complex.
No. Team C.
Acneiform eruption.
Team D. Team A.
Amyloidosis.
Audience. Sumit. Okay. Sorry, Sumit, but this is necrotizing infundibular crystalline folliculitis. Something rare. So pride complex is very extensively discussed. This is something which is not very commonly discussed. So of course this is necrotizing infundibular crystalline folliculitis. This was for team B. So now the direct question for team C. I want the complete answer. The 3 FDA approved biologics for hidradenitis suppurativa. Team C. Plus 3 for one biologic.
Double करना है। Adalimumab, secukinumab, and bimekizumab.
Very good answering. Team C gets plus 10. You could have asked for a double. This is adalimumab, secukinumab, and bimekizumab. Team C gets plus 10. We go to team D. I'm very fond of Bollywood, so in my quizzes I make sure there is always something from Bollywood. So each time I revolve around Alia Bhatt or Deepika, this time I have shifted a bit 1970s. This is a famous Bollywood actress who was diagnosed with leprosy at the age of 12 years. She got her first screen break in the 1973 Indian Hindi language musical romance film produced and directed by Raj Kapoor and written by Khwaja Ahmed Abbas. You have to identify the actress. This is a very interesting trivia. You Google. This is very interesting trivia. Team. This is for team
D.
D. This is a very
Dimple Kapadia.
team A. Team B. You want to bounce? Are you sure? Team C. Sorry, team B.
Dimple Kapadia.
Team C. I was playing with the teams again. This is Dimple Kapadia. Team D has answered correct. They get plus 10. Sorry, Team B, you don't get anything because the question was already answered. Team D gets plus 10. This is Dimple Kapadia. You just Google. There is a very interesting trivia about this. Okay. Direct question goes to Team A. Team A ready? Connect the images to give a diagnosis. The clue lies on the right side. If you are sure, ask for a double. Something is shown on the right hand side which is very characteristic of the disease. And the disease is named after these two scientists. Team A. If anyone is sure, please ask for a double.
Erdheim-Chester disease.
Team B.
Necrobitic xanthogranuloma.
Team C. Yes.
Gloma cell tumor.
Team D.
Reed-Sternberg cell.
Audience? No. The image is showing emperipolesis. Alright, so this is Rosai-Dorfman disease. Alright, the scientists are Rosai and Dorfman. I thought emperipolesis was a clue. Okay, no problem. Now the direct question goes to Team Bhubaneswar. Ready? Let me finish reading the question and then answer. The image shows a very characteristic and pathognomonic skin manifestation of a syndrome. This syndrome also has thick lips, nostrils and tongue. Now, on March 25, 2026, just 1 month back, FDA granted accelerated approval to a drug for treating the neurological manifestations of this syndrome. Okay? Developed by Denali Therapeutics, this is the first approved therapy designed to cross the blood-brain barrier, and it takes care of the neurodegenerative decline. You have to identify the syndrome and the drug. Something very characteristic is shown in the image. You have to name the syndrome and the drug. Team B.
Trametinib.
Team C. If you're sure, you go for a double.
Gaucher's disease.
Team D.
Sir, tuberous sclerosis, miralapitinib.
Team A.
The drug is remibrutinib. Is it?
Audience. The characteristic image shows pebbling of skin. Right? This is not urticaria, this is pebbling of skin. And so that this is not confused with urticaria, I also mentioned it's a syndrome, thick lips, nostrils and tongue. Pebbling of skin is something very classical of Hunter syndrome. Okay? This is directly taken from the Andrews textbook. And this is the new drug. You can pronounce it yourself, I cannot. Avlaya. Okay? So Hunter syndrome, pebbling of skin, this is something very characteristic of Hunter syndrome. Alright, nobody gets this. Now the direct question goes to Team Delhi. Team C, yes. You need to give me the diagnosis. This is a 4-month-old boy with hyperpigmented horizontal lines on the abdomen, back and limbs, noted at 1 month of age. Now pigment network is absent, accelerated brown or black globules on dermoscopy examination, and faint linear hyperpigmentation is seen on dermoscopy. You have to give me the diagnosis.
Bounce.
You want to bounce? Plus 20. Yes? You want bounce? Plus 20 minus 10? Okay, Team C.
Transient pigmental lines of newborn.
Excellent answering by Team C. They get plus 20. So pigmentary lines of the newborn, or transient pigmented lines, or striped hyperpigmentation of the torso. All are same. Team C gets plus 20. Okay. Team D. I'm talking of 3 patterns. One is the eosinophilic or allergic pattern, Team D. One is the Crohn's disease-like pattern with granulomas, and one is your crystal storing histiocytosis. What is the connecting link of these 3 patterns with regards to leprosy? Team D.
Azaran leprosy.
Team A, if anyone is sure, ask for a double. Team B,
Histoid.
Team C,
Bounce.
all right, plus 20 minus 10.
Clofazimine induced enteropathy.
Very good answering. This is clofazimine-induced enteropathy, and these are the three patterns. One is your eosinophilic pattern, one is your Crohn's disease-like pattern, and one is your crystal storing histiocytosis. All right, so team C gets plus 20 again. Direct question for team D now. What is the diagnosis?
Sir, hereditary hemorrhagic telangiectasia.
Yes?
Hereditary hemorrhagic telangiectasia.
No, team A. Team B.
Darius.
Team C.
Angiokeratoma.
We pass to the audience. Sumit. That is the closest differential diagnosis, but no. This was Flagel's disease. Hyperkeratosis lenticularis perstans, right? So, nobody gets this. All right. We come to the last question of this infinite bound set. Then we will go to the spotters. Now the question will go to team A. Nail the syndrome. Congenital onychodystrophy and anonychia, fifth finger brachydactyly, digitalization of the thumb, absent or hypoplastic distal phalanges of hands and feet. Just to rule out ectodermal dysplasias, hair, teeth and sweat glands are normal. The skin overall is normal.
Gold syndrome.
Team B,
EEC syndrome.
team C, pass. Team D,
Sir, Witkop syndrome.
audience. This is a very rare variant of ectodermal dysplasia, the Cook's syndrome. All right, so skin is absolutely normal, the hairs are normal, teeth normal, sweat glands are normal. All right, nobody gets this. Now can we have the scores once? Team D, that is Team Patna, is at 23 points. Big claps for Team D. Team Bhubaneswar, that is Team B, is at 60 points. Big claps. Team A is just ahead of Team B, that is Team Ajikor, is at 63 points. And Team Delhi, that is Team C, is leading with 100 points. Okay. Now for the spotter round, I would request all the teams to have a piece of paper with them. You need to write down the answers. Do not say anything on mic. Something will be shown on the screen. You have to just answer on paper. Do not answer on mic. Plus 10 for correct answer, minus 5 for wrong answer. So tables can turn. 10 spotters. So it's a 100-point gamble. If you're not sure, do not answer. If you're sure, then answer plus 10. If you're wrong after answering, you get minus 5. Ready? We go to the first spotter. We go to the next one. Next. Don't be too much excited, okay? जोश में होश नहीं खोना है. Next. Team B, your lips are readable from distance. So be careful. Next. अरे ये सिंपल है. क्विज मास्टर के पब्लिकेशंस पढ़ के आने चाहिए. ओके, सो दिस वन इज सिंपल. Even if you give the short form, I'll take it. Next. I told Bhaskar this is tough, but he insisted on keeping this. So, next, this is the undersurface of penis of an infant. Number 9, very simple. Don't name the appearance, give me the diagnosis. And the last question. There's a dermoscopic image. I don't want to know the name of the appearance, you name the condition. I'll go back to the questions again. What is the diagnosis? Again the diagnosis. Diagnosis again. Name the sign in context of syphilis. What is the diagnosis? The diagnosis again. Diagnosis. Undersurface of penis of an infant. Diagnosis. the condition. Done? You can just give us your sheets. Please write A, B, C, D clearly. We go with the answers now. So this one is mace hair in trichotillomania. Okay, this is trichotillomania. Tinea nigra, yes. Anyone got this? Yes? Mike. Now you can answer on mic, yeah.
Acquired digital fibrokeratoma.
No. Ectopic nail, yes. Onychoheterotopia. Ectopic nail, yes. Nobody got this. Okay. This one? Necklace of Venus. Yes, this is necklace of Venus. Team C, don't fight amongst yourselves. Okay. Team C, okay. Wisp of white hair coming, yes. This is trichofolliculoma, very characteristic. Wisp of white hair coming out of that lesion. This is trichofolliculoma. Yes, this is mites. Midfacial infantile toddler excoriation syndrome. This is mites. Even if you write mites, we will give it to you. Anyone? Yes, poroma. Poroma or ecrine poroma. Anyone got this? This is median raphe cyst. Yes, this is median raphe cyst. ये तो cylindroma, jigsaw puzzle like appearance, right? Cylindroma, jigsaw puzzle. Okay. If you write cylindroma, we will give it to you. And last one. Yes, this is seborrheic keratosis, cerebriform appearance of lesion. This is seborrheic keratosis. Let us complete the scoring and then we will. Do we have a tie? No? Yes? We need tiebreaker questions, I think. Thank you everyone for being there. This was during last year Dermacon quiz finals, where in the audience round me and Bhaskar won I think 4 or 5 those audience prizes. But it was the same book repeatedly which we were given, and we distributed the books to our juniors later on. Thank you Bhaskar for being a wonderful co-quiz master. Thank you Mubarak for helping us with the logistics. Heartiest congratulations to all the 4 teams, Patna, Kolkata, Bhubaneswar and Delhi. Okay, it was very narrow. Team D got 15 points in the spotter round. Claps for Team D. Team C, that is Delhi, got 50 points, 5-0. Claps again. Team A got 55 points. Big claps. Team B did very good. They got 85 points in the spotter round. So, third runners up for this Clinicon PG Quiz Finals 2026 is Team PMCH Patna. Big claps for Team PMCH Patna. Can you please announce your names on mic once again?
Sir Divya.
Dr. Divya
Zainul.
and Dr. Zainul. Big claps for Team D. The team which finishes on second runners up is Kolkata, Team Arjikor at 118 points. Can you please announce your names once again?
Dr. Shinjan Pramanik.
Dr. Manisha Som.
Shinjon and Manisha from Arjikor. Team Bhubaneswar and Team Delhi, they were very close. Prior to the spotter round, Team Bhubaneswar was at 60 and Delhi was at 100. At the end of spotter round, Bhubaneswar is at 145, Delhi is at 150. So it was a very close fight. Team Bhubaneswar was on first runners-up spot and Team Delhi is the winner. Bhubaneswar, please announce your names on mic once again.
Dr. Mohit.
Dr. Preetham.
Dr. Mohit and Dr. Preetham, big claps for Team Bhubaneswar. You did very well in the spotter round. And winners, of course, Team AIMS Delhi, Saransh and
Manoj.
Manoj. Big claps for Team Delhi. Heartiest congratulations to all of you. I think the prizes and the certificates will be given in the valedictory. So if you go for sightseeing, come back by 6 p.m. Okay, 6 p.m. Thank you everyone once again for being there with us. Thank you.
A warm, cold, and a bit of sleepy good morning to everyone. After an enticing session of PZ quiz, let's start the scientific session for the day. For the first session of the day, we have Dr. Abhishek Ranjan sir, Dr. Pushpendra Kumar Singh sir, and Dr. Rekha Singh ma'am. Please kindly join us on the dais to be the chair the first session.
So, good morning, all of you. Good morning, respected chairpersons. With due permission of the chairpersons, I would like to start my talk. That will be a brief discussion about the management of psoriasis at various difficult sites. So, these are the difficult sites that we face due to various reasons. Uh, the scalp, where we get a barrier of hair and thick skin, the flexural areas, the areas with high moisture content and repeated frictions, the face, which is a sensitive area, having cosmetic concerns, the genitals involved in the inverse psoriasis, the palmoplantar psoriasis, where we get the thick stratum corneum. So, what we need to understand here is that a facial plaque of psoriasis, even if it is very small, can have a disproportionate psychological and functional disability. So relying on the standard body surface area metrics consistently underestimates the severity of the localized diseases, delaying their crucial systemic intervention. Also, the anatomical barriers at these sites, like the thick stratum corneum of the palms and soles, the hair density of a scalp, the thickness and toughness of the nail plates, the sensitive occluded skin in the groins and the folds, all these create a difficult situation for us to treat them. And coming to the clinical reality, the patient experiences severe localized pain, functional limitations, and social stigmatization that frequently leads to depression and isolation. And what we observe in the plaques of these sites is just a tip of the iceberg. Underneath lies a massive quality of life devastation. There is huge social stigma, sexual dysfunction, loss of employment, and even the DLQI fails to adequately capture the mental aspects of the patient's quality of life. So these are the major sites that are difficult to treat. It is important to understand that these are not very rare edge cases. These are very prevalent manifestations, either presenting alone or in combination with the chronic plaque psoriasis. And hence we need to provide a tailored, individualized approach in each patient to manage these difficult sites. Now coming to the scalp psoriasis, there are various anatomical, clinical, and psychological barriers in treatment of scalp psoriasis. First of all, it is highly prevalent. The dense hair physically blocks the topical applications. The rapid cellular turnover creates thick, impenetrable scales. The routine hair care, like combing, it triggers the Koebner's phenomenon. The patients face intense pruritus, burning, and even bleeding. The visible flaking is stigmatized as the poor hygiene or dandruff, and also it has a negative prognostic indicator, a 4 times higher risk of developing the psoriatic arthritis. So apart from using the conventional matrices, it is important to use the psoriasis scalp severity index as the severity metric. In the management, the step 1 is always the potent topical corticosteroids either in solution or foams. It can be combined with the vitamin D analogs. Keratolytics is to be used to remove the thick scales and tar-based shampoos. And even if the plaque is small, the manifestation, the impact can be significant. So we need an early escalation to the systemic therapies. The drugs are well known to us, the methotrexate, cyclosporine, acetratine, apremilast. And whenever affordable and needed, we must switch to the biologics as soon as possible if the patient can afford. The interleukin 17 inhibitors are to be used for faster clearance rate, and interleukin 23 inhibitors for better durability and maintenance. Various nanotechnology based topical systems are being designed for better follicular penetration, drug stability, and targeted drug delivery, as the drug delivery is as important as the drug itself. The newer formulation, the topical roflumilast, is the non-steroidal, recently approved for scalp psoriasis in 2025. It has better penetration via foam vehicle, and it is ideal for hair-bearing areas. The newer, smaller molecule, that is deucravacitinib, the TYK2 inhibitor. And in biologics, interleukin 17 is to be used for rapid relief, and interleukin 23 inhibitors can be used for longer remissions. Now coming to the plaques, the facial involvement carries severe stigma and high risk of steroid-induced facial skin damage. The facial skin is thin, highly sensitive, and hence there is a risk of developing steroid-induced atrophy and telangiectasias and ocular complications if applied around the eyes. The psychological barrier is very significant, as it triggers a social isolation, fear of negative stereotypes, and elevated risk of depression and suicidality. We should prioritize the steroid-sparing agents for facial lesions. The calcineurin inhibitors are ideal for facial plaques, and especially around the eyelids, nose, and mouth. Short duration steroids, mid potency or low potency, can be used for 10 to 14 days. We should educate the patient properly about the quantity of the creams that is to be applied by giving them the fingertip unit method. The overuse will never result in a faster result, and obviously we need to combine the treatment with moisturization. What we should not do is we should avoid the high potency steroids on face. We should avoid the use of irritant therapies like colta, salicylic, and ethanol on face, and we should not apply the medications around the eye without guidance. The nail plate acts as an impenetrable fortress. The main barrier here is the anatomical barrier, because the topicals cannot penetrate the hard plate to reach the inflamed matrix or nail bed. And the clinical barrier is that all the local injections, intramatricial injections, are excruciatingly painful, leading to high patient refusal rates. And nail involvement is a negative prognostic factor. It has a 3 times higher chance of developing psoriatic arthritis, directly linked to subclinical enthesitis. These are the newer advancements that are being made for management of this nail psoriasis. The physical enhancement, it includes microneedling, laser ablations, iontophoresis, sonophoresis. The ultimate aim is to create the microchannels or pores, and so that the drugs that are applied have better penetration to the matrix and nail bed. Also, there are nanotechnology based formulations using liposomes, neosomes, and lipid carriers for enhanced drug stability and better penetration. The systemic options are the conventional methotrexate or acitretin, the oral small molecules of apremilast, deucravacitinib, and JAK inhibitors, and the biologics interleukin 17 inhibitors and interleukin 12 and 23 or TNF alpha inhibitors. There are few case reports of use of intralesional secukinumab injection for management of nail psoriasis. Here the needle was inserted from the two sides of the proximal nail fold and on the anterior nail plate as shown in the image. The 30 milligram secukinumab was injected into each fingernail. 150 milligram secukinumab was injected into each hand. The patients were injected once every 2 weeks for 3 months. Then the treatment was changed to subcutaneous injection of 150 milligram once a month for 9 months. A significant reduction in NAPSI was observed over a period of 12 months. Coming to the palmoplantar psoriasis, even if the plaques are small, it can be deep, leading to painful fissures, extreme indurations, and coarse hyperkeratotic scaling. It takes a functional toll by hampering the physical day-to-day activities of the patient. It is worsened by smoking, repetitive mechanical traumas which cannot be avoided over hand and feet. The severity metrics that needs to be used here are the ESIF, that is erythema scaling, induration and fissuring scale, and the palmoplantar global assessment scale. Here you can see the hyperkeratosis and deep painful fissuring on the extremities of palmoplantar psoriasis. For management, for the thick skin, there is a reduced drug penetration, so we need to use high potency topical corticosteroids under occlusion. For prominent scaling, we need to add the keratolytics, that is salicylic acid and urea. For painful fissures, emollients and barrier care is important, and the systemic therapy has to be initiated as early as possible. The phototherapy can be effective. We should try to avoid trauma to prevent the Koebner phenomena. There is a strong association with smoking, so we should advise cessation of smoking. It often requires combination therapies. Now, behind the fold lies the psychological distress of the inverse psoriasis. Here, since there is a repeated friction and moisture content, the typical silvery scales are wiped away, so it can be frequently misdiagnosed as fungal infections. This soft macerated skin, there is a higher risk of increased percutaneous drug absorption. Also, there is a significant psychological barrier. In 63% of the patients of inverse psoriasis, there is a risk of embarrassment, preventing them from proactively participating in the society. Coming to the treatment, for these intertigenous areas, we need to use the low potency topical corticosteroids, and tacrolimus, pimecrolimus are safe for long-term use as they don't cause any atrophy. The newer modality in the drug delivery system is the lipid-based and vesicular system, where they have developed ethosomes and transforosomes, where there is high content of ethanol forming ultra-deformable and flexible membranes, where the drug is released only when they penetrate deeper at the target areas. It enhances the drug delivery without causing macerations. The systemic therapies have to be initiated. The use of conventional agents, that is the methotrexate, cyclosporine, acitretin, apremilast and JAK inhibitors. In the biologics, we have the targeted therapies, the adalimumab, secukinumab, ustekinumab for resistant or moderate to severe cases. So it is important to understand that at these sites, although the body surface area involved is less, but it has a disproportionate higher impact on the patient's life. So we need to provide them a tailored treatment approach to them. Thank you.
Well presented. Just one question I have, like what type of steroid we should use on face and groins when
Mid potency if the disease is very severe, or otherwise the mild ones, hydrocortisone or desonide, only these should be used on the face, or fluticasone.
yeah.
Yes.
Right, we are in the era of biologics now.
Yeah,
So
exactly.
we absolutely say no, but yes, limited disease, facial lesion, we try to use steroid for short course,
Short course.
less than 10 days maximum.
Yeah.
But I really want to ask a question, doctor. I mean, intralesional injection of secukinumab.
Yes, sir.
Because psoriasis being chronic inflammatory internal disease, are we not wasting patient money by not giving subcutaneous or just injecting into the nail bed?
So I have personally not used it. This was in the literature. There are few case reports, so just I shared it with the audience. I have not used it, and I don't have much experience about intralesional use of this secukinumab injection.
India has not progressed so much, like ILS of secukinumab.
Thank you, sir.
Thank you so much, our speaker and chairpersons. I would request our speaker and chairpersons to kindly collect their memento. For chairing the next session, I would like to invite Dr. Diptashri Sen, Dr. Gopinath, and Dr. Rajesh Kumar sir to kindly chair the session.
Good morning. I request Dr. Mohammad Nazir to speak on biologics in psoriasis, I think. Okay.
Thank you very much, ma'am. At the onset, let me thank the organizers for giving me this opportunity. And also, I thank them to prepone my talk. I had to reach home very fast. Good morning, respected senior colleagues, my dear friends and students. There is no conflict of interest in this talk, and there is no financial funding also. I think all of us, at least majority of us, are attended the last Dermacon conference 2026 at Bangalore. I usually attend the conference with my family, so my time spending to the conference is minimized or hampered. Last time I attended alone, so I used to spend more time in Bangalore conferences. I was mainly attended the inflammatory and the autoimmune disorders. Majority of speakers ends talk with JAK inhibitors. When I went back to the hotel, I was thinking what was I learned on that day. Most of them was ended with you can give JAK inhibitors. So I don't know if it is freely available in our country. What is the cost of the medicine? Whether the RCT was completely done for this patient, where any randomized control study was conducted. What are the complications? What are the investigations? A lot of questions made me to read more about JAK inhibitors. That made me to stand in front of you. There are a lot, huge data collected and utilized in cellular and molecular pathway, made us to change from the traditional treatment of the steroids, methotrexate, cyclosporine, to a biological era. We are navigating through the biological era in the inflammatory and autoimmune disorders. But we are witnessing a small paradigm of shift from these biologicals to a more superior immunomodulators, precious immunomodulators, because of our knowledge on intracellular and intercellular pathways are broadening. we initially thought we have only JAK pathways. Now there are multiples of pathways are there. Each pathways carries different signals. There are interconnection between these pathways. If you block one pathway, the signal can transfer through the other pathways. So body itself is changing. When we're introducing one drug, body itself is shifting to another pathways. JAK inhibitors, or just another kinase, is a family or a group of intracellular non-receptor tyrosine kinase. The main function of this is to transfer the signals from the receptors on the cell wall to the nucleus. So JAK helps to transfer the signals from the receptor to the nucleus, where the nucleus reacts with the DNA and the modulation of gene expression happens. It can be positive or negative. Janus got its name from the Roman god of duality. So JAK possesses two similar phosphate. It has two transformed domains. One helps to stimulate or activate the enzyme activity. In reverse, others will have a back loop feeding, the negative feeding mechanism. There are three major proteins in STAT-JAK pathway. One is the cell receptors, next is JAK, next is SAT. If these three together make the JAK-STAT pathway. When the ligand is binded with the receptors, there is a clustering of the receptors. When there is a receptor clustering occurs, it recruits JAK kinase. This JAK kinase form a phosphorylation, or attach the phosphate to the receptors. When that has happened, it recruits STAT. Then the recruited STAT usually have a single. Then it became attached to the phosphate, became a dimer. This dimer, only the dimer is permitted to infiltrate into the nucleus. So dimer is infiltrated into nucleus, it attaches DNA, then STAT dimer bind to DNA and transcription of target genes happen. So this will be a negative or positive to the human being. What happens next? Same thing. When the cytokine attach to the receptors, the JAK will be called to help. It forms a phosphorylation. Then the STATs are usually a single unit. It became attached to form a dimer. Dimer only come inside. When dimer is attached to the DNA, to the nucleus, it forms cytokines, chemokines, and other proteins. This take parts in inflammatory and pro-inflammatory responses, immune responses, drug resistance, survival and destruction of cancer cells, hematopoiesis, and embryonic genesis. There are 15 different types of procytone kinase receptors in the cell wall at present. The numbers are slowly increasing. Tomorrow the researchers will find out with newer receptors. Three main receptors are interleukin receptors. We all are well aware of the interleukins. Second one is interferon receptors. Third one is colony stimulating factor receptors. All this can be stimulated, but the duration of the transfer of signals and the amplitude of the signals will be tightly well controlled. This picture shows only the receptors. There are 15 more receptors on the cell wall. Some receptors binds only with a specific domain. Others can bind with multiple domain. Single domain can bind with different receptors. So in JAK family, there are 4 JAKs, JAK1, JAK2, JAK3, and tyrosine kinase 2. In STAT family, there are 7, JAK1 to 4, 5 as A and B, and JAK6. There's something called SOX, suppressors of cytokine signaling proteins, which negatively controls the inflammation of the STAT stimulated by the JAK-STAT pathway. So negative feedback inhibit the signaling cascade. This is just a summary of what I've already told you. By looking this one, you can select whether you want JAK1, JAK2, JAK3, or tyrosine kinase. Depends on the inflammation cytokines involved in your disease you are dealing. From there, you can choose whether you want JAK1 or you want a combination JAK1, JAK2, or a pan-JAK. There are interaction of JAK-STAT pathway with other signaling. This is the main issues now. So when you give signals to JAK and tell them to transfer to the nucleus, it can be hijacked or can be transferred to other. See, there are people who stake in the TGF-beta pathway. It contains MAPK pathway. It takes a lot of signals from the JAK and make another route. So when you develop newer JAK in future, a JAK inhibitors in the future, we have to consider this data transfer from one signal to another signal. See, when you take the previous slide, the interleukin-17s are not covered. So interleukin-17 blockers, secukinumab, but we are commonly using, it is not comes under JAK pathway. It is entirely following a different pathway. That is why till the FDA is not approving the JAK inhibitors for the plaque psoriasis. Then why jackpot is boiling? Everybody is interested on JAK. People have started using JAK left and right. What is the reason for that one? Biological targets single or two cytokines, either interleukin-17 or interleukin-20, 23, any other interleukins. But JAK inhibitors are small molecules that block the central portion, intracellular signaling pathway. JAK slowly moved to more specific and more selective. Initial JAK, that is the tofacitinib, is introduced around 12 to 13 years back. It was not selective, it's a pan-JAK. It blocks JAK1, JAK2, and JAK3. So when you select more JAK, you get a better results, but side effects also became more. So we are planning for a more selective JAK inhibitors. So your abrocinib and upadacitinib is JAK1 inhibitors. Now they are planning for newer, the third generation JAK, that is JAK inhibitor without a transfer of signal to other pathways. Comparable to biologicals, JAKs have a shorter half-life, so the side effects or adverse effects are minimal compared to biologicals in JAK. And no neutralizing antibodies, that is what we are facing now. Secukinumab gives is not effective after some time. That is because of the antibody formation. That is not happening in JAK. This is the 4 advantages combined to biologicals for JAK inhibitors. JAK inhibitors are a group of drugs. It immunomodulates the JAK signaling pathway blockage. The first one to approve by the CDC is the ruxolitinib. It is a JAK1, JAK2 blocker. Initially, it is around 15 years back, it was approved for myelofibrosis and acute graft-versus-host reaction. Recently, it is approved for atopic dermatitis. Second one was tofacitinib. Actually, it was approved for rheumatoid arthritis. It was approved psoriatic arthritis afterwards, but is not approved for psoriasis as such, cutaneous psoriasis so far. There are 11 conditions whether the JAK inhibitors are using in dermatology. The first 3, atopic dermatitis, vitiligo, and alopecia areata, that is the 3 main diseases with JAK inhibitors are used. Psoriasis, SLE, dermatomyositis, lichen planus, sarcoidosis, hidradenitis suppurativa, graft-versus-host disease also JAK inhibitors using, but it is an offline treatment or in a research work. Psoriasis, recently, deucravacitinib 6 mg OD is approved for the JAK as for psoriasis. Tofacitinib and upadacitinib is approved only for the psoriatic arthritis. The future applications, you can improve the application of JAK more into lichen sclerosus chronicus, IBD-associated skin disorders, pyoderma gangrenosum, erythema multiforme, granulomatous cheilitis, even bullous disorders, bullous pemphigus vulgaris, dermatomyositis. JAK shows to inhibit the auto-antibody productions. In Behçet syndrome, JAK THS17 overexpression can be controlled by tofacitinib. Eczemas also, the topical tofacitinib started using and approved. What are the common side effects you are facing? Compared to other drugs, side effects are minimal, but you can't say there is no side effects. Common side effect is upper respiratory infections and nasopharyngitis. If this happens, you can tell patient to temporarily stop the medication, continue medication when that is happen. Or when you prescribe the medication, you can tell the patient to stay away from the infections or take yourself. Herpes simplex, herpes zoster reactivation, another one. Tuberculosis is more important for as far as we are concerned, because we are living in a country with an endemic area of tuberculosis. So tuberculosis is important for us. GI manifestation like nausea, vom, and diarrhea usually controls within a week. Neurologically, most of the patient complains headache, but maximum is 1 or 2 days. On the skin, it causes acneiform eruptions, then burning and pruritic sensations. Laboratory investigations, mainly in elevation of CPKs, anemia, increased lipid levels. But all are minimal one only. Risk factors, when you prescribe medication, the JAK inhibitors, you should make sure that patient is not above 65. They are more prone to have side effects. They should not have obesities also. They should not be a smoker, they should not alcoholic. They should not be undergoing hormone therapies, high BP patient, people with cardiovascular diseases, people on malignancy, on treatment, then people on history of coagulation disorders or DVTs. These patients are more prone to get investigation. Prior, you have to do LFT, RFT, then the hepatitis B, C markers, HIV, CBC, baseline lipid panel, the quantiferon gold. Now, as far as we are concerned, quantiferon gold is very important. Hepatitis B, C is there. Other things, you can do it starting before, then first month, then every 3 months. There is a black box warning in this thing. Black box warning actually started, in the United States, they combined the TNF alpha and JAK inhibitors. The group was people with overage, above 65, with rheumatic arthritis. At the end result, when they analyzed the result, a lot of people developed cancer, a lot of people developed cardiovascular accidents, a lot of people developed venous thrombosis. That is 2021, they given a black box warning. How far it's applicable to a dermatology is a question. These are presently the FDA approved drugs for the dermatological uses is mainly the four diseases the drugs are approved is atopic dermatitis, alopecia areata, psoriasis, vitiligo. So this is selective and non-selective JAK inhibitors. Selective, you get a good result. Non-selective, you get a good result, but side effects are more. Non-selective, of course, you get less side effect, but cost is unbearable. So these are the JAK inhibitors available in our country. We have oral medications. Freely available is tofacitinib, baricitinib, upadacitinib. Cost also given. Ruxolitinib is a little costly. 1.5% creams are available. It is not that freely available. Less commonly available drugs are last two. So takeaway message is JAK inhibitors are not just another option. Don't jump into JAK inhibitors if you are not getting improvement in that one. There are precious tools, so use it very carefully. For atopic dermatitis patient, you get a rapid control disease. I am also experienced. You get a rapid control of diseases, and uncontrolled itching also can be controlled. In alopecia areata and vitiligo, they are first-line treatment for disease-modifying results. In vitiligo, it's mainly an inflammatory process. Pigmentation, you have to go for a phototherapy. But the new lesions coming up can be controlled. In Indian way, don't afraid to the black box warning. We are mainly using in a healthy young patient. Compared to rheumatoid arthritis in Western countries, they're using for older people. But we have to screen vigorously for tuberculosis and zoster. So thank you very much for your time. Happy to hear inputs from the senior colleagues, their experience.
Very good presentations. And any questions from audience?
What is the highest age of the patient you have treated with JAK inhibitors, sir?
Which I couldn't get you, sir.
Highest age group of the patient, elderly patient coming to us with atopic dermatitis. Now
See,
we are seeing 70, 80s. That's
See, I tell you true, before I'm reading, I used to give to all patients. Now I restricted to 50 years.
And how many patients of herpes zoster reactivation you have seen?
Very few. It is negligible. That's what I told.
Thank
As
you.
an Indian concern,
Yeah.
you have to mainly concentrate on tuberculosis.
You're
That
right.
is all.
Thank you, sir.
Nasir, that was an excellent presentation. Here, Dr. Gopinath here. This side, this side. No?
Why did you say it is not used in psoriasis? Sorry.
Please, sir, please.
In psoriasis, you said because of 17 pathway is not blocked. You said.
It is not approved, sir. It is not approved. People are using it. Offline, people are using it. But FDA is not approved. They say it is interleukin is not taking these pathways. It is taking a different pathway. It is not a JAK pathway it is following. Which one? Arthritis approved.
But it blocks interleukin 17, no?
No, it is through JAK it is not blocking. It is following another pathway.
And CPK you do for all the patients?
CPK, it is better to do it all the patients. But it usually come back to normal.
Subsequent visits, sir.
No, but unless we have a baseline, we cannot do as subsequent.
Initially, before starting, you have to do it. Then you can. But majority patient, we never see that we never goes so high. But if they go for a medico-legal cases.
Everything increases the cost, no? That is the reason.
Yeah, cost is a main factor for this.
Nasir, how long you have to continue for alopecia areata and totalis and other thing? What is
there
your
is no
experience?
particular protocols. I was treating one alopecia totalis for the past 2 years, and she is already a dermatomyositis patient. So I discussed with the rheumatologist, say it is useful for that thing also, so you can continue it. So at the time being, I'm continuing. I don't know. That's nowhere it is written because most of the inflammatory reactions you may have to continue for a long time. That is why we are slowly switching over to topical medications. So if there is not much side effect even if we continue with it. Only thing combined to biologic, it is cheaper. Side effect are less, but cost-wise is almost same.
The problem is I have 2-3 totalis patients and subtotalis. Once, 5 milligram doesn't work at all. It is 11 milligram extended release, it works. But once you taper it after they attain a good result, naturally the hair, what they had grown now, they also goes away. So we tend to continue it for long. That is the issue. For majority of the patients, we cannot stop it.
You have to continue. See,
That
side
is the
effect, we are not following the 20 milligram dose what the Western people is following. We are going up to 10 milligrams. So that is maybe the reason why we are not getting much side effects compared to Western people.
But if you are using for a fresh case tofacitinib, if you stop, it won't go.
Sir, for a fresh case, should we use topical tofa? Okay. Systemic tofa should we use?
Why not? It is the best drug available now. It can be the first line of treatment. Instead of harming the patient with steroids and methotrexate, you can start tofacitinib. In those patients, if you stop tofacitinib, the hair does not go off. So we should not always believe that if the hair comes by tofa, if you stop, it will go off. No. Because sometimes in alopecia areata, without doing nothing also, hair grows.
Yeah, that also happens.
So, only in the resistant case, where because of tofa the hair grows, if you stop, you will find it goes.
Tofa is pan and is comparatively cheaper. Side effects as well less because it is in the look. It is JAK 1, 2, 3.
Pan-JAK. That is the
Even the pan, it is not much act on JAK 2. JAK 2 only causes the anemia and the myeloproliferative and depressive ones. So it is safer compared to other things. And we are giving a very low dose, 5 milligram BD or 11 milligram. So we are not going for higher doses.
When you ask for the thing, JAK1 upadacitinib is comparatively comparable with the tofa and little more specific for the JAK1. But the side effects are almost recurrent nasopharyngitis happens. We used to give them influenza vaccines. Acne, it occurs in both the thing. Abrocitinib, what I had understood in my patient, 2-3 patients on abrocitinib, the recurrent upper respiratory tract was less, and the actiform eruptions was also less. That was my experience, but very costly, 50,000 to 60,000 per month.
But Upadacitinib compared to JAK, it is not much that costly. So you can continue with that drug. It is not, no, by my experience, I didn't have any experience with recurrent because that's what I told. It is JAK1. JAK2 in blocker only have give more suppressive for the blood. Hemoglobin TCDC will be more reduced with JAK2 inhibitors compared to JAK1.
Thank you so much, sir. That was such a wonderful discussion, and I think it would just go on because it's a wonderful topic. I would like to request our speaker and chairpersons to kindly collect their mementos. For the next session, I would like to call upon stage Dr. Ranjit Kumar and Dr. Pradeep Kumar to kindly chair the session and introduce our speaker.
Yes. Good morning, everyone. I welcome Dr. Bhaskar sir for their topic, new biologicals in the management of the psoriasis. Sir, please.
Good morning, all. Respected seniors, colleagues, and my dear friends. So I'm going to talk on newer biologics in the management of psoriasis. When I'm a poor biologic man, I love to use biologics. And I am very happy to present my talk in next 15 minutes. I'll take you to the new biologics. As you all know, psoriasis is a chronic inflammatory disease which is more than skin deep, which affects skin, nail, joints, and then it is strongly associated with many comorbidities. In all psoriatic patients, it is not just skin, it affects every organ. The most common associations are NASH, psoriatic arthritis, and then the cardiovascular comorbidities, stroke, and involvement of pancreas in some patients, pancreatitis, IBDs, and then anxiety disorders, dyslipidemia, metabolic syndrome. There are many comorbidities associated with psoriasis. That is the reason in the era of 2026, we are seeing psoriasis as a systemic disease. It is not just anymore a skin disease. It is more than skin deep. That is why we evaluate a patient thoroughly and then we proceed with the pro-inflammatory cytokines. Tildra and Gussel deliver durable skin response. Next generation therapies demonstrate superior efficacy and quality of life by offering safer, more effective and subtype specific. The best advantage of biologics are there's no end organ toxicity. They just exactly work on the cytokine. I really want to present one of my patient. I gave this man who lost his hope. He was given initially adalimumab, then secukinumab. Then he met me with very bad joint pains and severe extensive disease. He's an Australian-written boy. He's a software engineer. He lost hope. He has suicidal tendency. He met me. I just gave one dose of guselkumab, that is Tremfa, which costed him 88,000 to the patient. After 1 month, he has sent a photograph. He said, just 1 month gap in between, November, December. You can see the photographs. Amazing. Yes, doctor. You can show, but don't give this to anyone, sir, please. I'm not married. Don't give it to anyone. He responded extremely. Look at even the hair growth. The best part is, it stopped the inflammation. When it stopped the inflammation, everything goes. That's the beauty. He gained weight. He lost hope. He lost hope. He gained hope. That's the beauty of biologics. One of my patients, my cases, so multiple therapies. He met me in a bad situation. I just run through the photographs. I'm not posing, but I have given in thousands of patients. I love to use biologics. A young boy with a very severe disease. Look at it. What drugs give this kind of clearance, including post-inflammatory hyperpigmentation? This lady, 68, with palmoplantar and flexural disease. So, I really want to ask you this question. How do we see psoriasis patient being managed now in near future? So now we start with DMARDs and then we switch over to the available drugs. Now TIC2 is coming to the Indian market, deucravacitinib. How far we away from cure for psoriasis? So psoriasis behaves like a memory-driven disease. Long-term remission requires targeting the memory pool. IL-23 may induce a state similar to functional cure. There's no complete cure, but there's a functional cure. The theory often used to explain why IL-23 inhibitors perform IL-100 durability. So the durability is more with IL-23s than IL-17s. Blevard psoriatic knockdown theory proposed that long-term IL-23 blockade depletes pathogenic Th17 memory cells leading to reset of psoriatic inflammation and durable remission. This is a wonderful paper in IPC 2024 think tank meeting. This is what I've shown you, knockdown theory by Dr. Andrew Blevald. What do patient expect from psoriatic treatment? One thing, I want complete cure. I always tell my patient there's no cure. Before I start any therapy, I am loyal to my patient, but I educate, explain in a decent way. Patient expectations, improving eliminating lesions, alleviating symptoms, reducing frequency, finding treatment regime that is effective and fits into patient lifestyle, enhancing patient quality of life. Why do we need a change in treatment paradigm from conventional therapies? Look at methotrexate, it's amazing drug. I am not against conventionals. Methotrexate, gastritis, hepatotoxicity. Anyway, patient of psoriatic already had NASH. Why are you hitting it again with methotrexate? Number two, the second most difficulty, cyclosporin, nephrotoxic, and then it has own side effect, tremors, paresthesia, and then hypertension. The acetretin, it's working differently. It's not working on the immunological cycle. Apremilast, jack of all trades, master of none. And then coming to the available other drugs like MMF and all, they're not proved. So the best way is, if you're not convinced with the conventional, rotational, sequential therapy, the best choice is always biologics. So current challenges is adverse effects associated with treatment, emergence of resistance, high cost, significant individual variability. Because every phenotype is different, every genotype is different. And the most important point is most of the new biologics do not have anti-drug antibody formation. Remember this. They are very effective. There is no ADAs associated with the recent available IL-17s and IL-23s. So as you all know, this is what is psoriasis. So many comorbidities. There is a low-grade inflammation. There is a low-grade inflammation. Remember, my dear friends, when you are treating psoriasis, we are treating psoriatic patient as a whole. It is not just about skin. So this is a new term given to the NASH, MASLD, F3 fibrosis. How important is to screen all psoriatic patient metabolic disease? I was in type with one pharma company where they are doing all my patients for free of cost for HEPA-scan. We are doing HEPA-scan to every patient. Surprisingly, most of the livers are very sensitive. So do not hit with the drug which is hepatotoxic. Why screen? Why do we choose biologics? So this is the latest IPC consensus 2020. According to IPC guidelines, patient is considered candidate for systemic therapy when BSA is more than 10, when lesions affect special body areas, when topical therapy failed to control symptoms. So this is a very important question. Does early treatment with biologics offer any advantage in long-term disease? I'm not promoting biologics, but this is true. Act fast, hit hard, prevent further relapses and remissions. If you have a single plaque on scalp, hit it. Scalp is directly proportional to your heart. Cardiovascular comorbidity. So again, read this paper. And please read think tank meetings of IPC. They're amazing. Every 2 years they meet and they come out with wonderful guidelines. So this is what I said, faster, sustained. So how do you choose biologic for your patient? So it's all the comorbidities, IBD, age, extensive disease, cost of therapy, there are many things. Which biologics to choose? I'm sorry, I have only 23 seconds. Which biologics to choose? So I just go fast because I have to finish. What do you next? How do you stop biologics? This is very important. Post-clearance strategy. Continue maintenance dosing, consider dose interval extension, monitor, switch strategy, shared decision making. Give me 2 minutes, please. What is your current preferred biologic and why? What lab parameters? The basic things. They are very safe. They are very safe even we use it in hepatitis B positive patients. But yes, in conjunction with the ID specialist. What are the preventive strategies for infection prevention? They are the very important thing, infection preventive strategies. All these things I have taken from BID guidelines. What are your views on 2 IL-17 blockers, say Q and ICSI? So IGRA, not much role in the era of IL-23s and 17s. They are safe, but for legal purpose we do. Now we have something called IGRA+. So why IL-23s are better than IL-17? IL-23 sits higher. As I said, it sits higher. So IL-23 produces IL-17. Remember this. That's the reason we are blocking IL-23. It sits higher in the inflammatory cascade. It's an upstream cytokine. Remember this. This is an upstream cytokine. Produce multiple downstream effector cytokines like IL-17A, F, 22, GM-CSF, including TNF-alpha. Blocking IL-23 shuts down entire TH17 axis, not just IL-17. This leads to deeper, more durable, sustained suppression of psoriatic inflammation. Why IL-23s fit in the theory better than IL-17? So IL-17 blocks only effector cytokine, but pathogenic C cells persist. Once drug is stopped, rapid relapse within weeks. But in contrast, deplete, exhaust TRMs, tissue resident memory cells. Reset the disease biology at deeper level. So switching, there is a concept in switching from one class to other. So with this, I'll close my talk. So what is the role of dermatologists in biologic therapies? Dermatologists need to familiarize themselves with the rationale, mechanism of action, and most importantly, efficacy and safety of biologics and the treatment of psoriasis. Dermatologists, we should seize the opportunity to use and prescribe biologic therapies for their appropriate patient. We are in a better position than other specialists to manage the complexities of psoriasis on long-term basis. To conclude, biologics continue to establish efficacy, tolerability, safety profiles across the psoriasis and other several indications. No defined organ toxicity, very rare. Rare incidents of well-defined adverse events. They can be used safely in most patients with vigilance, guidelines, and good communication between physician and patient. Adverse events may vary between biologics, and the long-term safety should be monitored. With this, I thank the organizers for giving me the opportunity. Thank you very much.
Thank you, sir, for your nice presentation. Any question from audience?
Go ahead.
Okay. Thank you, sir.
Thank you, dear.
Thank you, sir, for such a wonderful session. Now, I please request our chairpersons to chair the next session.
Our next speaker is Dr. Tamil Malakar. He will talk on the topic atopic dermatitis, recent updates in management.
A very good morning, everyone. Let's delve into the recent updates and management of atopic dermatitis. So, looking into the evolution of therapeutic options in atopic dermatitis, starting from topical and systemic corticosteroids to the steroid-sparing agents, then starting with dupilumab and now with nemolizumab, lebrikizumab and tralokinumab, it has traveled a lot of distance with many recent advances. So coming to the topical medications, tapinarof is a non-steroidal aryl hydrocarbon receptor agonist, which is combined with the nuclear translocator and reduces the transcription of Th2 cytokines, Th17 cytokines, increases the expression of epithelial barrier components like involucrin, filaggrin. It also has an antioxidant effect, which is mediated by the NRF2 pathway. So it is available as 1% cream used once daily for the moderate to severe atopic dermatitis in the age group of 2 years and above. It can cause nasopharyngitis, folliculitis, and headache, but the advantage is that the systemic absorption is very minimal, so it can be used over a larger body surface area, and it can be applied on any site and for duration. There is no limit. Coming to roflumilast, it is a PDE4 inhibitor after the invention of crisaborole. So it inhibits the conversion of cyclic AMP to 5-AMP. So reduces the production of pro-inflammatory cytokines and increases the anti-inflammatory cytokines. It is available as 0.15% and 0.05% cream, used once daily, which is a very big advantage. It used in mild to moderate disease. 0.05% is approved for 2 to 5 years and 0.15% is approved for 6 years and above. It can cause mild discomfort, but lesser than crisaborole. It can cause nasopharyngitis, but there is a very rapid control of itch and it's non-greasy. It can be applied on any site and for any extent of body surface area. Tefomilast, it's the new selective PDE4B inhibitor, which also has the capacity to regulate filaggrin and loricrin expression. It is available as 1% ointment, which is used twice daily for the treatment of mild to moderate disease from 2 years of age. It can worsen atopic dermatitis along with secondary staphylococcal infections. It can cause nasopharyngitis, but the local discomfort is mild. Doxepin 5% cream is approved for short-term management of moderate pruritus in adult patients with atopic dermatitis. So coming to the JAK inhibitors in atopic dermatitis, the oral JAK inhibitors are baricitinib, upadacitinib, and abrocitinib. The topicals are deglocitinib and ruxolitinib. The off-label use is with tofacitinib. So ruxolitinib is a JAK 1 and 2 inhibitor, which is a 1.5% cream used twice daily, approved for mild to moderate disease from 2 years of age. But the application is restricted to less than 20% of the body surface area and to less than 60 grams per week. In case of delgocitinib, it's a pan-JAK inhibitor available in 2 concentrations, 0.25% and 0.5% ointment, which should be used twice daily. It's approved in Japan from 6 months, not FDA approved till now. It can cause nasopharyngitis, eczema, herpeticum, impetigo, folliculitis, rarely Kaposi varicilliform eruptions. So it should be restricted to 5 grams per application. And tofacitinib, which is a JAK 1/3 inhibitor, available as 2% ointment used twice daily. It is approved by Drug Control General of India for the mild to moderate disease. It can be used for difficult to treat areas. It has antipruritic effect, which is very rapid, and it's well tolerated. Coming to the systemic medications. So apart from the JAK inhibitors, we have multiple biologics. Dupilumab acting on interleukin-4 receptor alpha, tralokinumab and lebrikizumab acting on interleukin-13, nemolizumab acting on interleukin-31, and amlitelimab acting on OX40 ligand, telezolimab and rocatinlimab acting on OX40. So upadacitinib is a selective JAK1 inhibitor, which is available in 15 milligrams and 30 milligrams, usually started with the lower dose and then escalated if needed. Abrocitinib is also a JAK1 inhibitor, available as 100 mg and 200 mg tablet. Both are used once daily, approved for moderate to severe disease from the age group of 12 years. Baricitinib is a JAK 1/2 inhibitor, available in 2 milligram and 4 milligram concentration. It is approved by European Union and Japan for 2 years and above. So the problem with the JAK inhibitors are infections, particularly nasopharyngitis, urine tract infections, and reactivation of tuberculosis, and then headache, GI intolerance, acne, which is called JACNE, worsening of atopic dermatitis, cytopenias, dyslipidemias, and laboratory value alterations like raised CPK and liver enzymes. And they have the potential risk of cardiovascular death, malignancy, and thrombosis, which is very well documented with the rheumatoid arthritis patients. And abrocitinib has the potential to trigger inflammatory bowel disease and pancreatitis. Oral tofacitinib is used as an off-label drug, which because of its low cost and wide availability for adults with refractory AD. So nausea is more frequently noted with abrocitinib. Dyslipidemia, upper respiratory tract infection, and headache are more commonly encountered with baricitinib. Acne is more common with upadacitinib, which responds to the standard therapy of acne. So to decide on biologics versus JAK inhibitors, so if the patient has the other atopic comorbidities like asthma, chronic rhinosinusitis, nasal polyps, and others, dupilumab goes on the first one. If the patient has prurigo nodularis, nemolizumab takes the first place. And for patients with the rheumatoid manifestations, baricitinib and upadacitinib are on the higher side. Active malignancy, and for patients who have a risk of malignancy, Janus kinase inhibitors are not the drug of choice. Biologics are comparatively safer. So those patients who have serious infections or at a potential for risk of serious infections like herpes zoster or react untreated tuberculosis, for all these biologics are much safer than Janus kinase inhibitors. As well as for those patients with history of atherosclerotic heart disease or gastrointestinal perforations, biologics are comparatively safer. Similarly, for kidney failure and especially for liver cirrhosis, JAK inhibitors are contraindicated, and dupilumab has the side effect of ocular surface disease. So, in active pregnancy, anything is better to avoid all these, but the effect of biologics is uncertain. JAKs are definitely contraindicated. For elderly patients, better to go to biologics than JAK inhibitors because of the risk of cardiovascular death. The Janus kinase inhibitors have a broad inhibition of cytokine signaling pathways. So they have faster onset of action, so they can be used for management of the acute flares and intermittent treatment, but they require a tedious laboratory monitoring. For both, pre-medication evaluation is important, but more laboratory monitoring is important with Janus kinase inhibitors. Biologics, for those patients who have fear of needles, Janus kinase inhibitors can be preferred. So to switch between biologics, if we are switching between two biologics, since they have longer T-half, it's better to introduce the new one at the next scheduled dose. If we are switching between JAK inhibitors, since they have shorter T-half, immediate switching can be done. From biologics to JAK inhibitors can be started on the day of next dose of biologic because biologics have a longer T-half. From JAK inhibitors to biologics, they can be started after the last dose of JAK inhibitor. So coming to the newer drugs under trial and investigations. So topicals, Esivatrip 1% cream is available, is under trial. It is a TRPV1 antagonist, which is a cation channel antagonist. It reduces the pruritus as well as increases the expression of epithelial barrier components. And the newer JAK inhibitors which are available are ivamasitinib, brepocitinib, jaxitinib, ifidamcitinib, sedulatinib, and lebzatinib. Recently, live colonies of Roseomonas mucosa are also tried, which regulate the Staphylococcus aureus overgrowth. The oral medications under investigations are, coming to the JAK inhibitors, ivermecitinib, which is a JAK1 inhibitor, jactinib is a pan-JAK inhibitor, deucravacitinib is a tyrosine kinase 2 inhibitor, gusacitinib is a JAK and spleen tyrosine kinase inhibitor. Then the next group of drugs are NK1 receptor antagonist. They are serlopitant and tradipitant. Basically, the NK1 receptors are expressed in nerve fibers as well as mast cells, so they act on pruritic pathway, getting a rapid control of itch. The DPT2 receptor antagonists are prostaglandin D2 receptor antagonists, which are fevipiprant and timapiprant. Histamine 4 receptor antagonist is adriforant, which also has antipruritic effect. P2X3 blocker is camlipixant. P2X3 is a purinoreceptor, so blocking it reduces the itch. Peripheral kappa receptor agonist is difelikefalin, and sphingosine 1-phosphate receptor modulator is etrasimod. Basically, it reduces the migration of peripheral T lymphocytes into the skin from the lymph nodes. So coming to the injectables, the drugs targeting OX40 receptors are rocatinlimab and telazorlimab. OX40 is a receptor expressed in the T cells, which is important for the activation of T cells. and the ligand is OX40 ligand, which is expressed in the antigen-presenting cells. So the blocker is amlitelimab, and vixarelimab acts on the OSMR beta. Cendakimab and zumilokibart act on interleukin 13. Respegaldeslukin is an interleukin 2 receptor agonist, which has a stimulatory effect on the T regulatory cells, which then modulate the dysregulated immunity, which is seen in atopic dermatitis. Iblasakimab acts on interleukin 13 receptor. Stapokibart acts on interleukin 4 receptor. Ligelizumab is an anti-IgE antibody similar to omalizumab, but it's not that effective. Pitrakinra is interleukin 4 variant. So some of the failed drugs are tezepelumab, itokimab, benralizumab, because they have no statistically significant effects compared to placebo. So for mild disease, we can use low to medium potency topical corticosteroids for initial 1 to 10 days and continue for 3 to 7 days beyond the skin clearance. We can alternate with topical calcineurin inhibitors, PDE4 inhibitors, JAK inhibitors, and tapinarof also. For mild to moderate disease, we can add we can switch over to medium to high potency topical corticosteroids. For moderate to severe disease, biologics like dupilumab, tralokinumab, lebrikizumab, and nemolizumab can be added, or oral JAK inhibitors where biologics are contraindicated like upadacitinib, abrocitinib, and baricitinib, and the conventional systemic immunosuppressants, phototherapy, and wet trap therapy. Thank you.
From the audience? Thank you, ma'am.
Thank you, sir.
Thank you, ma'am, for such a nice session. Now I please request our chairpersons and our speakers to collect their memento. For next session, may I please request Dr. Deepti Behra and Dr. Nipen Kramakar to chair the next session.
Hello, good morning everyone. Welcome to the scientific session on biologics in special situation. I would like to invite Dr. Deepti Konda to deliver her speech on biologics in special situation.
Thank you, ma'am. A very good morning to all of you here. It's nice to see the audience leaving the beautiful Ooty and sitting here for the talks. Okay, so today I'll be speaking about biologicals in special situations. So this we've been seeing since morning multiple times, so we'll not go into the details of it, but I just want to briefly say what are the main drugs which are used biologicals. So we have TNF-alpha inhibitors, interleukin 12, 23 inhibitors, and interleukin 17 inhibitors. And the newer ones, which is already covered by Dr. Vijay Bhaskar, interleukin 23 and 36 inhibitors. So as we all know, psoriasis is a chronic immune-mediated disease with various biological targets. However, most of the time, psoriasis is associated with concomitant conditions and physiological conditions where it becomes difficult to choose a biological. So in this session of 15 minutes, I'll try to take you through what particular biological to be used in which particular condition. So these would be the special situations which I would be talking about. Now, tuberculosis is one of the rampant infection which is seen all over the India, and we are mostly concerned about tuberculosis when we are about to start a biological. The most important point to be kept in mind is this. TNF-alpha controls or inhibits the Mycobacterium leprae infection. So whenever we are using TNF-alpha inhibitors, it is bound to prevent that control, which further leads to the proliferation of Mycobacterium leprae. So TNF-alpha inhibitors carry a very significant higher risk of tuberculosis activation, and so are more or less contraindicated, or if at all we have to use, has to be used with a very high caution. interleukin 17 and 23 inhibitors are considered to be at a lower risk when compared to TNF inhibitors. So the rule of thumb is before starting biologicals, always there should be a mandatory screening of tuberculosis if there is a latent TB. Now, of late we have been seeing that whenever we do a routine IGRA test for patients, most of the patients test positive for IGRA. And there becomes the dilemma whether to go for a biological or to withhold it or not. So recent guidelines says that whenever is IGRA positive and you're not able to catch the active focus of infection or the patient has a latent focus, it's always better to start your ATT prophylaxis, start for 1 month, then add on your biological and continue the treatment. However, if active TB is documented, please complete the treatment of ATT and only then go for the biologicals. Now, next most common condition associated with biologicals is inflammatory bowel disorder. Now, there is a strong genetic as well as pathological link between both psoriasis and inflammatory bowel disorders. Now, in contrast to TB, what we have discussed, TNF-alpha inhibitors are known to be the treatment of choice for psoriasis and active IBD. So, TNF-alpha inhibitors become the choice of drug in case of IBD. Interleukin 17 inhibitors, because interleukin 17 is one of the main molecule which is known to control the inflammatory bowel disorder. So, IL-17 inhibitors are absolutely contraindicated in active IBD because they are known to either trigger or exacerbate the conditions of IBD. So, this we can see the interleukin inhibitor secukinumab should not be used in inflammatory bowel disorder if it is associated with psoriasis. Now, just a small mixing psoriasis and Ooty. Which biological would you pick up as your Ooty Express for rapid clearance? Would it be TNF inhibitors, interleukin 17 or interleukin 23 inhibitors? Yeah, it's 17 inhibitors. So if you want a rapid clearance, it's always 17. So we'll have two such questions Ooty related, but before that again let's go back to our regulatory topic. So liver disorder, now we see our routine drugs, methotrexate, where we be to be very careful in liver disorders. In contrast, biologicals are considered to be safe even if a patient is known to have any liver disorder. Now we know this non-alcoholic fatty liver disorder is highly prevalent in psoriasis disorders. However, biologicals do not lack or they do not cause any direct hepatotoxicity. So the baseline LFTs, viral hepatitis serology and regular monitoring is sufficient when you start a biological, and there is no contraindication in liver disorders. Now, one more important, almost like tuberculosis, is hepatitis B infection. Now, similar to TB, hepatitis B activation is also a very major concern. And similar to the same, TNF-alpha is again known to control the hepatitis B proliferation. So, TNF-alpha inhibitors again have a higher reported risk because it plays an important role in HPV replication. Interleukin 17 and 23 on the contrast, they are known to have a better antiviral prophylaxis activity, and so they are the preferred drugs in case of hepatitis B. So this I want you to remember. So if a patient is hepatitis HPSAG positive, it's a high risk. So mandatory prophylaxis with the antivirals is compulsory. However, if the patient is HPSAG negative and still the HPSC positive antibody, it's a moderate to low risk. So monitoring HBV, DNA and liver function test is sufficient while you start the biologicals. Hepatitis C, exactly remember it's opposite to hepatitis B. Hepatitis C virus does not integrate with the host genome. So the reactivation is very, very rare. So TNF-alpha inhibitors are considered to be safer, or sometimes it has been seen that it is very beneficial when you give in hepatitis C because TNF-alpha is somehow involved in even the HCV-related liver damage. Now this drug most of us have must heard when we were studying. Interferon was considered to be one of the drugs of choice for hepatitis C. But it has been seen that interferon worsens the psoriasis patient. So if a patient has hepatitis C and psoriasis, TNF-alpha inhibitors become the choice because they are known to improve both psoriasis and HCV. Now one more small change, what they prefer usually are these direct-acting antivirals in contrast to the interferons. So hepatitis C virus patient, biologicals are safe. Chronic kidney disease, A cyclosporin, a big no-no. Methotrexate, we use with caution. So again, biologicals, they become a preferred drug. In contrast to our routine drugs, most of the biologicals are not cleared by the kidneys. So dose adjustment in chronic kidney disease is typically not required. Generally safe for use. However, again, dialysis is a tricky situation where we don't have limited data of the biologicals. But most of the doctors even now use, even if the patient is on dialysis, they consider using biologicals but with a little more caution. Okay, this also has been repeated so far from the morning, but just a quick. Which pathway is like preventing the fog formation in Ooty rather than clearing it later? Which will prevent it. That means what Dr. Vijay Bhaskar has been mentioning it again and again and again, which is the primary thing which we need to hit it hard so that we prevent the next. So there's no fog formation, that is interleukin 23 is the first molecule. So you hit it, there is no inflammation and you don't have to worry about the later 12 or 23. Okay, next common condition which we face, psoriasis and pregnancy. Now we have very few drugs, especially because the mother and the baby become at risk. So pregnancy, we know that psoriasis can improve in 55% of the cases, it can worsen in 23, and the remaining percentage of cases, it remains more or less same. The main problem is the active maternal inflammation which is seen in the mother is known to affect not just the mother and even the baby with side effects or with effects like preterm birth, low birth weight. Now this is the drug. So in a pregnancy, if available, certolizumab is the drug of choice because it does not cause the placenta either in first, second or third trimester, so it's absolutely safe. It is now available in India as Cimzia. So if a pregnant lady with psoriasis wants a drug, please go for certolizumab. However, TNF-alpha inhibitors also have been widely studied and they've been considered very safe. Only exception, remember, it must be used very carefully in the third trimester because TNF-alpha inhibitors are known to cross the placenta in third trimester. So if pregnancy whole you want to use certolizumab, first and second trimesters, TNF-alpha inhibitors. Interleukin 12, 23 and 17 inhibitors, there is very, very limited data, so better not to risk them with these inhibitors. However, at the end, this, as all the conditions, treatment always should be continued only if the benefits outweigh the risk. So here we can see interleukin 23 active passing of the placenta throughout all the trimesters. TNF-alpha inhibitors safe in first and second trimesters. So in the third trimester, even TNF-alpha inhibitors also become a sort of box warning. Next category, children. Children are not just small adults. They have a different psychological, emotional, safety profile is totally different when compared to the adults. But one good thing what is all the biologicals which we've been talking are approved in children. The only thing what we need to be very sure is about the dosage of those drugs. So as you can see, TNF-alpha inhibitors, interleukin 12, 23, 17, all of them are approved. Only thing is it's around 4 to 6 years. Few prefer to start at the age of 4, few prefer at the age of 6. So whenever a child needs a biological, we need not hesitate. In fact, those are the preferred drugs and can be safely given. So these ages plus or minus depending on the patient's condition. The short-term safety is reassuring. However, because these are kids, they are in the growing age, the long-term data on growth, development and malignancy is still being collected. But again, an important point, in spite of screening hepatitis B and TB, the children should be properly immunized and completely up to date. Cardiovascular, not really bothered about when biologicals come into place. Psoriasis itself is an independent risk factor for cardiovascular events. So it is seen that controlling psoriasis inflammation also controls the cardiovascular events in the long term. Okay, to just summarize everything, if biologicals were our Ooty experiences, TNF-alpha inhibitors would be a classic toy trains, interleukin 17 would be the fast cab ride, and interleukin 23 inhibitors would be a very luxurious stay with a very long-term comfort. Agree or disagree with all this, right? So if you want to hit it hard quickly, interleukin 17. If you want it to be slow, but you want a long term and with the comfort, interleukin 23. And the TNF-alpha inhibitors are old friends. They're just like a classic toy train. Slowly they move, but yes, we do have a benefit with them. So this is just a gist. If even this you don't want to remember, this slide has to be remembered. So the take-home messages are: tuberculosis, avoid TNF-alpha inhibitors. Hepatitis B positive, avoid TNF-alpha inhibitors. Inflammatory bowel disorders, avoid interleukin-17 inhibitors. Pregnancy, use certolizumab all the trimesters or TNF-alpha inhibitors in the first 2 trimesters. Pediatric age group, all the drugs can be used, but with the age-specific guidelines. Liver, renal, cardiac, hepatitis C. In a way, they are our friends, so they can be used, but with again, same cautious rules. Yeah, thank you so much for your patience.
Thank you, Dr. Kunda, for your very interesting, difficult information presentation. Any question from the audience, please? Okay.
Yeah.
Sir.
How do we change? Like, can you start with interleukin 17, control it, and then go to 23? Is that a good idea?
It again depends on the patient basis. So suppose if the patient is ready for 23 from first, better. But as you said, if interleukin 17 we have started and you want to maintain, definitely we can shift from 17 to 23.
Any question from?
Just one point to be added here is like
Sure.
apart from switching for the sake of efficacy, probably people are willing to shift for the sake of cost also, because number of dosages
Right.
per year as well as the overall cost has come down with even IL-23 compared to IL-17.
Right.
That works out costlier. So I have actually done that in some of my patients.
Okay.
Thank you.
Even starting also when we but the problem is when you start discussing the cost, no sir, because they don't want all this 12, 23 business. Because sometimes practically cost becomes their main concern. So if you say efficacy is more or less same, then obviously they'll start choosing the lesser cost efficient one.
How is this duration determined? Like secukinumab we give at this interval. This one 23 we give at this interval.
Right.
What makes them decide that this is the interval? Because there are some people who say that they have taken 1 dose of secukinumab and they are all right for the past 6 months.
Right.
So how do they come with this dosage schedule? Because sometimes it is a disadvantage to us and makes the treatment very expensive.
Right. Same thing, so like for example, we have one patient who is on secukinumab, very, very bad psoriatic erythroderma. He's been having it. Just 1 dose of secukinumab and it's all gone. Around 80% is gone. So the patient says, when it's gone, why do I have to take a second dose of drug? But the thing is, after again, maybe, yeah, you were trying to say something. It comes back. So usually what we do is we follow that schedule of 4 plus initially the aggressive course and then maintain it again, the maintenance doses. Maintenance doses, I think it's totally doctor dependent. If you give it for once in 2 months, if you give it for 6, and I've even known people who are giving it for once for every 4 months also.
Even the patient learns when they are about to get the recurrence and they themselves adjust that on demand. Actually in panel discussion, I think one such case is there. My own case, which I think I'll point out.
Yeah, sure. Okay, thank you.
Thank you, ma'am, for such
Okay,
a wonderful
we
session.
should close the session. Thank you.
Thank you, sir and ma'am, for such a wonderful session. Now, please may request our chairperson and speakers to collect their memento. Next is a case-based discussion on psoriasis. Now, please may call Dr. Sudhavani, Dr. Kinnoor Das, Dr. Naeem Sadat Hanif, Dr. Pranab Kumar Saha, and Dr. Rohan Barua for the next session.
I think one more chair is required there.
Good morning, everyone. So, welcome to the panel discussion on psoriasis. So, first, I would like to thank Dr. P.K. Roy sir and Team Clinicon for conducting this wonderful conference in Ooty. So, coming to the psoriasis, we all know that psoriasis is now not only not just a skin disease, it is a systemic, chronic systemic immune-mediated disease with many, with a impact on patients' social, psychological and metabolic health. So we, in our day-to-day practice, we are not just dealing with the plaques, we are dealing with the comorbidities like hypertension, metabolic syndrome, obesity, etc. So now why the psoriasis management is challenging, this is not because of lack of therapies, but choosing a right therapy for the right patient at the right time. So this makes a patient and for us also very easy, but this is very important also. So now with the advent of biologics, now we are not just aiming for clearance, 100% clearance, and we are aiming for 100% clearance, not just clearance of the skin lesions. So now we have eminent panelists with us. So we will discuss day-to-day challenges or real-world challenges in psoriasis and how to clear those doubts and all. So if you have any doubts also, you can ask our panelists. So this is being a case-based discussion, case-based panel. First, I will start with the case. This case is sent me by Dr. Kinnar Das. So this is a patient with psoriasis and tinea, which we often see in our clinical practice. So the question is psoriasis, anyway we will see combination of this, but psoriasis and tinea can be seen in the same lesion. Dr. Kinnar Das.
Psoriasis and tinea I've never seen in the same lesion, but in the same patients at the different sites I have seen. Even tinea capitis along with psoriasis also I have seen.
Yeah,
but
different locations.
Yeah, different locations we
we
come
are
across, and maybe it's more frequent nowadays.
Dr. Naeem Sadat, what is your opinion? Have you seen both in a same?
Sometimes I've seen, madam. In some cases, they occur in same place also, maybe carbonization. It is also seen in other diseases like pemphigus also. Carbonization is seen of tinea. Nowadays, we see all scenarios in tinea. Everything is possible.
Right. So most of the times we see combination of tinea and psoriasis in a single lesion. So then how to approach this case? Dr. Pranab? So when both coexist.
We first diagnosed whether it is tinea or psoriatic lesion. After diagnosis, I prefer to treat the tinea first, then I will go for treatment of psoriasis. I usually stop application of topical corticosteroid in the psoriatic lesion, and I switch over to other thing, vitamin D3 analog, etc.
Okay. Sir, C.R. Srinivasan, sir. So do you come across cases like this, psoriasis and tinea, and how do you manage that?
Madam, may I add one point here? In a new patient, yes, it is easy to choose whether to treat tinea or so on. But in a patient who is already on some hepatotoxic drugs like methotrexate, giving drugs like itraconazole becomes an issue. So
That's
this is something.
sir. What if antifungals
Yes,
worsen the lesion? Tell me, sir.
I think basically at that time we have to stop the drug for psoriasis. Methotrexate stopping doesn't matter because even after you stop, it is continuing to act. But other cyclosporin or other drugs, you can stop, treat the fungus, and then go.
So actually, I would like to share a case of mine. That patient was actually presenting with extensive chronic plaque psoriasis, and superimposed over it was actually tinea lesions. So she was on capsule cyclosporin for a long period of time, and she was absolutely responding well to it. But after 2 or 3 months, suddenly there was an exacerbation of the lesions, which she was complaining. And previously, the lesions were absolutely not itchy, like she was complaining after the next visit. So on careful examination by me, particularly not only the exposed parts, but also the unexposed parts, I found that it was not only the psoriatic lesions, but along with the psoriatic lesions, it was more of the tinea lesions which were superimposed. So I actually discontinued cyclosporin in that patient for around 2 to 4 weeks. I was only giving her on capsule itraconazole, 100 milligram BD for 4 weeks, along with emollients. I did not give anything else for psoriasis. And then when she came after 4 weeks visit rather, so she was absolutely free of the pruritus. Her lesions, the erythema, which was actually due to the superimposed tinea, that also subsided. And then when she actually got cured of tinea, then I gradually started introducing cyclosporin in the patient. So that was a very tricky case for me because she was initially responding, suddenly she developed superimposed tinea over it.
Whenever psoriasis and tinea is present, first we should look for a mixed morphology. Active borders and asymmetry is the one. And history is very important, whether they have used any steroid creams or not. And KOH mount. From
Can I ask
active
a
edge.
question? And during that period, what about the psoriasis? Because you suddenly stopped the cyclosporin.
Yes, ma'am. When I suddenly stopped the cyclosporin, there was not very much aggravation of the psoriasis lesions because the problem was that when she presented to me with rapid onset of itching and all, it was actually because of the flare of the tinea lesions which she had. So when I stopped the cyclosporin and when she returned back after 4 weeks rather, there was no psoriasis lesions flared up. Yes, there was psoriasis lesions, but because the tinea lesions resolved, I found that the patient was symptomatically much better. And then gradually I started introducing cyclosporin in that patient.
Yes.
Okay.
So first, whenever both are there, treat the tinea first and then psoriasis. So that is the important thing. And this is one, sir. Likely to consider. Right, sir. Thank you, sir. So this is a 42-year-old male patient with itchy lesions over the palms and soles, and we can see disfigurement of the nails and even involvement of genitalia. So what is the first line treatment would you like to start in this case, starting from Dr. Pranab? So here,
I will start topical corticosteroid with or without salicylic acid under occlusion. And then along with that, I will go for, if contraindication is not there, then acitretin I will start.
Dr. Naeem?
For palmoplantar lesions, as Dr. Pranab mentioned, acitretin is a good option, apremilast is also a good option, but over the genital lesions, use of corticosteroids has to be mild corticosteroid or at the most a mid-potent for a very short duration. Things like tacrolimus probably better, but they have a problem of irritation. Nowadays we are looking forward to tapinarof in such areas, which will be a good molecule. It's a topical application, which will be very suitable for areas like this without the irritation component of the TCIs as well as without the heterogenic component of the topical corticosteroids.
Dr. Kidarvas.
So if this is a 40-year-old male, so if he comes first to me, I will give him the topicals and I will send him for investigations and I will give him a starter pack of apremilast. Okay, so just to see whether they are tolerating it or not. So in the meantime, that I usually do in the 7 days time. So when the investigations come, then we are very much clear which systemic drugs to start. And because I've seen many a times whenever apremilast works, it works very nicely. So we can start with that. Then gradually means we can monitor accordingly.
Yeah. Dr. Rohan, only one word answer.
Just I want to add one thing is that because along with palmoplantar component, he is also having nail involvement as well.
Yes.
So once with the start of the medications which we are giving, we should also follow up the patient to see whether the nail involvement is also improving or not. Because that is also a matter of concern. So accordingly, we can target the nail component. Sometimes not only the systemic drugs, topical or intramatricial injections also help, particularly for nails. So in that cases, we can follow up the patient for the nail involvement.
Nail involvement. So one drug which can treat all the indications.
Madam, in such scenarios, because the palms for a person involved in occupationally it is important for the palms to be clear, as
yes.
well as an impact area, high impact area like genital involvement. If the patient is affordable, my first choice will be biologicals. IL-23 has shown great results in such patients. Even the tildrakizumab, which has recently come, Ilumya, is showing excellent results in such patients. Wherever possibility is there, feasibility is there, we can go for it.
Yes. So even nail involvement and genitalia, even though they're localized lesions, we need to treat them with systemic drugs, with the systemic drugs. So this is after the treatment. We started, this came to our government medical college. We have given a short course of cyclosporin and then we put him on methotrexate. So methotrexate is the one which has given these results because biologicals in government setup is very difficult to start up. So now we discussed about genital lesions and nail lesions. So beyond the rule of 10, who truly needs a systemic treatment? So we are not going that this is PASI score is this much, we need to start, our PASI score is less than 10, we should not start this. But there are special areas where we have to start systemic treatment immediately. So anyone, any panelist can take up this.
So as I was mentioning, involvement of genital areas, scalp, palmoplantar.
Palmoplantar.
Occupationally also palms are very important area. So that way.
This is
even if the percentage is less than 10, the DLQI will be high. We don't do DLQI very common in our practice, but that is something which is to be considered in our decision making.
So even the rule of 10 classifies psoriasis severity index based on BSA, PASI score and dermatology life quality index. Even though it is less than 10, there are special areas where we can start when there is topical or phototherapy failure is there, then also we can start. And psoriatic arthritis and severe variants like pustular erythrodermic psoriasis, comorbidities are there along with small involvement of skin and genital and nail involvement. Like this we can start systemic. So this is a case of Dr. Rohan. So you just briefly tell about this case, brief history.
So this is basically a patient of Down syndrome. So he actually presented to me at around 18 years of age, but his history of psoriasis has started right from 10 years of age. So as we can very evidently see from the pictures, first and foremost, he is an obese male, so which is one of the most important risk factors. So because he was already diagnosed with psoriasis previously, he was on and off on methotrexate from outside. When he presented to us, he was off all the drugs. He had severe exacerbation of psoriasis. So thinking of the economical background and being practicing in a government hospital, we first started him on methotrexate, initially starting with a low dose, test dose, and gradually we increased the dose. So he was all right initially with all the investigations coming out to be normal. When the dose was increased up to 15 milligram per week, then actually he presented with the abnormalities in the liver enzymes, particularly the transaminase levels. Initially, it only shoot up to 2 times when we still continued with the methotrexate. But on further continuing for 2 weeks, when a repeat LFT was done, it actually shooted up to almost more than 200, both SGPT and SGOT. So immediately we had to discontinue methotrexate in this patient. Not only that, we also did a fibro scan or transient elastography in this patient to look for any methotrexate-induced liver fibrosis or not. So that came out to be negative. Other than that, we actually planned to start cyclosporin in this patient. So initially we gave cyclosporin. He was responding very well to cyclosporin, but because of his financial background, he stopped cyclosporin immediately. And just when he stopped cyclosporin, again the disease flared up. And the last option which was left to us was with biologics. So initially we started him on secukinumab, that is interleukin-17 inhibitor. It is available free of cost in our government hospital. So we admitted him. After doing a proper panel workup of all the investigations which we found to be safe in his case, we started him on secukinumab, and presently he has received first dose and he is being admitted for the second dose. I've shared some pictures of first dose after receiving secukinumab as well. So basically his history was this, and we have actually gone through these modalities of treatment, and presently he's on biologic secukinumab.
Cyclosporin you could not give. Finally, you started
exactly,
biologicals.
We had no other options
patient.
left for
yes.
me actually.
So severe. This is a case of. This is a very interesting case where here the patient is having comorbidities like obesity and also Down syndrome. So severe psoriasis PASI score is high. So methotrexate failure and toxicity is there. Cyclosporin gave rapid control, but the compliance limited by the compliance and cost. So secukinumab is given. So here the important thing is a difficult host. When the disease is severe, better we choose biologicals. So why secukinumab, is there any thing, why you have chosen secukinumab in this patient? Because it is available in the government hospital freely.
Actually, ma'am, there are two types of biologics which are presently available. One is the TNF alpha inhibitors like infliximab, adalimumab in our hospital. And the second one is the interleukin 70.
Interleukin 70.
So because he was suffering from such a long time and we wanted a rapid clearance of the lesions, so, and he did not have, most importantly, did not have any evidence of psoriatic arthropathy though. No nail involvement, no psoriatic arthropathy. So we chose actually interleukin 17 over TNF alpha for rapid clearance and because he did not have any features of psoriatic arthropathy also.
Anything, sir, you would like to? So now this is a girl aged 15 years with a chronic plaque psoriasis and then a generalized pustular psoriasis. This is a case of Dr. Naeem Sadat. So just tell me the brief history.
Yeah, in this patient, madam, she presented with multiple types of morphology. From time to time, she was developing chronic plaque and follicular type of psoriasis, and then generalized pustular psoriasis, as you can see in the image. And initially, we started off with cyclosporin, but in this patient, I would like to point out that it should be used only as a crisis buster. Though there was very good response with that, I was not inclined to give for longer time, but the patient ended up taking it for almost 1 year, not like affordable for the biologics. It was a couple of years ago, even before the ixekizumab or ustekinumab had come into the market. So secukinumab was the best option, so I was pressuring her to go for it. But initially I gave cyclosporin, then maintained with acitretin for some time, but considering her age, acitretin we can't give for really long time in a girl, unmarried girl, of course the childbearing potential later on, as well as the epiphyseal closure. Premature epiphyseal closure can happen with acitretin. That is something to keep in mind. So ultimately she agreed, after 1.5 years, she agreed for secukinumab. If you can show the next slide, she already had the clearance. So absolute PASI was actually 0 when I started secukinumab in this patient. My task was to maintain it at 0 or less than 3 after initiation at that time. I did not start when the patient had more severity. That was a very unique aspect in this patient.
So how long you have given secukinumab?
Now she's on secukinumab and continuing. And as I was mentioning to Srinivas sir some time back during our previous question, so this patient is taking secukinumab once in 6 weeks, sometimes 8-10 weeks also she comes, as late as even 3 months sometimes, because of the cost affordability factor. Even then she is maintaining. Just about end of 2.5 to 3 months she gets the new recurrence. When she starts finding mild recurrence, then she comes to me. But as sir was mentioning, there is a risk of development of anti-drug antibodies if that happens, if that prolongation happens beyond the recommended dosage schedule. Ideally, it should be once in 4 weeks maintenance.
Once in 4 weeks. Because, and being a 14-year-old child, is there any special points or precautions we need to take before starting biologicals or any other systemic drugs?
Yes, madam. As Dr. Deepthi was mentioning in her talk, all these biologicals are approved from very early age onwards.
6 years and
4 years for the TNF alpha inhibitors and 6 years for the IL-17s and IL-12 and 23, ustekinumab also. So they are quite safe, madam. Actually, very, very safe.
Yes, biologicals we can start even in a child above 6 years.
Yeah, and all the standard precautions which we apply for other patients, they same apply here also.
So this is after, yeah. You can
Yeah,
see
this
the
was-
improvement.
She's
So
melting
almost
well.
cleared.
Yes, yes, ma'am.
Almost cleared,
Yes, ma'am.
the lesions. And this is another case. Again, Dr. Naeem, please enlighten about this case.
Yeah, in this patient was referred to me by Dr. Raghuram Rao sir from Vizag, and she had extensive pustular psoriasis, and she had taken secukinumab for 6 months, and then she was finding difficult to continue with it because of, again, affordability issue. She was a little junior IT employee, but her entire salary was going into that. So she was not prepared to continue with that, and I gave initially cyclosporin again to control the disease. Then she agreed for ustekinumab, which had just come into market. And with that also she is maintaining very well. In ustekinumab, 2 things I would like to point out is, when we start with this drug, some people can get a paradoxical flare of pustular psoriasis. Even in a chronic plaque psoriasis, even paradoxical pustular psoriasis can occur in ustekinumab. It did happen to this patient actually. And there was aggravation, again controlled with cyclosporin, continued with ustekinumab, with which she came under control. Yeah.
So here the before and after 2.5 months, we can see a great
Complete
improvement
clearance.
in this patient. So you have experience with secukinumab and ustekinumab. So what are the basic differences between these two biologicals?
Yeah. As Dr. Vijayabhaskar Malela and Dr. Deepthi were mentioning, these IL-17s are very fast in action. Secukinumab is very fast in action. Ustekinumab little slow. Sometimes we have to wait till the second booster dose for the action to start. That is one difference. Affordability-wise, actually ustekinumab scores better. Number of doses per year-wise, again ustekinumab scores better. And in some patients, I have seen excellent results both in chronic plaque as well as in pustular psoriasis.
So faster induction IL-17
17,
and maintenance for longer duration IL-23.
I think ustekinumab is the cheapest biosimilar we have in the market compared to any other drug.
And cost effective.
Yeah.
So then we are dealing not only with the psoriasis, and there are many comorbidities are there in the, along with the psoriasis. So we have to check for the diabetes, hypertension, dyslipidemia and depression. So are we doing this in our day-to-day practice? Dr. Pranab. So are we checking all these whenever any patient comes?
Yes, always we consider this thing. We screen for diabetes, hypertension, dyslipidemia, and this psychiatric problem.
Yes. So even obesity, even 5% reduction in the obesity improves treatment efficacy very well. So we are not just treating the skin, we are modifying the systemic inflammation. So I think already all these are discussed by Dr. Vijayabhaskar and Deepthi Konda, but still just, so psoriasis and comorbidities are there. Who gets which systemic drug? So this is like psoriatic arthritis is there, IL-17 inhibitors gives better results. When metabolic syndrome is there, infliximab, ustekinumab, and we can give these drugs. Cardiovascular diseases, TNF-alpha inhibitors and secukinumab, and any IBD is there, the TNF-alpha inhibitors are IL-12 or 23. Malignancy, IL-12/23 we can give, that is ustekinumab, and methotrexate and TNF-alpha. So avoid cyclosporin in metabolic syndrome and avoid IL-17 in IBD. And TNF is safest in the pregnancy, and IL-23 is preferred with malignancy history. So there are some diagnostic
I would just like to add one thing here. Whenever we are seeing a patient of metabolic syndrome and psoriasis, particularly if a patient also has hypertension also, we should also give attention to the fact that which antihypertensive he is taking. Because certain antihypertensive drugs, particularly beta blockers and AC inhibitors, they can aggravate psoriasis. So that is also very important to take a proper drug history of the patient. So if he or she is taking, we should try and refer it to a cardiologist or general medicine to change it alternately. And
One more point, madam, and TNF-alpha inhibitors, we should be careful in CHF, congestive heart failure. So that can be a contraindication.
TNF-alpha, right. So there are some diagnostic gray zones. So when biopsy is needed, is needed in classic psoriasis or dermoscopy versus biopsy? What is your opinion?
So being dermoscopy being a very handheld device, it's an OPD basis device, we usually also don't do dermoscopy very often. Particularly whenever we have some very close differentials for psoriasis, particularly if a patient comes with a lichenoid type of dermatitis or a pityriasis rosea type of feature, then to differentiate it, we actually do a dermoscopy. But the most consistent feature which I have found on putting a scope on a psoriatic lesion is the regular arrangement of dotted vessels. That is very, very true, and on an erythematous background, which we usually get with a fine scaling, which we usually get.
Right.
But truly speaking, biopsy for a confluent case of psoriasis, we usually do not go.
Usually classical case we don't do biopsy when there is any atypical morphology is there, and in case of treatment resistant case not responding to treatment or any suspected CTCL, then we do biopsy. Dermoscopy also helps for regular dotted vessels, as Dr. Rohan said, white scales, but cannot replace biopsy in doubtful cases, but biopsy is always gold standard. And this is a case of a 26-year-old male. He has multiple, sir. Mike, sir.
I agree with you, correct. For biologics especially.
One more mic. Sir, one more mic. Hello. Another mic, take another one.
Sometimes what happens, you see the patient after 10 years, you will find there is no evidence of psoriasis. It is fully atopic dermatitis. So at that time, if you have a documented this thing of psoriasis, you feel more comfortable.
I agree with you, sir. And also there is an overlap of psoriasis and atopy in as high as, yeah, 1/5 of cases. One more thing is documentation is important also before starting biologics or such, like, systemic treatment. Always better to have a documented histopathology.
Better to confirm our diagnosis. Confirm means proof. It's a proof that it's a psoriasis. So this is a 27-year-old male patient. He has been suffering this with the past 3 to 4 years, and he has multiple lesions on the hands and legs and few lesions on the trunk, and he gives a history of oozing. So whether other doctors are treating this as a psoriasis. So whether we can put this in either psoriasis or in the eczema spectrum. So that is where always we face these type of clinical challenges in our day-to-day practice. So there is, whenever last time also one patient, when I did biopsy, it came psoriasiform epidermal hyperplasia is there along with true spongiosis. There is an intercellular edema. So then I searched, then there is a literature showed that psoriasiform spongiotic dermatitis, it represents a histologic overlap pattern rather than a discrete disease. Here, the coexistence of IL-17 driven keratinocyte proliferation and Th2 mediated epidermal edema explains simultaneous presence of acanthosis and spongiosis. So, few authors say that psoriasiform spongiotic dermatitis it's not a single disease but a reaction pattern or overlap phenotype. It represents a clinico-pathological gray zone between psoriasis and eczema. So how to deal these type of cases?
Madam, this is actually known as SEMA or even Sorzima. And the literature says up to 1/5 of such cases are there in the literature. So obviously we have to deal with both. And fortunately some of the JAKis that we are having are effective for both.
Both eczematous
like for
and
example,
psoriasis.
Yes, ma'am.
Right. So whenever histopathology gives us psoriasiform epidermal hyperplasia and true spongiosis, we can start off JAK inhibitors.
Even cyclosporin also works for both.
But cyclosporin cannot.
Just one comment. So what is very well known, what you said, after secukinumab, which is now becoming quite popular, paradoxical presentation of atopic dermatitis is well known. So
yes.
it is a imbalance that you are describing. So it drives the manifestation first time of atopic eczema. So this kind of overlap can be de novo from the beginning, or it can come when you give a biologic. So that is something you need to look out for. Also, never forget contact dermatitis. That is, something which we may be missing in many of the cases. And the third point is, I want to ask the panel, and we think we should discuss. None of these biologics is like a magic or an antidote for everything. There is a subset of people who do not respond at all. Like Siku, we've been doing for many years. So unlike what some of the previous speakers said, we need quite a few doses, and B, there's a subset that does not respond. Then the question is how long to continue, when to switch. I think this is a very important and would be very interesting to discuss.
Yes, I agree.
May I take this question, madam, regarding switching? Minimum switching period, observation period to call any biologic failure is 16 weeks, 4 months, 16 weeks, beyond which you have to switch. That is one thing. And just to add on to the point raised by Deepika madam, just like paradoxical aggravation of atopic dermatitis, there are some reports of paradoxical lichenoid dermatitis developing, lichenoid reaction developing after the biologic, especially ustekinumab and secukinumab. This is documented.
So one more question what madam raised is, suppose the patient stopped responding to biologicals. So what is the next option?
If one biologic fails, we can switch over to the other class. it is better to change the entire class rather than trying a different drug of the same class. Sometimes they do respond, but that is a very rarity, and it is always wise to go for the different class. Most often, I think from IL-17 to IL-23 is the switch because they are available now. Obviously, madam. Yeah. That's absolutely correct, madam. Yes, madam. Absolutely agreed.
Yeah, with regards to switching, you can take 4 half-lives into consideration. That's number one.
Yeah.
Yes, in
That is the
emergency.
washout period you are mentioning.
Yeah.
Now, one debatable point over here is there is probably no need of washout period. That is a new literature.
You're right,
which
yeah,
says-
that's what I'm
Yes,
coming to.
Yes.
And the other case presented by Dr. Barua, Down syndrome patients have more propensity towards developing IBDs. You have to be very careful in Down syndrome patients where they tend to have IBDs. About 5% more, 5% population have IBDs, concomitant IBDs. We have to be very careful while using IL-17s in Down's patients.
Yeah.
There are topics.
Just to clarify this point, as I mentioned, there is probably no need of washout period, the 4 or 5 half-life that we used to consider, no need. And also they are saying like no need of even loading dose also. You can just straight away go with maintenance dose as the next maintenance is due for the previous biologic.
So what is the minimum gap? 3 to 4 weeks or 6 weeks?
No need, ma'am.
As per the new schedule, like suppose if the
3
patient
weeks,
is on,
I feel.
suppose
Minimum.
patient is on ustekinumab, if the next maintenance dose is due after 3 months, you can switch over to IL-23 with the same 3 months period.
We've had combinations also. People have used combination of biologics also.
Yes,
So
yes.
it-
Dual biologics.
Yeah,
Dual
okay.
biologics.
Dual
Yeah, so
biologics.
it is not necessary to have a
Necessary
washout.
to
Yes, ma'am.
wash out period.
I just want to put 2 points. Number one, fecal calprotectin. If you are in diagnostic dilemma, just do fecal calprotectin to rule out IBD. The simple test, fecal calprotectin. Take history, ask for irritable bowel syndrome, ask for any symptoms of gastric irritation, do fecal calprotection, rule out IBD, start IL-17. That's number one. One of my patients who was put on dupilumab developed paradoxical psoriasis, TH2 to TH1. We put him on apremilast, patient respond very well.
That's what we discussed, I think.
So,
Dr. Naeem
regarding
told
the
you.
gray zone, I have a single question that many of the patients come with seborrheic dermatitis and psoriasis overlap. That's a
Yes.
very big gray
It's
zone.
yes.
So, what should be the management? And I feel regarding the previous question, dermoscopy helps there. So I have to
Dermoscopy
come
helps, yes.
the previous
Yeah.
question.
Even
So-
atopic dermatitis, psoriasis, seborrheic dermatitis,
Sebopsoriasis.
Sebopsoriasis has become very common.
Very common, especially, yes.
So that's a big gray zone now.
Gray zone, right. So severity assessment, we all know PASI and visible areas, even though it is low, we already discussed. So moderate, even on the face and genitals involved, we need to give systemic treatment. So coming to this steroid misuse, which we are all facing now. So the psoriasis patients, they use steroid for a longer period, 2 months, 3 months, and they came as with the barrier damage and rebound. So how to manage these kind of patients who have used steroids for a longer period?
After having experienced the better efficacy of steroid and salicylic acid, they refuse to go to steroid and calcipotriol. That is one of the observations.
So whether we should we should give a systemic treatment or only with the local or topical management. How do you manage?
One of the most important part is moisturizer, and that we have to tell that this is means not only for the treatment but also for the prevention.
So steroid flare management is very challenging in our day-to-day practice. So if we stop again, there will be an aggravation will be there. So how to manage that? Any panelist can take up
TCIs are one of the good
Yes,
options.
good
They actually
option.
give better maintenance
results
effect. And
later.
also, as I said earlier, apinorf is one molecule which we are looking forward, though it will be little expensive, but that is a wonderful molecule.
Yeah. So tacrolimus and all. So and this current scenario, what are the conventional drugs like methotrexate and what is their role in managing psoriasis? Dr. Naeem, can you just
Madam, can you
explain?
please repeat the question?
So now this is the era of biologicals.
Uh-huh.
So what is the role of conventional treatments like drugs
Madam,
like
as
methotrexate?
Deepika madam was saying, when the new kid is there on the block, we cannot forget the old ones. They still have their relevance. and that is the probably most often prescribed molecules. We cannot do away with the conventional systemic agents in Indian scenario at least.
Indian scenario especially, where
Yeah.
the cost is considered.
Apart from cost, even efficacy was also, madam was mentioning,
Yes.
the biologic non-responders, and there are many patients who will do with short course of methotrexate, then they will not require for long time.
Long
So in such patients, we don't have to worry about end organ toxicity.
Yes, still we feel
And sometimes
methotrexate
as
is
it-
a gold standard in the management of psoriasis. Pardon?
And sometimes even in biologic failures also, when we actually see a case of a secondary biologic failure also, when we switch the class also, sometimes we even add a low dose of methotrexate to that also to maintain the patient, like 7.5 milligram dose. So that also has got a role. So it's true that biologics are coming up as very advanced options of treatment in psoriasis, but we should not even forget the conventional treatments in the form of methotrexate, acitretin, cyclosporin, so that should also be considered. Particularly in maintenance doses is very useful.
Very important.
I think it's very good for the psoriatic spongiatic disease, which we mentioned earlier.
Right, then I'll close. So cyclosporin and all, I think we have discussed acitretin and avoid. Biologicals, I think we discussed well. So when to stop biologicals also we discussed. So steroid withdrawal flare we discussed. And elderly patient, you prefer methotrexate or apremilast, and we have to avoid cyclosporin as there is a renal risk. Female planning pregnancy, Dr. Deepti told. So either we can plan topicals and narrowband UVB, and when there is a biological, switch to other class IL-17 to IL-23, and we need to check the. So other special scenarios also I think we discussed. Then what is the future? Will biologics replace all? Last question. So one word answer from the panelists.
No, I don't think biologics will replace conventional therapy. Never.
So will
All of us agree on that.
Biologics doesn't replace, but there is a lot of research is going on. Even oral biologics are in the pipeline because it's because of cost barrier, and they need a long-term safety data also we need. And JOC inhibitors are emerging, but here also there are many safety concerns are there. So this is the end of the panel discussion, and psoriasis is no longer just a skin disease. It is a lifelong systemic condition requiring individualized, holistic and evolving management. And thank you all. Thank you for the wonderful inputs. I thank my panelists for their inputs, and C.R. Srinivasan sir and Vijay Bhaskar, Deepti, they presented very well. And thank you very much. Thank you.
Thank you all. Thank you, madam.
Thank you.
Thank you so much, ma'am, for the wonderful presentation, and thank you, panelists, for such active participation. I think everyone was very much into it. Without further ado, I would like to call upon the stage our next chairperson, Dr. Amit Verma, Dr. Brahmanand Gupta sir, and Dr. Avishri Gupta ma'am to kindly chair the next session and call our speaker. I would request our chairperson and panelists to kindly collect their mementos.
May I call the speaker?
Dr. Barnali Datta ma'am, I would like to request her to kindly present her talk on lupus skin as a window. Thank you, ma'am.
Dr. Barnali Datta, she is professor and head of the dermatology and venereology department, Guwahati Medical College. She was best graduate in 1994, reviewer of index journals Joint Secretary ISBD, and member of ISPD ICS. And her areas of interest are autoimmune connective tissue diseases and pediatric dermatology, granulomatous diseases. I would request Dr. Bornali Datta to present his talk.
Good morning, honorable chairpersons, distinguished delegates. I'll start with my presentation, which is lupus as a skin as a window. SLE, we all know, is a great imitator and mimicker. Approximately about 25% of patients present for the first time with cutaneous manifestations, and the features are not only diverse but often atypical, so early diagnosis and treatment can alter the prognosis. The first case is an 18-month-old child who was admitted in the pediatrics ward with history of skin lesions for past 4 months. When we examined the patient, the child had intensely erythematous papulosquamous lesions over the scalp and periorificial regions. There were non-indurated annular and polycyclic, slightly atrophic plaques with telangiectasia and scaling, vasculitic-like ulcers over the palms and soles. Child was very toxic and irritable, but there was no positive family history. Hemoglobin was low, urinary protein was trace, ANA was 3+, anti-dsDNA was negative, but anti-Smith was positive. C3, C4 were within normal limits, C1q was below the detection limit. A genetic testing was called for, and analysis showed the frameshift deletion of C1qa gene. Diagnosis was early onset SLE. Treatment was given to the child, but the child succumbed to severe RTI. So young patients, when they present with cutaneous lesions resembling SLE, early onset of autoimmunity, normal C3, C4 levels, elevated ANA, negative dsDNA, C1q deficiency should be always suspected, and complement screening should be done. This was a 17-year-old girl who was presenting with facial swelling, which was being diagnosed as angioedema without response, and she then developed weakness, dyspnea, and crusted plaques over her cheeks and nasolabial folds. There was photosensitivity, pain over the knees and ankles, and pedal edema. When she was screened, it was found that her 24-hour urinary protein was high, ESR and CRP was raised, chest X-ray showed pericardial effusion, renal biopsy showed class 5 lupus nephritis, ANA was positive, dsDNA, Smith, U1, RNP, ribosomal P were all positive. Diagnosis was acute LE presenting as facial edema. So facial edema and crusted plaques can be a precursor to life-threatening acute SLE, which has been reported in the JAD, and in a 20-year-old African American who presented with dyspnea and hemoptysis with a history of fever and facial edema and rash. There was extensive diffuse pulmonary infiltrates. There was no evidence of infection or heart failure, but patient was treated with pulse systemic steroids to save his life. Later on, laboratory tests confirmed a diagnosis of SLE. Angioedema itself can be a presenting feature in patients with SLE, as seen in this case, where a woman developed rapidly progressive swelling of the tongue and neck, followed by respiratory discomfort and generalized non-itchy rash. Tracheostomy had to be done to save her life. Later on, history examination and relevant findings indicated SLE. Acquired angioedema is associated with lymphoproliferative disorders, infections, neoplasms, and autoimmune diseases such as SLE. In type 1, there is catabolism of C1-INH due to lymphoproliferative disorders. In type 2, there is an autoantibody against C1-INH. And a third type, there is transiently low levels of C1-INH, hypocomplementemia, and the absence of antibodies against C1-INH. Patients with SLE have type 2 or type 3 acquired angioedema. Normally, 59 to about 85% of SLE patients have cutaneous manifestations. Less than 5% will develop vesicobullous lesions, which may manifest in the form of vesicles, bulla, erosions, and or crust. The reasons behind this can be either subepidermal bulla in SCLE and ACLE, following severe liquefaction degeneration of the basal layer and dermal edema, classically seen in TN like ACLE and Rowell syndrome. SLE associated with autoimmune bullous diseases, including pemphigus foliaceus, perineoplastic pemphigus, and a separate subset, bullous SLE, which is a distinct type of non-specific autoantibody-mediated cutaneous SLE. 18-year-old female patient, she presented with erythematous macules and patches over her face, V area of the neck and the upper extremities. There was hemorrhagic crusting over the lower lips, evolving over 7 to 10 days. History of fever on and off, arthralgia of the multiple joints, history of photosensitivity, oral ulcers, diffuse hair loss, but there was no history of any preceding infection or drug intake in the recent past. There was livedo reticularis and vasculitic lesions over the palms, anemia, leukopenia, proteinuria, pleural effusion, ascites, ANA positivity, dsDNA, strong positivity made us come to a diagnosis of SJS like acute cutaneous LE. This has been reported earlier also. This was a 75-year-old male who was initially presenting with disseminated TLA. Later, he developed ANA positivity. He was in remission with steroids and antimalarials. He went off treatment on his own for about a year. Following photo exposure, he developed erythema multiforme-like lesions followed by extensive peeling of the skin. There was diffuse erythema, sheet-like discomission. Patient was febrile and had to be put on high-dose steroids, following which he responded within a week, healing with post-inflammatory hypopigmentation. Diagnosis was TEN-like acute cutaneous LE. So TEN-like LE, the severe spectrum of LE-specific vesicobular disease has been classified by Ting et al. Into 3 forms of TEN-like LE. One which is TN-like ACLE, TN-like SCLE, and TN occurring in SLE patients not having conventional LE-specific skin lesions. TN-like refers just to the morphology of the lesions, but the similarities with SJS TN end here because the mucosal involvement is much less here. ASAP, or acute syndrome of apoptotic penepidermolysis, has been proposed by Ting et al. To encompass all life-threatening clinical situations of massive epidermal cleavage resulting from a hyperacute apoptotic injury. Fifth case was a 19-year-old female patient who presented with vesicobular lesions associated with itching, which first started from the face. Over a period of 4 to 5 months, she developed lesions over oral cavity, lips, neck, back, trunk, arms and legs, including the palms and soles. There was arthralgia and hair loss. Lesions were typically annular. 3 episodes of seizure diagnosed as focal seizure. ANA was positive, dsDNA was weakly positive, proteinuria 3.3 grams. Histopathology showed subepidermal bulla with neutrophils, and the neutrophils were at the tip of the dermal papilla, which made us think of a differential of dermatitis herpetiformis and bullous SLE. But the DIF favored linear IgG and A at the basement membrane zone, establishing a diagnosis of bullous SLE. So bullous SLE, the diagnostic criteria given by Kamisa and Sharma in 1983, said the diagnosis of SLE should be there. Vesicles and bulla should arise upon but not limited to the sun-exposed skin. Histopathology should be compatible with DH. There is negative indirect immunofluorescence, and DIF will show both linear and granular immunoreactants. Subsequently, some slight changes where there should be a diagnosis, established case of SLE with a vesicobulous eruption. Histopathological blisters will show neutrophilic infiltrates in the upper subepidermal blisters and neutrophilic infiltrates, but the immunoreactants will mostly be in a linear IgG pattern, and there will definitely be evidence of antibodies by indirect immunofluorescence. The flare may sometimes coincide with exacerbation of SLE, especially that of lupus nephritis. Sixth case is an 18-year-old male who presented with erosion, scaly and crusted lesions in a seborrheic distribution. There was significant erythematous crusted plaques over the malar area of the face. Mucosa was free, bulla spread sign was negative, Nikolsky's sign was positive. There was history of photosensitivity, joint pain and intermittent fever. So we sent for an ANA analysis, and ANA was strongly positive. Biopsy showed subcorneal acantholysis, basal vacuolar degeneration, and apoptotic keratinocytes. Direct immunofluorescence could not be done because of financial constraints. Diagnosis was pemphigus erythematosus, senior research syndrome. So this has been established, Francis Senior and Barney Usher described the features as a variant of pemphigus, where there is clinical and serological overlap of pemphigus foliaceus and lupus erythematosus. Diagnosis is primarily based on the clinical presentation. Mucosal involvement is uncommon. All cases will demonstrate the cell surface staining pattern classic for pemphigus. Approximately 30% will have positive antinuclear antibody test and 80% will have positive lupus Ben test. Most patients will not develop systemic signs or symptoms of lupus. Some may progress to the generalized pemphigus foliaceus form. Diagnosis of pemphigus erythematosus variant of pemphigus foliaceus is largely one of historic rather than clinical significance. Seventh case is a 48-year-old man who was diagnosed in the periphery as a case of pemphigus for psoriasis because of the presence of papulosquamous lesions over the front of the chest, sides of the neck, back and upper and lower back. Scalp extensors of extremities, palms and soles were free. Patient was treated along with topicals. He was given a course of topical povasol, following which there was an aggravation in the lesions. There was intense erythema, which can be seen here, and there was also a malar rash, and patient had complaints of weakness, pain and swelling over the joints, history of intermittent fever and photosensitivity. There was a significant erythematous plaque involving the upper and lower lips with irregular margins. Upper and lower lips showed overlying adherent scales and crust. Oral cavity showed asymptomatic reddish central area surrounded by whitish irregular borders. Hemoglobin was low, ESR was high, ANA was positive, antibodies to Smith and U1-RNP were also positive. So we diagnosed it as subacute cutaneous LE presenting as psoriasiform lesions. So this can often become a diagnostic clinical conundrum. Eighth case was a 40-year-old female patient who presented with vesicles and bulla on an erythematous base over her face, trunk and extremities for the past 1 month. Patient was febrile. The vesicles were associated with perilesional erythema and they were characteristically sparing the knuckles over the dorsum of the hands. There were palpable purpura lesions and there were also erythema multiforme-like lesions. She had photosensitivity, oral ulcer, hair loss and arthralgia. ANA was positive, again dsDNA was positive, antinucleosome antibody was positive, complement levels were low, biopsy from the skin lesion showed leukocytoclastic vasculitis, renal biopsy showed grade 4 nephritis, diagnosis was SLE and grade 4 nephritis with cutaneous vasculitis. My last case is a 25-year-old male patient who presented with multiple joint pain and history of fluid-filled lesions over the face, trunk and extremities. When he presented before us, he mostly had erosions and ulcers. They were associated with burning and fever, and he had decreased frequency of micturition. There were, on examination, we saw that there were confluent erosions with jagged margins. There were punched out ulcers over the lower legs with and without overlying necrotic tissue. Hypertension, dyselectrolytemia was found, and there was, on ultrasound abdomen, there was bilateral renal parenchymal change with ascites and pleural effusion. UGI endoscopy showed esophagitis. ANA was 4+, dsDNA was also high. Antihistone antibody, nucleosome antibody, P-ANCA was also strongly positive. C3 was low. Diagnosis was SLE with cutaneous vasculitis. So though ANCA antibodies occur in approximately 16% of patients with SLE, its clinical significance is unclear as few of these patients have concomitant ANCA-associated vasculitis. So SLE vasculitis typically occurs in established SLE patients in the context of a disease flare and is generally mediated by complement and immune complex deposition. Vasculitis in SLE is reported to range from 11 to 36%. Cutaneous vasculitis is reported to range from 10 to 17%. Episodes of vasculitis are known to often occur during lupus flare, but it is noted that episodes of vasculitis do not always occur during periods of high disease activity. Clinical presentation of vasculitis in SLE can be heterogeneous, ranging from erythematous punctate lesions on the fingers and tips, followed by palpable purpura, ischemic lesions, and or ulcers, erythematous, papules, macules, articulated lesions, and nodular lesions. But bullous lesions seem to be extremely uncommon. So in acute LE, Cutaneous vasculitis is shown to be associated with lupus nephritis, neuropsychiatric lupus, hypocomplementemia, musculoskeletal, constitutional, cardiovascular manifestations, and Sjogren's syndrome. Ideally, histology should be done to establish the diagnosis of vasculitis, but a probable vasculitis may be set based on the clinical features alone. So take-home message is vesicles and bullae in SLE can appear due to severe liquefaction degeneration, development of non-specific autoantibodies or overlap with other autoimmune immunobullous disease. Though vasculitis and SLE can present in various morphological patterns, bullous lesions can be an uncommon manifestations. When SLE is suspected in the very young, a genetic analysis should be carried out. It can present in various guises and snags and can easily escape the eyes of an unwary observer. Thank you for your patient hearing. Thank you to the organizers and especially the scientific team for inviting me to speak before this August gathering, and a happy Bihu to you all. Thank you.
Thank you, Dr. Datta, for a very lucid and informative talk and presentation of several cases. May I ask one question? Apart from different tests, the conventional test, anti-nuclear antibody, anti-Smith test, complement test, and of course biopsy, is there any confirmatory test for this diagnosis?
Sir, SLE, mostly it's a clinical diagnosis and based on the criteria
Mostly
following.
we make clinical diagnosis.
Yeah.
But is there any confirmatory test in case of doubtful cases? What is the confirmatory test?
Doubtful cases, sir, regarding, sir, can you please be specific, sir, if you like, in what cases? The clinical, the cutaneous lesions, sir, we can always go for a biopsy or we can go for a TIF.
And since lupus involves various organs of the body, kidney, heart, joints, and skin, is there any sequence of involvement of various organs, or all the organs can be involved simultaneously?
SLE, sir, the features develop in evolution. At the same point of time, all the features may not be there, but there are certain signs which will suggest, like say, supposing there is vasculitis, we can always think that there might be involvement of the kidneys. Then if there are certain antibodies, presence of certain antibodies will indicate the presence of like ribosomal P antibody, we can think of a CNS manifestation. So all antibodies and the clinical manifestations itself will be a window to internal involvement, so internal organ involvement.
Excuse me, ma'am, my question is how can we counsel the patients about the life expectancy in SLE?
Yes, sir.
Especially a female patient.
Yes, whenever patients come to us, we always tell them that this is a disease where with proper treatments, with proper follow-ups, they can have a normal life expectancy, they can get married, they can have children. So the only thing is that they have to be very regular in their follow-up, they have to have faith in us, and they have to be very regular in taking their medicines. So that is how I counsel the patients, that there is nothing to be worried about. They have to stick to the treatment regimen.
Thank you.
Is there any questions from the audience? It appears there are no questions.
Okay.
Thank you very much, Dr. Datta.
Thank you, sir. Thank you, everyone.
Thank you, ma'am, for such a wonderful session. Now, please may request our esteemed panelist and our speaker to collect the memento. So our next topic is vasculitis, diagnostic approach and management. Now I please may welcome Dr. Shashikant Chaudhary and Dr. Shah Nimesh to chair the session.
I would like to request Dr. Ajishnu Prakash sir to kindly join as a chairperson for the session. ये था ना अजिष्णु सर इधर आएंगे session.
warm welcome attendee. Very good morning. I would like to request Dr. Deepika Pandey.
Thank you, sir.
She will speak on vasculitis, diagnostic approach and management, case-based.
Thank you, sir.
Please start,
Yeah.
Mrs. Pandey.
So thank you for the invitation. So it's a huge topic. I'd like to just cover as much as we can in 15 minutes. I have no conflict of interest. So we all know, we've heard in the previous talk also about vasculitis. It is by definition an inflammation of the blood vessels resulting in palpable purpura. This is the definition, but we all know it can go beyond that. It can be just maculopapular erythematous lesions. It can be nodulo-ulcerated lesions, petechial regions. So it's a very diverse kind of a presentation. So it may be skin limited, it may be a primary cutaneous vasculitis with systemic involvement, or it can be a cutaneous involvement of a systemic vasculitis. So we are going to focus on the first two because the third one is beyond 15 minutes discussion. So vasculitis, it presents as occlusion of blood, ischemia, infarction, and it ruptures and weakens vessels, and finally it presents as hemorrhage. So that is how you see the hemorrhagic purpuric lesions. So this was the Chapel-Hill classification. We are not going to talk about large vessel vasculitis. Medium vessel vasculitis, we all know about polyarthritis nodosa and Kawasaki. I'd just like to mention that as a dermatologist, we should be careful. Rather than a biopsy, the diagnosis is by an arteriogram. So that is something most of us mostly do not do. So just we may be missing diagnosis, just wanted to stress here. Small vessel vasculitis is what we usually deal with, both ANCA positive and ANCA negative. The immune complex mediated small vessel or cutaneous small vessel vasculitis is the commonest thing that we as dermatologists see. We will talk more about it, whether it is IgG-C3 mediated or IgA vasculitis. We can also classify as single organ or vasculitis associated with systemic disease, and like we heard in the previous talk, with some other disorders, whether it's lupus or rheumatoid vasculitis or associated with hepatitis C, B, or even syphilis. So this is the very typical thing which tells us when we are talking about the post-capillary venule, the classical presentation is as a leukocytoclastic vasculitis or as a cryoglobulinic or as an IgA. When we go to the medium vessel, like we said earlier, it is polyarthritis nodosa or Kawasaki. Even the ANCA positive, we have to remember, are predominantly small vessel vasculitis, whether it is the granulomatosis with polyangiitis or the eosinophilic granulomatosis with polyangiitis or microscopic polyangiitis. So what do we as dermatologists see? So we see either purpura, vesicles, bullae, hematuria, hemoptysis, splinter, hemorrhages, ocular symptoms, which are classical of all the small vessel vasculitis. When do we suspect medium vessel vasculitis? When we see nodulo-ulcerative lesions, livido reticularis, mononeuritis multiplex. This is a very important thing which most of us forget to ask. Mononeuritis multiplex is not only seen in polyarthritis nodosa, it can be a manifestation of actually vasculitis of the nerve. So mononeuritis, we should ask for any patient where you're suspecting medium vessel because of nodulo-ulcerative or livido reticularis type of lesions or microaneurysms, and that is why I said it is not a biopsy but an arteriogram which will diagnose. So we start with case 1. I think none of us would have a difficulty. The central clearing, the central pallor, you do a diascopy, you see the central pallor or the erythema. So this was a young girl, 11 years old, actually she was 9, and she presented with this urticarial vasculitis, which was biopsy and DIF proven. Now what was interesting is we know there are two variants. One is the normocompletimic, which is the more benign, and one is the hypocompletimic, which has low complement. So her complement levels were low, and we actually did a renal scan, and she had proteinuria, which was 400. So this is very interesting. Some people say this is like an overlap with LE. Most of these people may eventually evolve into LE because her ANA was negative, dsDNA was negative, but because of the involvement of an organ and the low complement levels, it is hypocomplementemic urticarial vasculitis is hardly seen in 20%, and it's even more uncommon in children. But this is an indicator that you need to screen for systemic involvement more carefully. Otherwise, for urticarial vasculitis, you would rule out chronic idiopathic urticaria, which unlike urticarial vasculitis would subside in 24 hours, whereas here you would have a lesion which is maybe painful or paresthesias may be there and last for 24 to 36. Another diagnosis which is more common in pediatric is urticarial multiforme, which we will discuss subsequently. So if you have an urticarial lesion which is lasting more than 24 hours, so see for whether you have a biopsy for a urticarial, for a leukocytoclastic vasculitis. It may be an indication of a lesion which is persistent. Check for ANA and complement levels. That is the message from this case. And if it is abnormal, evaluate for SLE and for other systemic complaints. So treatment here I'd like to stress is the treatment of choice is more benign because most lesions subside in 4 to 6 weeks. So it can be NSAIDs or hydroxychloroquine, Dapsone, and colchicine. This girl received Dapsone and cleared within less than 2 weeks. Do not start steroids. So most of the thing is we are over enthusiastic in starting steroids, which is not required in these cases. So now you even have newer therapy like IVIG, omalizumab, rituximab, and interleukin-1 inhibitor like anakinra. A pediatric emergency, another patient with this kind of lesions, you see the truncal involvement, severe truncal involvement with the edema. This is urticaria multiforme. It subsides in 2-3 weeks, no need of steroids, just symptomatic management for fever or any other. And again, here we would remember hemorrhagic edema of infancy, another condition where you have facial swelling, ears and scrotal swelling, and acral swelling, and again, symptomatic therapy, no need for immunosuppressives or, or any other steroids. So here, if you do a biopsy, you will again see urticarial vasculitis. So the message is to not be in a hurry to start strong immunosuppressives in urticarial vasculitis. Be more careful in ruling out. Even now, autoinflammatory syndromes have been reported with urticarial vasculitis. So please be sure about what we are dealing, especially when you have an early age of onset. Again, a very typical, you see the almost bilateral, symmetrical, purpuric, palpable purpura, and the ecchymosis around it. The dermoscopy will depend on the age of lesion, just like biopsy. So here you see the pinpoint and the globules, the petechial globules on the erythematous background. So palpable purpura with predilection is one of the soft clues is when this is more symmetrical and more widespread, it is more likely to be ANCA positive. So you must actually do ANCA in all the patients, biopsy and DIF in all the patients. ANCA on a roughly, even in private, I think costs somewhere around 3,000 to 6,000. It is not that prohibitive as we sometimes think. You may even have retiform purpura. So you think of vasculitis in all these presentations. Take a thorough medical history, especially for pre-existing sore throat, any other infection, hepatitis B, C, all the common causes, drugs, especially things like minocycline, propylthiouracil, even penicillins and tetracyclines have been reported to cause. So the drug history must be very thorough. We saw an increase of vasculitis after COVID. So even with influenza, it has been reported. So all these histories must be elicited from these patients. A thorough physical examination, look beyond the lesions. So if you have just the lesions, look for signs of asthma, of any sinusitis, nasal polyposis, to rule out other conditions which we'll subsequently discuss. Look for mononeuritis multiplex, like I stressed, lung involvement, systemic, at least screening. This by history and examination should be done so that we do not miss any of the systemic signs and symptoms. The diagnosis, of course, is only by biopsy and DIF. So this is another lady, you see the edema, you see the more symmetrical and involvement beyond the acral areas. This is the this was the dermoscopy. You see she has a more active lesions with the erythematous background and the petechial globules. The biopsy, as we all know, should be from an early lesion as proximal as possible. It should preferably be less than 48 hours. Otherwise, any biopsy will show only a lymphocytic infiltrate, and neutrophilic and others will not be demonstrable. For DIF, it should be 8 to 24 hours. The newest possible macule you should choose for sending for DIF, and it is imperative to send DIF. We all know we need to distinguish vasculitis from vasculopathy. So here you have infiltration of the vessel wall, you have disruption, and you have intramural fibrin or fibrinoid necrosis, and you have extravasation of the RBC. So these are important to label it as a vasculitis. And an etiological workup should, of course, include ANCA as well as ANA profile if you're suspecting the same. The therapy, like I already stressed, you have dapsone, colchicine, NSAIDs for most of our vasculitis. Interestingly, now better results are being reported with combination of dapsone and colchicine. I wonder how patients, accept it. We have tried it in 1 or 2. It's not common, but it is being reported to give very good results, the combination therapy. For more severe or with systemic involvement, of course, methotrexate, azathioprine, even rituximab and IV cyclophosphamide should be reserved only for very severe cases with very severe systemic involvement. Again, a very typical presentation, a young child with symmetrical, palpable purpura, and look at the non-compressible edema. So this, the first history you should ask is abdominal pain, arthralgia, and it follows a sore throat 1 to 2 weeks after, so this was suspected IgA vasculitis. Another patient, you see this is a more severe involvement. You can see the impending erosion. He had history of abdominal pain, multiple joint pains, and he had proteinuria. So he had literally all the 3 things, and he had recurrent lesions which were not controlled on dapsone. So this is one of the CAR classification which you can use to monitor the severity of IgA for the skin involvement, abdominal involvement, joint involvement, and renal involvement. So this can help you monitor the therapy and not start steroids prematurely. So you see the typical vasculitis, the extravasation and fibrinoid necrosis, and IgA was positive on DIF. But look at what happened. While on dapsone, he developed these ulcerative lesions. So were we mistaken with IgA? Remember, IgA can be present in DIF in a multitude of conditions. It doesn't indicate only IgA vasculitis like we think. IgA can be present even in venous stasis. IgA can be present in SLE, paraproteinemia, in a whole lot of conditions. So it needs to be correlated clinically. Do not base your management on only the lab findings. So he turned out to have tuberculosis. Once he was started on category 1 ATT, there was marked improvement and no recurrence. So look for underlying causes. We must remember less than 5% have recurrent lesions. Less than 5% in pediatric age group have ulcerative lesions. Almost 25% of cases are in adults and they have more renal involvement. So if you have an adult with IgA vasculitis, please be more vigilant in screening for kidney involvement. So this is his healed lesions after starting ATT. So this is the classical quadrant that you have to look for before you diagnose as IgA vasculitis, and appropriate use of imaging. Look out for abdominal imaging as well as kidney biopsy. Sometimes this is usually delayed and can lead to a pediatric emergency. Do not be in a hurry to start immunosuppressive therapy till you have ruled out all the causes that may be causing more severe lesions. Another patient, an adult patient, you need noduloulcerative lesions along with the typical here you should actually, of course, do an ANCA test. Look out for microscopic polyangiitis, the eosinophilic granulomatosis with polyangiitis, and granulomatosis with polyangiitis, which was known as vaginals. So we all know the theory. I'm not going to go into it. I'm just going to stress on DIF. So granulomatosis with polyangiitis DIF is positive in 70%. The supposed Churg-Strauss, it's in 50%, and microscopic polyangiitis, it may be negative. So the message here is a negative DIF does not rule out. Please be, like I'm saying again and again, the lab findings need to be correlated with the clinical presentation. So the ANCA antibodies that we are talking about, the classic are the PR3 or the proteinase 3, which were the C-ANCA, the P-ANCA, which are now known as myeloperoxidase, and you have atypical. So this is what it looks like on indirect immunofluorescence, the classical C-ANCA or the classical P-ANCA. So it is present, it's not positive even in, microscopic PAN or GPA or eGPA in 100%. So again, a negative result does not rule out your diagnosis. That has to be based on the criteria. I think that was a question for SLE. Every diagnosis is as per the criteria that have been proposed. Another patient, again with very widespread vasculitis, an adult patient, this was drug-induced. So there are a lot of drugs. Look, ask for a history. One of the most interesting is cocaine with levamisole. Why levamisole is added to cocaine, I'm not aware, but that is one of the leading causes. In addition to hydralazine and even antibiotics, so she had gangrene. Another marker that looked for something beyond just a simple leukocytoclastic vasculitis. But also remember, this kind of gangrene can be seen as part of DIC as a septicemia, so that should always be ruled out, and this is her treatment after MMF and Dapsone. So she did not respond only to Dapsone, so we needed to add. This is a very interesting patient. So you see she has this ulcerated lesion and she has this nodulo-ulcerative. She was sent as a case of leprosy. She was being treated in another institute for leprosy. The medicine department sent it to us as polyarthritis nodosa, please do a biopsy. So we did, and she had mononeuritis multiplex, which is classical of cutaneous PAN and even of systemic PAN. Her ANA was positive, dsDNA and ROLA were negative. She had lupus nephritis. So was this SLE with PAN, or was this PAN and the ANA? So this is very interesting. SLE in 10% can have classic PAN. So it's like the chicken and egg, what came first? So what is said is that the lupus nephritis predisposes to renal PAN. So you can have coexistence, and this patient received pulse methylprednisolone and cyclophosphamide IV 750 and responded to that. When she came, she could not even walk. So this is, I think we are almost out. This patient I'd like to share, this was a very interesting patient. She was diagnosed as SLE. But look at the lesions. You can see the hemorrhagic, somebody as vasculitis due to SLE. So when we saw this, we asked her history. She had asthma. Her eosinophils came out to be in multiple thousands. So she was a case of what was then called as Churg-Strauss, but what is now known as eosinophilic granulomatosis with polyangiitis. So look out for the asthma, nasal polyposis, and the peripheral eosinophilia is the thing that should, alert you to this possibility. Screen for systemic involvement. She had renal involvement. The renal involvement in these patients is posse-immune. You will not see DIF positivity. You will see crescentic glomerulonephritis. And here, just because of paucity of time, I want to stress atypical features like palpable purpura of the buttocks and purpuric dermal plaques of the palm, as was seen in our patient, are classical of Churg-Strauss or eosinophilic granulomatosis. So be a little bit more in your thing and you have this diagnosis. So these are the criteria. You need 4 out of 6, and she had all 4: asthma, eosinophilia, she had extravascular eosinophils on biopsy, and she had sinus pain or opacity. So here again I'd like to stress the biopsy is necrobiotic palisading granulomas, leukocytoclastic vasculitis, extravascular granuloma, and this is the treatment. So you see rituximab is now coming everywhere. So this is not showing up. And we have 2 drugs that are approved for vasculitis, and one of them is for Churg-Strauss. It is mepolizumab, which is an anti-IL-5. It has been approved by FDA for the treatment. So for secondary, already covered rheumatoid, SLE, she already covered. You can have overlap of vasculopathy and vasculitis as in this patient. Again, vasculopathy and vasculitis in the same patient. They will respond to immunotherapy, not to treatment for vasculopathy, which is the antifibrinolytic treatment. Another very interesting patient. So you see the unilateral involvement, very severe involvement. She had small to medium vessel vasculitis. We did an ultrasound and CT scan. She had retroperitoneal fibrosis. That is associated with SLE as well as with malignancy. So a vasculitis that is not responding, please look out for an underlying cause that you may be missing. So she responded to MMF and pulse steroid after we started treating the retroperitoneal fibrosis. Again, no problems in diagnosing nodular vasculitis. Traditionally, vaccines associated with tuberculosis, but now increasingly recognize that there are a lot of causes, hepatitis B, C, even hypothyroid has been reported, and drugs. So it's not only tuberculosis, so ATT only in patients do a PCR. Behçet's, again, vasculitis, look out for mimics. This is a very interesting, it was vasculitis secondary to dye. So for the immunocontrast, LCH, which mimicked vasculitis. This was also very interesting, diagnosed as PAN, cutaneous PAN, livedo with the ulcerative lesions. She actually had atherothrombotic emboli. So I think my time's up. Kawasaki, medium vessel, look out for that. Avoca PAN, I would like to end with this. This is another FDA approved for ANCA-associated vasculitis. It's a novel complement 5A receptor. The main aim now in vasculitis, like in LE, is to avoid high dose of steroid. So you want to bring down the steroid dose because morbidity and mortality is more with long-term steroids. So Avoca PAN has been approved for this indication. It has no effect on the ANCA levels. It has effect only in end organ. It reduces kidney, lung disease. So take-home message is, we are the first usually to diagnose. We have this unique advantage. Look out for systemic screening. Do not delay investigations, because the prognosis clearly in multiple studies is achieving early and sustained remission is the main goal in vasculitis treatment, because it prevents mortality and morbidity. So we need multidisciplinary approach and maybe referring to a center in case we have a case which is not responding to standard therapy. So treat right. Thank you for your patient listening.
Thank you, Dr. Padhi. Good presentation, nicely covered all corners. Any questions from audience? Thank you very much. I conclude the session.
Thank you, ma'am, for such a nice session. Now, please may request our panelist and our speaker to collect their memento. So next session is rituximab in pemphigus. Now, please may welcome Dr. Shwetalina Pradhan ma'am and Dr. Punkesh Kumar sir and Dr. S. Mishra sir to chair the session. Shashank Mishra sir. Dr. Punkesh Kumar sir and Dr. Shashank Shekhar sir to chair the session.
Now the topic is rituximab in pemphigus long-term outcome. So I request Dr. Shwetalina Pradhan, Associate Professor and HOD, Department of Dermatology, AIIMS Patna.
Thank you. For a change, after a long time, I'm speaking on pemphigus. So now we all are acquainted with rituximab. It's not any difficult thing for any of dermatologists giving rituximab. So to introduce pemphigus is an autoimmune blistering disorder caused by antibodies against desmoglein, which leads to acantholysis, intraepidermal blistering leading to erosions in skin and mucosa. And the important thing in pemphigus, because there is erosion, so there is a compromise in the barrier. So these patients are more prone for infection leading to sepsis, and sepsis is the most common cause of death in pemphigus. So the complications are more common in pemphigus, which leads to the mortality. So a key in infection
can trigger pemphigus, and because of pemphigus, an infection occurs. So though both aggravate each other. So key in controlling pemphigus is immediate disease control and healing of erosion. So that's how you can save the life of a patient. So being autoimmune disease, pemphigus is autoimmune disease, so key is the immunosuppression. So we have age-old treatment. Systemic corticosteroid was the gold standard for pemphigus. Since age-old, we have cyclophosphamide, azathioprine, MMF, etc. So IVIG can be also tried in a rescue therapy, but we all know IVIG has a short-acting, like its effect lasts for around 3 months. There's a cost factor, and treatment complications high with daily dose steroid and other immunosuppressants. So though systemic corticosteroids are drug of choice initially, but as I said, complications treatment is very high. So there are many comorbid conditions like diabetes, hypertension, patient is obese, you cannot give high dose of steroid in those cases. And moreover, systemic steroid has a non-specific action, that is overall immunosuppression. So in our era, we are lucky to have a targeted therapies for various diseases, and we have rituximab for the pemphigus. So then why rituximab? So as I said, conventional therapy have a toxicity. Rituximab is a targeted therapy because it specifically targets B cells. It has a steroid sparing effect. Now it is the first line treatment in moderate to severe pemphigus. So how rituximab acts in pemphigus? So what are the key cells which rituximab targets? That is mature B cells. These are responsible for most of the antibody-mediated autoimmune diseases and lymphoma. Memory B cells, they are long-lived B cells that remain as a memory of antigens. Pre-B cells, these are early B cells that have developed CD20 marker, and what rituximab spares. So rituximab doesn't act on the stem cells. That's why once the B cells are depleted, so they can regenerate. So it is not going to make your immunity zero for the lifetime. And plasma cells, the B cells always activate plasma cells. The antibodies were produced by plasma cells. So B cell, once the cell is converted to plasma cell, it doesn't have CD20. So plasma cells are not affected by rituximab. So that's why when we are giving rituximab, we give steroid because plasma cells are still there which are producing antibody, because rituximab will only act on the B cells. So in pemphigus, so how it kills the B cells. So the B cells having CD20 markers, they are killed by 3 mechanisms, that is, we know the apoptosis, complement-dependent cytotoxicity, antibody-dependent cellular cytotoxicity, and induces ultimately apoptosis of the B cells. So with result, so because there is no B cell is depleted, we have no antibody, autoantibody, so it controls the disease control and also maintains the disease remission. So these are, everybody is aware of dosing, the 2 protocols, that is RA protocol and lymphoma protocol. So with rituximab, there is a disease control, the disease activity is arrested, also healing, there occurs a healing of erosion and the remission of the disease. So these are the list, side effects are very minimal. Most common side effect is infusion-related reaction. So I will share our experience from institute. So infusion-related reaction like fever, chill, hypertension, patient can develop breathlessness, infections. So bacterial, viral, fungal, hepatitis B reactivation is a major, then can be a major issue in rituximab. Then hematologic, so late onset leukopenia. So most common is lymphopenia followed by neutropenia. So this is the side effect of rituximab, but it is not a major side effect, it is reversible. Then rarest theoretical risk, that is progressive multifocal leukoencephalopathy and decrease in immunoglobulin level. So these are the monitoring, basic monitoring, because looking at the side effect, you can do a viral screening or CBC monitoring. And during pregnancy, you can, during treatment, you can do a regular CBC monitoring for infections, and during infusion, be aware for the infusion reactions. So precautions, what precautions? No, I don't know what dermatologists are following. We have a strict protocol of giving vaccination. So with time we have evolved So because the infection is a risk, so vaccinate the patient and give rituximab. So what happens with rituximab injection? So while after 3 months, so initially significant improvement is seen at the 3 months. Then the effects is maintained for around 6 to 12 months, because after that stem cell will repopulate the B cells, they will develop again antibody. That's why we require maintenance therapy in rituximab. Not only loading dose, we also require subsequent maintenance therapy. So there have been studies of overall long-term efficacy. It's a high remission rate. So in meta-analysis, 76% patients had achieved complete remission after 1 cycle. Long-term cohort study has suggested 70% remission after multiple cycle. So this is, I will now share our experience from the institute's long-term outcome of rituximab in pemphigus. So till now we have injected around 138 patients of pemphigus with rituximab from 2019 to 2025. So whatever data experience I will be sharing, this is from our records. So efficacy we assessed in this presentation. I have minimized by decrease the slides. Only few crisp points I will be sharing. So why we actually rituximab was discovered? Because of the side effect of the steroid. So I will be focusing on how it was valuing in the steroid sparing effect, inducing complete remission and decrease the relapse. And safety was evaluated by any adverse effects which I stated previously. So we follow RA protocol in our institute for pemphigus. And as per the protocol, I'll screen all the basic screening, monitoring CBC, routine monitoring, viral markers, everything is being done. Then systemic screening for clearance of if patient has any comorbid conditions like cardiology, pulmonary clearance. So we little differ in our approach in our patients basing upon the severity. If the patient is having a mild pemphigus, we straightway give rituximab. If the patient is having moderate to severe pemphigus, so we first give first cycle of DCP as a rescue therapy, because IVIG is costly. So we prefer giving 1 DCP to the patients. Once the disease is immediately controlled, after around 1.5 months, we go for rituximab. This is our institute, we follow this, because DCP, only 1 DCP for rescue therapy. And with this approach, we can see the patients are almost off steroid, tapered off and off steroid around 8 to 12 weeks. This is our data. Out of 138 patients, so the most common age group was between the 41 to 50 years. You can see less than 27 patients were there, and total 138 patients we have given. And the duration of disease before we gave rituximab ranged from 3 months to more than 5 years. So it is because our institute being referral institute, many patients came with refractory disease after taking varied medications, and they land up to us. And we have some patients, new patients, who directly come to us, and we can give them straightaway rituximab. So the most common type we have given is the pemphigus vulgaris, followed by foliaceus, and then vegitans IgA 2 patients. So prior treatment history, exactly half of our cohort, 69 patients, received rituximab as a first-line treatment without any prior immunosuppressive therapy. Remaining 65 patients had received prior treatment both within and outside the institute. Among those, DCP was the most common treatment given outside, followed by plain dexamethasone, few cyclophosphamide, MMF, and some pemphigus foliaceus and dapsone, and IVIG in few cases. In many cases, rituximab was initiated due to inadequate disease control, relapse, or intolerable side effects from the prior treatment. So this is in nutshell what I said. So we started rituximab just before COVID 2019, and 2020 no patient disease because it was a COVID pandemic, the hospital was shut down. So from 2019, 21, 22, 23, 24, 25, so total 138 patients. So with time, with evolving experience, now we have almost totally shifted towards rituximab in pemphigus. So this is the number of cycles patients. We have a 5 years follow-up data. Not all patients, some patients are 5-year follow-up, some patients are in 3 years, some patients in 4 years. So this is in our cell the follow-up data of the patients. So final outcome, 88 patients now are in the complete remission of steroid. And partial remission on minimal treatment, 12 patients, ongoing 30, and 8 patients had a relapse. So adverse effects and safety profile, rituximab was very well tolerated in our patients. We had only 3 patients who developed infusion-related hypersensitivity reaction as urticarial racks, which are managed briefly by discontinuing and slowing the infusion rate, administrating the following all the protocols. Most of the time, it is the nursing staff which is a rapid infusion, you will develop a infusion reaction. And one patient developed urticaria, which the third patient, we just changed the rituximab brand and there was no reaction. So 6 cases for our cases had late onset leukopenia, which we initially confused with maybe azathioprine induced or maybe MMF induced or some other, but it is the rituximab induced late onset leukopenia. And infections are serious infections documented in 5 patients, and most common adverse effect was mild URTI, flu-like symptoms, frequent. They will come with fever and cough in our initial days, initial years. So the one patient had UTI with sepsis, pneumonia 1 patient, and varicella zoster reactivation. We had 3 patients. That was initial I think 2022-23, but now we have changed the protocol. We will actually give a vaccination to pneumococcus, PPV, herpes zoster vaccination. All vaccination we give, then we go for rituximab. So our protocol has changed with time. We are evolving. Now it is very safe with vaccination. Rheumatologists give vaccination protocol for all immunosuppressants. It is followed by the rheumatologist. So dermatologists also should give. You are telling data infection. So you give vaccine, so there will be no infection. Safe, keep the patient safe. Because for COVID also, patient, if you counsel the patient, he will definitely take the vaccine. So to summarize, after 1 DCP rescue, rituximab in our majority patient became off steroid after 10 to 12 weeks. Frequent URTI was most common adverse effect noticed in initial years, but subsequently with vaccination, it has gone down to very minimum. No single case of mortality till date. We have found, we are very lucky maybe with rituximab. 3 monthly we do a CBC monitoring for leukopenia, whom you have injected rituximab already, and infection screening in between. Rituximab is now first-line treatment in pemphigus. Adequate counseling post-rituximab is very important. Overall cost is rituximab is actually less. Initially, patient will tell injection is not costly, but if you see the side effect profile, daily, every month patient comes to visit you, all daily dose immunosuppression, patient will be diabetic, so many complications, osteoporosis. So if you see overall, it is very minimum with rituximab cost. So at the last, rituximab is safe on long term in terms of side effect profile, what we have gained experience in 5 years. So I want to acknowledge Dr. Battika, my SR, for compiling all the data. Thank you.
Any question?
How many doses did you get? In between means? Did
50.
You,
Now
between
we
2
have
weeks or is it after that? Did you follow up with cyclophosphamide and azathioprine after the 2 doses?
Yeah.
How
Cyclophosphamide.
long?
So up to 2, it's a maintenance dose. After 1 year we give, and for 2 years we give cyclophosphamide, and after that we stop it. Mostly we have shifted to MMF, but if patient cannot afford, we give cyclophosphamide. Otherwise, MMF or azathioprine.
Did you repeat the dose of rituximab after the 2 doses? Like, did you repeat it
Loading
every year?
dose,
or-
maintenance dose at 1 year,
Yeah.
and second maintenance dose, if there is some lesion, we give at least 2 maintenance doses. I showed you the data. Even we have patient who have given 3 maintenance doses.
So you continued the patient with cyclophosphamide or azathioprine or MMF after
After
those
2
2
years,
doses?
we don't
Even without any relapse, you gave the repeat dose at the end of 1 year.
Yeah. Daily relapse is very less because we give DCP1 rescue therapy with DCP. With that, the disease gets controlled immediately. Then we give rituximab after 1 month. Then with that, we have patient with very minimum relapse. We can give only prednisolone 20 milligram for 10 days, so 10 days, not more than that.
No, if you add steroid to rituximab, we don't give a rescue dose of DCP, but they do very well with rituximab plus steroid. We do taper off within 2 to 3 months.
It is why DCP was discovered, because daily dose of steroid causes more side effect compared to the pulse dose. If you give one DCP and the patient is off steroid after 8 weeks, if you give daily dose of steroid, we have given rituximab, it gets 4 months, 5 months. So patients are, so diabetes because of uncontrolled sugar, with one DCP, rituximab, then very minimum after 8-12 weeks, patient is totally off steroid.
No, we have given around 200 cases of rituximab in pemphigus, different pemphigus, and what we found was even without DCP, we can taper off the steroid by 2 to 3 months. Very mild case, you can taper it off in 2 months, and it's a little longer, very severe, maybe we continue for 3 or maximum 4 months, never more than that.
DCP
Without
only
DCP.
for severe disease, for mild, we straight with rituximab.
But you didn't wait for a relapse. For all the patients, you give rituximab at the end of 1 year.
1 year.
Okay, we have not given it at the end of 1 year, but still we didn't have any relapse. Around 100 of our patients received it, just 2 doses, maintained with one of these, azathioprine, cyclophosphamide, not usually MMF. But we never had a relapse.
We give maintenance dose at 1 year.
We have not given. In spite of that, we found that the patients have all done well, except during COVID pandemic, they had to discontinue. Some of them discontinued, some of them we couldn't give. So some 4 or 5 relapsed. That is, they have not completed the full course. I think one, in spite of completing and we had stopped the treatment, relapsed. Others didn't relapse with just 2 doses.
Dr. Shwetan, regarding herpes zoster vaccination, how do you manage when the patient has come with acute pemphigus, severe pemphigus? Because the herpes zoster vaccination
After 6
requires
months.
it requires 2 doses at a gap of 2 months.
Yeah.
This is
So
one
there
challenge.
is we have made a protocol. So risk benefit. Suppose patient has severe disease, we need to give now only.
Okay.
So we defer the
Got it.
after
So
6
in
months.
some patients you delay and then after 6 months, that's fine. And I give low dose rituximab 500 mg dosage protocol instead of 1 gram, and I have treated more than 200 patients. And I agree with the previous person who was mentioning regarding the maintenance. Azathioprine and cyclophosphamide 1 year or 2 years maintenance post rituximab is supposed to be very, very immunosuppressive, highly immunosuppressive. So I avoid that, and we rather maintain on doxycycline nicotinamide for a short period of time. And corticosteroid dosage, I do taper off within a month and stop it. We don't give for long time. Not required. Even with 500 mg, the relapses are very, very minimum.
Okay. Dr. Sutlina,
Yes.
even after completing the doses of the rituximab, we sometimes get the oral pemphigus cases after completing the thing. What's your experience?
So suppose patient has completed 1 loading dose and there is still time for 1 year for oral pemphigus. I am not getting your question. After 1 year, 2
Completing
years?
all the doses, first, second, and the 6
Maintenance
months.
after 1 year.
Yeah.
If the patient gets
Yes,
oral
oral
pemphigus.
pemphigus only, not the cutaneous lesion.
I have not seen, but 1-2 cases who were injected previously from outside, not our institute, we give intralesional triamcinolone. It is okay.
Thank you so much, Dr. Sutana, for nice and elaborated rituximab in the case of pemphigus vulgaris. Thank you so much.
Thank you, ma'am.
Thank you so much, ma'am, for such a wonderful session. Now I request our chairpersons and speaker to kindly collect their mementos. Now for the next session on what's new in immunobolus disorder, I would like to invite our respected speaker, Dr. Sheetal Pujari, and our chairperson, Dr. P.K. Roy, Dr. Pradeep Kumar, and Dr. Smita Prasad.
स्टार्ट नहीं किया सर.
Good morning, ladies and gentlemen. Good afternoon, rather, but must be tired. There are people sitting here since morning, very attentive audience, I must say. we don't have CV of Dr. Sheetal here. Can somebody put up Dr. Sheetal? Anyway, she is known to everybody here because she is the President Secretary of IADVL, which are primary our their thing. So I don't think she needs much more introduction, and I'll request her to start with her presentation straightway.
Yeah, thank you so much, sir, for the kind introduction. I'll be speaking on what is new in autoimmune bullous disorders. So I'll be covering few aspects of what is new in pathogenesis, some of the newer variants, the drug-induced bullous disorders, some of which have become more common now, newer diagnostic techniques, and advances in treatment of bullous disorders. Now coming to the pathogenesis of pemphigus, we know that desmoglin 3 is a primary autoantigen in pemphigus vulgaris, but proteomic studies have identified numerous antibodies in patients with pemphigus vulgaris which have roles in the physiology and the cell adhesion of keratinocytes. So what are the antibodies which have been detected? Antibodies to desmocollin 1 and 3. There are several muscarinic and nicotinic acetylcholine receptor subtype antibodies which have been detected. HSPCA1, which is the same antigen as detected in Hailey-Hailey disease, that is a mutation in Hailey-Hailey disease, and these may have direct pathogenic roles or synergistic roles when combined with DSG3. Another aspect is when there is a primary antibody to desmoglin 3, because of the exposure of the antigens, there may occur epitome spreading, and that is why the antibodies may develop to the other antigens as well. So desmocollins are the ones which play an important role in cell-to-cell adhesion. There is evidence of trans interaction of desmocollin 3 with DSG1, and in a large cohort of pemphigus patients, autoantibodies to desmocollin 1 and 3 were present in almost 44% of the patients compared with 7%. Now how much this contributes to the pathogenesis remains to be understood even now, but maybe testing for antibodies against the desmocollins may be helpful in patients who have atypical pemphigus, including of course paraneoplastic pemphigus, where anyway you have multiple antigens, pemphigus vegetans, and those pemphigus patients who are DSG negative. This is another antigen which has a possible role in pathogenesis. This is the same gene mutation which is seen in Hailey-Hailey disease, and these are in one particular study, again autoantibodies to HSPCA1 was seen in 43% of the patients. Coming to cholinergic receptors, these also have a potential role as prognostic marker during the course of therapy, these antibodies. Plakophilin 3 comes from the armadillo family of proteins, and this basically is a key to the dense network of proteins which stabilizes the desmosomes. So this basically has interactions with several proteins such as desmoglin 1, 3, desmoplakin, plakoglobins, and the epithelial keratin 18. So this is also an important antigen which may play a role in the pathogenesis of pemphigus. E-cadherin is another one which data suggests an important synergistic role of E-cadherin autoantibodies in the pathogenesis of pemphigus. So basically, pemphigus vulgaris may be resulting from a synergistic action of several antibodies to different self-antigens. So the pathogenic role of several of these antibodies remains to be confirmed, but possibly they may have synergistic action with the DSG1 and DSG3. As far as pathogenesis of bullous pemphigoid is concerned, we know it is the BP180 and the BP230 and the complement dependent and complement independent pathways. IgE autoantibodies also play an important role, and this is where omalizumab role also comes in the treatment of bullous pemphigoid, especially the refractory ones. Here also epitome spreading may lead to the different antigens also being involved in the bullous pemphigoid. So epitope spreading plays a major role in many of the bullous disorders. Coming to the triggering factors, this is important because nowadays the drugs like gliptins have become very common, and we are seeing many patients who either come with gliptin-induced BP or gliptin-aggravated BP. So this is one history which we have to ask for when a patient comes with bullous lesions, because nowadays at least I have seen many patients who have gliptin-induced bullous pemphigoid. Another group of drugs which is important is the immune checkpoint inhibitors. So, what are the characteristics of drug-induced BP? They are more likely to be seen in younger patients as against the classic BP. Atypical patterns may be seen. Even you may see mucosal involvement. On histopathology, you may see necrotic keratinocytes and marked eosinophilic infiltrate and presence of intraepidermal vesicles, and there may be blood eosinophilia. So this is the list of the drugs which are associated with bullous pemphigoid. Some of them we already know from before, but gliptins and immune checkpoint inhibitors are the ones which we are commonly seeing now. As far as the gliptin-induced BP is concerned, this was first reported in 2011, and the vildagliptin is the most likely to cause BP as compared to linagliptin and sitagliptin. So this is how it works actually. It cleaves the BP 180 into ectodomains like 120 kilodalton fragment and the 97 kilodalton fragment, and that is how it induces the BP. Coming to some of the variants of bullous pemphigoid, many of these are already known to you, not very new as far as we are concerned. But I would like to focus on one of them, the non-bullous pemphigoid, which I feel that there is a high index of suspicion which is required, because many of these cases, especially in the elderly who come with these kind of lesions, get missed. And hemiplegic pemphigoid, these also some of the cases we have seen recently. So non-bullous pemphigoid generally present with pruritus, erythematous, urticarial lesions, excoriations and eczematous lesions. So many times we might diagnose them as prurigomitis or just maybe as senile pruritus, because often the elderly present with these, and some of them may never develop blisters, even though histopathologically and antibody wise we may diagnose them as bullous pemphigoid. The autoantibodies are to the similar antigens, and as I mentioned before, they resemble several pruritic dermatosis and thereby causing long diagnostic delay, and even the histopathology may show the classical features of BP or may show only a non-specific perivascular infiltrate. That is why the diagnostic criteria are the pruritus and or predominant blisters, IgG and C3 in a linear n-serrated deposition, and IgG on the epidermal side as revealed by indirect immunofluorescence. So we may need all these three criteria to diagnose non-bullous pemphigoid. This was one of our patients who remained undiagnosed for quite some time. She presented with only excoriations, and you can see the faint urticarial lesions in the axillary area. Another new entity which has been described is the anti-P200 pemphigoid. It is defined by predominant skin lesions with involvement of the extremities, often the palms and the soles. It is characterized by linear deposits of IgG, C3 and blister fold staining on the salt split technique, and the reactivity with the 200 kilodalton P200 protein by immunoblotting. And on histopathology, you would see subepidermal blistering with neutrophilic or mixed infiltrate. So this is one of the newer variants of pemphigoid. As far as what is new in diagnosis, there are variants of ELISA for autoantibodies. There's a new technique which has come, which is biochip mosaic technique, antigen-specific assays, and serration pattern analysis is not really that new, but I'm mentioning it over here because that is very useful for diagnosis of subepidermal bullous disorders. Coming to DIF, we all know we do pattern analysis, so the intercellular network-like deposits is classic for pemphigus, whereas the linear binding along the dermoepidermal junction is classical for the pemphigoid group of disorders. And the serration pattern analysis, as I mentioned, is useful for distinguishing between EBA and the pemphigoid disorders. So in EBA, you get the U-serrated pattern which arches closed at the bottom, whereas in the other pemphigoid disorders you get the N-serrated pattern. So this is how it appears, the U-serrated pattern in EBA and the N-serrated pattern in all other pemphigoid disorders. Coming to serology, whatever antibodies we order for the patients, measurement of the antibodies is done either by indirect immunofluorescence microscopy on the tissue substrates. So that means you need tissue substrates to detect the antibodies, or you do by the ELISA technique against the various antigens in pemphigus and bullous pemphigoid. So what is the variants in this which are now available? One is the multivariant ELISA, which enables a parallel identification of different autoantibodies, and this compiles different target antigens including desmoglein 1, 3, the BP180, BP230, type 7 collagen and enmoplekin on a single ELISA plate. So you can order a single multivariant ELISA if you are not very sure about the diagnosis of the bullous disorder. Another thing which has come useful is the biochips. Now, biochips are miniature substrate. This is not only useful in immunobullous disorders, which I'm going to mention here. This have been used in various other investigations also, because this markedly reduces the cost and makes the investigations much easier. These are basically miniature substrates that can be assembled together like a mosaic on a single incubation field of a laboratory slide. So an individual biochip would be composed of a tissue substrate or transfected cells, meaning virus transfected cells expressing the recombinant target antigens on the cell surface or directly the recombinant target antigen. So for the autoimmune bullous disorders, the biochip mosaics which have been developed are composed of 6 biochips. So primarily salt split skin, a primate esophagus, recombinant BP180 or HEK293 cells which are transfected with the C globular domain of BP230, desmoglein 1 and 3. So basically this is a very cost effective measure for when you want to rule out multiple diseases. So this is not only done in bullous disorders, but this has been used for multiple disorders. Even in cancer diagnosis it has been used. So this approach basically allows simultaneous testing of autoantibodies against several antigens at a time. So a very minimal amount of the sample is also required and several antigens are tested in parallel. And its diagnostic accuracy has been shown to be comparable to that of standard multi-step approaches and allows serological diagnosis in more than 90% of the cases. And wherever there is new diagnostic techniques, AI cannot be far behind. So there is a deep learning algorithm which has also been developed, and this will further speed up the diagnostic process for autoimmune bullous disorders. As far as what is new in treatment is concerned, in pemphigus, we have the FGARTI mode humanized anti-FcRn monoclonal antibody, which specifically targets the FcRn receptor. What is FcRn? It is a major histocompatibility class 1-like molecule, which is expressed on different cell types and is involved in recycling of the IgG molecules. And initial studies have shown rapid improvement in pemphigus with this particular drug. Then there are some newer anti-CD20 monoclonal antibodies also which are there. So there are some new drugs which are there, ofatumumab, veltuzumab and ocrelizumab. So these probably are less immunogenic in nature because they are fully human and less likely to provoke the transfusion reactions, but these are still under trial. Then there is something called as bispecific antibodies targeting both CD20 and CD3, which are being studied on an experimental basis in pemphigus. Then there are tolerizing nanoparticles, which basically tolerizing nanoparticles have the potential to promote the expansion of the T regulatory cells so as to control the immune process. Coming to bullous pemphigoid, Shwetalina mentioned very nicely about rituximab in pemphigus, and now we are largely using it in bullous pemphigoid as well, although not probably as first-line therapy. In refractory patients, rituximab, omalizumab, IVIG are recommended. So what are the indicators as far as the serological indicators are concerned? Apart from the antibody levels, the total IgE, the count of the peripheral blood eosinophils, D-dimer levels, interleukin-10 are some of the most promising indicators for their severity. So what is the role of rituximab in bullous pemphigoid? We can use it in patients who are not responsive to conventional treatment, or in early cases of severe cases of bullous pemphigoid, or in patients with comorbidities whom you cannot give steroids or other drugs which immunosuppressants. So this is one of our patients, an elderly patient who came with very severe bullous pemphigoid, and she was on sitagliptin, probably one of the causes which aggravated her lesions, and she did not respond to our conventional therapy including steroids and immunosuppressants. So ultimately we give her rituximab, and this is 1 week after the first dose and 1 week after the second dose. She is quite good now also with no new vesicles or bullae. These are the photographs 3 months after the second dose. So rituximab is gradually, we are using it in bullous pemphigoid as well. I do not know whether it will become primary mode of therapy because bullous pemphigoid generally is less severe than pemphigus. But nowadays we are seeing very severe bullous pemphigoid in the elderly, especially in those who are on gliptins. Coming to omalizumab in bullous pemphigoid, High levels of this circulating BP 180 IgE antibodies and total Ig in the serum are correlated with the higher scores, clinical scores of BP patients. So any patients who show a total elevated IgE eosinophil levels or resistant to immunosuppressive therapy with intractable pruritus and have other complications like osteoporosis or infections and you cannot give steroids, these are probably the patients whom you can try omalizumab, although very full-fledged trials are not available, but in these patients with very increased total IgE and intractable pruritus, the patients have shown good response. I have not used omalizumab. I've largely used rituximab in bullous pemphigoid. You give a subcutaneous injection of 300 milligram every 4 weeks or as monotherapy and with varying maintenance time up to 18 months, they have given in various studies. There is an open-label single-group design phase 3 clinical trial which is evaluating combination therapy of rituximab combined with omalizumab in the treatment of bullous pemphigoid. Coming to dupilumab, dupilumab has also been successfully used in refractory BP, especially for relief of intractable itching. In June 2025, dupilumab has been approved for moderate to severe BP, and there is a RCT also which is going on. There are some biologics which are coming up targeting the complement, so I'll just rush through them. This is one of them, sutiminilab, which is a humanized Ig4 monoclonal antibody and specifically inhibits C1s. Avdoralimab, that is a specific antibody against C5AR1. So this also, because this is a specific blocking of the C5A, C5AR1 axis. So these are some of the drugs which can look forward to. Other biologics targeting eosinophils, that is bertolizumab, which is a human monoclonal antibody targeting eotaxin-1, which is involved in the recruitment of eosinophils. So a phase 2 clinical trial is going on and it has an orphan drug designation as per FDA. There are other interleukin-5 inhibitors which are coming up, that is benralizumab and mepolizumab. So we have several investigative techniques on the horizon, especially this biochip technique is very significant, I feel, because that will reduce the cost as well, and when we are in a dilemma of diagnosis, the biochip method will be very, very helpful. And some of these new drugs, especially the anti-CD20 and some of these drugs targeting the complements which have come up, definitely will improve our therapy of bullous, autoimmune bullous disorders. Thank you so much for a patient hearing.
Thank you, Dr. Pujari, for your nice presentation. Any question from the house?
Please identify yourself and then.
So much advances. How to remember all this? Is there any app or something which can tell us that in this case, this thing is going to, so many new things are coming?
Yes, sir. With biologicals, yes, as you would have noticed when I was pronouncing those names also, I was finding it difficult. So it is going to be difficult, sir, but I think with all the biologicals in psoriasis, we have managed quite well. So I think with pemphigus also the same thing will happen. And some of the drugs will fall by the wayside because still these are in the very initial trial stages. So as of now, I don't know of any apps, sir.
Dr. Sheetal, this biochip-based immunofluorescence studies, where are they available? Because
the biochip studies, no, right now they are not available.
Because
yeah.
I tried it
right now they are not available in, as far as autoimmune bullous disorders, they are not available in India. But in hematological disorders, like hemophilia and all, they are already there, biochip-based.
None of these big labs do it.
No, for autoimmune bullous disorders, no. But these biochip-based tests are already in vogue for hematological disorder.
Available
I was
for
not
all
aware.
common vesiculobullous disorders.
It is available, sir.
Yeah,
Achha, I was not aware.
In
sir.
fact, Dr. Kripa Shankar spoke about the biochips.
Okay, sir.
Only
I was not aware, sir.
IgA was not included. I asked him, he said it is available
Okay,
for
sir.
that also.
Okay. I was not aware,
And
sir.
hemoplakin, all that are coming.
I was aware for hematological disorders.
Could you tell us the cost of it? Biochip?
Sir, I think sir will have to answer that question because I was not aware.
And where is it available? No idea. Lal it is.
Outside in Lal laboratories, Kripa said it cost about 8,000 rupees.
Okay,
At
sir.
PSG, about 6 months ago, they were doing at 3,000. But
Okay,
every
sir.
3 months, they increase the rate.
So this biochip has all the 6 antigens or
Yes,
only
all
for
the six,
pemphigus?
all
Okay,
the 6
sir.
antigens. BP you can have, and all the pemphigus you have, all that you can find out. And for EBA,
Okay, sir.
EBA also can be diagnosed. But they don't have for enboplakin. And in his list, he did not include IgA.
Okay, sir. Mhm. Okay.
Thanks, Dr. Pujari.
Thank
Thanks,
you, sir.
madam.
Thank you so much.
Thank you so much, ma'am, for such wonderful session. Now I request our respected chairpersons and speakers to kindly collect their mementos. For the next panel discussion on case-based discussion on pemphigus and pemphigoid, I would like to invite our respected moderator, Dr. Aditi Snehal, ma'am.
Good afternoon, everyone. I would sincerely like to thank the organizing team, especially Shwetlina Pradhan ma'am for giving me this opportunity and for becoming the moderator of such esteemed panel. So for the same, I'll like to call upon stage our panelists, Dr. Jaydev, Dr. Shahrukh, Dr. Rakhi ma'am, Dr. Anidrut sir, and Dr. Nanjunda Swami sir. I have been given such a vast topic on which the discussion can be on the whole day, but I have been given only 30 minutes. So as the treatment has been already discussed in a lot, mainly we'll be centering on the diagnosis part. Thank you, panelists. So should we start? Okay. So first case, I'll be discussing the most common cases which we come across in our ward. So the first case is a 32-year-old female, housewife. She has recurrent painful oral ulcers since for 2 years, on and off, coming and going. For the same, there was a large ulcer, so there's difficulty in swallowing food. Later, now she has, after 1 year, she has started developing multiple flaccid bulla all over the body, which ruptures spontaneously, giving raw areas of erosion. That erosion expands peripherally. There is like 5 times she has developed this flare-up. She has every time given oral steroids from the local practitioners. And only temporary remission is there, but very frequent relapse was present. Now she has developed Cushingoid features like moon faces and facial plethora, central obesity, and buffalo hump. So clearly a case of Cushingoid. So first I'd like to add, any panelist would like to help the PGs to diagnose between the pemphigus and pemphigoid case.
As you explaining in the case, there is a clear-cut history that proceed towards the diagnosis of pemphigus vulgaris. Because as you mentioned, there is vesicle, spontaneous rupture, and spreading periphery. There is oral lesion. So I think in this case, there is no confusion regarding either it's pemphigus vulgaris or bullous pemphigoid.
Yes, ma'am.
As I tell my postgraduate students always that any patient, your diagnosis, your treatment, everything comes when the patient enters your clinic. From the first time when the patient with pemphigus will come, you will smell the fishy odor.
Sure, sir.
That is one thing. There will be a lot of lesions, flaccid bulla with all the hyperpigmentation of the heel lesions, and there will be a lot of oozing. And the patient will be of a younger age group. These are the first thing that you will notice, and then you go for the history. History, most of the bullous pemphigoid will always give a history of an arterial phase. Because a few days back only I went to see a house call of the elderly patient was diagnosed as urticaria and or age-related pruritus, But later on, she developed bullous pemphigoid because it was in the arterial stage, which the other dermatologist couldn't diagnose. So we have to go through a history, ask the patient the history, whether there's arterial phase or when did he start, how did he start, and after it healed, whether there's hyperpigmentation or not. These are the initial things that we should say. And obviously in the bedside, we should always check for Koebner's phenomena, whether whether bulla are flaccid or tense bulla. These all, and then only we'll go for biopsy and DIF. One thing that we should always tell the postgraduate students that whenever you do a biopsy or DIF, first sample should be the DIF, then the biopsy. Because if you use the same instruments, it will always make the DIF wrong if you do it the other way. And then obviously we know what are the reports with the interepidermal bulla split with aconatic cells goes in favor of pemphigus. If it is subbasal split, it goes more in favor of bullous pemphigoid. And then the DIF findings.
One important thing which we should do as bedside is a Zank smear. Something basic. That is something which PGs should know. It's something that's commonly asked as well. And like Sir said, pemphigus will most likely present with oral lesions first, as in this case. There are other bedside tests that can be done. Nikolsky sign is there, Asbo-Hansen sign. Again, these things are things that have to be kept in mind.
I think we did one study on ELISA.
Okay, sir.
Identifying. We used only saliva also, and we got a good result saying that even simple ELISA testing for Ig and antibodies will help in diagnosing without doing all these invasive tests. So it can be used as a corollary. But what about this Zank smear? One thing, sometimes the Zank smear may show you multinucleate giant cells. So very often, especially if you are taking from the oral cavity, you may end up seeing multinucleate giant cells when you do a Zank smear. So you need to be little careful when you do that and interpret it. So that's one thing. Of course, these can also become acantholytic cells later on. So you need to be little careful. So otherwise, the investigations are basically the same. This is one information I just wanted to give you.
Thank you, sir. Anyone would like to add anything? Yeah, so about the history, as sir said, as the patient walks in, so my third year PGs says that मैं तो pemphigus सूंघ के पहचान लेता हूँ. So it has a very typical odor, and all the features are due to the split of the level. So pemphigus is above the basement membrane, so it expands and the lesion do not heal, and it is a persistent lesions. Otherwise, the bullous pemphigoid has the basement membrane to hold the erosions, so the erosions are same as the size of the bulla. Everything else is discussed. There was a very vast discussion before the two about the biologics and rituximab. So how much do we rely on DCP and how much are we going towards the rituximab?
According to our experience, we have already stopped this DCP therapy, owing to its lot of side effects. We had a very bitter and experiences regarding this. So in this patient, rituximab 500 mg monthly once will be most preferable because the patient is already on having moon phases.
Yes.
So just by assessing her stature only, we can better decide the course of the disease. Rituximab will be better.
Okay, so 500 monthly.
500 monthly, 4 months.
There was latest guidelines have given out in December 2024, India's consensus for treatment of pemphigus vulgaris. In that, Dr. Dipankar, they and everyone, Manasa Rajesh and everyone was there. And they have not mentioned anything about DCP. They have clearly got out all the criteria of how to treat mild, moderate, and severe. And they had told that mild can be treated with dapsone, with or without oral corticosteroids and topical corticosteroids. Moderate, they have given moderate with penicillin, and they have mentioned rituximab. They have mentioned that 1 milligram monthly twice, one first day on the 15th day, and there have been reports with 500 milligram first day on the 15th day, but more reports are needed so that. But there have been some studies that have come out that even lower doses of rituximab do also have a play a role and have seen benefits with those. But they have to be more studied so that we and see how much the relapse rate with those lower doses of rituximab give. That is one important thing. And in this case, if the patient is on steroids, first thing that I should always see that whether the patient is still on steroid at the time when the patient comes to me.
Okay.
And if the patient is on steroid, what is the dose of the steroid the patient is having?
Okay.
Whether is the 1 milligram dose or below that, because in severe cases like this, 1 milligram is the dictum, 1 milligram per kg per day. If it is much lower, so like some physicians give a much lower dose, then I can stop it. But if it is 1 milligram, I will not stop it immediately. I will obviously taper it down, and then I will think of other therapy. I will just not stop it because then the HP axis may get hampered.
So what I understood is if the low dose of steroid is given, so you stop it and you give rituximab.
Yes.
That is.
Yeah.
But
And
in
it is very low dose.
very low. Okay.
Some people give 10 milligram, 50 milligram.
Okay. And do we add a adjuvant also with the rituximab, like for because patient was having daily dose steroid, or we are just giving rituximab with no adjuvants?
Now, in this space, I will obviously see the other parameters and then decide whether I'll give it with something else or not.
Okay.
And yes, that is what I will do.
What was the patient on at the time you
she
saw?
was on steroids, sir. She was on steroids.
How
only.
much? How much?
She was on 30 mg steroids.
30
and her
mg.
weight was about
30
70.
mg of prednisolone.
Yes, sir. Yes, sir.
But in this case, there is feature of cussing white is also present, na? Just
Yes,
show me the last previous slide. There is cussing white feature is
Yes,
also
ma'am.
present.
Yes, ma'am.
So if you will give her the high dose of steroid, then there may be a severe, most of the complication may develop.
Yes,
So in this case, taper it now. But still disease is also active.
Yes,
then why not we go for the rituximab after doing the workup for the sepsis?
But ma'am,
I told I will give rituximab, but I will not stop the steroid immediately.
No, we will not stop this steroid immediately, but we can plan after doing the workup for the sepsis, after rule out the sepsis, we can go for the rituximab, and side by side we can also add the other adjuvant, like either if family has been completed, then we can go for the cyclophosphamide or azathioprine, any drug.
Okay, ma'am.
And also do the treatment for the hypertension, diabetes, and other osteoporosis, several features.
Okay. But in our current Indian scenario, so rituximab is very costly. And this patient, it was the same. Like we counseled for the rituximab, but then she said
In that condition, in that condition, you can go for the pulse. In that condition. But that pulse is more better than if you are planning for to give the daily dose of a steroid. Daily dose, how much? If you will plan for 1 milligram per kg body weight.
for daily dose.
For daily dose, then it
But
will go
ma'am,
to the
ma'am,
approx
DCP
40
is
or
also
50.
steroid sparing. So any other panelist would like to add what DCP, if the patient is not taking biologics but for any reason?
Then in that condition, pulse is more better.
Pulse.
Why we will give for 50 or 60 ml steroid per day? Why not go for 1 day pulse therapy to minimize the side effect?
And taper the steroid fast by
Yeah.
doing that. Okay.
But you are giving steroid also in
Yes.
the DC pulse.
Yeah,
You
but
are
sir-
also giving steroid. So it is not that you are not giving steroid. You are giving steroid. No, whether you are giving pulse or not, but you are giving steroid, right?
Yes, sir.
So in sometimes, I'm just giving a practical point of my view. Sometimes even changing the salt also of the steroid does help. So if this lady was taking prednisolone, you switch over to either betamethasone or to dexamethasone also will help sometimes. Of course, you will have to keep the HPA axis issue in your mind when you are about to stop these steroids abruptly. So you need to be little careful about
Madam,
that.
may I add one point if
And
permission?
I just wanted to.
Yes.
There are many people who have used rituximab as a first line among the audience. So I think it's better to take their views also.
Yeah, as sir said, we use rituximab as first line and we have forgotten DCP and yeah, long back. And regarding adjuvant therapy, like azathioprine or cyclophosphamide or mycophenolate, most people are confused. It is not part of the updated S2K guidelines. Dr.
Yes, sir.
Anirudh was mentioning about it.
Yes,
It
sir.
is not there in the guideline and not required also. Before COVID pandemic happened, I used to give azathioprine for 9 months, borrowing the concept from DCP,
Okay,
DCP
sir.
and DAP.
Okay, sir.
After COVID, I have stopped giving, and more than 2/3 of my patients, I have more than 200 patients under treatment,
Yes, sir.
and it is found that rituximab alone is sufficient. Even
Okay.
I use 500 milligrams, not even 1 gram, at a gap of 15 days. So that
Okay.
is sufficient to give good enough remission and no relapses, the same 1/3 of the relapses that you expect in rheumatoid protocol, that much relapse only, so there is no real need. But what I do additionally is I give doxycycline and nicotinamide as an adjuvant rather than the azathioprine, because which can be immunosuppressive. And also it adds to the late onset neutropenia which can be caused by rituximab also. The bone marrow suppression can happen. So that is one point. The second point is regarding one more point was, I missed that I think. So anyway, I'll come back if I remember. Thank you.
Doxycycline works, I think, better in bullous pemphigoid.
Yeah, the same concept I have borrowed here, and in pemphigus also it works very well. Pemphigus also it works very well. And there's no real need of repeat booster doses at 6 months or 1 year as the S2K guidelines go. In India, what we do is we generally wait for the recurrence to happen, and as and when there is a major recurrence happening, we go for repeat dose.
Repeat dose, sir, or maintenance dose?
Maintenance dose, that is. Maintenance dose, like maybe most of the recurrences happen after 1.5 to 2 years.
Yes, sir.
That is the ideal period that happens.
Okay, sir.
Now, how long was the doxycycline or niacinamides were given?
I have given for almost 8-9 months in some patients. Some people require only about 3-4 months of maintenance treatment. And as I mentioned earlier also,
Then they are off drugs.
They are off corticosteroids within a month. Quick tapering.
No. They are off drugs
Off
for
drugs
everything?
completely, and more than 2/3 of them don't even recur.
No supportive treatment
No
at all?
supportive treatment, sir. Up to 60% patients don't even recur, even after one course of rituximab. Some people who recur, once you give the second course, then they don't recur. Very few handful of patients require repeated courses of rituximab.
Sir, doxycycline 100 milligram OD or BD? Sir?
BD. And nicotinamide up to 2 grams, 2 to 3 grams per day. Majority have given 2 grams only. The one factor which I remember now, Dr. Deepankar Dey has done a multinational study along with Enno Schmidt and various other European countries. They found that the desmoglein quantity which is seen in Indian patients is much less compared to the Europeans, and we don't require much of corticosteroid doses. Our corticosteroid dose requirement is much less, as well as rituximab also, the low dose, how it works better in Indian patients is because of the same reason. Some people have given even 100 milligrams per dose, not even 500.
I think in the study they also mentioned that the Europeans are on a higher dose of corticosteroids than us. That's why the relapse is much lesser in them than
Exactly.
us.
They require 4 to 6 months of prednisolone, but our Indian patients don't require that long. And that is my experience as well. They don't require.
Sir, but rituximab takes like some time to act, like as it is.
Hardly 15 days to 1 month. And till that time, you can cover with corticosteroid dose for some time. There's no real need to rush with tapering it.
Okay.
Depending on the patient's condition. Suppose if the severity is still there, you can continue it for some time. And I feel giving DCP pulse before rituximab is also not required. That's my feeling. We can shift over once the septicemia is under control and little bit disease activity control. And once the lesions start drying up, you can start off with rituximab at that point.
Okay, sir. So dealing with the Cushingoid habitus, that is also very common in not even pemphigus in our or daily patients also. So how do we approach a Cushingoid habitus? Do we do a cortisol level? How do we approach it?
I think referral to an endocrinologist is paramount. First thing, it's their domain. We shouldn't interfere much. But of course, we should also daily supplementation of calcium, pantoprazole, all of that has to be kept in mind. The cortisol level should be checked. That will also guide our treatment protocol immediately. Do we really taper the steroids or continue it for a persistent period before shifting onto a steroid-sparing agent?
So like in our case, like Cushingoid habitus is present. So mostly the patient will be having the cortisol level will be. So what should we do a physiological level of steroid?
Yeah, we can start as a dose of physiological 7.5 milligram per kg body weight. We can also go for serum cortisol level.
Yeah, so serum cortisol level, as it is advised, you have to stop the steroid for 72 hours.
Stop steroid for 3 days, then go for the fourth.
So, but this patient will, I think, collapse.
Just for 3 days, it's not so much.
Okay.
The ideal drug to taper the corticosteroids in a Cushingoid patient will be hydrocortisone, which the endocrinologists also prefer, especially when you come down to 7.5 milligrams of prednisolone per day. From that time onwards, you have to convert it into hydrocortisone and take it from there.
Because it's short acting. Okay. So moving on to the next case. So here is a case of pemphigus, first developed oral erosions as fluid-filled lesions, painful oral erosions, difficulty in eating, swallowing food, and then after some time, patient developed very few lesions over the neck area. with erosions expanding peripherally and crusting, everything was present. There was no other lesions over other part of the body, only neck and mild erosions were on the genitalia. So, and scalp was involved. So how do we approach a mild to moderate pemphigus? Like,
in this condition, duration is only 3 months.
yes, ma'am.
But one thing that is important is fast progression. If she never took the oral steroid, then we can start oral steroid in a dose of 1 milligram per
Yes,
kg.
ma'am. She has never taken steroid. She
Then we
came
can
new.
start, because duration is only 3 months. So we can start with oral steroid along with adjuvant. And we wait and watch. If she get response, then it's better. Otherwise, we can plan for other treatment modality.
Okay. Any other panelist would like to add?
If you go to the
That should be the protocol.
If you go to the picture, we can see the first picture, there are
Yes,
more
sir.
than 5 lesions with some gingivitis. There are more than 5 lesions. So we can either start with oral steroids,
Okay, sir.
or we can directly go to rituximab because it's moderate. So that's the protocol that we can start with rituximab 1 milligram, or we can if the patient is affordable, or if we can if the institution based treatment, or you can go for oral steroids. But both will work here.
Okay.
That's what I.
Instead of putting the patient to early corticosteroid usage, if the patients are affordable or the institute provides the medicine, low dose rituximab works very well here.
Low dose, sir, means 500. Okay. Okay, so we kept the patient on, we gave steroid and tapered it fast and kept it on azathioprine, and the patient was fine till date. 3 months has passed and there are no new lesions. So we are keeping her on that.
Opinion about recalcitrant oral lesions?
Yes, sir.
Recalcitrant oral lesions, any opinion from
Sir,
the?
there are 2-3 approaches, sir. One is intralesional corticosteroids, and also like Dr. Deepak Reddy has done a small study on intralesional rituximab also. That also works well, as well as platelet-rich plasma, nicotinamide patches, pilocarpine drops, the epidermal growth factor. These are all some of the agents which can be used.
I think we should again do a further study on intralesional rituximab. That was a very small study, but not followed up by any other further evidence on that.
Yes.
I'm not aware, but that study
Agreed,
I'm
sir.
aware
Agreed.
of that.
Agreed, sir. Yes.
Because intralesional steroids, okay, for a localized area it is fine.
Yeah.
But to a large extent, we need to be little careful. I think. Yes, sir. You can also, of course, you can do that also. Add an antiviral drug along with your protocol.
Agreed,
I have
sir.
done that also, so it has helped in some cases.
Sir, in very, very recalcitrant cases, we should also suspect paraneoplastic pemphigus. These are some of the patients who actually end up in that zone.
Sir, have you tried, sir, intralesional rituximab?
No, I have not tried personally, and I find excellent response with
Ma'am, would
ILS
like-
itself, intralesional steroid itself. It has
Recalcitrant case, we can go for rituximab.
Yes, ma'am.
In our ward, we generally give, and we got good response with rituximab.
We are talking about intralesional.
Intralesional.
They are talking about intralesional.
Oh, intralesional.
So we've tried intralesional rituximab for persistent cutaneous lesions also. Oral is well described.
Yes, ma'am.
Intralesional oral persistent lesions, rituximab is well described, but we have even recently given for when everything heals, 1 or 2 ulcers. You cannot give it. Scalp also it has been described, but we actually gave it on the leg. So that person, earlier somebody had given PRF and everything, it was not responded, but it responded very well to intralesional rituximab.
For 1 or 2 lesion, ma'am.
Only 1 lesion.
1 lesion.
And ma'am, it was only on one patient, or you have tried on many patients?
Multiple session or 1 session, and you got to the result.
We have done 2 sessions.
2 sessions.
वो उसमें बस-
That's good.
Sir, you would like to add something? No. Yes, recalcitrant oral lesions also, after giving rituximab first dose, I have seen like oral lesions take very time to, so if intralesional rituximab works well, so can we give like rituximab 2 doses and then in between also?
That's what we did. So
Okay.
rather than repeating, because it's not indicated, you have
Yes,
to wait
ma'am.
for 6 months.
Yes, ma'am.
And scalp, we have to realize in anything now is being recognized as one of the sites which is usually resistant.
Yes, ma'am.
So rather than giving the systemic thing, it is better to try local.
Sure, sir.
This actually I learned from Professor Devrata Bandyopadhyay.
Yes, sir.
And he has not done a study. But what he taught
that time he used to do. He used to take 2 tablets of betnisol fort, put 2 drops of water,
Okay, sir.
and injection was made. And once this was made, it was applied locally on the lesion.
Okay, sir.
Not patient in history. Twice a day for 10 days. And I'd seen magic with this, magic with all recalcitrant herpes simplex also.
Yes, sir. We also used to do it in our PG course. Yes, sir. Yes, sir.
That is
Very
called
old
as swish and
It's an old modality
spit.
of treatment. Yes, sir.
That is called as swish and spit technique. That is an old one.
Oxycycline, cyclosporin, but this is actually the
But it gives results.
We still doing.
So we are talking about low dose rituximab. So is the relapse really very much with low doses? Because efficacy we know now that it is about the same. So what about relapse with both the regimens? Low doses, ultra low dose. Any panelist would like to take up?
I have absolutely no experience with rituximab.
I also know it because we are not using the low dose regimen. So no idea.
Out of 200 patients where I have treated with 500 milligrams at a gap of 14 days, the relapse rate has been just about 1/3 of the patients, which is equal to a meta-analysis. A large meta-analysis has been done for the rheumatoid protocol. Even that also gives the same recurrence rate, around 38 to 40%. Exactly the same recurrence rate I have seen in 500 mg.
And so the ultra low doses.
Ultra low dose I have not tried.
Regarding this oral lesions not
Yes, sir.
healing,
Yes, sir.
whether it is the pemphigus which is not healing or it is a
The
non-healing
supra-
ulcer over there. So into that, if you go on putting more and more steroids, steroid is going to further delay the wound healing.
Wound healing.
So
Yes,
we
sir.
should not be, no, we don't know why it is not healing, we don't, because pemphigus has subsided elsewhere in the mouth, why the hell that area alone is not going away? So it
Okay,
could be
sir.
some other cause.
Okay,
So
sir.
we should think twice before pushing in steroids.
So then what will you?
I'd like to say something in
Rituximab
response to
sounds
that.
like a good idea. Acyclovir is a good idea.
Okay,
Or
sir.
maybe you could go for cyclosporin or something else. But we definitely know that the epithelialization is delayed by use of steroids.
Okay, sir.
So here, one thing we have to remember is pemphigus actually has what is known as pseudocopners. So, and in India, dental trauma is one of the commonest cause for non-healing oral ulcers. And people just, because our dental care actually is very poor. I've seen in most of our patients, that is the reason for persistence. So you have to take care of the dental, whatever, whether it's sharp cusps, it's that micro trauma that causes for persistence of the lesions. Talking about 500 gram, I have not used lower dose, we use 500. What we've seen is monitoring desmoglein titers. That actually works beautifully. You can predict, we've had patients with one single lesion and a titer of 200 and we have repeated the dose after 6 months.
Okay.
So please, you can do what is known as a triage. So you don't unnecessarily give.
the
It
steroid.
costs only 3,000. It's not very, very expensive.
Okay, ma'am.
Madam, one more thing I want to add here.
Yes,
To reduce that relapse and all, you can add MMF along with this pulse therapy. So you can get the better results with the drug.
Okay, okay, sir. So moving on to the next case. So here a 55-year-old female came with chronic recurrent non-healing mucosal erosions, as can be seen in the photograph. And in history, she does mention few vesicles over the oral lesion, and it rapidly progressed to a hole over her mouth. It was associated with burning sensation. She confirmedly complained of hoarseness of voice. Like it was her first clinical feature, like mera awaaz badal gaya hai. And obviously dysphagia and a foreign body sensation in the throat also. So now she presented with one-sided eye mucosal erythema also, which has been for like 1 month. So how would you like to proceed with this kind of a case? Any panelist would like to take up? Oral erosions.
Like any case, head-to-toe examination is of paramount. See any other skin involvement or not before jumping to, let's say, mucous membrane or cicatricial pemphigoid. Also, what is the nature of the vesicles? Is it tense? Is it flaccid? Healing, non-healing, spreading beyond the margin? Any characteristic arrangement or not? And of course, biopsy and DIF has to be done.
Okay. So Only mucosal.
It's only
involved.
mucosal involvement.
There
So
was
it
no
may be a
lesion.
mucous membrane pemphigoid because eyes is also involvement, the oral involvement, and also there is history of Somita just previous. Yeah, there is in sore throat, epistaxis is also. So there may be a case of mucous membrane pemphigoid because all mucosal
The
involvement.
lesions were very larger and they did not heal at all. Like they were persistent lesions which she was suffering from.
If we see some scarring also, that will
Yes.
also help to come to the diagnosis of whether it is a MMP or it's the initial stage of pemphigus vulgaris. So that's the two differentiators we should always consider. But it looks like because the other mucosa is involved, it goes more favor in MMP, and we should treat in those protocols as we treat MMP.
So do we see hoarseness of voice with pemphigus initial stages only mucosal? Yeah. Can it be there?
Not initial stages. Chronic course, we do see that
Hoarseness of voice. Yes. Okay. So how much helpful is DIF in this case? Like
Not so much, it's a maybe clinical diagnosis because if you will go for the DIF in both the condition in bullous pemphigoid and in mucous membrane pemphigoid, you will get the almost, if you will give her the salt split techniques, then you will get something specific.
DIF will be helpful in differentiating between pemphigus vulgaris and MPP. And we know because then we should be ready with those other protocols. That's the thing which we should see if we do a DIF in this case.
Okay, sir. Sir, and for the PGs, sir, what other conditions with oral involvement with these cases and how to differentiate clinically between them?
So even with bullous pemphigoid, there's around 30% that can come up with oral lesions.
Yes, sir.
So we should also see that. But looking at the patient is younger age, so we should rule out BP.
Okay.
Because that's, and then we should think of the other two diseases that we have already asked. And obviously paraneoplasty pemphigus, but
sir.
there will, body lesions will also be there, and there are other symptoms. Patient looks absolutely all right, so we can rule out that. So these all things, one by one, we should rule out, and then we'll come to a final diagnosis.
You can think of even SLE also in this case, because the mucous membrane conjunctivitis is there, oral lesions are there.
So, but it's very painful.
No, I'm just, she asked me what about the oral lesions.
Yes, sir.
So
yes.
I'm just giving the
DDs.
differential diagnosis.
Yes. So in SLE there will be non-pain.
Yeah, that may be also like pemphigus vulgaris.
And mostly over the hard palate and not noticeable with the patient. Others are LP, which will also have pain, but it will have that lichen
It's
pigmentation.
painful, it's
Yes, ma'am.
painful,
Yes,
it's so
ma'am.
much painful in
Yeah,
SLE.
how would we proceed to treat this case, specifically this case?
Just the last only we talked about how to treat. We can obviously go for
But
this
with
oral steroid.
pemphigoid also like the same.
Mucous membrane pemphigoid, I will obviously go for oral steroids as my first line of treatment.
Okay, sir. Yes, the scarring is can be dreaded.
And obviously, so I will obviously take the ophthalmologist with me.
Dapsone.
Because eyes is involved. Ophthalmologist has to be there with me, and I will start with oral steroids and.
Dapsone is the drug of choice.
Yes.
In this case, we should first try Dapsone.
Dapsone, yes,
Then
sir.
you should
Sure,
go for
sir.
other drugs.
So, but prompt diagnosis and treatment is necessary because there may be chances of stricture and blindness.
Sure, ma'am. So ophthalm, ENT, because epistaxis is also
consultation,
there.
that is mandatory, yeah.
And a gastro also, I think, referral should be done for the patient. Okay, moving on to the next case. So a known case of pemphigus vulgaris with more active lesions, painful erosions present. The patient also has pulmonary TB, okay, and type 2 diabetes mellitus. So what should be done with pemphigus with TB?
Yes, completed ATT horizon. He
No,
is on.
I'll just give you the this
Sir,
one,
so
because this
it's
is my
sir's
case.
case.
So the patient had active TB on ATT, irregular, and he had received rituximab. One dose, had some issues with cardiac bradycardia and something. So the treating physician, dermatologist, told no more rituximab, and patient had such a severe lesion, and of course he was irregular on treatment with steroids also. He was given steroids, but he was not taking, alcoholic for that matter. So all these things added to this patient. So it was a very, very complicated case for us to treat because we didn't want to again go around proving the diagnosis because it was already proven with Zank smear and biopsy and DIF studies. So we didn't want to go around looking for that. So we were in fact, we were very much confused as to what to do with this patient. So I just put this, how the erudite panelist and the members will
Rifampicin is known to cause pemphigus.
yes, sir. That was another issue for us. Rifampicin, they were giving. So rifampicin, so we tried to change that, this one, regime also, but still it did not help. And this patient had a problem with swallowing. Now that's another issue for us. So we had, and when he came, there was absolutely no IV line available for us. So we had to go for a central line treatment. And any opinion by the
and the possibility of overlap between TEN and pemphigus also can be considered because it's an ATT. The drug reaction can be there.
Very common.
So instead of just treating only as pemphigus, we may have to look deeper to find out if there is some other thing that is causing. In which case, maybe we could try IVIG.
So we also looked into that this patient may be going into TEN because of the ATT rather than the pemphigus vulgaris worsening. But the problem was to put the patient on IVIG, which he was unwilling to take because of the cost involved. And we were unwilling to start rituximab because he had a cardiac event post-rituximab. So it was a bit too confusing. So we started him on steroids or systemic steroids also because that was probably the most safest way of treating this patient. So that's what we did. But unfortunately, the patient succumbed after a long fight with this patient. Any other opinion about this, sir, from anyone else?
I think in such patients we should not proceed with rituximab because the area of denudation is so huge, and I feel septicemia may be there, even cutaneous infection may be there active, and of course there is a TB. In other patients whoever is on ATT without these many erosions, so if they have completed the intensive phase 2 months, then also we can consider rituximab. But it's ideal to wait out for the 6 months. 6 months treatment, ideal, but not in these patients. Definitely not in these patients.
The dictum is saying that with these diseases and if the patient is on ATT, oral steroids is the way out. Otherwise, we cannot go for rituximab because the patient is already on ATT.
Correct.
So complete the ATT and then only we can start after 6 months. We can start with rituximab.
After 6 months, ideally after 6 months. Ideally after 6 months, but if
Initiation.
in a stable patient, suppose like the patient is not having these many erosions, no further risk of infection, and also TB is reasonably under control, then we can go after intensive phase, 2 months.
Thank you so much, my panelists, for such a detailed discussion. I personally have learned a lot from the whole discussion. Thank you so much. And thank you, sir.
Thank you, Speaker Ma'am, and our esteemed panelists for such elaborated discussion. I request our speaker and panelists to kindly collect their mementos. For the next session on artificial intelligence in dermatology, I would like to invite our respected chairpersons, Dr. Alka Gupta Ma'am, Dr. Rajat Sarkar, Dr. Amit Singh Bhatia, Dr. Vivaswat Bakaya. For the next session, I would like to invite our speaker, Dr. Sumit Gupta.
Very good afternoon, respected chairpersons and fellow colleagues. I know it's lunchtime, but we have to go ahead. So we are going through the norms with clinical dermatology right now, but a little shift from the paradigm that is AI in dermatology. So what is the biggest shift which is happening right now? And we have to understand this. This is nothing but AI in dermatology. So we know that we were using AI for a long time, unknowingly, but see, we use Google for searching as an engine. We use Google Map also. We use social media platforms. We are using OTT platforms. We are using face recognition to unlock mobile. And we are also using products to buy online. These are all nothing but AI tools. And this AI is expanding so much, so high, that if we do not run with it, forget about walking, we will be left behind in our field as well. So since everyone has an access to AI, so many quacks and even common people are using AI tools for diagnosis and even treatment purpose. You must have known so many people coming to you and they said that, doctor, this is the disease and this is the treatment. Now you are zapped that they are coming up with such great questions that you have to be updated with AI technologies. So it's time for a dermatologist to become smarter and move in the era of artificial intelligence. So there are 4 ways of embracing AI. First is being ignorant and doing nothing, so you will be left behind. It's the time of the artificial intelligence. Second is knowing but doing nothing, not using AI. Third is knowing it and doing something about it. And fourth is creating your own AI. So which level are you in? So if you are in the second level, please move to third level. And if you are third, then move to fourth level. That's the scenario which is right now trending. So let us understand some important tools in AI which can change our thought process. First is a face GPT. It is a personalized facial skin routine by generative AI. So whenever patients come to my clinic, my staff give them their mobile and they say, please scan your face or the problem which you're having. So the patients scan their face and the problem levels come up. So this is the data which they get it, and there are 2 pages of data where we get. So problems are marked over there. You get the dark circles, wrinkles, eye bags, eye wrinkles. Similarly, pigmentation, deep wrinkles, pores and acne. So whatever patient is coming to you, they know more than now that the problem exists much deeper with eye bags or sunken eyelids or whatever the pigmentation is there. So they may interact better with you and they want more treatment for lasers and aesthetics also now. Second AI tool which I can suggest is consensus. It makes scientific research more accessible and efficient. So if we are using this tool, what it does, it allows users to perform specific research tasks and draft content and receive topic overviews, all grounded in scientific literature. And it provides a visual representation of the scientific consensus on yes or no questionnaires by analyzing relevant research papers, helping users grasp the overall direction of finding on a particular topic. So it does a lot of searching engine work and give you a yes or no kind of a tool where you can ask your patient and do a research on a particular project. So this is what we do. On the topic, as if we write, is hyaluronic acid filler safe for patients for autoimmune disease? So what it does, it gives a consensus meter. And on this meter, on the basics of the meter, you can understand the potential for inflammation, immunogenicity, autoimmune reactions. And this way you can do your research work. Third is AI skin analyzer by Perfect. This is all available on your mobile phones. You can just go through them, and this all Perfect, just type Perfect, and you will get that research work. So what it does, AI skin analysis is being done. It can be done on a free basis, or you can charge for that. And it gives out problems like wrinkles, textures, dark circles, redness. And in a high definition analysis, this is a patient which comes to me, and this is a high definition analysis which is done by the this artificial intelligence tool. And at the end, it finds out the problematic areas, like the tear trough is having a problem. So what can be done over there? Like dark circles, so it is written that you might use retinoids or stimulate collagens to stimulate collagen, or if you have moisture is less, you can, it is written that pour yourself a glass of water and drink up, and supplements with daily moisturizers with hyaluronic acids and glycerine and ceramides. So it gives a lot of idea where a patient will understand his problems and can narrate his problems more easier to you, and may come with an overall view where he was lacking with. Now this is most commonly Google Lens, which I think everybody is using nowadays. Google Lens is very common. It is with the Google platform. You can search for skin conditions wherever you have doubts. It gives you the differential diagnosis, and you can just go with the differential diagnosis wherever you are lacking behind. So these were the all tools which are available, but now upcoming tools, and that will simply blow your mind. One is SkinEye. It is an artificial intelligence accuracy to identify skin diseases. So there's a platform, SkinEye. You can use this platform to understand and diagnose a disease. It gives skin analysis in 3 steps. You take a photograph, it assesses the skin health. In a matter of seconds, SkinEye app will analyze skin health and provide you with complete skin analysis. And then patient triage. Whatever doctor you want to refer, it will also help you to understand that this problem is related not just to skin, but endocrinologist has to be involved with, or a urologist has to be involved with. It tells you the triage in which you can consult about this skin disease. So it gives you more than 50 skin lesions that can be detected by AI. And it has a high precision score of 94.7% sensitivity. This is according to the accuracy report of 2022. And it can detect pre-cancer areas, acne, viral skin diseases, mycosis, papillosquamous disorders, skin cancer disorders, you name them, it is there. So this is known as SkinEye MD. Then Elsber have now launched his AI, and this is known as Clinical Key, and answers you can trust. It is a summarized evidence-based answers from detailed, in-depth content backed by citations. So you have citations which are backed up, and you get the evidence-based knowledge that this particular disease is having so many citations behind this.
This is Clinical Key AI.
This is how you
from
have to
Elsevier
use
Health.
it.
With Clinical Key AI, you can enter questions in a conversational manner. This can be simple or complex. Previous conversational search history will be to the left, and sample questions below. When ready to engage, simply type your question and click Ask. It first restates the question, followed by several bullets of information related to the question. It then forms a summary statement substantiating the answer. Content comes from Elsevier and non-Elsevier sources, including leading medical journals, books, clinical overviews, CDC, and more. There are references below to see exactly where the content was drawn from.
So at the end, you get the references also where you can see whatever citation you want to learn from. So if you're new to AI, how can you start as a beginner? AI means ChatGPT initially now. Recently, I'm just reading 2-3 days back that something has new innovative come up, that is Derm GPT. The Derm GPT app is now launched, and I've just downloaded this Derm GPT. You can ask your question from Derm GPT, and there's consensus from all over the internet, and you get the answers from that. So how many of you are using ChatGPT to do your work? I think many of you are doing that. So getting best out of it, you need to become an engineer than a doctor now. So what you have to do, you have to give a prompt. That is a command to execute your desired results. And you need to understand what you want as results. So a bad prompt versus a good prompt you need to understand. Supposingly you want a comparison for hair transplant myths versus fact post. So this is not a so good prompt, but a good prompt will be, we want to educate our audience about common misconceptions surrounding hair transplant. Can you provide an engaging caption that debunks myths and highlights the fact about hair transplant procedures? So this will give you the detailed summary of hair transplantations and myths about it. So most of us are using websites. We all have our websites, I believe. We have a clinical, the clinic's website is always there. But we do not have frequently asked questions, which is there. That is a must for a website to have. Now what it does, when a patient is searching for a question, a frequently asked question helps you to understand that they will directly go to your website to know about this question. So you can give prompts to create frequently asked questions. So you ask to create frequently asked questions about Botox, fillers, and other cosmetic procedures, and not just cosmetic procedures, but also clinical driven questions as well. Last few is, as a dermatologist, you will find it hard to take out time to read lengthy articles or chapters. I believe many of the luminaries are here. They are going through a long reading of chapters, but app has come, sir, to understand this. This is known as Cider. This Cider app is with Gemini, and what it does, it takes out the summary of this whole article and give you as an abstract, which is, you can read it through. The summarized articles comes as an abstract, which is on the corner. So you will give less time to understand what the article means. So we are living in the age of social media, and a present definitely makes an impact in people's minds. So do not shy away from the internet, and you can make your own AIs. For this, Adobe Firefly is one of the creative tools. You can give generative commands that expand it or remove the things which are there. So you can make your own articles out there. And or you can give simply prompt like generative fill or remove background. So you can fill up the background or remove the background as well. So you can give generative fill by adding new objects before there is an empty space. Now you can add up your own tool like a laser or a robot in this case. So where it is useful for before and after image editing and where else? So we have to understand viewers remain 95% of the messages which is watched on the video compared to 10% on the reading text. So a social insider study found that the reels were seen on average rate of 30.81%. That's double the reach of the rate of any other content formats. So if you're forming reels, it's not a bad idea to inform the patients about your work you are doing. Warn is another tool which you can use to create and animations, videos, and use it for public educations and clinic promotions and more. Vions create dynamic videos.
Do you also want to highlight your advanced treatments
last
without the
video.
hassle of video shoots? This tool makes it easy. Step 1. Open any browser on your PC and search for Vion. Then click on Vion AI Video Creation. Step 2. Complete your login process. Step 3. Click on the Create button and choose Create with AI. Step 4. Enter the topic name only and select a layout according to your needs. Here, I am selecting the conversation layout. Step 5. Click on Create a Video. Step 6. After processing, you can make changes to the content, as well as modify characters, their expressions, actions, and any other elements.
You can take
Step
characters,
7.
you make
Afterwards,
your
click
own
on Save and download it.
voice, or you can add your own
Step 8.
messages,
Within
what you
3
want
to
to add
4
over here.
minutes, your video is ready to post.
So this is what at the end it looks like.
Have you ever considered getting laser hair removal treatment?
Yes, I have. But I'm not sure if it's worth it.
Well, did you know that laser hair removal treatment is more effective than traditional hair removal methods?
Really? How so?
Laser hair removal treatment targets hair follicles directly, destroying them and preventing future hair growth.
So this is how you can move ahead. So at the end, I'm sure everyone will be interested to use AI tools as a learning tool, as well as a tool to interact to the public via social media. Thank you so much.
Which paid thing we should go for? Because once you do, they say sign up or pay up. So we don't know whether we are getting into something wrong or how to decide on that.
So first, they have a free tool, or they offer you for a 2 or 3 days free uses of that tool. So if you are going ahead with that and you feel that it is good for you, then you buy that tool.
And what is the approximate rate of those tools?
So everything has a separate rate.
Say ChatGPT, if I want to go to the next level, what will be the rate?
Somewhere around, in dollars it is $100 beyond, $100 to $200 for a subscription for 2 to 3 months, sir.
Thank you, Dr. Gupta, for a very new and very beautiful presentation. Thank you,
sir. Thank you so much.
Thank you, sir, for such wonderful session. I request our respected chairpersons and speaker to kindly collect their mementos. For next session on platelet-rich plasma in alopecia areata, I would like to invite Dr. Lakshman Besra, Dr. P.B. Prabhakar to kindly chair the session. I would like to invite our speaker, Dr. Stiba Hussain.
Good afternoon, everybody. I'll take this is a small discussion, what we have achieved in our OPD. Alopecia areata is a T-cell mediated autoimmune disorder causing non-scarring hair loss with significant psychosocial impact and no universal effective treatment. Intralesional steroid remains the standard of care for patchy. Alopecia areata, but offers only transient suppression, carries a notable relapse rates and risks local adverse effects such as dermal atrophy and hyperpigmentation. Platelet-rich plasma has emerged as a promising steroid-sparing alternative, combining follicular regeneration with perifollicular immune modulation, addressing mechanisms that corticosteroid alone cannot. Despite growing interest, robust and randomized data directly compared activated PRP with intralesional steroid with long-term relapse outcomes and macroscopic endpoints remain limited. This study was designed to bridge that gap. Our aim was to evaluate efficacy of activated intralesional in a patchy AI, compare outcomes with intralesional steroid, determine 12 months relapse-free survival and treatment durability, identify trachoscopic predictors of response. For the study material, prospective randomized double-blind clinical trial conducted over 12 months at the Department of Dermatology at Kathia Medical College. Patients, 40 patients aged 18 to 60 years, patchy alopecia areata, randomized and monthly session for 6 months. Inclusion criteria included age, which was between 18 and 60, clinically diagnosed patchy alopecia areata, SALT score 10 to 50, no treatment in the preceding 3 months. Exclusion criteria include alopecia totalis, pregnancy or lactation, platelet disorders, active scalp infection, systemic steroid using in preceding 3 months. This is the two group A and group B, and the primary outcome measures for the was SALT score changes at 6 months, and secondary trachoscopic hair density patient global assessment 12 months relapse rate. This is a slide showing that PRP achieved a mean SALT reduction of 58.4 versus 42.1%. Difference between groups was statistically significant. Complete regrowth 65% in PRP group versus 40% in intralesional group. 12 months relapse-free survival 72% in PRP group versus 47% in intralesion steroid. Trachoscopic hair density gain, PRP group gain 18.4 follicular units versus 11.2 with the other group. Trachoscopic predictor of response, low baseline yellow dot density predicted non-response in the PRP group. This is a slide showing the efficacy. Next. Next slide. The adverse effect, PRP was associated with only transient erythema and pain in 35%, resolving spontaneously. No atrophy or hyperpigmentation was observed in PRP group. In intralesional group caused injection site atrophy in 20%, hyperpigmentation in 10% of the patient. Overall, PRP demonstrated a significantly more favorable safety profile. Discussion means that the superior efficacy reflects its multifactorial mechanism, acting both on follicular regeneration and perifollicular immune modulation beyond the purely anti-inflammatory effect of the steroid. Calcium chloride activation ensures standardized growth factor relapse consistent with 2025 meta-analytic evidence favoring activated PRP formulations. Superior relapse-free survival rate suggests PRP has a disease-modifying potential rather than mere suppression. Low baseline yellow density on trachoscopy serves as a partial predictor for patient selection and counseling. Absence of atrophy and hyperpigmentation makes PRP a safer option for a long term, especially in young patients. To conclude, activated PRP is superior over the steroid efficacy, durability, and safety in patchy alopecia. It's a disease-modifying potential and a favorable adverse effect profile make it a viable steroid-sparing alternative. Baseline yellow density on trachoscopy is a useful predictor of response. Multi-center trials with standardized protocols are warranted to validate these findings. Thank you.
Thank you, ma'am, for the wonderful talk. Any questions from the audience?
Thank you.
Then we'll conclude the talk here.
Thank you so much, ma'am, for such wonderful session. I request our respected chairperson and speaker to kindly collect their mementos. For the next session on evolving paradigms in the medical
I would request our speaker and chairpersons to kindly collect their mementos. Because we were running a little late of time, we would skip the lunch. If anyone wants to go and do it, they can do it on the day. And we will continue with the session. For the next session, I would like to call upon our chairpersons, Dr. Gyandev Verma sir and Dr. Shudhanshu Singh sir, to kindly call upon our next speaker, who would start the Melanin Matters Pigmentary Disorder session.
Hello. Our new next topic is evolving paradigm in the medical management of vitiligo. I invite Dr. Rishi Parashar from Delhi to take.
My talk, sir. Dr. Vikas? Yeah. Not here. It will. You can do this. Yeah. Okay. Great. Good afternoon, everyone. I think there's a slight glitch, where's my talk?
Sir, there is a slight technical difficulty. Just give us 2 minutes.
Always happens with me.
No,
so
sir.
I thank
Special
the
people, special
10th
moments.
10th Clinicon. Huh? मैं दूं फिर से? Right. In the meantime, Dr. Kripa is doing the Kripa of taking my photographs. Right. So, yeah, it's there. Right. ये लाइटें आँख में आ रही हैं हाँ. Thank you all. Thank you, Dr. Vikas Shankar. Thank you, Dr. Singh. Thank you, everyone, for giving me the opportunity to give a talk here in this August forum. And it's not every day that I'm invited to such a high mic. So the talk I have to give is evolving paradigms in the management of vitiligo. We know vitiligo, various times in life, destroys life. Apart from any other skin problem, does not have that kind of an impact on the patient's life. The quality of life is totally gone. The career, the social standing, totally gone. No matter how much we teach the patient, very difficult. This is me. Vitiligo is a chronic disease, and this slide I just wanted to show, there seems to be a belt from Punjab till Gujarat, which seems to have more vitiligo than rest of India. This was one of the things that I wanted to pull up for you guys. We all know the classification, and the etiology is a khichdi of genetics, autoimmunity, oxidative stress, and neural hypothesis, especially for the segmental vitiligo. Most of the vitiligo that I tell my patients is autoimmune. Sometimes can go. This is the convergence theory. These are sort of terminologies which are there to look pseudo-intellectual. You join all of them and call it the convergence theory, right? And you can print a paper. So, lately, interferon alpha and JAK, STAT signaling axis, creates a self-amplifying vicious cycle of inflammation leading to destruction of melanocytes. This was something new which came up. So we needed JAK-STAT inhibitors. And we have to also know that vitiligo, whether it carries a lot of comorbidities like the thyroid disease, and in women, if you see on the right side, thyroid, family history, duration of vitiligo, and disease extent, they all matter as to how you would take care of the vitiligo. I'm not going into the semantics right now, how to deal with the patient. I'm talking about the newer paradigms. We all know management should be for stopping the vitiligo, arresting the disease, and maybe repigment. Easier said than done. Treatment of segmental vitiligo, I'm talking about the topical corticosteroid and topical immune modulators, narrowband UVB, lamps that we all have and we should have. And if the disease is stable and there is leukotrichia, no activity in 12 months, then we can go in for various surgical techniques. I'm fast forwarding these slides. Non-segmental vitiligo, we can use targeted phototherapy, plus minus systemic antioxidants, and calcipotriol can be used. Various other topical immunomodulators can be used, the tacrolimus, the pimecrolimus, and I use a lot of Soralin. I'm slightly old-fashioned. I use a lot of narrowband UVB on my patients, but these have a problem because there's a significant gap between what the patient wants and what we've been able to provide since decades. And we know steroids, they can cause havoc. We have a ITATSA in dermatology which tells us what is wrong with long-term steroid use. Phototherapy requires 2 to 3 sessions. I tend to lose my patients, they lose interest. Calcineurin inhibitor, variable. Pimecrolimus almost never works apart from genital areas or the eyelids, but I have never seen it work. And surgical techniques carry a lot of, we are still living in India and we should have the realities with us. What were the recent advances in vitiligo? And what are the new upcoming treatments is what my talk is all about. Recently, the most promising agent has been the ruxolitinib cream. I don't know how many of us have used it, but ruxolitinib seemed to make the vitiligo much better because if you can see, the true V1, V2 studies were done with the JAK1, JAK2 inhibitor, and you can see the improvement over 1 year, and the patient seemed to recover very, very fast. And prolonged ruxolitinib treatment in patients for up to 1 to 2 years carried no side effect. So they saw a lot of improvement in facial vitiligo, which was something new, which was not happening. And they showed robust, if you see the last line, robust, repigmentation amongst the patients later on also. So just when we thought the vitiligo had become stable, the vitiligo showed some response. So this is one of the things that I want you to carry from my talk, that ruxolitinib would be the compound for the future. Now this is Dr. Amit Pandya. We all know him. He did a study on povorcitinib in vitiligo. This is still in stages, and he also found over 1 year, you can see the improvement in vitiligo, which was significant. Upadacitinib, we all know it is now available in the Indian market and it is not very expensive. It is almost the other abrocitinib and other things that we were using for atopic dermatitis have almost gone out of the market because of this molecule, but works very well for vitiligo. And they saw that it worked very well for non-segmental vitiligo. And this study was done over about almost a year. And it showed no adverse cardiac events. The MACE was not there with this, and it was very, very safe. So whatever doubts we had about other JAK inhibitors, upadacitinib, I think how many of us are using, it is a safe molecule, and it is, we have to see that cost to benefit analysis is very good for a country like India. Rituximab is another thing that I have never used, but it is still available abroad as Litfulo, and a lot of studies have been done, and it was seen that facial repigmentation especially, till now it has been studied for the facial repigmentation, is one of the, some of my patients tell me, Doc Sahab, leave aside my arms and legs and every hidden area, I want my face to be bettered. I think these things are working very well for the face. And again, baricitinib, which we've been using very, very extensively for other things, they saw that narrowband UVB with baricitinib seems to work very well. So combination is the king paradigm, works for this kind of a condition. I'm just fast forwarding because then comes jack of all, according to me, something which is being sold all over India as a toffee. Almost for every goddamn thing in the world, tofacitinib. But we have to know that tofacitinib, along with phototherapy, narrowband UVB, works magic. So we have to know all these baricitinib, tofacitinib, they seem to work better. And topical tofacitinib cream is available in India. It is not available in many parts of the world. I use it. I use it along with the tacrolimus or the pimecrolimus in my patients so that we do not cause the steroid atrophy and telangiectasia. It's a steroid sparer, so works well. Then there's something called ivarmecitinib. I don't know how to pronounce it. This was started in China and it is seemingly very good. I think all the studies which come out of China, just like the country, are questionable because when it comes in their journals, they use a lot of adjectives to explain it, and it seems to be very excellent according to them. Then we have the afamelanotide, and this activates the melanocortin-1 receptor, and it is used as an implant, 16 milligram implant. I do not know how to use these things, but these are the newer paradigms and seems to work very well. And when again it was used along with the narrowband UVB, seemed to work better. So we do not know right now whether the drug is working very well or the narrowband UVB is working. Whenever we mix and match, this is a problem that we face. Which one worked and which one did not, which is the dominant partner and which is not. Anyway, decapeptides have been here for a long time, and the beta FGF fibroblast growth factor stimulates the melanocyte activation, migration and repigmentation, and in combination with tacrolimus or phototherapy seems to work very well. And I have seen in my patients who are smaller areas, when we use the roll-on stick on the facial areas, seems to work. I do not use it on the lid area because it irritates. Otherwise, I think all of us have been using this molecule. I wish it was cheaper and we had a bigger package. Even the XL pack is only 10 ml. This is a photograph of vitiligo. Then we have the abatacept. This is again marketed as Orencia abroad, and it is actually FDA approved for rheumatoid arthritis. Again, the proposed mechanism of action is prevents the T cell attack on the melanocytes. So again, one means the moment we are having the JAK inhibitors and the biologics, we should know there will be a lot of crossover, and not only one disease accidentally, the other disease will also start showing improvement because of the way they work. PD-1 ligand, which is the programmed death ligand 1, has been studied for psoriasis actually, and it's a critical immune brake that maintains the tolerance to self-antigens, including those on melanocytes. So something which we can say with confidence works against the autoimmune aspect of vitiligo. This is why the etiopathogenesis is important. Genetic, autoimmune, then you have the oxidant, and then you have the neural hypothesis. So all these things they are trying to target now, and we have shown some kind of a movement in the last 5 years, which was not there for decades on to end. So it's supposed to be better for autoimmune destruction. Rapamycin, commonly called sirolimus, works on the mTORC1 pathway, which is the mammalian target for rapamycin complex, and protective mechanism against the oxidative stress, especially the hydrogen peroxide induced damage to the melanocytes. So it has a dual ability to stop the autoimmune attack and potentially stimulate the return of the skin pigment, which is there. Sirolimus is, I don't know if it has come to India, Dr. Kripa, has it come to India? Not come, right. So we have amongst us somebody who's been using most of these molecules. Honorable mentions would be oral vitamin D, E, and C. I personally do not know whether these work. The pharmaceutical, the medical reps, they come to us and they name certain very dubious studies and dubious journals, and they seem to work in certain cases. These are all, according to me, anecdotal evidences. I haven't seen this oral cocktail of vitamins ever working on vitiligo in any one of my patients. At best, we can call it a adjuvant. Simvastatin again, we use it as a statin, and it has a pleiotropic effect. That means benefits that go beyond the typical cholesterol lowering and reduces the autoimmune response. Again, something that we can study, but these would fall in realm of science fiction as far as I am concerned right now, when we have so many promising molecules which are there. So with this, I round up my talk about the newer paradigms in medical management of vitiligo. Thank you very much. Of course, we have the apremilast and other stuff, and you can go through with the slides. Thank you very much. Huh?
Patient, what do you prefer, tofacitinib or UPA?
Upada I have started using very recently. For vitiligo, practically none. So whenever we are given a challenge of giving such talks, this is where the learning for the speaker also begins. I had used it for other things, not for, but I've used tofacitinib, and tofa I think is a very hyped up drug according to me. Very, very, very hyped up for every kind of a disease. I think upadacitinib is a drug which carries much more promise as far as the Indian market is concerned, and it has almost put the abrocitinib out of the market because of all the superior results. Yes.
Yeah, so I can just share my experience. I've used it. They were coexisting with severe atopic dermatitis.
Yeah.
So they did really well on vitiligo also, upadacitinib. So it does well, and it's selective. So you can always go to that.
Thank you, sir. It was very nice session.
Thank you very much, both of you, for giving me a chance to stand on this august podium. Thank you,
sir.
Thank you, sir. We would like to request the speaker and the chairpersons to collect their token of appreciation. For the next session, I would like to call Dr. Ajay Kedia and Dr. Pradeep Kumar on the stage. Dr. Ajay Kedia and Dr. Pradeep Kumar.
So I would like to say, sir, you can start the sessions, and Dr. Chatterjee, sir, and for the topic non-melasma facial hyperpigmentation, a practical approach. Please, sir, go ahead, sir.
Thank you. I'm just waiting for my PPT to load. Someone else's. So till the time the PPT is uploaded,
Thank you, respected chairperson, for the kind introduction. The esteemed chairperson has already put up a nice prologue for my topic, because facial hyperpigmentation is a matter of great psychosocial concern for the patients, and that is the reason this is one of the most common complaints for which patients visit a dermatologist. And till now, we have made significant advancements regarding understanding of the pathogenesis, classification or diagnostic criteria for as far as melasma is concerned. But that doesn't hold true for the other conditions, because there are a truckload of indications, and most of the times they are present in the same patient either in concurrence, or the diagnostic criteria and their pathogenesis are not clearly identified. So I would like to, for the sake of the brevity, I would like to limit my presentation with the diagnosis of these conditions and how we can differentiate them from each other only. Treatment will be discussed by my esteemed colleagues in further lectures. So, dawn melasma facial melanosis, or in short we can call it as NMFM. So through this lecture I would like to first give an introduction of what is non-melasma facial melanosis, try to give a working classification, a feasible classification useful for your clinics, diagnostic overview of the majority of the common and uncommon conditions, a diagnostic approach through investigations, and a few take-home messages. So introduction has already been made, so let's straight away jump into classification. This is the most practical approach where we can classify the disorders into developmental and acquired conditions, aphylides or freckles and lentigens, periorbital hyperpigmentation, nevus of Ooty and the variants, pigmented transverse nasal band, pigmentary demarcation line or PDL, and erythromelanosis follicularis et fasciae, of fasciae et coli, or face and neck, as you can say, according to your convenience. These are mostly the developmental disorders, whereas PIH, acquired dermal macular hyperpigmentation, this is actually an umbrella term, we'll delve into it a little later. Peribuccal pigmentation, exogenous ochronosis, acanthosis nigricans, maturational hyperpigmentation, Addisonian pigmentation, and seborrheic melanosis, facial frictional melanosis, poikiloderma of civet, and erythromelanosis interfollicularis coli, post-chikungunya pigmentation, and macular amyloidosis are some other conditions. So acquired dermal macular hyperpigmentation is basically an umbrella term which covers three entities: lichen planus pigmentosus, Reals melanosis or pigmented contact dermatitis, and ashy dermatosis or erythema dyschromicum perstans. They are a little different, which we will take on later. So freckles and lentigens are very common. All of you must be encountering in your day-to-day practice. As we well know, freckles are mostly seen in younger individuals with more fairer skin, and they fade in winter and gradually disappear with advancement of age. In contrast with lentigens, which are mostly seen in more aged people over sun-exposed skin. And pathogenesis-wise, in freckles, there is increase in number as well as size of the melanocytes, whereas in case of lentigens, the melanocytes only increase in size. So post-inflammatory pigmentation is an acquired facial melanosis which comes as a sequelae of various inflammatory disorders like acne, drug reactions, phototoxic response, infections, trauma, allergic reactions to procedures, as well as other disorders. More seen in darker skin, and mostly presents as macular pigmentation at the site of previous insult. No specific dermoscopic features, and maybe non-specific brownish dots and globules with a pseudo-reticular pigment network. As we can see, do I have a pointer? Yeah. So this we can easily identify. It was an old case of tinea. The patient applied ditranol, and that led to post-inflammatory pigmentation. So now acquired dermal macular hypermelanosis consists of LPP, Reels melanosis and acidermatosis. All three present with kind of dark gray to dark brown reticular or diffuse pigmentation with, which may also be patchy. Either are ill to well defined, and often history of previous applications like mustard oil, amla oil, cosmetics in case of LPP, and cosmetics, fragrances in case of Reels melanosis, and ammonium nitrate and other contrast media in case of acidermatosis are seen. Histopathological changes are more or less same in all the three entities. Basically, we see a dermal hypermelanosis as well as basal layer changes. And a dermoscopy, whereas LPP shows a dark brown and bluish gray dots and globules arranged in reticular, pseudo-reticular or heme-like pattern. The Reels melanosis presents with brown and blue-gray pigment globules in a pseudo-reticular kind of network. These are the main difference. Globules are fine and smaller in size than LPP. There is superimposition of brown dots which are characteristic, and other findings are a perifollicular halo. Whereas in case of acidermatosis, the small gray-blue dots and globules are irregularly organized in linear and circular fashion. So on our left, where you can see a classical case of lichen planus pigmentosus, you can see a bluish black pigmentation and kind of reticular network involving the ear pinna also, whereas the other picture shows a Reels melanosis or pigmented contact dermatitis due to hair dye. Peribuccal pigmentation of Brock, mostly seen in middle-aged women, characterized by diffuse brown-red pigmentation symmetrically around the mouth but sparing of the vermilion border, may extend up to the temples, forehead and angles of jaw. Mostly due to photodynamic component of the cosmetics, the fluctuant erythema and persistent pigmentation are the characteristic features. Dermoscopy shows dark brown reticular to heme-like pattern. So this is a classical case of peribuccal pigmentation of Brock. Sometimes they may appear as contact dermatitis due to lipsticks or chewing gums also, or as a sequelae of perioral dermatitis. Periorbital hyperpigmentation seen in young adult women, also may be seen in elderly. The light to dark colored brownish black pigmentation surrounding the eyelids. Heredity, atopy, excessive vascularity, aging have been incriminated. This is a classical case. Nevus of Ooty and variant, all of you are well aware, it's oculodermal oculodermal melanocytosis. But I'd like to just stress on the one point, whereas the pattern of blue-gray pigmentation of the area supplied by ophthalmic and maxillary division of trigeminal nerve are well known to each other. In contrast to popular belief, the abnorm or bilateral nevus of Ooty-like macules or hoary nevus, which we used to think that it can be differentiated with nevus of Ooty due to lack of mucosal involvement, it is not true these days, because there have been several case reports where hoary nevus has presented with palatal pigmentation. So fusiform elongated dendritic melanocytes and melanophages are seen histopathologically, while as this picture shows the classical nevus of Ooty. The other picture is the hoary nevus or acquired bilateral nevus of Ooty-like macules. Exogenous ochronosis, a very common entity encountered by all of you due to long-term application of hydroquinone, particularly the alcoholic solution, and in excess of 2% of strength. Characterized by deposition of homogenesic acid, ochre-colored pigment in the skin, asymptomatic blue-black macules on photoexposed area, especially malar area, temples. Dermoscopy shows dark grayish-brown globules arranged in annular and arciform pattern, giving curvilinear and worm-like structure at places. Confetti-like depigmentation and multiple telangiectasias may also be seen due to often admixture of hydroquinone with topical steroids, which causes pigmentary dyschromia. Acanthosis nigricans, it is the latest clinical marker for metabolic syndrome. The skin is characterized by facial acanthosis nigricans, typically rough, dry, verrucous, chamois leather-like skin. Moreover, malar and zygomatic areas, often associated with involvement of other typical areas, seen in young adult obese males, or they may present in non-obese individuals also. This is early clinical indicator for insulin resistance, metabolic syndrome, and diabetes mellitus. Dermoscopy shows multiple cristae and sulci, hyperpigmented dots or streaks of white. This you can see along with facial involvement, there is pigmentation of the neck band area also. Maturational hyperpigmentation, this is a more of a recently described entity characterized by diffuse pigmentation generally occurring on the lateral forehead and cheekbones. It is more of a diagnosis of exclusion due to lack of specific diagnostic criteria. But chronic sun exposure has been incriminated, typically seen in Fitzpatrick skin types 5 and 6. Asymptomatic granular hyperpigmentation and typical granular pattern on palpation is characteristic. Dermoscopy shows non-specific pattern excepting multiple scattered brown colored dots and globules, circular to oval shaped brown rings with perifollicular accentuation. So, seen in both age groups, you can very well appreciate the classical granularity over the pigmented area, the malar area. Addisonian pigmentation due to primary adrenal insufficiency, also associated with mucosal pigmentation. Dermoscopy shows accentuated, sir, is my time over? Okay. Dermoscopy shows accentuated pigmentary network. Seborrheic melanosis, a pretty common entity, localized darkening of seborrheic areas of face like most commonly the alar grooves, angle of the mouth, labiomental crease, and associated or preceded by scaling. More often seen in young females, dermoscopy shows prominent pseudo network, which is typical with all seborrheic disorders, linear and arborizing vessels over the light pink background, whitish yellow excrescences erupting from the vellus hair, dilated follicular openings with plugs. You can see the typical involvement of scaling and pigmentation of the alar grooves and the labiomental creases. Once the patient kind of purses his lips, then they become more prominent. Facial frictional melanosis occurs due to vigorous rubbing or cleaning of face and pigmentation, and also due to beauty parlor procedures like facial scrubbing. Usually a distinct vertical linear band of sparing is seen in the middle of the forehead, sparing of apex of nose, which stood out in contrast of the surrounding hypermelanosis. These two are the characteristic features. Dermoscopy shows accentuated pseudo-pigment network and irregularly placed globules. And patulous follicular openings are seen due to repeated rubbing. You can see the characteristic sparing of the midline of the forehead. Pigmentary demarcation lines, usually they're physiological, sharp transitions. 5 types have been identified, which are typical of the body, type A, B, C, D, and E. A is more on the upper arm, B for the lower limb, and C, D, and E on the torso. Whereas for facial pigmentary demarcation lines, they have been classified as 3 types. The F type shows a V-shaped hyperpigmented patch. G type shows W-shaped hyperpigmented patch on the lateral aspect of the face, and the H type shows linear bands of pigmentation extending from just below the angle of the mouth to the lateral aspect of chin. This will be well clear. You can see the F, the V-shaped pigmentation, G, the W-shaped pigmentation, and the H, the from the angle of the mouth. Extending from the, in the picture, you can see a kind of F-shaped line. Poikiloderma of civet is a well-known entity, mottled hyperpigmentation with atrophic hyperpigmentation with telangiectasia over the sun-exposed areas of the face. The main differential diagnosis should be steroid-induced rosacea and topical steroid-damaged face. The dermoscopy shows a combination of linear and dotted vessels, areas of linear telangiectasias forming, I'll wrap up in 1 minute. Forming rhomboidal or polygonal vascular structures, light brown structureless dots and globules, white keratotic follicular pluggings. Erythromelanosis follicularis of fasciae et coli. This is a developmental disorder, mostly seen in middle-aged males and sometimes in adult females. It is also associated with keratosis pilaris, so vitamin A deficiency has to be looked upon. And alopecia characteristically affects the fine vellus hair and spares the terminal hair. Dermoscopy is not very substantial. Post-chikungunya pigmentation, very important, shows centrofacial freckle-like macules, diffuse hyperpigmentation of the face and extremities, flagellate pigmentation, pigmentation of the existing acne. This is a very characteristic feature, and a distinct pigmentation over the nose known as the cheek sign. Dermoscopy shows prominent pseudoreticular network with perifollicular sparing. And as you can see the typical accentuated pigmentation of the nose or the characteristic cheek sign. So just going briefly, history, age of the patient, age of presentation, onset, duration will determine your diagnosis. History of exposure to cosmetics will lead your diagnosis more towards ochronosis or pigmented contact dermatitis or Reals melanosis. History of prolonged sun exposure, history of diabetes, past history of infections like dengue, tuberculosis, trauma, personal history of diet, family history of autoimmune disorders, and treatment history. Examination includes typically the nature of pigmentation like color, pattern, sites and extent of mucosal involvement, involvement of eye, nail, palms and soles, genitalia, dermoscopy of course, investigations as per the causes and suspected syndromes, like skin biopsy, if there is a diagnostic dilemma, patch test, particularly important in contact dermatitis, thyroid function tests, HbA1c, lipid profile, and the fasting insulin level, of course. So take-home messages, non-melasma facial pigmentation poses a significant dermatological concern, particularly in skin of color, remain under-recognized and poorly understood, leading to diagnostic and therapeutic challenges. Reinforced clinical awareness is required and a deeper understanding of their pathogenesis. Standardized diagnostic criteria and evidence-based treatment protocols are essential. I have no conflict of interest. I am obliged to Dr. Dibyendu Basu for some of the clinical photographs, and written informed consent has been obtained from all the patients for the usage of their photographs and anonymity. These are my references. Thank you, and I'd like to thank the organizing committee of Clinicon for giving me this opportunity.
Okay, sir. Any questions from audience? And sir, I want to ask one thing. So, is there any psychological impact of these disease on the patients? Although these disease is being in a patients for a very long period of time, although they are getting treatments and not getting results, and they are ultimately impacting their social and psychological life.
Yes, definitely, sir. In the very beginning, as we discussed, due to the profound psychosocial impact only, this is the most common concern for the patients to come to a dermatologist, and probably to non-dermatologists that might aggravate these conditions. And because involvement of the face as we can say, is the mirror of our mind and body, and it definitely affects their regular well-being, leads to kind of social isolation as well as family isolation, but difficulties in marriage, difficulties in their married life. But as we have right now what should I say, well-documented studies regarding the psychosocial impact of melasma in Indian women as well as in other races. All these non-melasma facial hyperpigmentation and the psychosocial impact has probably not been studied to the similar depth. That is the only thing.
Thank you, sir, for the informative talk. Thank you so much.
Thank you, sir, for simplifying such a complex topic. I request our chairpersons and speaker to collect their mementos. So the other side. For the next session, I would like to invite chairpersons, Dr. Om Prakash sir, onto the stage, Dr. Ovung and Dr. Rakesh SV. requesting Dr. Shivangi Singh to come to the stage, please.
Hello. Good afternoon, everyone. Our next topic is on melasma, basics to innovation. So I would like to request my colleague to introduce our speaker.
Yeah, we have a very interesting session, a nightmare for most of us dermatologists when we have to deal with the many times realistic expectations of this treatment. So it's Dr. Shivangi will be speaking to us on treatment of melasma from basics to innovations. Is there a CV of Dr. Shivangi or? Can you project the CV of Dr. Shivangi? No, okay. Okay. You can start, I think.
Thank you, sir, for the introduction. Good afternoon, everyone. So I'll be talking about the treatment of melasma, basics to innovation. So I'll be talking about the 2026 latest clinical updates. The session will include the updated pathogenesis understanding with the dermal epidermal crosstalk model, and it has to be contrasted with the first line therapy, that is topical corticosteroid versus novel non-hydroquinone agents for efficacy and safety. And then we'll see the review systematic topical and oral tranexamic acid protocols from 2024-2025 meta-analysis, followed by discussion on some procedural synergy with the latest laser technologies. And lastly, we'll talk about the present practical clinical decision algorithms. So understanding the melasma pathogenesis, earlier we all know that melasma has been a burden for so many people, not only in the form of a disease but also because of the psychosocial impact it creates on the patient. We all know that the prevalence is 1% in general population, but in specific predisposed group who are having OCPs or in pregnancy, the prevalence rises from 9 to 50%. So phenotypic classification of melasma is epidermal, where we see brown patches, well-defined borders; dermal melasma, where we see bluish-gray, poorly defined borders; and mixed, where we see combination of both. So the updated pathogenesis model has shown us that the triggers were earlier called as UV rays, hormones, reactive oxygen species, heats and genetics, but we have seen that high intensity visible light is also aggravating melasma. And the environmental factor triggers has been pollution, drugs and cosmetic use. Now these triggers, what they do is that they secrete melanogenic cytokines at the keratinocyte level with the help of endothelin-1, stem cell factor and KGF, which causes melanocyte activation. This is followed by disruption of basement membrane, where the basement membrane breakdown occurs, which releases to matrix metalloproteinases 2 and matrix metalloproteinases 9. Now this in return affects our dermal microenvironment, where the senescent fibroblasts and mast cell, they together activates and then creates a pro-melanogenic milieu. And this is followed by endothelial and melanocytic signaling, where VEGF is secreted and that increases the growth of blood vessels at the hyperpigmentation level. So the outcome what we see is melanocyte hyperactivity at epidermal level, followed by melanin persistence, and there is relapse propensity. So the gold standard is triple combination cream, which we were using from day one. It is the basic one. We'll compare the newer non-hydroquinone creams with the present triple combination creams. So we all know that the combination and composition of mechanism of triple combination cream includes hydroquinone 4%, which is a tyrosinase inhibitors, which block hydroquinone blocks the tyrosinase enzyme, which leads to inhibition of melanin synthesis. The tretinoin in it increases the keratinocyte turnover, which accelerates the cell turnover and promote the pigment dispersion. And the mild topical steroid, that is fluocinolone 0.01%, it acts as an anti-inflammatory, reduces the post-inflammatory hyperpigmentation. The limitation and risk associated with the topical corticosteroid use is irritation followed by steroid-induced atrophy, and prolonged use can cause ochronosis and rebound pigmentation. Efficacy data says that the onset of action is about 4 to 8 weeks, and there is significant reduction in MASI score by 60 to 75%. So at present, the clinical role says that if a patient is tolerant to topical corticosteroid combination, then it has to be used as a primary drug for 8 to 12 weeks at once application at bedtime, and it has to be shifted to maintenance therapy containing non-hydroquinone topicals with photoprotection in the form of SPF 50+ and visible light protection. Innovation, we have non-hydroquinone topicals where we'll be comparing thymidol, cysteamine and 30% topical metformin, which is currently not available, but then it has been prepared by some pharmaceutical companies. So thymidol 0.1 to 0.2%, the mechanism of action, it is a potent human tyrosinase inhibitor which directly inhibits the melanin synthesis. Its efficacy has been seen to be 85% and the speed of recovery is 70%. It is well tolerated in patient, and it is comparable to hydroquinone with superior tolerability. And in 2025 randomized control trial, it is seen that it shows level 2 evidence and is ideal for maintenance and can be used as a first line also. Coming to cysteamine, which is available in 5 to 10%, it inhibits multiple melanogenesis pathway and affect both tyrosinase activity and melanin transfer with the efficacy of 80% and speed of recovery about 70%. The tolerability is good, and short contact protocol is available with the level of evidence 2 to 3, and nano formulations are emerging just to avoid the irritation because of the prolonged contact period. So coming to topical metformin 30%, it downregulates the PKCB or anti-inflammatory and cyclic AMP pathway. Its efficacy has been comparable to topical corticosteroid with an efficacy of 82%, and the speed has been 78%. The tolerability is excellent, and there has been comparable study with the topical corticosteroid where it has been found efficacy is similar to topical corticosteroid, and the side effects were minimal as compared to the topical corticosteroid, and it was non-inferior to topical corticosteroid at 8 weeks. Fewer adverse events were seen as compared to topical corticosteroid in the form of mild irritation and stinging. Systemic therapy, we have been using tranexamic acid in refractory cases of melasma. So the evidence-based dosing protocol and safety profile was there from 2024 and 2025 meta-analysis, where it was recommended to use topical and oral tranexamic acid in refractory and recurrent melasma as an adjunct to the topical or first-line therapy. The optimal dosage says that it has to be used 250 milligram TDS for 12 weeks. But because of the various side effects, we have to adhere it to 250 milligram BD for 12 weeks, and the maintenance has been given as 250 milligram OD for 8 to 12 weeks. The efficacy data says that there has been improvement in MASI scores in 82%, and at a period of 4 to 16 weeks, and there was 75% patient satisfaction. Key findings is that according to IGTVL 2023 network meta-analysis, it shows that 750 milligram per day of oral tranexamic acid for 12 weeks is optimal as an adjunct therapy. So before prescribing oral tranexamic acid, we have to screen for various vascular thromboembolic risk in the patient. We have to rule out any history of thrombophilia or any estrogen or OCP's therapy. Common adverse effect associated with tranexamic acid is GI upset and hypomenorrhea. Contraindications are pregnancy, breastfeeding, and active thromboembolism. And we have to monitor CBC and renal function if we have to give it for more than 6 weeks. Practical use, the clinical recommendation has been 8 to 12 weeks course with or without repeated dose after 3 to 6 months if required, along with strict photo protection with the help of a sunscreen of SPF 50+ and visible light protection. And it can be primed with topical tranexamic acid before starting the oral one, and we have to monitor for the side effect and adjust the dose if needed. So procedural synergy, we have so many procedures, but the newer procedures which are recommended for melasma treatment as an adjunct therapy, we'll talk about that. So coming to lasers, we have low fluence picosecond laser with the wavelength of 730 nanometer or 1064 nanometer which has been used, and it has shows that Marcy reduction was there with a lower recurrence rate, and the parameters used with the lasers were of low fluence with the largest spot size of 8 to 10 millimeter at an interval of 4 to 6 weeks. The key benefits is that it can be combined with oral or topical treatment for enhanced result, and it has a lower recurrence as compared to Q-switch Nd:YAG laser which we were using earlier, and it is safer for darker skin types. The newer laser which is said to be promising in melasma treatment is 1927 nanometer thulium laser. It targets epidermal and dermal junction pigment, and it improves the texture and dyspigmentation. The target is epidermal and dermal junction pigment, and it has to be performed like the other lasers at an interval of 4 to 6 weeks. It improves the skin texture and tone, and it has to be paired with antioxidants or oral tranexamic acid. Then we have exosomes and probiotics also. This has been used in few studies as a post procedure and an adjunct, where adipocyte-derived exosome has been used. And what it does, it targets reepithelialization, it acts as an anti-inflammatory and anti-melanogenic signals, and there is reduction in melanin and erythema. The clinical use, as I said, it has been used as an adjunct, non-monotherapy, and it has to be, we have to give something to apply post-procedure for enhanced recovery. So we'll lastly see the clinical matrix, which is evidence-based pathway for melasma management. So for the diagnosis and classification, first we have to confirm the diagnosis, then we have to classify the type of melasma with the help of Woods lamp if available into epidermal, dermal or mixed type, and then we have to assess the severity. The first line treatment has been, if the patient is hydroquinone tolerant, the topical corticosteroid was recommended as a first line for 8 to 12 weeks, and if the patient is intolerant, then the non-hydroquinone based treatment like thymidol 0.2% or cysteamine 5 to 10% has been tried. For special population like in a pregnant female and lactation women, azelaic acid and niacinamide are safe to use. If the patient doesn't respond to the first line treatment, then we move on to the refractory management, where we add oral tranexamic acid 250 milligram BD or TID depending upon the patient tolerability before screening for any risk factor. Now, if the patient is again not responding to the treatments available, then we can add the procedural treatment in the form of chemical peels or the newer lasers which are present, and it has to be followed by maintenance therapy in the form of a non-hydroquinone based topicals with strict photoprotection and sunscreen of SPF 30 or more. So this is a treatment matrix where we assess the severity, and in mild to moderate cases, we give topical monotherapy or a combination therapy. And if it is of moderate to severe variety, then we add topical corticosteroid plus some procedure or oral tranexamic acid. And in refractory cases, systemic tranexamic acid has to be added along with the topicals with or without advanced procedures. So there has been a recent case study where the refractory melasma was compared to the topical corticosteroid treatment, where the patient profile was 45-year-old female with a Fitzpatrick 5, centrofacial melasma with a 3-year duration. The topical corticosteroid treatment in that patient was failed when it was used for 6 months, and 4% hydroquinone was also used for 8 months. The severity score at baseline was 12.4. Intervention and outcome shows that if after the use of 30% topical metformin with sunscreen, at 12 weeks there was 45% improvement in the severity, and at 24 weeks there was 65% sustained improvement at 6-month follow-up. So we can consider this drug. These are the references. Thank you for your patience hearing.
Thank you, Dr. Sivani.
Thank you, sir.
A very good lecture from you. Any query from outside? Oh, nothing.
Okay. Can I ask something?
Yes.
I just want to know, excellent talk, by the way, very structured and all. I just want to know if there are any clinical markers for knowing if if there is an inflammatory component of melasma.
So we'll first see clinically we can see that there can be erythema and the pigmentation would be.
Now, Indian skin, we may not see
With the
erythema
help of
as such.
dermatoscope, we can see for the
Dermoscope,
yes.
excellent. Yeah.
With the help of dermatoscope, we can differentiate all the kinds of melasma. So in that, we can differentiate whether it is an active melasma or the patient has used any kind of topical, maybe it is steroid, and then we can see the telangiectasias over there, the follicular dots, the black dots in the perifollicular areas because of
I think it's very important that first you identify the inflammatory part before you embark on any treatment as such. I think rapid darkening on patient says the melasma becomes darker immediately on even mild exposure to sun, even that could be a sign of the inflammatory component. Then ill-defined margins, all of them. And sometimes, very rarely, they come burning or stinging sensation also. Thank you.
Okay, thank you very much, Sivani.
Thank you. I request our chairpersons and speaker to kindly collect their memento. For the next session, I would like to invite the chairpersons, Dr. Chinmay Raj, Dr. Pankaj Kumar Agarwal, and Dr. Monica Upadhyay ma'am on stage. Dr. Chinmay Raj, Dr. Monica Upadhyay, Dr. Pankaj Kumar Agarwal, can we have the CV slide for our next speaker, please?
Now I call Dr. C.R. Srinivas on the stage. A brief introduction.
I'll start, sir.
Moving forward, sir, you may start with the topic pigmented contact dermatitis. Sir.
Thank you, Dr. Agrawal. Very happy to be here. Like in Tamil we have this karpuda enakku pudicha color, and God is most of the places is black, but then pigmentation is not so acceptable, and it causes a lot of social concern for a person, especially when they develop pigmentation on the face. That is why so much talk on melasma and all we are having. And then in our color, in our skin, the contrast is often striking, especially when a person becomes little darker and when they go out in the sun, the effect of tanning is much more. So the difference is more marked. And it is a type of non-eczematous contact. By contact dermatitis, we mean that mostly there will be oozing, itching and all. But this is a non-eczematous contact dermatitis, which is the pigmented contact dermatitis. And this occurs very slowly over a period of time. In other words, if you do patch testing, sometimes you may not detect the allergen. The allergen takes a long time to induce the pigmentation. And after you withdraw the pigmentation, it takes a long time to resolve. Unlike other contact dermatitis, where it resolves. So some of the terms which is used, acquired dermal macular hyperpigmentation, is the commonly used term now. I don't much like it because it is not telling us the etiology of it. Two conditions of totally different etiology brought under one roof, not to my liking, but then that is, or you can use the word pigmented contact dermatitis and lichen planus pigmentosus.
It occurs basically on the lateral part of the face. You'll get reticular blotchy pigmentation in the middle-aged women, the age where it matters most, where the husband is trying to run away. You'll find that the wife is very much disturbed by this. Kahan bhag jayega banda? She doesn't know how lucky if he runs away. Then, of course, we have the term was given by Reels and Gustav Riehl, an Austrian. I don't know how many of you have been to Austria. Austria is the place, one of the best museums and the best learning in the medicine. They got wax museum of the entire body you can see over there. Given a chance, go to Austria and see the museum over there. And there's a lot of, and Omsbergman was the person who coined this term. And it is Nakayama, and then subsequently Hayakawa, who was a close friend of mine, she and myself, we had discussed about the pigmented contact dermatitis, and way back we have shared the antigens for doing patch testing. Face, as I said, is the most common site. There are many things which is responsible. This is a little difficult to read, so let us leave it. Then we have it is multifactorial. Like what we say is, we say allergic contact dermatitis. It is not just contact. It is something much more than contact. There is an allergy over there. There is an irritation over there. Once an allergy occurs, the threshold for irritation comes over there. Once the irritation occurs, the threshold of causing allergy increases. And then there is friction over there. Many people will rub that site. There is sweat over there. There is sunlight over there. All these factors are responsible. So when you are treating these patients, you will have to address all these issues. So you see, friction, person, very useful thing to scratch, and you will find the pigmentation over there. And this also sometimes hides the fungal infection also. And then on the forehead is the site, men and women. In case of women, it is very, very difficult to tell them not to wear bindi. In case of men, many of them accept that. And you can see that unlike the lichen planus pigmentosus, this lichenoid dermatitis or the contact dermatitis will often be more palpable, will start from the place where it evolves. For example, kumkum, it will start here, hair dye, and then it will spread to the other places, whereas LPP will occur randomly all over the body. This is to the dye. This is patch tested positive to fragrance mix. This is the positive patch test to kumkum. Kumkum is nothing but haldi and lime. And to that many dyes are added. So these are some of the positive patch tests we have got in the pigmented contact dermatitis. And myself and Dr. Lal, we had worked with turmeric, where we were even reported the positive patch test to turmeric. So just because we think that turmeric is very, very useful, it does not cause dermatitis. Turmeric also can cause allergy. Then we have done various studies we have done for patch testing. I will come to that later once again. This is an interesting case which came to my clinic about few days before I came over here. She came, she had pigment. One of the important things about taking history is keep quiet over there. Observe the patient. Let the patient talk. As the patient talks, they will drop pearls. From that you will learn as to what is the cause. So give them some time to express themselves. This lady went on telling, I went on asking, hey, you did that, you did this. Then she said, finally she said she had given spray for the white ant. So that came nearly after 7 to 8 minutes of just sitting and talking to her various things. So she had used this spray, and this spray is a terminator, and it has got certain chemicals in that, which on examination we found that is a photosensitizer. We did not do patch test with that since we don't have the proper concentration for doing the patch test, and we should not do that way. Then one of the very common things is allergic contact dermatitis to counter irritants. We hardly think about it. Patient will come with dermatitis here, on the nose, various things, and this has got multiple, and we have done patch test with the various antigens, plant materials in that, and we can hit positivity in that. The counter irritants is one of the very common cause. See? Wicks, headache, they'll go on rubbing, contact dermatitis to wicks. Then after rubbing here, they will rub here for making sure the throat also is well. So for many of this, time is the most important thing. We'll have to gain time. Usually I tell a story, but today no time to tell a story. So these are the other things for prevention. We can tell CAP and all. Patch testing is essential.
We can also do photo patch test. We have started a study on photo patch test now. We have completely combined the antigens with Renita of Chennai, with Kims of Bhubaneswar. We are doing a combined study. Then dermoscopy will give you some information regarding the level of patch, where the pigmentation is, the color of pigmentation. But the most important thing which you look for when you are doing that is to look for erythema. If erythema is there, then tranexamic acid will work. So when you're looking for pigmentation, not only look for the level of the pigmentation, see if erythema is there. If erythema is there, tranexamic acid will work. These are the various things which you have got: temple, kumkum, henna positive. And we had done a study. Now, one other thing is, most of the pigmentation is following the interface dermatitis. Interface dermatitis means the pigmentation is there in the dermis. All the drugs that act in the skin will act only at the epidermal level. It will prevent synthesis, it will prevent transfer, it will increase exfoliation. But what if the pigment is there in the dermis? Nothing will work except laser. So then we thought, why should we think only of the epidermal approach? Let us think what we can do at the dermis. Why should I reduce? Can I bleach it? So we thought as to what are the common bleaching agents which are available. Can I use that bleaching agent to bleach the pigment in the dermis? And with that we came up with the idea of benzyl peroxide. Benzyl peroxide is a good bleach, and we bleached, we can see the hair incubated in benzyl peroxide get bleached. Then we did a study wherein it's a bleaching agent, powerful bleaching agent. And then we did this on 2 patients we did with LPP, bilateral on 2. On one side we applied benzyl peroxide, on the other side we didn't. And then we found that at the side, after about 6 months or so, at the site where we had applied the benzyl peroxide, the pigmentation was less apparent. And if we continue with that, maybe it can improve. So that was the one which we had published. Then we had done another study on 30 patients at KIMS, wherein we did the patch testing. In that we added the kumkum and the various things that is available for patch testing on the photo exposed areas. This is the distribution you can see. And these are the various allergens which you are able to get: PPD, fragrance milks, multiple allergens. And then quite often you will get to what the patient brings. The patient will bring the chemicals with them. It is very easy to do patch testing. If the thing is for general use, you don't need to do anything. You can apply as is. If it is a concentrated irritant, then there is a protocol for that, which is totally different. So how do you manage this pigmented contact dermatitis? As I told you, a good history, listening to the patient, trying to find out what is the cause, tell them to some of the common errors which they will likely to rub the face, and then remember that all the things which are given for protection can also cause, sunscreen can itself cause allergic contact dermatitis. And now you don't know, for example, we are talking fungal infection and itching. We have reported lot of antifungals causing allergic contact dermatitis. Likewise, the topical which are used can itself be the cause of the allergic contact dermatitis. Hydroquinone can cause itching and burning, and that can further add to the dermatitis. And today, peeling is off your, everybody goes and gets themselves peeled, and when you peel, you remove the stratum corneum, and when you remove the stratum corneum, the barrier goes off, and whatever you apply over there can cause irritation and allergy. So be careful. You are going to see, you are going to create pigmented contact dermatitis, and then you are going to treat pigmented contact dermatitis. So, but eventually many of these patients improve. They come to us in a very sad state. You can tell them that all this pigmented contact dermatitis, especially the LPP and all, will improve over a period of time. Time is the one that matters. Hold their hands, go on giving the treatment, and they will improve. Thank you very much.
Thank you so much, sir, for the enlightening session. Is there any question from the audience?
Sir, in a large number of your patients that you reported, you saw that, in fact, PPD was the leading. Were all these patients with PPD who had pigmented contact dermatitis, was it preceded by an eczematous phase?
It need not happen with pigmented contact dermatitis with dye, hair dye. Hair dye will cause 2 types of sensitization. One, there will be eczematization where there will be erythema, oozing and all. Other, there is no eczematization. That is a sort of the non-eczematous type of allergic contact dermatitis that is caused by the PPD.
Because the reason why I ask, sir, is, of course, this is not a question, this is an observation, if you permit me. Can I go ahead and make an
Please,
observation?
please.
Because I have patch tested lots of patients who come positive to PPD but have never had an eczematous phase. And then I find that actually they cross-react to parabens in the products that they use. However, while they show a positive reaction to PPD in the patch test, they show no reaction to paraben mix itself.
Very true.
So I take it as an extrapolation. I get them to bring all their stuff in a bag and look through the ingredients. Of course, these days Google, you can get the ingredients of all the products. And then I systematically eliminate all those products they are using which contain paraben topically, and over a period of 6 months or so, they respond with a physical sunscreen.
Very possible. But there is also another thing known as the paraben paradox, wherein a person may be allergic to paraben, but they may not react.
Yeah, thank you, sir, for sensitization. What is your experience in pediatric age group related to pigmented contact dermatitis?
Fortunately, pigmented in pediatric age group, it is not all that common. It is relatively very, very uncommon seeing pigmentation, which we often see post-inflammatory following some disease like LE and this thing. Even lichen planus pigmentosus, I don't think I've seen much in case of children. Allergic contact dermatitis can occur in children, not that it cannot occur, but I have not seen this sort of pigment. As I said, lichenoid, this sort of non-eczematous pigmented contact dermatitis occurs after a long time, 10 years, 15 years, 20 years. After that it appears. So this child has got time to develop.
Any reasons for that less incidence?
That's what I'm telling you. That this is the sort of pigmentation wherein probably the sensitization occurs slowly over a period of time.
The duration.
Yeah.
Good afternoon, sir. Thank you for the excellent, crisp talk, sir. So I just want to know, have you come across cases of pigmented contact dermatitis or cosmetic dermatitis related to Neelamari, indigo blue? Because I happen to see quite in fact, it seems to be much more common and it doesn't cause any irritant contact dermatitis. So it's like, it's an incidence onset. And Neelamari, they apply it in oil and they apply it regularly. Lot of other methodology for application also. Have you come across them? Have you practiced it?
What is happening is, many of them, they buy indigo. And this indigo, they buy from a shop who is selling indigo. People will buy indigo from that shop only if he mixes PPD, otherwise hair won't get black. So quite often you will find that the indigo which they buy has been already adulterated with the hair dye. So what you should tell them is not to use the indigo powder, but to buy the indigo leaf on Amazon, crush that and use. The leaf is unlikely to get adulterated. Same thing for henna. So I have done patch test with indigo. I have not got any positive patch test.
So one more question, sir. So last 20, I've been a dermatologist for 25 years. If I look at the number of cases of LPP or pigmented cosmetic dermatitis, it has gone up by leaps and bounds in the past 25 years. I'm sure, do you agree with me on
Very
that,
true,
sir?
very true.
Any reason other than the increased use of cosmetics, any other reason you think you can attribute
I
it
think increased use of cosmetic is the reason. Is the reason as to why there is so much amount of increased pigmentation. Maybe people's outdoor activity and those sort of things. Pollution might be another reason as to why that is occurring. There are a lot of antigens in pollution, and pollution also is increasing day by day. Maybe all that is contributing.
I ask this question because many people who come with LPP, you ask them, many of them actually tell they have never used any cosmetic in their life. So
yeah, especially if a female tells that, don't believe.
Okay. Thank
Sir, have you tried OMP in LPP?
I used to, madam, but nowadays I don't. Because OMP is something when you want a quick result. So in LPP, which is going to be a very long drawn process, there is no reason for giving steroids. We can go for agents which is going to act slowly over a period of time. Maybe isotretinoin, acitretin, or even metronidazole or methotrexate. These can be given in a slow dose over a long period of time. And we buy the time before itself. We tell them it's going to take 6 months to 1 year to 2 years.
Sir, just two quick comments. Just one is why everyone is having a PCD nowadays is now because most of the 18 years old boys and girls, you will see that they are dyeing their hair, number one. And number two is that regarding this last question is that ये जो colors है, so the colors are always the henna, and this is a very common observation. We have also noted that if they are alpine, the leaves they don't have.
Yeah, but then you cannot.
Marketed henna is.
So what you tell the patient is that plug the leaf, make a paste yourself. Don't even trust your sister or sister-in-law.
Unfortunately, it is not available.
Yeah.
Henna leaves.
Henna leaves are available. The साग वाला वहाँ पर henna बेचता है. उससे बोल देगा ना, वो लेके आएगा.
Now, I would like to end the session. Thank you, sir. Thank you so much. Now we will move to the next session.
Thank you, sir, for your wonderful signature talk. I request our chairpersons and speaker to collect their mementos. For the next session, I would like to invite Dr. D.K. Patel, sir, Dr. Dinesh Ranjan Panda, sir, Dr. Purushottama SM, sir, on stage. Can we have the CV of the next speaker, please?
So, this is due to some changes in the program. So there is some reshuffling is there. Now we are going with Manoj Kumar Ram. He's a very, interesting person from Cuttack. He always keeps smiling, and he is a MBBS MD. Apart from that, he is a medical officer in Department of DVL. And he has gone with so many, bias cases, and always be able to give support to anywhere, in fact. That is a great thing that he is having. And he is going to have some talks, and my colleagues will be going to give you some.
Sir will be talking on updates in patch testing. Over to you, sir.
Thank you, respected chairperson, sirs, respected audience. At the outset, I would like to thank Abhishek Bhai, Bikasan, BP Roy sir, Siparnam, Svetlina, who have invited me to speak some of my work in before you. So patch testing. So what's new? These are the standard set of slides. So basic refresher is it detects type 4 type of delayed hypersensitivity reaction. Allergens applied to bag for 48 hours. Readings after 2 days, it may be 3 to 4 days also. Scored using ICD-10 grading, we generally use Indian Standard Series. So this is me in a nutshell, doing patch test with Indian Standard Series and having the results. So if you are doing patch tests for long, everybody knows about patch testing, so why this topic and why here? As we know, patch test still remains the gold standard for diagnosis of allergic contact dermatitis. But in the field of contact dermatitis, as Srinivas, the pioneer and my teacher in patch testing and contact dermatitis told, the rising trend, every day we are seeing a different type of presentation leads to a different type of allergens. So there must be need for modernization of indications, modernization of techniques, modernization of isolation of antigens, application of antigens, taking readings, use of AI. There are a lot of slides, we will go through simple and important ones. So in our OPD, patients such, if they come, eczematous patch on the cheek with a young girl, as Prasad said, pigmented lesion on the cheek of a young male. This lesion, most probably you can say it's allergic contact dermatitis or irritant contact dermatitis, to be more specific, contact depigmentation, construction worker. If we see through these cases, what the idea strikes to us, number one is relieving the patient of his problems, then trying to isolate the causes. So along with chronic and recurrent dermatitis and occupational dermatitis, as sir also told, cosmetic dermatitis is a new indication. It's an indication every clinician who is seeing the young patient, maybe a old patient, this cosmetic dermatitis should never be left out. Drug-related delayed hypersensitivity in special cases and atopic dermatitis which are atypical, which are resistant, which doesn't fit into the standard category. Regarding implant and device-related reactions, dental materials, orthopedic implants, cardiac devices, now slowly it is coming under scrutiny with patch test dermatologists. Leg ulcers, we are seeing leg ulcers every day in our OPD, hyperpigmented ulcers with stasis dermatitis, swollen foot. Now, can it be a contact allergy to topical medications, the dressing material used, or the antiseptics they are using? Unexplained generalized dermatitis, where we find a person having severe itching, not responding to anything, then we must think of a standard patch test. So after the indications comes what's new in the allergens. As you know, Indian standard series we do. There is extended Indian standard series if available currently. When I was doing research in AIMS, the footwear series was there, cosmetic series was there, dental series was there. So there are so many series, but the most noticeable is fragrance mix. And to tell you the truth, quite some time before, Srinivas had told regarding fragrances, everybody remembers that aftershave, no? That aftershave, anybody remembers musk ambre, Old Spice, you should not take the name. Anyhow, so that started the journey of fragrance contact allergy. And methyl isothiazolinone is a synthetic preservative in toothpaste, cosmetic creams, dishwash bars. They are the new allergens. Acrylates in nail and cosmetic industry. Even I am surprised nowadays my daughter uses a long nails. What are these nails? These are synthetic nails, you can dispose of them. They are acrylic, no, that I have seen with my own eyes. So they are new textile dyes, regional variations. So we need to update. We need to update. So antigen selection, we know the screening patch test. The most important line in this is the patient products. Never, never, ever forget to use the patient products and along with the Indian standard series. You are applying Indian standard series the back, you can apply the patient broad things on the arms. So as we know, solids are applied direct, you can scratch the dust of it. Liquids, patient has brought a hand wash, you can dilute it 10 times, take a drop, put it in a piece of paper, blotting paper, put it in the aluminum chamber and fix it. Ortho implants, this is new. In few cases in clinics also I seeing eczematous reaction above the incision size where the implants are there. So we are patch testing it and research is still going on, many papers are also there. Fragrance patch test, the most problem in the fragrance patch test is the fragrance goes away. You don't find the fragrance after so many days. So you can use a freshly made fragrance which is difficult, or you can use the fragrance mix which comes in a liquid form. You have to keep it sealed, just put a drop of the paper in the aluminum chamber, you can fix it. Dental materials, so we have got so many articles, but one case I particularly remember when doing my fellowship of code fee under V.K. Sharma sir in AIMS New Delhi, we had a patient with a burning mouth syndrome. Nothing could alleviate his difficulty. Then V.K. sir told me, Manoj, iska to patch test karao. Then he came positive, we did the ISS and we scrapped the denture. He was wearing the dentures and we put it in the arm. The denture came positive. Then sir told me, go to the dental department and read contact notice by Fisher and find out an alternative. So Fisher's right, vulcanized rubber. Luckily, vulcanized rubber was available in names. A next set of denture was made, the patient was given, and the burning pain simply vanished. That's the beauty of patch tests. Tattoo allergy. Nowadays everybody comes with a tattoo here, there are semi-permanent tattoos, permanent tattoos, 1 to 2 days tattoos. So it's difficult to patch test tattoo allergies because they contain hundreds and hundreds of synthetic colors. So many colors is very difficult to predict, but you can always do a ISS series
This is very important, cosmetic allergy. Along in Indian standard series, you use the patient brought things. What he or she is using, sunscreens. The patient जनरेटर सर मैंने तो कुछ लगाती नहीं sunscreen. मैंने कुछ cosmetic use ही नहीं करती. But she uses a face wash, she uses 2 to 3 types of sunscreens, she uses serums, she uses so many things. So you test them. In chronic urticaria, reports suggest nickel and balsam of Peru may do have occult sensitivity, but practically I have not found it. Advances technique. This is very nice. We do patch test, right? We clean the back, we put the patches in. Strip patch test means you use that micropore, you just apply to the full length and strip. Not like the girls in beauty waves must be in the waxing procedure. You apply and you strip. 3 to 4 times you strip it to remove the superficial layers. That area will be slightly erythematous. In that condition, you apply the patch test. Some antigens may be unable to cross the intact skin barrier. They will give you a positive result here. Atopy patch test. Type 1 allergens known to elicit Ig-mediated hypersensitive reactions. Sometimes it helps, can be used as a diagnostic tool. This is our favorite photo patch test. You apply 2 sets. One you irradiate it with UV light, one you do not irradiate with. In a typical sun allergy case, PLE case, actinic dermatitis case, this gives good result. And these are markings. Now, before going to this, let me show you a small video. Can you play the video? Flowers have gone. Now we want to remove the patches. So we'll remove this is how we remove additional micropores first. Now comes the crucial moment. Before remove out the patch, I am using a simple skin marker, white marker. Mark it. This is the number 1 allergen. The most difficult part is remembering now which allergen is put where. So like draw a border line, mark the corners, then you remove and cross check. So this after removal becomes a little bit messy. So I'll let you know how to mark, how to remove and how to take readings. So now we have marked. This is the standard procedure I was talking about. Carefully. And you join the dots. This has to go into bio-waste. So this is what we do. And this is the different types of markings with a permanent pen marker, surgical marker. When I was a postgraduate doing my thesis on patch testing, we used Jensen violets. And this is the marking using the patch test mapping system. These are the recent ones. The video says the old school method which we still use today. And the correct selection of vehicles, currently it is petrol atom, which we are trying. I mean the contact dermatitis group is trying to update. Extraction methods. This is basically for research purposes, how you extract hydrophilic allergens, lipophilic allergens, solid substances, metals, like that. This is a beautiful publication, flower antigen extraction. The patient comes with fingertip allergy, mostly in the right hand or the dominant hand. You see a non-specific allergy spanning over years together. You think of patient, an elderly patient, lady or gents, must be there plucking flowers. So this is how you can readily extract the flower antigens. These are the newer chambers. We use thin chambers made up of aluminum. Now there are IQ chambers, there are Vanderbilt chambers, the chamber X, and this is the empty tablet cover can be used to patch test. There are publications regarding this, and this is the true test. It was available sometime back in India. We also used it, ready to use. This is chamber X, and this is published by Handa sir, and this is by our own Srinivas sir, to preload the allergen trays, keep them in fridge, 5 to 6 allergen trays. Whenever the patient comes, it can be quickly applied because loading the chambers is the most difficult time consuming part. Reading, standard reading is taken 48 hours. You can take a delayed reading. The patient may not come every day to you for next 7 days. So what we do, we ask them to take a photograph, send in WhatsApp. Sometimes this delayed reading catches hold of these weak positives. The right time to read. This is a tape reaction. One of our patients developed widespread erythematous reaction. This is due to the allergy to the tape, the marking tape that you use. So use of hypoallergenic pepper 10 can be used. Special situations, like Sir has also told, children, we do not routinely do patch testing in children, elderly, pregnancy, and nowadays people are coming with biologics in their prescription for patch test. So in children, so the future directions will be molecular allergology, AI-assisted interpretation. What we do, we sit 2 feet apart, look at the back, remove the patches, keep the patient seated for next half an hour. After the pressure wears off, we take the reading. Here AI can help us. So practically all patients should be tested with Indian Standard Series, their own products. And as usual, the take-home message, the hunt for the ideal patch test still continues. And the greatest abuse of patch testing is failure to use the test. Welcome to Midnamakon 2026, Bhubaneswar, September 11, 12, 13. Thank you.
So, any questions from house? So, Dr. Ram, if the house is not having any questions, I would like to have one thing, particularly that all the standards, protocols, it is a very old one that we are following it. Is there anything new which is being, say, visualized or you are thinking about?
So the testing with Indian Standard Series that I have been doing for last 25 years, there is extended Indian Standard Series which takes into account the photo patch test, some fragrance, some footwear series also. And there's a photo patch test which is new, although it's old, but still we consider new. But you got to have the right equipments in an institute to conduct that photo patch test. Patient self-bringing material like solids you can apply directly. Like he has brought a soap, we can simply scrub with a blade and that can be used for a patch test. But if it has come with a liquid one, we have to dilute it at least 10 times. And research is still being done to take up new patch test series, and they have to be quantified by ICDIG group and in India also the Contact and Occupational Dermatologist Forum, that's a code fee. Once it is standardized, then only we can use it.
And second thing, particularly that use go on extracting that from that organic things. It's antigen, say, means you are making yourself. How you get the standard of that?
Yes, sir. This is basically the patient's own product. We simply scrap the solid. Now, it's not standardized, but it gives a hint of actually if the allergy is allergic contact dermatitis 1, then if the patient comes positive to that extract, then we are going to look into the constituents of that soap. And if, as far as possible, if the constituents are available separately, particularly in institutes, we can directly test them.
No, you see that particularly we are very much concerned about that qualitative and quantitative standard. Particularly the extraction of that antigens, that if you go on increasing its strength, it will behave something different.
It will produce an irritant contact
reaction. In a diluent matter, it could be something different.
But irritant contact reactions will tend to burn more, sir. And they will be noticeably more in the first 6 to 8 hours. But the allergic ones will tend to itch more. And they will be obvious regarding the second 48 hours or 96 hours. That is our practical experience.
You don't think that false negative and false positive perspective is?
Yes, sir. That will definitely come. Then there comes the experience of the doctor or the dermatologist who is doing it. And if there is any case which is really needs discussion, that can be forwarded to us also. We can take it of the code fee discussion group also. There we can go better insights also. But those are very rare, sir.
Can I come in on that? Here.
Yes, sir. Sir.
Yeah. we can do two types of extraction. One is an alcoholic extraction or acetone extraction, and or sometimes even aqueous extract. Once you make the extract, then you have to dilute it. You make various dilutions of it. 1 in 1000, 1 in 500, 1 in 100, 1%, 0.05%, various dilutions. And then initially you try without any occlusion, you try the ones. And then you put the various dilutions and find out in which one you are getting the allergic dermatitis. That will give you an answer. Second is, if you're still in doubt, you have to do on 10 controls. With this same thing, you will have to test on 10 controls. And if the 10 controls, 8 or 9 test positive, that means it is an irritant reaction. If nobody tests positive, then most commonly, possibly it is allergic type of reaction. For soaps and all cleansers, we do 1 in 10 dilution. That means 1 drop of soap with 9 drops of water. You do that and then do the patch testing.
Thank you, sir, for a very wonderful talk. And you have left us with a new thought on molecular allergology.
Yes, sir, that's new in line.
That is for the future. Thank you very much.
Thank you, sir. Thank you.
Thank you, sir, for a very interesting talk. This concludes our session on dermatitis and dermatology. We'll move on to the next session on trichology. And I would like to invite Dr. M.K. Sinha and Dr. Amlan Shome onto the stage for the next session.
Good evening, everyone. So we are moving to our next session, and that begins the session of trichology. We have today with us Dr. Sri Parna Dev. She would be speaking on alopecia areata, evidence-based therapeutic options. Sri Parna Dev does not require any introduction. She is very active in IADVL, in our association, particularly in Vihara IADVL. She has done her MD from Patna Medical College and Hospital, and till recently she was serving as senior resident in Nalanda Medical College and Hospital. So over to you, Sri Parna. Please begin your talk.
Thank you so much, sir, for the warm introduction. The topic that has been given to me is alopecia areata therapeutic options. So, alopecia areata, as we all know, is an autoimmune condition where there is non-scarring hair loss of any part of your body. The global disease prevalence is 2%, and I am one of the 2%. I had it once. So, 80% of the population who get alopecia areata get it before the age of 40 years, and there is a little bit of female predominance. So, to understand the pathogenesis is important, because only then we can target the treatment. So basically, alopecia areata is a T-cell mediated autoimmune disorder. Here, mainly what happens is the T-cells play a central role in immune dysregulations. The cytokines first that were identified were interleukin-1 and interferon gamma. So I will just tell in this. So there are so many pathways that are set to target the inner root sheath and outer root sheath. As we can see, Th1 is one that target through interferon gamma. Then I have got Th2 also seen to target it. Here is our T cell, and these are the JAK inhibitors, the JAK pathways where the JAK inhibitors are supposed to work. Then we have the PDE4 pathway where apremilast is supposed to work. We have the CD26 where abatacept is supposed to work. And then we have the interleukin-15 on which again the JAK works. So this is basically where we have to focus. Like in psoriasis, by knowing the pathway, by targeting those particular molecules, we are able to control the disease. The same thought is supposed to apply in alopecia areata, but because the pathogenesis is not very clear, it's not that well proved, but we will go through it. So the treatment of alopecia is unpredictable because some patients will just get spontaneous regrowth. In some, even after a successful treatment, you will have a loss of the hair and relapse. The treatment here we mainly direct towards halting the disease activity, and so that we can maintain the response that we get, and lower the relapse rate. So the history tells that even in 1500 BC, there was mention of alopecia areata, and the treatment that point of time was topical irritants. Even Corlius described this as patchy hair loss, and they used irritant to be rubbed on the scalp, and even bloodletting was done by them as a site of purification to treat alopecia. Transition to modern medicine also, we go for the irritants like anthraline and DPCP are well known. In 1952, there was the major shift whereby Dillaha and Rothman introduced the concept of cortisone as an immunosuppressive therapy to tackle alopecia. So, corticosteroid, like this one is many of the studies that I come across. By Tulsi et al., a study in 2006, where clobetasol was compared with placebo, and we all know the effectivity is there. Then here I would, this study by Tiwari et al., where interlesional steroid plus topical was compared with topical alone, and obviously the combination shows better result. So this study compared the intralesional versus the topical. So obviously the intralesional shows a better result. The Munchen et al. Study compared a foam versus lotion, and foam showed a better result. We all know effectivity of corticosteroid. The first line for us all would be corticosteroid, but what form is something that has to be decided according to the extent of the disease and the age of the patient. So again, this study by Tulsi et al. Said these are the various concentrations that we use in intralesional, but they did show better result than the placebo, but in between themselves, nothing was more superior. Intralesional is generally used when the involvement is less than 50%, and if you're not getting any results with intralesional, even after 6 months, you should abort the line of treatment. Minoxidil is another one which has been tried. The vasodilator role is definitely known, but it has some immunosuppressive role as well. So this is a systemic analysis that I have taken, and here in the study, it talked about various formulations that were used: topicals 1%, 3%, 5%, and oral 5 milligram. These all studies were included in it. So the overall response was around 33%, and some claimed up to 100%, but I am very doubtful about it. Even oral 5 milligram was used, they got good results of around 39%. So minoxidil is something we can try in alopecia areata, both in topical and in oral formulation. Even if whatever is the amount of surface area involvement, not more than 25 drops of minoxidil in topical formulation is advised. Coming to Soraline, this was a study by Taylor et al., where a 10 years experience was seen, but the relapse rate was very high. Most patients, though they were put on PUVA and Soraline and UVA, initially they got a good response, but after a few months, the relapse was around in 88%. So we affirm that it is not a very effective treatment. Coming to our most favorite nowadays, the JAK inhibitors, baricitinib, riltesinib and duroxetinib are the ones that are actually FDA approved for severe alopecia areata, but what we mostly use is tofacitinib, obviously. So in alopecia areata is driven by interleukin 15, which causes the JAK pathway activation, as we can see here, and these are the targets which are now tackled by baricitinib. So this is how JAK inhibitors work in alopecia areata. So these are two studies I would like to note. One is of baricitinib. This had two phases of clinical trial, BRAVE A1 and BRAVE A2, where around 400 patients were taken and a response of 40% was seen in it. A study of oral riloxatinib was also done, where 20 milligram per day was given for 3 to 6 months, and more than 50% hair regrowth was seen in 9 out of the 12 patients. I have just grouped various studies here. So this is a study of tofacitinib where 80 patients were taken and a moderate efficacy with 33.8% showing remission was seen later. Colin et al. Included a pediatric population where the topical tacrolimus was used and it showed response in 8 out of the 11 patients. Baricitinib was another one which we already talked about, the BRAVE 1 and BRAVE 2 study. Other one was duroxetinib. The study is THRIVE. Here in severe alopecia areata, 8 to 12 milligram has been used and the key result showed a good response. Where in rileticinib, the study is known as Allergo, and here again the dose was from 200 to 50 milligram and it showed a very rapid response. The thing is, long-term analysis is yet to be done, but it shows a good safety. For these are other of the JAK inhibitors that have been tried and shows promising response. Main is they have the side effect profile is upper respiratory tract infection, urinary tract infection and headache is common for both, and we have already mentioned that these are the drugs which have actually been approved for alopecia. Coming to apremilast. Apremilast is a phosphodiesterase E4 inhibitor which increases the intracellular CAMP. A higher CAMP decreases the other cytokines and that is what it leads to broad immunosuppression, and this is why it has been used. So this study shows, it's a small case series actually where only 4 patients were included, but the results were very promising. And yeah, apremilast is such a drug, I would feel. If it works, it gives you good results, and if it doesn't, it gives no result at all. That's like my personal take on it. This is another trial done on the mouse model where apremilast is seen to reverse the effects. So another molecule that is very frequently used, I would say, cyclosporin. So this study talks about cyclosporin with and without corticosteroid, which has been used in alopecia areata. It is a systemic review. Out of the 2,104 studies screened, 340 patients with alopecia areata were included in the study. The overall response rate was 65%, and obviously combination therapy was better. And those which has a combination therapy with methylprednisolone showed a better result. Next, moving to methotrexate. Methotrexate was again used in alopecia areata. If it is mainly the cumulative dose that mattered, but again the long-term safety is again an issue and the age group has to be kept in mind. So methotrexate does stay as a viable option that can be used. So these were the various options we have already talked, like oral minipulse, azathioprine, cyclosporin and methotrexate. All do give good results, but then again after stopping, the relapse is something that has to be kept in mind. These are the new things that we have, like topical tacrolimus, but this is a study which shows that 11 patients, even on being put on it, they showed no terminal hair. It is just like a placebo being used. So yeah, it has been shown to have no role. Dapsone versus topical immunotherapy was again done in alopecia areata. The efficacy again was inferior to topical immunotherapy, very similar to spontaneous regrowth. So a few other is abatacept. So abatacept, here 15 patients were treated. The patients were followed for 6 months and a good response was seen. The hypothesis is it has a T cell activation which reduces the inflammatory cascade. So it can be used as an option. Another is alopecia areata being treated with elifacept. Here a 21 years woman with alopecia universalis was put on the therapy, and after 12 weeks, a complete regrowth was seen. Ustekinumab is another one because we have seen interleukin 12-23 is again involved in the pathway of alopecia areata pathogenesis. This study talks about the same, where patients put on it were shown to have very good response. Lastly, alopecia areata during the era of biologics. We are using biologics for so many things, and expectedly we assume that it can be used, but etanercept, ifalizumab, altifacept, all has been tried but shows no response. Rather, there is a case report of worsening of alopecia, new onset alopecia in such cases after using infliximab. Thank you.
Thank you, Sripanna, for the wonderful presentation. The
Session is now open for discussion. Any questions from the house?
Thank you, sir.
Okay,
Thank you, sir. I request our chairpersons and speaker to collect their mementos from the corner of the stage. For the next session, I would like to call Dr. R.R. Madhukar sir and Dr. Rajiv Thakur sir to chair the session.
So our next speaker is Professor Dr. Sudeep Das. I don't think Sudeep Das sir need any introduction, but sir is MD from AIMS New Delhi. He is currently professor and head Calcutta National Medical College and Hospital, and he is our future president of IADVL, maybe next year or next to next year. Welcome, sir. Welcome. He will deliver the topic on.
Thank you, Brother Rajiv, for the kind introduction, but at present, I do not have too much inclination into fighting another election. Let me see. Straight going to the important. Low-dose oral minoxidil in hair disorders. Now, I have a question. How many of in this audience have shifted from the topical minoxidil to oral minoxidil? So, I can raise a lot of hands now. Although, till now, neither the FDA nor the CDSCO has approved it in their as an armamentarium for the treatment of, and let alone androgenetic alopecia, So it was for minoxidil was first established in 1970 for hypertension. The brand name was Lonitin. Resurgence in literature from 2020. And how it works? The sulfonyl transferase enzyme in the liver, the oral ones, and the topical ones for the phoriatic papillae. Vasodilation, the dermal papillae, shortening of the telogen to prolonging the anagen phase, upregulation of the vascular endothelial growth factors, and activation of potassium channels. This is very short. So literature where all the activities have been spotted. If you map them, AGA in men and women, chronic telogen effluvium, frontal fibrosing alopecia, and even lichen planopilaris. Reports are there. Alopecia areata, especially refractory alopecia areata, traction alopecia, and monolithics. There are reports of use of oral minoxidil in these conditions. Now, coming as alopecia, 58% of the population has a prevalence rate of 58% in males, in particular 30 to 50 years. In all cases, it increases gradually with age. This is as per International Trichology Journal 2019. So, it is the most common form worldwide and is characterized by progressive terminal hair loss. So, affecting at least 80% men and 50% women by the age of 70 years. So, I am not going into the details of this. Itself is unique in distribution. You can, looking at the hair, you can easily diagnose which is an androgenetic. This typical loss hair and the temporal recession will tell you, and the female there is central pattern of baldness. You can diagnose even without doing the patient walks in your chamber. Now, this is actually the complex etiopathogenesis. Definitely, this AG has a complex etiopathogenesis, genetically susceptibility, elevated activity of the type 2 isoforms 5 alpha reductase, follicular microinflammation, oxidative stress, all this come into the picture. So what happens when you are giving in androgenetic alopecia is androgenetic alopecia hair follicles spend less time in the anagen and they are miniaturized, leading to abnormally short, thin, vellus hair shafts. Androgens lead to gradual conversion of terminal hair into intermediate and vellus hair, resulting in the gradual hair thinning and loss from the proliferation in the patients in AGA. This is actually how it progresses. You can see from the normal hair follicle to the miniaturized hair follicle. So minoxidil is definitely one of the FDA approved treatment. The topical one, again I am correcting, minoxidil and oral finasteride are the only topically approved treatments, oral finasteride and topical minoxidil approved treatment for FDA. So we'll get straight into the 5 alpha reductase. We all know this, but mechanism of low-dose oral minoxidil. Vasodilatory action first increases supply of oxygen to the hair follicles. Anti-inflammatory action reduces microinflammation. Action of the beta-catenin signaling pathway and anti-androgenic action. So all these force action lead to the activity of the minoxidil. But what are the topical minoxidil? Limitations of topical? Variability in the sulfonyl transferase enzyme activity, particularly in the hair follicle, affects the efficacy of the topical minoxidil. ADRs have been reported. Lot of my work, I have noted at least 10 cases of ADRs in use of topical minoxidil. Compliance, topical minoxidil needs to be applied twice daily, where oral minoxidil you can give only once. Variations in sulfonyl, it is a prodrug, it is converted to minoxidil sulfate. The positive effect of minoxidil on hair growth is mainly due to its metabolite, minoxidil sulfate, and the enzyme responsible, we all know, is sulfotransferase. Now we are talking of this hepatic salt as well as the follicular salt. Actually, this is actually the area where we are speaking of. We are trying to stimulate the hepatic salt, which is more uniform, whereas the topical, the hair follicle salt is not that uniform. And particularly, these are the ADRs that are related. Now, compliance with low minoxidil, obviously, low dose with lopical minoxidil, topical minoxidil needs to be applied twice daily due to active and busy schedule. Often patients forget to apply, do not apply, results in less compliance. Now, coming to the variability in the sulfonyl transferase enzyme, topical side effects, itching and irritation, twice daily application affects the compliance. So these are important. Now coming to the basic, we already described these things. I'm not going to come into the more controversial things. Once a day therapy, the maximum recommended dose is 50 milligram, but this is for the blood pressure reduction, not for the important. You remember, the blood pressure reduction starts from 10 milligram to 50 milligram. But here we are using from 0.5 to 5 milligram. And very few of your patients will have cardiovascular or other side effect that we normally talk of minoxidil. The initial dosage should be 0.2 milligram, not single dose. The dosage will increase 50 to 100 per increments. And you can, for androgenetic alopecia, you normally 0.6 to 5 in females. And you can go in males, you can start with 2.5, increase to 5 milligram. And 90% of your patients will respond with that. After a single oral dose taken with or without food, half-life is 4.2 hours. The total duration of action is 75 hours. Excretion mainly through the kidney. So what are the latest clinical evidence? I will last speak on these things. This is the efficacy and safety of oral minoxidil 5 milligram once daily in the treatment of alopecia areata. This was reported in dermatological therapies. Now you can see that oral minoxidil dose of 5 milligram will significantly increase the hair growth in men in AGA after 12 and 24 weeks of treatment. That is the minimum period that they have taken into the account. Another report, safety of low-dose oral minoxidil treatment for hair loss, a systemic review and pooled analysis of individual. It was 0.25 milligram, showed 40 to 60% improvement. 0.5 to 1 shows 79% improvement. When you are hiking the dose 2.5 milligram, 90% improvement. And 5 milligram had almost 100% improvement. This was as per this meta-analysis study. These were almost 9 studies and a large number of patients, almost this study actually had it turn out over 10,000 patients in the survey. So many case reports are published in its effectiveness, safety of oral minoxidil in treatment of hair loss. This we are talking of telogen effluvium. So alopecia areata definitely, as Sipanova was taking earlier, this is very important. When I asked went to AAD, I saw a lot of papers were being presented on AAD on oral minoxidil in this alopecia areata. And now papers are coming, more and more papers are coming, not only in alopecia areata, people have telogen effluvium, it has shown to be excellent results, although they are more of case reports. This is, I am quoting, these 12 patients of female AGA, excellent results with 0.5 milligram daily of 3 months. The dose was increased to 1.5 to 2 milligram. Efficacy outcomes. You can see there how the hair density has changed, how the total hair has changed, terminal hairs has changed, hair thickness has changed, triple follicular units. All these have increased. The requirement to monitor, yes, that is the very important area. Yes, you need to monitor. I'm not telling you you need to be you need to not monitor these things. This is very important. This is a very important article published in 2025, important published by Cummins and international publication. Doses of oral minoxidil have better efficacy than topical? Yes. Now minoxidil oral 5% solution, a randomized control trial. This is a head-to-head almost a trial where they have shown that in 6 months of treatment, the oral minoxidil had better improvement than important. The safety, as per 1404 patients, hypotension was observed with low-dose oral minoxidil. Yes, it was observed, but how many percentage? It was a very few, 43 out of 1400 patients needed to discontinue the therapy, that too mainly because of hypertrichosis. We all know if you are using in females in doses more than 2.5 milligram, even with 1.25 milligram, I had evidences of hypertrichosis. So there, that is the biggest problem with treating female patients. In male, hypertrichosis is not a problem. You can hike to up to 5 milligrams safely. No, there is no issue in that. This is how you go on increasing, including IgA types 3 or vertex free. You can see oral minoxidil 5 milligram oral daily. I never go beyond 5 milligram. I have always important. And what are the things I will always check? Now, what is seen that total hair counts from baseline to weeks 12 is increased. At week 24, the increase was far more palpable. Photographic assessment from the vertex area, expert panel revealed 100% improvement. Score was greater than +1. 43% of showed excellent improvement of score +3, 700% increase. The frontal area showed increase, a significant response, but less than of the vertex area. Vertex and temporal shows relative. This is the picture that additional 12 weeks treatment that the results were obtained. Now, efficacy of safety of oral minoxidil 5 milligram treatment, male patients with androgenetical open label global photographic assessment. So this was another study which I am not going into in details. This was published. Now, what I'll just important is that female pattern hair loss 48 showed 64.9% improvement. Photochemotherapy, these were compared, these are the indications where they are used. Traction alopecia areata, 4 patients, 5.4%. Chronic telogen effluvium, 1 case reports. Frontal fibrosing, 3 case reports. Frontal alopecia, these 3 reports. All these were their conditions were the important. The adverse effects noted were mainly hypertrichosis. Some cases reported dizziness, lower limb swelling, in few cases, palpitation, headache, and nausea. So dermatologist's concern is basically the fear of hypotension. Below 10 milligram, there are very few cases where you will find that the cardiological side effects. So this is the study balancing effects. You can see 0.25 milligram, response rates are less, but when you hike the dose to 2.90% of your patient respond, 100% of your patients will respond. Versus the side effects also, you can see the lower the important side effects, 4% with 0.25, 4.9% with 2.5, and 20% with 5 milligram. So side effects will be obviously more. So hypertrichosis remains the most important. Cardiovascular safety, yes, if the patient has tachycardia, if the patient has palpitation, if the patient has pedal edema, and rarely periorbital edema, rare at low dose below 5 milligram, you be cautious. Explain initial telogen phase to the patient that you may lose hair in the starting phase, don't abandon the treatment, and pregnant, lactating, and severe cardiovascular disease not to be given. Now, effect of 2.5 10 normotensive patients, yes, you can give 2.5 to 10 milligram to about 10 milligram. These doses of minoxidil have little effect on normotensive patients. The renal clearance of minoxidil would thus be higher in normal subjects. This is as per Journal of Clinical Pharmacology, published way back in 1989. Healthy volunteers, the blood pressure remained in the normal range, never went below 100 systolic and below 70. This is again another proof of this. To summarize, topical minoxidil has got very result. We have these local side effects we have already described. So convert into active component, no local side effect, once daily therapy, better response than topical, extensively studied in alopecia areata now, and establish safety in alopecia patients. So these are actually the summaries. I'm head-to-head studies. One head-to-head study is been published in JAMA Dermatology in 2024, where they just found the response rate was high in LDM versus topical 5% moderate. Vertex potentially superior. Cosmetic elegance is definitely excellent. Local side effects none. Higher hypertrichosis very low, and compliance is excellent. So minoxidil should be avoided if you have drug allergy, pheochromocytoma, pulmonary hypertension with mitral stenosis, severe hepatic impairment, angina, recent myocardial infarctions, left ventricular hypertrophy, and heart failure. If you are pregnant or breastfeeding, think thrice before giving. Planning to have a baby also, ask your doctor or pharmacist. Minoxidil passes in the breast milk and is not recommended if you are breastfeeding unless your doctor thinks it is absolutely necessary. So oral minoxidil has proven its efficacy with doses in 0.625 to 5 milligram to optimal response. Men with resistant AGA and severe AGA may need higher doses like 2.5 to 5 milligram. So dermatologist concerns of fear is basically now baseless below 10 milligram. But dermatologist has to consider the dose because I told there is no randomized control trial. The most important thing that we require for it is important. And also there is no consensus trial. These are the two things that should be done by us immediately. So 3 to 6 weeks after treatment, the patient may lose their hair and hair growth is expected only after 3 to 6 weeks. That you need to explain to the patient. The hair may first noticed on the forehead and the temples if you are, and then eyebrows and on the other part of the cheeks if you had hypertrichosis. Later hair may grow in the back, arm, leg, scalp. Now concomitant antihypertensive therapy. A low dose oral minoxidil has no significant change in, I've already told that. Patient with hypertension who are prescribed minoxidil should only be closely monitored. No changes in antihypertensive drugs. Now, available evidence shown that is safe and prescribing, already told. Now, how I manage the side effects. Yes. The common side effect, oral hypertrichosis, we all know how to manage it because this is a reversible side effect. Once you stop, it will stop. But yes, it has psychosocial disturbances. So laser hair removal you can think of. Pedal edema in patients with obesity and poorly controlled hypertension is mainly caused by sodium and water retention with blood flow redistribution. So weight reduction plays an important part. Low salt diet should be recommended to patients who are taking oral minoxidil and co-admission with spironolactone, synergistic diuretic and antihypertensive action. Take drug at bedtime. That is another important. ECG is not required below 2.5 milligram whenever you're using, unless patient complains of palpitation. And this is the last evidence, low dose oral minoxidil comprehensive review that was published in this very year, 2003 March edition. So monitoring guidelines, they have already been put there, monitoring BP every week for the first week, then once a week for a month, then once a month if the patient is on other antihypertensive, and CBC, LFT, RFT at baseline after 1 month of studying, minoxidil therapy, then every 2 to 3 months. So these are a monitor only if symptomatic or hypertension, otherwise no regular monitoring is required. So consensus Delphi guidelines, this is our recommendation, establish clear guidelines, sulfotransferase testing, scalp biopsy and genetic testing, explore sublingual minoxidil, and another thing which already I have suggested to, I'll not name, 3-4 companies, I have already stimulated them from fixed drug combination, LD, low dose viral minoxidil plus finasteride or dutasteride. So that will actually be more compliant. Patient will be more compliant once therapy, and long-term monitoring protocols for potential side effects. Thank you. We cordially invite you to Derma Summit in 2026, 13th and 14th June. Whoever wants to participate, particularly the PG students, it contains handsome prizes up to 30,000 rupees for the first prize. Thank you.
Thank you so much, sir, for such an elaborate talk. What is the, this is my question, that what is the dose to start with if it's of a long-standing alopecia areata?
You are taking speaking of male or male patients, you can start with 2.5 milligrams straight away, no problem. But female patients, I normally for the first 2 months, I don't start more than 0.625, the half tablet of 1 to 1.25. I don't start with below.
So in alopecia areata?
In alopecia areata, IgA, all conditions. In females, I'm super cautious.
Thank you, sir. Any questions from the house? Thank you, sir.
Sir, apart from this hypertrichosis and pedal edema, any other complication you have seen?
If the patient has palpitation, cardiovascular, well-known cardiovascular, has undergone a recent myocardial infarction, you should not be using that. Heart failure recently, so you should not be using that.
No, you have come across, sir, any like patient complaining for headache or giddiness?
Headache is an occasional complaint that can occur with the vitamin also. So, though you need not give importance to that, yes, obviously you have to measure the blood pressure, measure the whatever requirement you have, suspicion, refer to a cardiologist if required, and you do accordingly.
So you combine dutasteride, finasteride with this?
Yes, I do combine. Definitely I do combine. I combine oral minoxidil with topical minoxidil also, oral minoxidil with dutasteride also, or finasteride also. Definitely.
Thank you, sir. Thank you so much.
Thank you.
Thank you. I request our chairpersons and speaker to collect their mementos. For the next session, I would like to call Dr. Aman Keshri and Dr. R.R.K. Rahul sir onto the stage to chair the session. can we have the CV and slides of the next speaker?
Our speaker for this session is Dr. Naveen Thomas, sir. Sir is MD, DNB, FRGUS, dermatosurgery, fellowship in hair transplantation, consultant dermatologist and hair transplant surgeon at Medical Trust Hospital, Kochi. Sir is awarded with several awards like Galadari Award for Best Presentation at 5th Continental Congress of Dermatology at Dubai in 2016, Presidential Award by FUE Asia in 2025, IADVL Kerala Research Grant Award in 2023, Best Paper Award at Derma Zone South in 2014, Best E-Paper Award at Clinicon Kane in 2014. Sir has many achievements like numerous publications in various international and national journals, invited speaker and panelist for various international and national forum including.
Oh, sorry. Okay, I think.
Yes, sir, you can start.
By mistake. Thanks so much for that kind introduction. Good afternoon, everyone. I'll be talking on something a little different. I'm talking on something which I found in my clinical practice and which I couldn't find much of literature in the books and in the articles. So I'm going to be presenting about a presentation which I've seen with males presenting with thinning over the temporal area. So when it comes to hair loss, in females we often feel, okay, it's difficult to make a diagnosis. There can be your chronic telogen effluvium, female pattern hair loss. Many times they can coexist and make the diagnosis very difficult. But we feel very confident when it comes to male. We feel that the androgenic alopecia in males is very typical with the frontotemporal recession or thinning over the vertex area. However, there are certain variants like your diffuse pattern of androgenic alopecia, Dupa pattern, which can come as a part of androgenic alopecia or alopecia areata, and retrograde alopecia, which are a little different from this usual androgenic alopecia pattern which we commonly see. Usually in males, like I said, it is usually pretty straightforward. We are not very confused. But I'm going to show you a little different presentation. So these are 3 patients with 3 different diagnoses, all presenting with thinning in this area, okay, just above the ears, thinning of the hairs in this area. Anyone from the audience wants to take a guess what the diagnosis could be? We'll make it a little bit more active since it's an afternoon session. Yes? Sorry? Pressure alopecia, okay, that is one. Then, any other thoughts? Trichotillomania, any other thoughts? Alopecia areata. So these were the things which we also thought of initially when we saw these patients. And I'll show you a couple more cases to make it more evident. So if you look at this patient has a very good hair elsewhere. There is no frontotemporal thinning, there is no baldness in the vertex area, but only has thinning in this area. So this patient is a young patient around the age of 25 to 30 presented with this presentation to the OPD. This was his complaint, the hair getting thinned in this area. So initially when the patient started presenting like this, I used to think that probably they're being too particular. Maybe they cut the hair a little thin in that area. But soon we started noticing this in more number of patients. This patient, excellent hairs elsewhere, but again came with complaints of thinning in this particular area. This is again another patient, not much of thinning, but still you can make out some thinning is there in this area. You can see good hair here, you can see good hair here, and good hair elsewhere. This is the youngest patient we have in this series. So this is a 14-year-old boy who surprisingly came to us telling that he thinks that he's going to become bald. There was a family history of baldness, and in this patient also, I don't know if it is very clear in the picture there, there's some amount of thinning in that particular area which we could notice. So again, showing you more cases. So this is case with thinning in this area, but however has some amount of vertex baldness. And then we started noticing this in patients not just with good hair. We started noticing this in patients who had, like, for example, this case, a diffuse androgenic alopecia and a very prominent thinning in this area. Again, patient with typical androgenic alopecia, thinning in this area. And then when slowly we started noticing some of these patients also had this retrograde alopecia, thinning in the occipital area. And you can see here the central area is preserved, like what is typically described in retrograde alopecia. More patients with thinning here, retrograde alopecia, thinning here, and had some amount of retrograde alopecia, typical AGA otherwise. And this is very young patient. This is a patient who is 23-year-old who came for transplant actually with such a high grade of baldness. And again, we noticed thinning in this area for this patient. And this probably is a patient with DUPA, just as an involvement of thinning elsewhere, had involvement in this area also. Again, more cases like this with thinning in this area. So clinically, we were sure that this entity, even though not described much in our textbooks, patients coming with thinning over this area is not very uncommon. We probably overlook that because there is a, navy cut, what some people call, which patients often come with. And some of them had very good hair, and some of them had associated androgenic alopecia. So we looked into this further. This is the first patient whom I showed. If you see the trichoscopy, you can see a lot of good terminal hairs, but there are some vellus hairs that are there in this area, marked by the green arrows. This is the area which comes in the safe donor area. This is the area where the alopecia, androgenic alopecia does not affect, and this is part of the donor area from where we take hair for the transplantation. So we don't expect this anisotrichosis in this area. However, there was no black dots, no exclamation mark hairs, no broken hairs. And we went ahead and using the photo finder Livia cam, we did a trichoscan which showed the percentage of hairs. And you can see here the numerous number of intermediary hairs. So this is in between your 30 to 60 micrometer. Above 60 micrometer is your terminal hair. Below 30 is your vellus hairs. And you can see numerous intermediary hair in this patient, again showing the variation of the diameter. In this patient also, thinning here, again, a lot of hairs in the 30 to 60 micrometer. So there is hair shaft diameter diversity in these patients again. So this is biopsy from the youngest of our patient, the boy I showed with 14-year-old. We couldn't see much of anisotrichosis in this patient. And you can see here a miniaturized follicle. There is absence of any perifollicular, peribulbar infiltrate in this patient. So among the 30 patients whom we noticed this, from 14 to 40 years of age, we categorized the patient into 3 categories. There were 6 patients who just had thinning in this area and no hair loss elsewhere. There were 10 patients with temporal thinning with clinically evident androgenic alopecia, typical androgenic alopecia, without any retrograde alopecia. And there were 14 patients who had thinning in the occipital area. That is your typical retrograde alopecia. One thing we noticed that in all these patients, there was a strong positive history of androgenic alopecia in the family. So the trichoscopy we already discussed. The hair pull test was negative in all of these patients, and the hair analysis showed increased proportion of intermediary hairs. We did biopsy for 3 cases where we had doubt with the anisotrichosis that was there, and none of them showed any inflammation, and we could see miniaturized follicles in some of the patients. So with this, we came to a conclusion that this temporal thinning, what we see here, could be a under-recognized variant of retrograde alopecia because the retrograde alopecia typically is described from the occipital area here. We could only find one article where they've described along with the occipital area in the higher grade. They've mentioned in grade 5 or grade 6, sometimes the thinning can extend to the area above the ears also. But however, you can see from this case series that this is not a finding which is present only in a very advanced case. So you can see patients who just presents with this as the initial symptom. So this was our final diagnosis. This is what we think it is. We like to know the opinion of the audience as well. So going back to the 3 cases that were there, this is the trichoscopy of the 3 cases. So I think it makes the diagnosis easier in this case. So here there is a lot of anisotrichosis, good terminal hairs that are there. So this is the retrograde alopecia, probably a different pattern of presentation of that. This is actually a patient with alopecia areata. He had some hair growth after the ILS injection taken. You can see here the patch is little bit extending, and you can see areas of hair loss with numerous vellus hairs that is there. And this is just a boy with the fade cut. You can see good terminal hairs and no anisotrichosis as opposed to in this picture. So this is one presentation I think which very often overlooked, at least by me. I don't know how many of you have noticed this in your clinical practice. So to conclude, the periauricular thinning in the temporal area is something which is uncommon, but it's not something which is rare, which I believe you all see in your clinical practice, probably not notice it so much. We believe it is an under-recognized manifestation of spectrum of retrograde alopecia. Trichoscopy helps in the diagnosis a lot. Anisotrichosis in the trichoscopy can help you make the diagnosis. However, histopathology may be needed in few cases where anisotrichosis may not be very evident. We don't know at this stage whether this is like a formifrosted expression of androgenetic alopecia with young patients presenting only with that. We don't know whether it's a predictor for a patient going in for advanced AGA with younger patient presenting with grade 5 or grade 6 baldness having this feature. So this is something which we would like to observe and find out in the future, hopefully. So with that, I conclude my talk. I would be very grateful to know the opinion of the audience also. I presented the same thing at EADV also last year and at the Cape Town conference of DASL. So this is something which we were quite, initially we thought the patient is just being very particular and telling about that small thinning young patients coming and telling, but then when we follow the patients more, this definitely a presentation that is there which is not mentioned in the books and which we all are probably overlooking. Thank you.
Thank you, sir. Thank you for such a wonderful and informative session. Any questions from the audience house?
It's always bilateral. No, in all these patients except for one or two were using spectacles, but other than that, no one was using any band in this patient. And there's no history of trichotillomania, at least that we could elicit in any of these patients. One or two of them were using spectacles, but that again is just coming in this area and not above the area.
Like we have had patients who have come with hair loss over here, and we always considered that possibly it is an early stage of alopecia areata, and maybe even we found on scopies and some signs of it. And with minoxidil and topical steroids, I think they have recovered. Though we didn't keep a record. It is just now that you say that I am recollecting that. But with these two, they had recovered. Three cases, they have come over here with.
I've had 2-3 cases with alopecia areata elsewhere also. So initially, actually, I've discussed this with others during the SIG trichology meet and all that. So we were thinking whether it's like kind of like a alopecia areata incognito presenting and all that. But once we did the trichoscopy and once we did the hair analysis with so many intermediary hairs, and we did biopsy for a few patients thinking we'll be able to pick up alopecia areata, and then we couldn't get any findings of alopecia areata. So that was the reason why we were thinking more of retrograde alopecia. But like you said, sir, even I have 2-3 patients who had alopecia areata elsewhere. Just 2 days back I saw a patient with thinning here and got an alopecia areata patch over the occipital area. But here the patient had kind of slight anisotrichosis. So we feel that it is a case of retrograde alopecia.
We do get congenital triangular alopecia in that area. But that means that area is something different. So we could approach it from that point of view, whether there is a link between that which is possibly appearing later on. They might have had the tendency is presenting itself at a later stage. Something like that is another possibility we can consider. Just I'm doing some wild thinking, that's all.
Yes, sir. Thanks so much for the feedback, sir. That's excellent take-home message for us.
Thank you, sir.
Thank you.
Thank you so much. I request our chairperson and speaker to collect their mementos. For the next talk, we have a panel discussion on hair loss industry, science or hype. I would like to invite our moderator, Dr. Rashmi Singh, to take over. The panelists would be Dr. M.K. Sinha, Dr. Rajiv Ranjan Thakur, Dr. Naveen Thomas, sir, if you could come back on stage, and Dr. Manas Puhan.
Good evening, everyone. I request all my esteemed panelists to be on the stage for the panel discussion. So in 2026, first I want to give a warm welcome to all my esteemed panelists. And with this, I'll start I'm going to moderate this panel discussion on hair loss industry, science vs hype. In 2026, we are standing at the crossroads to decide between the science and hype. So to introduce, the hair loss industry is currently a battleground between high-level regenerative science and aggressive, often unregulated commercial marketing. With this, I move on to the questions. So the first molecule, the one which we are going to discuss today, is exosomes. This is the most talked about molecule as far as the hair loss treatment is concerned in 2026. So exosomes are being marketed as a miracle cell-free therapy. Given the lack of standardized extraction protocols and the risk of commercial exploitation, my question is, how do we distinguish between clinical potential from current over-the-counter claims with respect to exosomes? And I request our first panelist, Dr. Naveen Thomas, sir, to take this question.
Yeah, so we're just having a debate on this next week at the SODC. I'm speaking against exosomes. So
And we had similar debate earlier also, sir.
Yeah. So I feel with exosomes, we are still at a very early stage. Yeah, the theory is good, and probably in the future that probably might be something which can be very useful and something which we can add on. But I think at presently, we do not have any standardization. We don't know how safe these are. The companies come and claim a lot of things, and we all know marketing and the claims are something, and whether in reality what happens is something else. So I think we are still at a very early stage, and I don't know how safe it is for us to use it. Definitely, I would be against injecting them because even the companies don't approve it. And a lot of times I feel it's like something new comes, everyone is going with the hype, and we without even like thinking and we without studying in detail about it, we just believe what they're saying and we are going by it. So I think it's a very early stage as of now. Hopefully something in the future, but as of now, that's my take.
Okay. So there is one more panelist I'll request sir to please join us on the stage. Dr. Bhavesh sir, yes sir, please come on the stage.
Chair.
So in the meantime, I request sir to further enlighten us on like exosomes. Can it be used as a meso solution? Please, Dr.
Yeah.
Manas sir.
So basically, I'm just continuing that one. So I'm still against exosomes, but one thing we are sure that it is definitely better than the stem cells, because we are not injecting them, we are not providing, we are not allowing the cell to enter, rather the extracts of the cells are in exosomes, so relatively safe. And most important thing is the source of work. When it is human derived, it works, but we are having an ethical concern. And when we are injecting, again it works, but we are again having an ethical concern. So we have to judge whether we'll go the unethical ways to get the result, or we'll wait till the time it is approved. So I'll wait till it is approved.
Okay, so it is still in the high phase.
Yeah.
So we need more science, more literatures to approve it as a hair loss treatment.
And whoever,
yes, sir, please,
whoever
Rajiv,
is marketing it, they are not clearly mentioning that either it is from human cell derivative or what? Yeah.
So actually we need to have
exosomes
certain
only,
questions to be put forward to them, those who are marketing it, as to how can we decide that which exosomes we have to purchase.
Regarding exosome, it's very, you see what source is there. It's a human source or animal source.
Right.
The human source, exosomes are better. That from umbilical cord only. Okay, umbilical cord or placentas. But the company manufacturing exosomes are not sure which exosome they are marketing. And sterilization process and, another marketing process, how does it been marketed is very important. Otherwise, in microneedling, you can use with microneedling.
Okay. Thank you, sir. So the regenerative paradox, is it a hype? Yes, of course it is. Right now we can say that. While the science shows 25 to 40% density improvements in controlled trials, the hype markets them as a permanent cure all for every grade of alopecia. This is how it happens whenever a new molecule comes to the market, they start advertising it like anything. So the key factors for deciding on exosomes presently, what we have in our literature is the source, as sir said, and all our panelists mentioned this, optimal age, that the younger the healthier donors due to the better hair follicle stimulating ability, the better it is. Concentration and purity, which is usually decided by the NTA or the nanoparticle tracking analysis to ensure a high density of particles, which should be usually more than 10 to the power 10 per ml. And the storage method, which is very, very important, because even if it comes to us, we also have to take care of this storage part. So I'll move on to the next question.
We have better options, PRP, GFC.
Yeah.
They are giving good results. So
why should we move on to an expensive treatment? With
Actually, what is evidence-based is more important, actually.
Yes, true, sir.
So, like, as a doctors, we are, like, as a dermatologist, we are practicing what is, like, evidence-based.
Yes.
And if you want to deliver the best, we should always try to follow the evidences.
And we have to counsel the patients accordingly.
Yes. So, because there is so much of floating.
Yeah.
So, if we are clear in communication, patient
We
will
will
understand
come
in
to
due
that
course.
too, sir.
Patient may not like initially because
Yeah.
he knows that we are telling him that you are going to get bald, so he doesn't accept it. But over time, he realizes it.
Yeah. So next very, very common topic which is being discussed is the scalp microenvironment. After the microbiomes on our skin, we have now, and our gut, and now we have come to the scalp. So the industry is flooded with scalp detox and antioxidant serums based on the research, suggesting oxidative stress and which impacts the pre-emergent hair. So with this, the question is there a genuine role for malassezia inhibiting agents like zinc, parathion, and antioxidant serums in preventing the premature hair loss beyond just treating dandruff? MK Sinha sir, please, if you can take this question.
You want to know about scalp detox, okay?
Yes.
So, if there is a healthy scalp, we'll have healthy hair. So, basic formula is that. So, scalp detox is not bad option because we have got so many options, so many creams, lotions, shampoos for detoxing hairs. So, just clean your scalp without, because there are so many things accumulated on the scalp like sebum and flakes and sebums also. So first detox it, then go for the real hair growth treatment. So hair detox, in my opinion, it's maybe useful.
Any other panelists? They can
If
also.
we are talking about zinc parathion, I don't think it has any role in premature hair. It does clear this malassezia. If the patient is having seborrheic dermatitis or scalp psoriasis, it helps in clearing that. But clearing that only. No evidence for hair loss.
So directly it doesn't help, but definitely it helps. I'll go for 100% like for zinc parathion or to reduce the malassezia, because once there is inflammation, whatever medication you are using, that may not enter properly. So that is the reason. And most of these patients, they don't do their hair wash every day. So you will have some amount of dandruffs, and that will hinder the entry of the molecule. But for the antioxidant serums, I'm little skeptical. Like, we know that beyond certain molecular size, it doesn't enter. People use vitamin E and all on the face and all. That doesn't work. So similarly, I will not suggest antioxidant serums which will scientifically work.
See, any inflammatory condition in long term may definitely affect hair follicles. So, like, while examining patient, because of the changing lifestyles, the seborrheic dermatitis incidence is also increasing. So in that way, if you manage, you follow it, it definitely works. In my college time, we used to listen from our seniors that when I treat dandruff, patients start getting good hair growth. So because that time there were no options. Now we put all together, so we don't realize what is working, what not working.
So again, it is a hype. So yes.
So I see a lot of in patients post-transplant who have a lot of seborrheic dermatitis and inflammation. I do personally feel that the results are sometimes a bit affected as compared to the normal person without much of seborrheic dermatitis. So I feel inflammation probably could play a role. But for me, the treatment would be the treating the dandruff part of it along with whatever we are treating for hair loss, and not chasing that alone. I don't think is going to help, but that can definitely be a good adjuvant.
So, sir, many of the patients, they're coming up with like they are already applying ketoconazole kind of shampoos. They are already taking like for dandruff, they are using it off the counter. It is available and they are buying and purchasing and using it. So, can there be any discrepancy in the or any difference in the microbiomes of such patients, and is it going to affect the already present inflammatory condition on their scalp?
So I think when it comes to treating like something like the seborrheic dermatitis, they need to be on this anti-dandruff shampoo for quite a long time. So whether they're taking on their own, it does not really matter. So most of these patients will be on this anti-dandruff shampoo for quite long. But I feel when we are treating hair loss, something like androgenic alopecia, that alone definitely is not going to be enough, and we need medicines like finasteride and minoxidil. This may or may not play a role along with that.
Any role of such microbiomes in alopecia areata and psoriasis, scalp psoriasis kind of scalp conditions? No.
See, we call psoriasis a condition, correct?
Yes.
So
Yes,
there
yes.
you link it with that. But and seborrheic dermatitis is there in 60 to 70% of the population.
Yes.
Okay, so it's very difficult to comment like that, but it might definitely might be having a role.
Okay, there are not much literature, actually not much science still present for this. So it is again a hype. So there are some literature which was present, which I have quoted here. Increased abundance of Malassezia staph and Brevibacterium has been seen to be associated with seborrheic dermatitis compared to the healthy controls in one of the study which I have quoted here. Then a higher proportion of Corynebacterium, Actinobacteria and Firmicutes, and low proportion of staph capri are seen to be associated with worse clinical outcomes that present in case of alopecia areata patients. Decreased prevalence of Actinobacteria and Propionibacterium and increased Firmicutes staph and Streptococcus are associated with scalp psoriasis. And studies of central centrifugal cicatricial alopecia suggest scalp microbial composition contributes to pro-inflammatory status in such conditions. So now low dose oral minoxidil, almost many of us are using this for treatment of male pattern baldness. So let's navigate with the safety of this. In recent years, this low dose oral minoxidil has become a darling of the industry due to high compliance, because patients also feel it comfortable to take and consume. They do not have to carry that minoxidil, and minoxidil has its own side effects on scalp. So with this, with recent discussions on its cardiovascular safety profile in mid-age to elderly patients, how should the Indian dermatologists like us balance the hype with the safety of the low-dose oral minoxidil? Your inputs, any of the panelists can take this.
So I think with oral minoxidil, getting a very serious side effect, especially with the doses that we use, are very unlikely. But having said that, the patient comes to you for hair loss, and even if there's a mild postural hypotension, that is something which for the patient they can get scared. So something like patient getting a little bit of edema around the eyes can be scary for the patient, because they're coming to you for hair loss and they're not expecting that. So I think it's not a drug we should be worried about, because it's something which is very well tolerated and gives very good results. So it is one drug probably which we know for sure if we give will grow hair. But at the same time, I think there are a few things which we need to look into, like postural hypertension, the fluid retention, like what Dr. Sudeep was telling in a patient who just recently had a cardiac event. Fluid retention, probably it's not a good thing to have. So we shouldn't also be like, okay, we can just left, right, give it to anyone. We should be careful of these side effects also. And the key I always find is to start at a very low dose and then increase it every month. So there is some amount of tachyphylaxis that happens with the cardiac side effects, and fortunately that does not happen with the hair growth. So hair growth is dose dependent. As we increase the dose, we get more result. But the side effects, as we slowly increase, does not come so much.
Okay, thank you, sir. So we have enough scientific, yes, sir.
Since
please.
last 1.5 year, I'm just telling my practical experience. Since last 1.5 year, I'm using this molecule in all my patients. Not very elderly, but yeah, in younger age groups. In generally male, 2.5 and female 1.25 for the initial month or maybe 6 weeks. After that, 2.5. Except hypertrichosis, I have not seen any other side effects.
So some of the
Blood-
patients have come up with headache because I'm
Headache,
also
headache,
using
headache,
it. Yes.
headache. Look,
Headache is one symptom.
Initial
Postural
stage
hypotension.
you have headache,
Right.
but except hypertrichosis, I have never seen anything else.
Actually,
I
sometimes
agree
it
with
is.
him. So I haven't also seen any cardiovascular, adversity with this molecule. So well tolerated, but you have to monitor blood pressure in a
Yes.
female patient and male patient also regularly, so that you are safe. And as we had a nice presentation by Dr. Sujit Das regarding this,
Yes.
hypertrichosis in female and in male patient. Earlier, this molecule was used to treat hypertension with BPH, benign prostatic hypermegaly. So now it has been used in all pattern loss and alopecia and androgenetic alopecia and all, and it's safe, I think. In my opinion, it may be used very cautiously, but may be used.
So now we have an open house question basically. Social media influencers and dermatologists, we are all facing this in our daily practice. So how should we react with when a patient comes running to our clinic asking for peptide serums or red light helmets popularized by the influencers? How should we counsel the patient regarding this? Should we start showing them the scientific literature or something like that?
So most important, they first listen to the patient what he wants.
Yes.
Okay, I say, okay, let us leave this social media apart. What is your problem? I start from my clinical part. I examine the patient. I do a trichoscopy, and then I tell what is the problem, what is the pathology, like why you are losing hair, and what is required. Okay, and again, if the patient is persistent, I talk about the evidence medicine, what I said earlier, and you convince them that we have to follow a protocol of treatment. Social media, these are all pharmaceutical agents sort of things, like the cosmeceutical agents, where there is no perfect control of laws on marketing. Otherwise, I could have also marketed it, but I have to market what is evidence-based. On that basis, many of the patient understands, and we do it.
Okay. Any audience, anyone from audience also, if they want to give their inputs or any experiences they have to share regarding this?
Yeah.
Yes.
So normally I give them, I give them one example like खाने के बाद कुछ मीठा हो जाए, who has told? It is a Cadbury who has told. So they have imprinted in our mind that after also food you take little bit of more energy which will make you fat and it will damage your health. But the thing is, when you exactly if you think, then it is not required. Same thing. If you are listening to all these influencers, then it is up to you. I am having that option, but I am not going to start. This is my straightforward answer.
Rightly said, sir. Very, very nice example you have put. So,
I think
yes.
with regards to serum, peptide serums, you mean like Procapil,
Yes, sir.
Redencil. So I find them very useful when the patient is having active shedding. So I do hair pull tests for all the patients who come with hair loss, and if the hair pull test is positive, whether it's telogen effluvium and sometimes in androgenic alopecia also, I do feel peptides are a good option to reduce the hair shedding, and then add on minoxidil later once the hair shedding is better.
Thank you, sir, for your input.
Really, I don't mean that they are not good.
Yes.
We have to tell what is required for you and how I am going to manage you.
Yes.
And
So laser
that's
light
what-
therapies are also there that I mentioned.
So we
that
are
they
also using these molecules, but
Yes.
they have to be justified why you are using, how you are using, and when you are using.
Yes, true. So this is regarding that red light. It has been seen in the scientific literatures are there that treatment with 650 nm red light postpone the hair ketogen transition in an in vitro culture model. But we need more studies regarding this before we can conclude. If you have any experiences, please you can share on any of these topics.
The laser for hair growth, actually, in one of the earlier guidelines, European guidelines, this is before there were a lot of studies which came for PRP. Actually, they had given a much more evidence for the laser light therapy, low-level laser light therapy than PRP at that point of time. Now, of course, we have more studies for PRP. So it's not something which does not work, but many a time it's cumbersome to come to the clinic and use that. And other commercially available ones which the patient are buying online how much of that has the actual light that needs to be, wavelength needs to be delivered, we don't know.
Thank you, sir, for your input. So next in the line is AI in diagnostics. It is being AI everywhere. It is AI. We are all being trained in our colleges and everywhere. We are being in fact, we have been given like certificate programs are also being run to train us for this. So AI-driven trichoscopy is emerging, and question is, can these AI algorithms truly replace a dermatologist's clinical eye in diagnosing the early stage cicatricial versus non-cicatricial alopecia, or they're just oversimplifying the complex pathologies? Any input on this? Like,
so the images which I showed during my presentation, the hair analysis showing intermediary hairs, those are like the AI based one by photo finder. That's probably the best we have available, but it does have its own limitations. Okay, so for the diagnostic purpose, it's not very useful. The place where I found it useful is when patient present with very early androgenetic alopecia and they have very minor anisotrichosis, which we may not pick up with the dermoscope, where we have only 10x magnification. This has a much higher magnification, and because of that, that early anisotrichosis sometimes it can pick up. And in diffuse alopecia areata, that numerous vellus hairs that is there, so to measure the diameter of the hair less than 30 micrometer, these are two places where I found it to be diagnostically useful. Otherwise, it's more for showing the patient result from what it was earlier. Like say baseline, you had so much of hair count, and after 6 months it is this much. And that per se also, if you don't use it correctly and don't use it at the same point, again it can be tricky.
so it can be helpful, but again, if we, yes, sir. Yes, sure, sir. True, sir. Yes. Thank you, sir. Yes.
The best example is when you are using AI, you will not miss certain things. It may give you certain other things which is not necessary for you, you can exclude them. But sometimes our human mind, we are not every time in a same state of mind. So we miss something which AI will not allow us to miss. They will give us the data. Now you have to verify and you can ignore certain things.
So
Like Dr.
preparing
Thomas
our
said, so
yes, yes, sir.
Dr. Thomas said that the diameter is measured, so we don't have time to do almost these things. So it is going to make it very quick and very
Yes,
efficient.
sir. So fastening our work, like it can, if we are in a busy OPD, it
It's
can
like
help
you
us.
are like having an assistant who is
Yeah,
giving all the
true.
data, then you are applying your own mind to give the final diagnosis entry.
Right, sir. So while AI assists in pattern recognition, it cannot yet replace the clinical eye for complex inflammatory scalp pathologies. So technological advancements, AI in robotic focus, again, I'm discussing this. Robotic system like ARTAS promises 90% plus graft survival. So a question is, for a country like India, where manual dexterity is high and the costs are lower, is the robotic tag a genuine medical upgrade or a marketing tool to justify the premium cost of AI-assisted surgery?
So the hair transplant surgery by robotic, well-trained human is definitely can take out better grafts without much transaction. And even the places, most of the places which has ARTAS, that is more for marketing purpose. They do most of the surgeries by themselves. There are only very few places, not just in India, I'm telling, in all over the world, where they're dependent on ARTAS. So that again, as of now, is not something which we can rely on. Probably with advancements in the future, if something like that comes, it reduces our work, well and good, but not at the moment.
Thank you, sir. So a new topical DST blocker, that is clascoterone, is there in the market. It is actually under trial for as far as the DHT, as far as the male and pattern hair loss is concerned. So how is it going to find its place in the already established DST blockers available for the male pattern hair loss?
I know clascoterone 1% cream is now available in India for acne vulgaris treatment.
Yes, true, sir.
It should be applied twice a day on an active acne case. But it is still under trial for use in androgenetic alopecia or pattern hair loss. Because it is an androgen.
Yes,
No.
it is still under trial. That is what is there in the literature. Yes.
Still, I think dutasteride
Yes.
is best
So we have
and
better
second
DST
finasteride.
blockers.
So no need of this clascoterone.
It
But
still
maybe
needs
in
more
future
studies,
studies
basically.
are needed.
Yeah. So this is one study which I have quoted here. cortexolone 17 alpha propionate is a novel, which is clascoterone basically. It is a novel androgen receptor antagonist that inhibits the production of lipids and inflammatory cytokines from SIBO sites. So this study was actually for the acne, which has been done, and for male pattern hair loss, as we discussed, the literature is still lagging behind. So yes, this question is for Dr. M.K. Sinha sir. Sir, please take this question. However, with the black box warnings on systemic version of JAK inhibitors, how do we manage the scenario where the industry is trying to push these drugs even in the mild cases of conditions like alopecia areata, though we have evidence mostly for the severe cases of alopecia areata?
No, we should not use this JAK inhibitor in mild cases of alopecia. We have other good options for mild cases of alopecia areata. So alopecia totalis or universalis, you can just think over of JAK inhibitors. But why do you use in minor cases alopecia? Simple treatment, simple conservative treatment can, give a very good result in AA. So in my opinion, for severe cases, it should be reserved for like universalis or totalis alopecia or recurrent alopecia areata, recalcitrant. Then there we can think of using this JAK inhibitor.
So first we should go for the conventional treatments like steroid pulse and all before. Yes.
Nowadays, we have seen that in even single or double patches, people are using JAK inhibitor.
That is what, sir.
But we should use only topicals, and even ILS can be given in single or two lesions. But
and we should investigate basically why the patient after all is developing those alopecia areata lesions rather than straightway going for the...
Actually, JAK inhibitors has now the JAK of all trades, like Dapsone. I was preparing a talk for scabies, and there are few articles for scabies nodules. They have used JAK inhibitors.
Sir, enhances reaction, type 2 reaction enhances.
So no, if it can be used for scabies nodules, it can be used for anything.
Yes.
This is the thing.
True, sir. Thank you, sir. So nutraceuticals, we have saw palmetto. This is like patient coming and saying that we are using such products, and they themselves are using it because it has DST inhibition activity. So question is, where do you place it against finasteride? And what is your take on combining it both in oral or topical form? Any of you can take this case?
I think there is it's no match for finasteride, definitely. There's no doubt in that.
So we have to clear it to the patient that no, there is not such things like finasteride.
Overdosing, it's like overdosing yourself. Like,
yeah, true, sir.
Because you are targeting the same thing, same this mechanism. But of course, if you are choosing in between the two, then definitely you have to decide why. And finasteride and dutasteride better one.
See, these are all adjunctives. If patients come to you and say that I don't need minoxidil, I don't need finasteride, then you don't have any option, then give this. Otherwise, I don't think finasteride.
But we have to counsel at the same time that don't.
But most of the patients, they come.
This saw palmetto is a pine extract, as far as I know, and it is found in US territorial areas in Tamil Nadu also. So in India, Tamil Nadu is being sold saw palmetto. So in cases we don't use this finasteride or contraindicated, you may try this saw palmetto oral, not topical.
Okay, sir. Thank you, sir. So this is one study which I have quoted here. There are a few studies which have shown that as an adjuvant therapy it can work, but not definitely. It cannot definitely replace the finasteride, which is an already present established DST blocker with which we have lots of experiences. So
one point, if I may add on
sure,
that,
sir,
so
please.
palmitol, many times I see this multivitamin that they're coming out with. Sometimes they add these anti-androgens, and many doctors, without realizing, they give it to females also. So that is something which we need to be careful, because if it has an anti-androgens, we have to be careful when we are giving it in females.
So this is one scientific part we have to be careful about when we are prescribing any such medications. So with this, we are ending our this panel discussion. The year 2026, it marks a reality check for AI and robotics. We must transition from AI hype to AI precision. With next generation JAK inhibitors and topical androgen receptor blockers like clascoterone and saw palmetto entering the battle, the clinician's role has shifted from prescriber to protector of the patients, from multi-billionaire dollar nutraceutical industry that often lacks corpus indexed validation and other indexing as well. Evidence-based psychology means with influencers dictating the therapy, the dermatologist must remain the ultimate protector of evidence-based science rather than hype. So let's embrace the innovation but interrogate the evidence. And any inputs from the audience if they want to share any experiences with on this science fierce hype in hair loss industry. Yes, sir. Sir, Botox is also there. Actually, it is again, there is some science, but yes, there is hype too.
Yesterday,
That as
Doctor.
a vasodilator and supposed to work. There is some literature on that. I've heard experience of some people tried it in some patients and got results, but it's
Same,
again not very standardized. And whether we can
We don't have
reproduce,
any standardized protocols on
yeah,
this.
again whether we can reproduce the results in all patients, we don't know.
Yesterday, Dr. Anil Ganju was giving his presentation. So he was mentioning about this Botox, and surprisingly, he has mentioned a new thing. He is using threads for hair growth.
Threads also
Especially in the vertex area.
So the
Threads are being given like which we give in the
So
skin.
it's basically to promote that growth factor release, and thread supposedly gives a longer result. So some people prefer to use it for people who are coming from abroad and cannot come monthly for the PRP and things like that.
A rejuvenation kind of a thing. Threads, yes, sir. Thank you, sir. Thank you all the panelists for their very, very important and nice inputs on this topic. Thank you, everyone.
Thank you, ma'am, for this wonderful panel discussion on hair disorders. Moving ahead for the next session, I would like to invite the chairpersons, Dr. Ajay Jaina, sir, and Dr. Sanjeev Kumar Juari, sir.
Hello. So good evening. For the next session, I would like to request Dr. Shahana P. Raju will be talking on veterinary superiority by evidence-based treatment to practical challenges. He is Assistant Professor, Bangalore Medical College and Research Institute. Hello. Brief Bavskej is author of books Salt Papers Dermatology for PG, Ready Reckoner Dermatology, Assistant Editor of Dermatology Directory, and Adevil Textbook Dermatology, more than 20 publications and 15 presentations, Joint Secretary of ACDI, area of interest, pediatric dermatology, general dermatosis, and vascular malformations.
Thank you, sir.
Yeah.
Thank you. I would like to thank the entire team of ACDI for giving me the opportunity to speak on hidradenitis suppurativa. I'll be focusing more on the surgical aspects of management of HS. I do not have any conflicts of interest. So before we move on, we all know the Hurley staging. Stage 1 is there are only abscesses and nodules without any sinus tracts. Stage 2 is abscesses with sinus tract, but they are widely spaced. And stage 3 is where there is multiple interconnected tracts and abscesses. So there are a lot of scoring systems in HS, but one particular thing what is used for assessing the response to biologics and surgical management is IHS4. So there is an online calculator. You just need to enter how many nodules are there, how many abscesses, how many tunnels, and it gives you the score. Anything more than 11 is considered as severe HS. So these are all the various options which are available to us for the management of HS. There is no Indian consensus as of now for management of HS in skin of color. So we need to choose and mix and match between these methods and tailor the management according to the patient's needs. So let's talk about antibiotics first. So any stage of HS, if it is an active disease, topical clindamycin 1% is what is recommended as the first line among the topicals. Of late, resorcinol is also being used. It is the only chemical peel which can be used for the management of HS. So it has anti-inflammatory, keratolytic, antimicrobial activities. So I have been recently using it in all of my patients of HS. It is very easy to procure. It is available online as crystals, and you also get the sodium metabisulfite crystals which are added to prevent the oxidation of resorcinol. You just have to mix it with NS to prepare a solution of 15%, and they also give you a cream which is petrolatum based, and you prepare this formulation and give it to the patient. It is applied overnight, and it is giving pretty good results. So we did a lot of other therapies for this patient as well. Don't get confused with the picture. Only the circular part where you see the granulation tissue, we saw very good resolution of abscesses and nodules, but we also did a lot of surgical methods to get this result in this patient. Moving to oral tetracyclines, they are recommended as the first line therapy in mild HS. Of course, to be kept in mind, contraindicated in pregnant women and children less than 9 years of age. And this is our favorite combination, rifampicin and clindamycin for moderate to severe HS. The dose is 600 milligram per day, and we need to give it for a minimum period of 12 weeks before we can say that this patient is non-responding and we can move on. Rifampicin is never used as monotherapy. Clindamycin can still be tried as monotherapy. An IV option is also available because it has a high propensity to cause pseudomembranous colitis, so that has to be kept in mind. Ertapenem is gaining a lot of traction these days. The only downfall with this is it is given IV, daily IV as a 6-week course. Otherwise, it is an excellent antibiotic for HS, which is severe and refractory to all other therapies. These are the other antibiotics. Again, these are all second and third line, not in very great use. Right, so do we actually need to do a swab before we can start the patient on antibiotic? So there is no consensus which says this, because the axillary and groin microflora is very heterogeneous and swab is just very meticulous. So we start an antibiotic irrespective of what the organism is, and we also know that HS has a greater propensity to produce biofilm. So oral antibiotics not responding is a very common scenario, and it requires other therapies like laser and surgery. So again, role of corticosteroids, if it is a very severe inflammatory disease, we can give corticosteroids either in the form of a short-term oral therapy or long-term, or my favorite is the intralesional corticosteroids. You inject it right at the base of the nodule. 2 to 3 sessions, there is reduction in the severity, but it should be kept in mind that more than 40 mg per session is not recommended. Coming to hormonal therapy, we have to choose the patient, not recommended in everyone. Female patients with signs of hyperandrogenism, you always get a hormonal profile done. Any variability in the hormonal profile, the drugs which can be used are anti-androgens like cyproteron. Cyproteron works very well when it is combined with estrogen. Spironolactone and finasteride have also been used, but there is no strong evidence against use of these, and it has to be kept in mind that they are highly teratogenic and to be used cautiously in women of childbearing potential. Role of retinoids, again, we need to choose the patient. Anybody who has seborrhea, very severe acne, follicular occlusion, triad, these are patients in whom acitretin is preferred over isotretinoin, but again, not very great results. These are some of the miscellaneous drugs, dapsone, colchicine, and zinc gluconate. All of them are used as second and third line therapy for HS. Next, coming to biologics. So this is the eligibility criteria. So we can even consider it as the first line drugs for moderate HS or severe HS if there is unstable or progressive disease, signs of complications like lymphedema. In my case, I would prefer it as a second line therapy if the patient is not responding to antibiotics after 12 weeks. So there are 3 FDA approved drugs, adalimumab, secukinumab, and bimekizumab is not currently available in India. The first 2 are. The regime for giving adalimumab is a loading dose of 160 mg and 80 mg from week 2, 40 mg per week from week 4 to week 12. So when should we actually stop biologics is when you don't see even a 25% improvement after 12 weeks, then you have to consider a loss of biologic or failure. So adalimumab can be given even in children above 12 years of age. One of the major downfalls of adalimumab is recurrence. So we had this patient who was not responding to any antibiotics. We even gave ertapenem, but she responded wonderfully to adalimumab. This is after about 4 months of therapy. Weekly, we were giving her adalimumab. And then the minute we tapered down the adalimumab, she had a recurrence of the disease. So this is common in any drug, but this goes to show that even biologics, there is a recurrence of the disease. The other drug which is popularly used is secukinumab, 300 milligram weekly dose for 5 weeks, and then you give a maintenance dose of 150 milligram every week. So how do you choose between these two drugs? When you see only from a cost point of view, adalimumab is much cheaper and cost efficient to the patient. But in yesterday, Dr. Anupam's talk, he happened to mention that adalimumab causes hypertension and hyperlipidemia. So it has to be used very cautiously in patients of HS who also have metabolic syndrome. So probably secukinumab can be preferred in such patients, but otherwise adalimumab is the choice of biologic in patients of HS. Bimekizumab is not currently in India. It is a biphasic biologic. It has activity against both interleukin 17A and F, but it's extremely costly. The loading dose itself, I think, costs about 1.5 lakhs. So these are all the other biologics which are used for HS, but none of them are approved yet. So again, our favorite drugs that are being used for everything. Tofacitinib, unfortunately, does not have any effect here. Upadacitinib has shown to be effective, very mild results in few cases. The dosage which is to be given is 15 milligram per day. So again, these are everybody's new favorite drugs. It has been shown that bariatric surgery improves the symptoms and signs of HS by 70%. So why not an oral drug which can cause weight loss? Semaglutide at a dose of 0.8 milligram per week for about 8 to 9 months. This causes a weight loss of almost about 20 to 25 kgs. And there are a few studies which have shown a very good improvement in HS, and there are a lot of companies now which are coming out with very cheap drugs. So before they used to have pre-filled syringes. Each syringe was about 10,000, but now a lot of companies are coming out with vials which hardly cost 1,000 or 1,500 rupees for about a month. So it's becoming very economical as well. So this is the main topic today, surgical techniques in HS. So there are various methods: incision and drainage, deroofing, excision, cryoinsufflation, and a novel method that we do in our institution is FUE. So we need to match the surgery to the disease stage for best outcomes. So this is a simple video showing a deroofing technique. So what we do is you infiltrate anesthesia, and then you use a skin probe to identify where the tunnel is, and you insert the probe into the beginning of the tunnel, and you either take a CO2 laser or a simple electrosurgical probe and remove the roof of the lesion. So, and then it is left to heal with secondary intention. This is a very simple procedure, and it usually gives very good results. So these are some of the cases that we did. As you can see, the sinus and fistula have resolved quite well. This is about 1 month post deroofing. Excisional surgery, there are two types. You can either excise the lesion or you can do a wide local excision. So this is one case where we did a wide local excision. Usually what the consensus recommend is you do not close the lesion. You do not put sutures. You leave it to heal by secondary intention, or you go in with a skin graft after about 4 weeks. But the patient needs to be highly educated, because leaving such a large wound usually gives rise to secondary infections. Because I work in a government institution, we usually close, but post-surgical closing is not recommended. Delayed skin grafting, or you can even do a negative pressure wound therapy. So this is another very simple method called cryoinsufflation. So what you do is, to your cryotherapy gun and probe, you attach a 21 gauge needle, and then you identify where the mouth of the tunnel is. You insert it and you slowly release liquid nitrogen. So we usually do 2 to 3 freeze-thaw cycles, about 5 seconds each. So what this does is it freezes the tracts. Again, this is a minimally invasive method for patients who do not want to undergo surgery. This is another method that we tried in our institution. Instead of doing a wide local excision, what we thought is we'll do a simple curettage. So this is how we just release the acne scars. You just do back and forth movements. We did this method in about 6 patients, and we did about 2 sittings. and it gave a very good result. Again, these are all minimally invasive methods in patients who do not want wide local excision. And usually surgical methods have to be done in an inactive disease. Sometimes they can be done in active disease when the patient is on biologic as well. But usually the disease has to die down for you to try these methods. Next, moving to laser and light therapy. We all know that the follicular component is a very important pathology in HS. So we do laser hair removal with Nd:YAG and alexandrite, and CO2 laser is used for performing all those invasive excision methods. So we thought as long as we are doing laser hair removal, why not permanently remove the hair follicles? And then we tried FUE for the hair follicles. For this we gave tumescent anesthesia, and using a 0.9 mm punch, we aimed to remove 60 to 70% of the hair follicles in the axilla. We have only tried this for axillary HS. And then we did a simple paraffin dressing for about 5 to 7 days and gave a course of oral antibiotics. FUE can be done in all stages of HS. You need not wait for the disease to become inactive. So this is one case where the patient had an active abscess. We excised the abscess and did a simultaneous FUE. Even in stage 2, where the patient had a sinus tract, we did FUE over the lesions, and it gave us wonderful results. So this was about 1 week post FUE. Here you can see a resolution of the not only the non-inflammatory component, even the inflammatory component of HS also reduced with FUE. Right, so for people who do not have the expertise and the machines to do an FUE, even a simple electrolysis of the hair follicle should also work. So this is one case which I recently tried. The patient has not yet come back for follow-up, but electrolysis is again another method of hair removal. So whatever methods we try for hair removal, all of them can be done for HS as well. So there are a lot of miscellaneous therapies now. Botox has been used, photodynamic therapy with 5-amino-levulinic acid, IPL, hyperbaric oxygen therapy. There are silver-coated garments, and there is microbiome modulation. These are all the newer methods which have been tried for HS. So summing up everything that I spoke today, the first line would be oral tetracycline, and if you want to go for the biologic, it would be adalimumab. Surgical methods can also be used as first line if the inflammatory component is not there. So a flap plasty reconstruction is what is recommended as first line. So my prescription usually for an active disease would be topical clindamycin and benzoyl peroxide gel and topical resorcinol. And my choice of tetracycline is usually minocycline because it gives me good results and it's used as an OD dose. Rifampicin and clindamycin combination for moderate to severe disease. I always add a probiotic because it not only decreases the gastrointestinal side effects of the antibiotic, but also probiotics are used, as we all know, in acne, so many cases, metabolic cutaneous cases. So HS, please add probiotics as well. And I shift to adalimumab if I'm not happy with the response after 12 weeks. I recommend LHR for all my patients of HS, and now that is gradually shifting to FUE. Thank you all for your patient listening.
Any questions from the audience?
Regarding this cryoinsufflation,
yes, sir.
Niti Kungar does phenol cauterization of that. But I have my doubt about that. Because here inside the abscess is getting collected. There is pressure inside. Because of the pressure, the fluid seeks the line of least resistance. And through that line of least resistance, it forms a sinus, and what is there inside gets discharged.
Yes,
it is like volcano erupting.
Yes, sir.
So, what we are doing is, we are closing the sinus. But by closing the sinus, if the abscess collects inside, it is going to form another sinus.
So the point is that if there is a sinus, the oral antibiotics will not act because there is a nidus of infection there. So we need to remove the sinus tracts by any of these methods, either by a laser or by a surgical, or we
is
freeze
not the
it.
pathology here.
No,
the
but
pathology is the hair follicle, those debris which is getting collected inside, the abscess being formed.
Yes, sir.
Sinus is only a passage.
Yes.
So by removing the passage, how do we actually convince ourselves that this is going to work?
It becomes aesthetically more appealing. Because, I mean, when you look at a patient of HS, if there are so many abscesses, I mean, sinus tracts and fistula.
But at least in the past, it would have come out through the same sinus. So you have closed the sinus and you are giving an opportunity for a new sinus to form.
Sir, we don't
Okay,
always see discharging
you just
sinuses.
think it
Yes,
over. Think
yes,
it over.
yes.
There is always a chance to rethink.
Yes.
I personally believe that one should rethink about closing the sinus. Closing the sinus.
Yes, sir. Thank you.
Any other questions? Okay. Okay, thank you, Dr. Sana, for the nice presentation. With this, we close this session. About you, Praganijas.
Thank you, ma'am, for your wonderful insights on hidradenitis suppurativa. I would request our speaker and chairperson to collect their mementos. Moving ahead for the next session, I would like to invite the chairpersons, Dr. Meenakshi Muni ma'am and Dr. Nihar Ranjan Pati. Dr. Meenakshi Muni and Dr. Nihar Ranjan Pati, if you are.
Good afternoon to one and all. It's my privilege to serve as chairperson in this session. Without further delay, I would like to invite our speaker, our esteemed speaker, Professor Dr. Swastika Subriya, Head Department of Dermatology, King George Medical University, Lucknow.
So at the outset, I'd like to thank the organizers, Dr. Abhishek Jha, Dr. Vikas Shankar, and Dr. Shwetlina Pradhan for having me here. And the topic of my deliberation today is Beyond Skin Deep, Connecting Clinical Dermatology with Radiological Insights. So unlike dermatology, which is a world of colors, imagine the plight of a radiologist. They would have to decipher this condition with 256 shades of gray. So for them, air normally appears black, bone white, and soft tissue appears in varying intensity of gray. So these are the 256 shades of gray, depending on the intensity of which they identify the location, the pathology, and the extent of the disease, and provide us a probable report. So histopathology remains the gold standard for us dermatologists, but radiological imaging may serve an important adjunct in few selected cases. So in this lecture, I'll be just covering about X-ray, CT, MRI, and USG by few case scenarios. So X-ray, we all know, is good for calcinosis and to detect bone involvement. The cheap and quick procedure, you can get it anywhere, even it available at PHC. The problem with it is the poor soft tissue contrast. It won't give you the pathology of the soft tissue and the risk of radiation. Now CT again is good to detect any bony pathology, but not good for any soft tissue. The problem with CT scan is again high dose of radiation. Now MRI is very good. It has minimal, no risk of radiation. It's good for imaging the soft tissue part. And moreover is operator independent. So somebody who check the MRI, it's not that you would give a different report, some other radiologist would give a different report. It's an operator independent procedure. So that's the biggest advantage for MRI. But the problem with it is the cost of MRI. And it's not good for any bony pathology. For ultrasound, we all know we have been using it for decades for assessing the peripheral nerves in leprosy. It detects the peripheral nerves, the nerve enlargement. It's a bedside procedure can be done. It's a cheap procedure, but the problem is again, it's operator dependent. So some radiologist would give some other conclusion and the other might differ on that. So it's not operator independent as compared to MRI. So I'll be discussing few other case scenarios in which we have used radiology at our place to help us in reaching a diagnosis, to identify the extent of involvement or help us in managing cases. So this kid was, he was brought to us at 2 years of age. He was a male child. As you could see, he had a large congenital giant melanocytic nevus covering the entire trunk along with satellite lesions, multiple. So neurocutaneous melanosis should be ruled out in such cases. The protocol is there to get an immediate MRI. But this kid presented to us late. He presented at 2 years of age. So we did a MRI, a CMRI was done for the brain as well as the spine. The MRI identified hyperintensity, as you can see, in bilateral medial temporal lobe, the orange arrows, and also in the cerebellar tonsils. So of course, when you have a giant CMN, it carries a size-dependent melanoma risk around 5 to 15%. And neurocutaneous melanosis is asymptomatic proliferation of the melanocytes. Is often asymptomatic, but then you need a prolonged follow-up in these patients. They have high chances that these patients might develop melanoma either in the brain or the lymph nodes. So the risk of melanoma is highest when it's less than 10 years of age, accounting for 50% of the CMN-associated melanomas. And ideally, MRI brain and spine should be done early, less than 3 months. Why? You would avoid contrast. Myelination is not complete. It would be relatively easier for the kid. So malignant degradation of CNS melanosis on radiology is suggested by the central necrosis, hemorrhage, edema, and local mass effect. And for that, you need to do serial MRIs. So this kid, despite our advice, he presented to us again a year back. By that time, he had developed a large hard node, as you can see, a large mass in the right inguinal region. So of course, he had developed melanoma in the inguinal lymph node. A biopsy was done, which proved to be a melanotic melanoma. And I could not put the images of the ultrasound. This is the X-ray image, which shows the relatively well-defined radiopacity in the bilateral inguinal region, right greater than left. So unfortunately, we lost this child after 3 months. He developed metastasis at multiple places, and we lost this child after 3 months. Now, Sturge-Weber syndrome is a triad of port wine stain, mental retardation, and seizures. So when should these patients be imaged? So you can see this patient had a PWS. Also, you can see the glaucoma in her right eye. So ideal imaging to detect the calcification in brain for these cases is a non-contrast CT. You don't need to use a contrast CT. And we get a tram track calcification in the parieto-occipital region. They run parallel, like a train line. So it's called a tram track. Along with calcification, there is cerebral atrophy, volume loss, as was there, ipsilateral hemiatrophy was there, here also, and there is calvarial enlargement. And you can see the port wine, the calcification will be ipsilateral to the side of the port wine stain, like in this case, it's on the right side only. So it's the third most common neurocutaneous syndrome, SWS, after neurofibromatosis and tuberous sclerosis. The cutaneous clue is when you see a port wine stain, these patients should be imaged, but only 3 to 6% would have associated SWS. The highest risk is whenever the forehead is involved, or the port wine stain is bilateral, which predicts a bilateral brain disease. So brain involvement we discussed is usually ipsilateral, there is a tram track calcification, and bilateral disease, though rare, is linked to a poorer prognosis. The tram track calcification appears, to classical imaging, it appears best after 2 years of age and should be seen on a non-contrast CT. Now we have been using this modality quite often in our patients of Hansen's disease. So both how to assess the peripheral neuropathy along with UHE, you can also do something known as MR neurography, MRN. That would image multiple nerves at a time and would be operator independent. So normally an ultrasonography on a transverse section, there is a honeycomb appearance of the nerve, as we can see in the golden image, the honeycomb appearance. So what happens is whenever these nerves are thickened, like here, this patient presented with ulnar claw, on imaging, the honeycomb appearance is lost. You can see the white arrow, as compared to the left side panel, the panel A, where the honeycomb appearance is there. Here the honeycomb appearance has been lost. What also happens is normally the peripheral nerves have minimal vascularity. The vascularity would increase. So the vascularity is increased and that honeycomb appearance, which is there like this, has been lost. And whenever an abscess is formed, the region would appear totally black, like this. Now the other image, this panel shows a MRN. We have been doing it as a thesis at our place in patients of leprosy. The advantages of using MRI for imaging of peripheral nerves is that you can image multiple nerves at one time. It's operator independent, and you can see there's a hyper-intense signal near the ulnar nerve. Mostly a perineural abscess was identified, which was clinically not evident. Now, nowadays there is much debate about CNS involvement in leprosy, that leprosy is also involving the brain and the cord, the evidence for which we have is again in the form only of imaging. Of course, these areas can't be imaged on ultrasonography, so MRI is the modality of choice. We have done 2 studies at our place, and patients coming especially with element type of cranial nerve palsies, like in this patient, you can see the Bell's phenomenon is evident on the right side. If these patients are imaged using an MRI, dedicated MRI of the brain and the spinal cord, sometimes you can identify signals. Other chronic disease like diabetes, vasculitis have to be ruled out. So the cervical spine showed a long hyperintense signal here, a white signal from C3 to C7. Also ganglions, they were enlarged. There was dorsal nerve root ganglionitis. So even the brachial lumbar plexus and the dorsal nerve root ganglia are being involved at both C5 and C7 levels. So this is a much debated thing. We have followed these patients even after a year of MDT, and in majority of the cases the signals are resolving. Of course, a definite evidence we do not have for these patients. You can't go and biopsy these areas, but the only evidence for now we have the MRI. So HRUHG is the preferred method for imaging the peripheral nerves in leprosy to detect abscess, increased vascularity, nerve enlargement and fascicular distortion. These could be markers of early or subclinical neuritis. So MRI, we have discussed, is an operator independent procedure, especially useful when you are imaging the deep nerves. Obese patients, HRUHG might not be useful there. MRN would be useful and would help you in image the roots and plexus as well. CNS involvement has been discussed, and CNS lesions may explain the deficits disproportionate to peripheral neuropathy and are to some extent, in few papers that have been published, they are reversible with treatment, supporting a possible inflammatory basis for these lesions. This is one of our papers which has been published in the Journal of Central Nervous System Disease. It was a thesis from the neurology department. And generally, where is the involvement there? The CNS involvement is generally seen in the brainstem and spinal cord as a T2 hyperintense lesion. The nerve plexuses may also show irregular thickening without post-contrast enhancement. So this was a very interesting case. This lady, she was a lactating female. She was referred to, 31-year-old female, referred to us from the Department of Surgical Oncology. So she had this orangish plaque, slightly warm. She was given multiple course of antibiotics by the oncologist, and they had no clue what they were dealing with. They didn't advise any investigations, and the patient was referred to us to seek opinion. Now, seeing the lesions, the PUD orange kind of a plaque, slightly retracted nipple areolar complex, you can see there was a small lymph node also about 2 into 2 centimeter in the right axilla. The differentials that would come to our mind would of course be a malignancy. But seeing the lesions that was warm, we also prescribed antibiotics, but the lesions did not improve at all. We then advised a HRUHG breast for the patient. In the panel B, a cystic lesion was seen containing multiple linear and curvilinear structures. What was interesting is, in this anechoic area, you can see these echogenic structures. These are chaotic twirling movement of the adult filarial worms. So when you get it, it's diagnostic for filariasis. So it's chaotic and twirling, and it's generally characteristic for the adult worms. So we also went ahead, did a mammography. We were still suspicious. Though it's diagnostic, the radiologists were very sure we don't need to work up the patient now. We worked up the patient. We did a mammography. There were few foci of linear and curvilinear. World calcification was seen in the outer quadrant. Now the calcified worms will be generally the dead worms. We also went in with a USG guided FNA because we wanted to write the case. It showed numerous filarial larvae with tail tips free of nuclei and their eggs. This was a follow-up pic of the patient after 16 weeks. The patient was treated with diethylcarbamazine, 6 mg per kg, 2 cycles of 21 days each. For persistent lymphoria, we managed the patient with sclerotherapy along with the surgeons. So for breast filariasis, radiology is diagnostic. You do not need a further investigate the patient. In this case, like we could avoid a biopsy and the cosmetic disfigurement could be avoided. So filariasis normally would be confirmed by a peripheral blood smear demonstrating microfilariae. As our area in UP, these are endemic for filaria. So breast involvement generally, many a times is confused with malignancy. So you can seek help of your radiologist, may present as a nodule or lymphangitis. And the filarial dance sign is highly sensitive and specific, around 85 to 95%. So once you get it, the dance sign, you could treat your patient for breast filariasis. Don't need to go in for any biopsy. So this is one case was published in Clinical and Experimental Dermatology, and we named it as a dance that paves the way for diagnosis. Now this was another interesting case. He was a farmer by occupation. 41-year-old male, he complains of these nodules, abscesses and sinus tract on the scalp. He had a history and fight with his brother. His head was banged against the wall, which developed a secondary infection. And then again, he presented to us with this picture on the left side. And he had a minimal headache, very minimal headache he complained of, but still we went ahead with an MRI, which showed a heterogeneously enhancing soft tissue thickening. These thickening was identified along with erosion of the underlying calvaria. The bone was also eroded. The radiologist suspected some sinus involvement, and then what they ordered, they asked him for a MR venogram. That is one special kind of venogram that is done. So his sinuses, they were occluded, the left transverse and sigmoid sinus. They were involved, but fortunately for him, the collaterals had developed. So he was not that symptomatic. His ICT was not increased. He had only minimal headache. Without treatment also, he had this collateral development. We did in a biopsy, and as you can see, the biopsy on special stain also, these showed the grains. So actinomycosis, we all know, is a chronic granulomatous infection caused by actinomyces. Can be of a varied types. The commonest one is cervicofacial, like in this case, thoracic or abdominal. Gram stain and histopathology are the clue, because cultures could be negative in 50% of the cases, like even in our case. The problem is these patients are being treated with repeated short course of antibiotics by the physicians outside before they come to a dermatologist. So skull vault or CNS involvement is rare. You can see calvarial osteomyelitis in our case, epidural or subgaleal collection of brain abscess. The radiology would show the osteolytic lesions, as in our case. But what was interesting about our case was the sinus involvement. We sought consultation, referral from a neurosurgeon, but they asked not to intervene. The patient had developed multiple collaterals. We went in ahead with oral antibiotics only, doxycycline and clarithromycin. Clarithromycin was stopped after 6 months, and again, doxy was continued for next 6 months. So surgery would be reserved either as a diagnostic or therapeutic purpose in CNS cases, generally in reference with the neurosurgeons. But in this case, they decided not to intervene, only a skin biopsy was done. So this is again published in IGDVL. Now, mucormycosis, these series of cases, it was published by us in IGDVL as an original article. We could get a number of cases. There's a COVID ward, and we could get around 51 cases with cutaneous involvement of mucormycosis. As for this case, see, the first diagnosis that comes to our mind, seeing these rolled out edges, the first thing that comes to our mind is BCC. Because he was admitted during COVID times, and the first thing that is being done for these patients when they come to the ward was a MRI. So a T2 weighted suppressed MRI showed a ill-defined soft tissue mass here involving the skin and subacute tissue with mild skin irregularity, and there was involvement in the brain as well. So the lesions, of course, you need to biopsy and culture. There's a case of secondary cutaneous mucormycosis, which would show the rhizoids. So cutaneous mucormycosis may present as a primary disease where the skin is primarily involved. We could get only one in a series of 51 cases. There was trauma at the site. You could get it as a primary disease or secondary dissemination. The cutaneous, the skin is involved, secondary to dissemination from the rhino-orbitocerebral mucormycosis. We could get a number of morphologies, and the commonest one was the abscess, which we could get, nodulopustular, eschar, which is commonest one. We could get only one case. Mucosal lesions we could get as corrugated plaques, as ulcers, and there was a number of mimics that we identified. Also, we identified in the nodulopustular lesion the dot and circle, which we till now is very specific for mycetoma. In these cases, we could also get the dot and circle, the cases of mucormycosis. So probable disease, especially because the mortality is so high, you can make a probable diagnosis like in this patient. Based on clinical features and radiologist, because the microbiology and histopathology will take time for a definite diagnosis. Because these are life-threatening, you can start the patient on IV amphotericin B. So this was again published in IGDVL. Now this is a case of psoriasis. Now psoriasis may, along with erosions, you also get bony proliferation as compared to rheumatoid arthritis, which is only erosion. So what is characteristic here? The blue-black arrow shows the erosive changes. The blue block arrow here, erosion. Here there is proliferation, there is new bone formation, and here the yellow arrow shows the penicillin cup deformity. Now cervical spine is generally involved early in cases of psoriatic arthritis if it is, and here the cervical spine showed calcification of the posterior longitudinal ligament in this case of psoriasis. We got this case from our rheumatologist. And unlike this, you see the rheumatoid arthritis, there is more osteopenia and much more erosions, but then there will be no new bone formation. In rheumatoid arthritis, the new bone formation is not there, osteopenia is marked, and as we discussed, it's erosive and proliferative. Here it is purely erosive. So this again shows the image of a case of a dermatomyositis. This shows the calcification. Now X-ray is good for this calcification, or you could do a CT as well. Generally the hip area is preferred. Here it showed multiple specks of calcinosis. So calcinosis universalis is a severe dystrophic calcification involving the skin, subcute and muscles. The imaging would identify the sheet of subcute calcification, as in this case. Not only is the commonest one to be seen in juvenile DM, though it could also be identified in case of SLE, mixed connective tissue disease, polymyositis. The management is not very definitive. Response is variable to bisphosphonate and sodium thiosulfate. So I'd like to conclude that radiology with clinical correlation can transform these grayscale images into clinically meaningful insights. It might not be solely diagnostic, as in our series, the only where it was solely diagnostic was the case of breast filariasis. You might need the help of the histopathology as well, which remains the gold standard. But it enables you the precise evaluation of deep and systemic involvement. And when used appropriately, imaging may become a decisive tool in diagnosis, disease mapping, and of course, management planning for these patients. These are my references. Thank you.
Thank you, ma'am, for your excellent and insightful talk. Any questions from the audience side? Thank you, ma'am. On to the next session.
For the next session, I would like to invite our chairpersons, Dr. N.K. Behra sir and Dr. Suman Jagdev. I'd request our speaker and chairpersons to kindly collect their mementos.
The next topic is psychodermatology in day-to-day practice. So I would invite Dr. Abdul Latif to come to the dais and deliver his speech.
Yeah, very good evening to you all. At the outset, let me thank the organizers for inviting me for this lecture. We know psychodermatology is a very important area in our day-to-day practice. There are some famous quotes in Bhagavad Gita: man is made by his beliefs, as he believes so he is. And there is another quote by Prophet Muhammad: there is a part in our body, if it is healthy, the whole body is healthy. If it is sick, the whole body is sick, that is mind. Psychodermatology, we know this is actually, there comes the dermatology, psychiatry, so a combination of these two areas. Skin and brain both originate from the same ectoderm. So diseases of the mind can affect the skin, and diseases of the skin can affect the mind. And skin, the largest organ of our body, and an important organ of emotional expression. And various studies are showing psychiatric morbidity in our OPD patients that ranges from 30 to 40%, an IP patient up to 70%. And there are so many psychiatric morbidities, anxiety, depression, adjustment disorder, these are very common. And we know skin is a part of a nice system, neuro, immunocutaneous endocrine system. So if there is an issue arising in the skin that will affect the immune system, that will affect the central nervous system. So see, if there is a problem in mind, that will affect the other systems. So all these system has to be managed simultaneously. So stress can induce or exacerbate many of the dermatological conditions. And we know the stressors activate two major pathways. One is hypothalamo-pituitary adrenal axis, and secondly, the sympathetic nervous system. So all these two systems, if affected, that will affect the immunity. So their management is essential in the management of dermatological practice. And you can see there is very high, very rich innervation of almost all structures in the skin. So this is very important in the management of mind. So stress has a significant role in the pathogenesis and prognosis of many skin diseases. And all cases has to be considered as psychodermatological cases unless otherwise proved. Or if response to routine therapy is less, or obviously there are psychological manifestations, then you have to treat it as psychodermatological condition. Then these are the various types of psychodermatological conditions. One is primary psychogenic dermatosis, where there is a primary psychiatric disease that will lead to skin disease. That is very less, like delusional disorders, factitious disorders and all. Then the second group is there is a secondary emotional disorder along with skin disease. As primarily there will be a skin disease that will lead to psychiatric disorders. That is common. And the thirdly, multifactorial diseases where common dermatological conditions exist, that is exacerbated by stress. Then the fourth group contains mucocutaneous pain syndromes. So there are other classifications, but I'm not going to that. So these are the various psychological issues that can arise in dermatological conditions. I'm not reading all these things, but you have to realize the skin disease can produce a variety of psychological issues in the person, and in turn that will affect the immunological system, and that will affect the smooth healing of the skin lesions. So we have to manage all these areas. So we had conducted one study how the dermatologists are comfortable in diagnosing the psychodermatological area, an online study among dermatologists in Kerala. So they had shown only 13.3% were very comfortable in diagnosing psychodermatological conditions. In another study, we had conducted the depression literacy rate among dermatologists. That was almost a very good percentage, almost 60-70% were able to diagnose, but majority are not treating the cases. So these are the various cases we are seeing in our day-to-day practice, but how to manage it is very difficult to manage some of these cases. So I'm conducting a psychodermatology clinic in Government Medical College, Calicut for last 15 years. So for the last 10 years, I had just taken the data. Then on an average, around 600 patients attending yearly and 200 new cases and 400 review cases yearly. And the patients are referred from dermatology OPD or from outside also. So these were the common cases attending our psychodermatology clinics, where you can see almost all common dermatological conditions are attending the psychodermatology OPD. So I'm not reading the conditions, so you can see almost all conditions are there. These are all primary dermatological cases. These are the primary psychiatric cases like psychogenic pruritus, delusional disorder, skin peaking syndrome. But in addition to the dermatological problem, there will be an underlying primary psychiatric problem is there. So almost all type of conditions are attending. And the overall psychiatric morbidity in dermatological conditions attending the psychodermatology OPD was almost 71%. And the various psychiatric diagnosis in primary dermatological conditions attending this OPD were these, and I have classified them. And I had conducted another study in prurigo nodularis patients that had shown almost 40% had psychiatric morbidity, and depression was very common. And also another study I had conducted in psoriasis, where a case control study where relaxation therapy was given in 2 groups. And almost 50% had a PASI became almost 50 at around 3 weeks comparing to the control group. So in psychodermatology cases, a biopsychosocial approach is very essential. So biopsychosocial approach means for any disease there is a biological factors like age, gender, metabolic syndrome, such things. And there will be a psychiatric background and there are social factors. So we have to analyze all these factors and treat. So a detailed history taking is needed. So a psychodermatological consultation is more time consuming and that requires a good relationship skills, empathy, and a basic understanding of psychodermatology is needed to be an efficient psychodermatologist. So the various psychological interventions are essential in dermatological management in these cases. So where psychotherapy and pharmacotherapy, these are very essential. So there are so many psychotherapeutic procedures in current practice. So these are the various psychological intervention we can use, and many of these interventions we are using in our clinical practice. So out of which there are various counseling techniques are so there. So one among is the psychoeducational counseling, supportive counseling, and psychotherapeutic counseling. So psychotherapeutic counseling is used to manage various psychological problems such as stress, anxiety, depression, and all. So out of which psychoeducation is very, very important in our many conditions. So regarding the etiology, you can see this is a prurigo nodularis. So in our part, especially in Kerala, most of these prurigo nodularis cases that's attributed to spider bite. So that poor spider is attributed for many of these skin diseases. And they're afraid of that. They will go to some quacks for taking this poison from the body. So they are very much afraid of all these things. So that will increase the disease. So we have to teach them the etiology, why that's developing, the precipitating factors, role of stress. And also some people, they are afraid that this is contagious to the family. Recently, one old lady came to me. The daughter-in-law is not allowing to touch the grandchildren. That's why she was very much stressed. So we should teach them and also the family members regarding the non-contagious nature, various treatment options, the consequences, the prognosis, and your successful treatment in the past. All these things you have to teach the patient. So you can see majority of these cases, there are some kind of stress. In this age, especially the adolescent age, the common stress is educational stress. So there will be some difficulty in comprehending some subjects. So when they are opening the textbook, they will start stressed and they will start scratching. So this is one reason why they are getting this type of lesions. So other group, there are some other stressors like adjustment disorder, depression, anxiety, some marital conflict, economical problems. So many issues are in their personal and family life. So we have to intervene these things, then only we will get a good response. So here the various other methods. So psychoeducation, if you are giving almost 50% of the psychological management is okay in the stress-induced dermatological conditions. And this is another thing, that's cognitive behavior therapy in dermatological conditions. So here, actually, the disease is not actually stressful, but how do we perceive the situation, that's very important. So in cognitive behavior therapy, what we are doing is we are just changing the perception. So they have one pattern of perception. We are just changing it to from unhealthy perception to a healthy perception. For example, so if there is an adverse event that will lead to some beliefs, that will lead to thoughts, attitudes, and assumptions, so that will lead to the consequences like emotions, feelings. So for example, a person fail in exam, he is thinking I am stupid. I will never be able to pass that exam again. So that will lead to depression. So that's one way of thinking, irrational thinking. So, but if that person is thinking in this way, I have failed the exam, that's right, but it is unfortunate that I failed, but I did not study hard enough, that's why I failed. So I must make sure that I will study harder and I can get it. So that will not produce any emotional consequences. So you can just tilt their way of thinking, that's very important. So in dermatology practice, for example, if a person have got a vitiligo patch, he is thinking people will think it is contagious and they will hate me, so that will lead to depression. And if you are just changing their thought process, I have a white patch, that's right, but you can see that wall where the paint has lost, but doesn't produce any problem to the wall. Similarly, there is my color of the skin that is gone, that will not produce any problem. So that emotional consequences has been changed. So there is a simple way in conditions where sometimes we will not be able to give a complete cure, but we can just change their thought process and that can give them consolation. Here you can see this previous Kerala governor, he was attending all the public functions without any hesitation. So the attitude is very important. Then comes the various behavioral therapies. So here we want to change one's behavior. So there are so many behavioral therapies are there that's useful in our day-to-day dermatology practice. So this one is a simple one is called a systematic desensitization. In these cases, I had done this. Actually, that girl came to me with some kind of pain or itching that she was unable to describe what is the sensation she was feeling. At around 7 p.m. every day, that girl felt such a sensation she was unable to read. Then I understood there is some problem in that girl. Then I had taken for that girl and to this systematic desensitization. And before that, I asked her what is the problem. Then she told me I had witnessed one circus scene at around 7 p.m. and where there was a death well and where a cyclist was doing one cycle things and she was shocked by seeing that. So at around 7 p.m. she had witnessed that scene, and every day at that time she is getting these symptoms and she was very much uncomfortable. So by by even a single session she was almost okay. Then I had repeated another session. So she was completely okay without any medication. And the another girl with henna phobia, she was very much afraid of henna due to some smell. Then also here also I had done the same thing and she was completely okay. Then another thing is habit reversal. This is very, very simple but very useful in our day-to-day practice. So itching is a sensation that needs medical management, but scratching is a habit that has to be, that need a psychological approach. So any habit involving the hands, like scratching, biting, sucking and all, so we can teach them a simple exercise like this. They can just hold their hands, then very firmly they can push around the against their thighs in standing or sitting, any posture. So they can control their urge to scratch. So, and also during reading, if they are scratching, they can hold some balls, some like this thing in their hands. They can squeeze it. Then they can control their urge to scratch. So these are some balls, some magnet and all. That is also useful. Then another thing is mental imageries. That the last session will be a relaxation. So I will just visualize make you understand how is the mental imagery is helpful. So here this is very, very useful. After relaxation, we will give them some mental imageries that usually in these types of patients, the body picture will be highly distorted. So they are thinking the body is completely distorted. That distorted picture will be in their mind. So we can change that distorted picture into a healthy skin. So that will change the psychoneuroimmunology so that you can get a rapid clearance of the disease. So this is useful in all these cases. So I had tried in Hansen's disease. Even venereal phobia, one person, he was about to commit suicide. So by doing this mental imagery along with relaxation, I could save his life. Then trichotillomania, here also we can use this imagery, mental imageries also, and also habit reversal. So we can combine many methods in single patient. So mental imageries will help calming the mind and body, promotes relaxation, improve immune function, and improve healing and decrease blood pressure, all these things. Then breathing exercise also will do almost similar function. That will help to calm the mind and body, and that will help to increase the parasympathetic activity. Then similarly, relaxation therapy, we are going to practice it. So relaxation is a skill to be learned through repeated practice. So relaxation methods, there are different types are there. Progressive muscular relaxation, deep muscular relaxation, rapid relaxation, so many methods are there. If you practice it, we can do it with a few seconds, 20, 30 seconds, we can go to relaxation. And I have done this relaxation therapy in psoriasis, I told you, almost 70% achieved PASI, 50. So these are the relaxation therapy I'm using in various conditions, like this is atopic dermatitis, chronic urticaria, lichen amyloidosis, prurigo nodularis. In all these conditions we can use, this is a skin picking syndrome. So this is a Hansen's disease with erythema necroticans. So we can use this relaxation therapy in many of these conditions. So that will help in calming the mind and body, increase self-esteem, normalization of sleep, decrease psychological morbidities. Then meditation, especially now the mindfulness meditation is getting very high attention. Globally, so many studies are going on, so we can use this mindfulness meditation also. Then another important thing is group therapy. This is very simple, especially those conditions where we can offer nothing, especially vitiligo and such conditions. If the disease we can cure, this is very useful because that will help to share the concept of the disease and emotional problems they have faced in their family and society and the various coping methods, treatment options. So a problem shared is a problem halved. You can see the many vitiligo patients are attending the group therapy, so that is very, very useful. They can get very good emotional control by group therapy. And family therapy also is very, very important because family involvement is very, very important in the patient management, especially psychodermatological treatment. That is very, very important. Then hypnotherapy is also very, very useful. So hypnosis is an intentional induction, deepening and maintenance and termination of a natural trance-like state for a specific purpose. So we can, I'm not going into details, so you can use hypnotherapy in all these conditions. So that's also very useful. You can see in alopecia areata and also this Hansen's disease. I have published one article, Hansen's disease with neuralgia and type 2 reaction. Hypnotherapy was highly useful. So especially neuralgia, we will get immediate result after hypnotherapy. So factitious dermatitis, hypnotherapy is highly useful, and without any recurrence we can treat it. These are all the conditions I have treated factitious dermatitis with hypnotherapy. I'm not going to the history. These are all long histories in all these patients. You can see hypnotherapy and trying. Then comes the pharmacotherapy. So pharmacotherapy also is very important in the management, especially few molecules we should be very familiar, especially mirtazapine. That is a very good molecule, antidepressant. It has very high antipruritic action and very good sedative. So those people, if they have sleeplessness, very severe pruritus, mirtazapine is a very good molecule more than our antihistamines. Then other antidepressants, non-sedative, escitalopram, fluoxetine, these are all useful. And if the person has got lack of sleep with depression, with not much itching, then you can start sertraline. And also this anxiolytics for a short period we can try. Then antipsychotics, especially risperidone, aripiprazole, these are all useful in our delusional parasitosis. So we should be familiar with few molecules. That's very important. So it is better to be familiar with one or two molecules. So the advantage of psychodermatological approach in our dermatological practice is the treatment response will be very rapid. The cure rate is very high. Patient suffering is minimized. Patient satisfaction excellent, and the dignity of the doctor will increase. So the frequent indication for psychotherapy in dermatology is deterioration of the skin symptoms under emotional stress, excessive manipulation of the skin, pronounced social anxieties and sociophobia, severe depression, and disfiguration syndrome. So in this condition, so we have to refer to a psychiatry or psychologist. So if you are trained, you can try to up to a great extent, but if these symptoms are there, major depression, lack of insight, bipolar disorder, suicidal ideation, then you have to refer to a psychiatrist. So in conclusion, psych has an important role in the pathogenesis and prognosis of many dermatological conditions. So dermatological treatment alone is not complete in the management of skin disease. So in minor psychiatric morbidity, psychotherapy along with dermatological treatment is okay. But in case of major psychiatric problem, psychotherapy plus psychopharmacotherapy is essential. So the take-home message is skin is a major organ of emotional expression. Mind-body has to be considered as a single unit, and referral to psychiatrist is often not acceptable to the patient. So basic level of psychiatric knowledge is essential for a dermatology. So this area is still in infancy, you have to work for that. So these are really references. So thank you for the patient listening. Then we can go to the relaxation for 5 minutes. Okay. So after that, any questions are there, you can ask. So time is limited, that's why you can. So before going to the relaxation, all of you, please switch off your phone. And
One question can I ask, sir?
Yeah, no problem.
So thank you very much for your sensitization, especially on the psychodermatologist, which needs high sensitization. What is your experience in pediatric age group, the psych and the child skin?
We will think the pediatric group is, their emotional issues are less. That is usually our thought process. But they have got a very high emotional issues, especially those conditions where the atopic dermatitis, for example, if the body is full of lesion, they will not be able to go to the school. Even if they are going to the school, there will be so many problems from the students, from the teachers. So the psychological issues, anxiety, depression, adjustment disorder, such psychiatric, even major psychiatric morbidities are very high in depending upon the severity of the skin disease. So there is one area not much explored and that needs much exploration, especially in Indian scenario. So especially the educational issues are very, very common. And atopic individuals, the Indian scenario, the studies are very, very less how their education is going on. So many are stopping their education 10th or plus 2 level. So the psychiatric issues are very, very high. So that area has to be explored.
And you mean to say the severity directly proportional to the psychological aspects?
But there are both ways. Some individuals, not only the severity of the skin, that also depends on the
Exposed
perception
parts.
of the...
For example, if psoriatic patch is there on the face, so if they go to school or psychologically they're bullying, so that will not be taken care by either teachers or the parents.
Yeah,
so
that
parents
is
are there busy with
visible
their own.
area, the psychiatric morbidity is very high. And also depending upon the perception of the individual, that is also important. Because some individual, if they are the perception, they are thinking of taking it very easy, then the psychiatric morbidity will be less. But even small lesion on the face, so my white patch on the face, I have seen the person is very much depressed with the suicidal ideation. Any more questions? Then we can go to the relaxation. So you can just remove your spectacles and also you will be completely relaxed. And can I get one cordless mic? So all of you, please sit very comfortably. It's better to sit comfortable. Keep your hands on your thighs. Keep your legs a little bit apart. And sit very comfortably. Then if these lights are, can you just dim it those lights, then that will be better. So, yeah, that's good. Now you close your eyes. So I'm just first you're taking to the relaxation, then some imageries I will put, then you can enjoy, and you can understand what's happening in your mind. So close your eyes. All of you, close your eyes. Keep your legs on thighs and keep the legs apart, not locked. Be comfortable in sitting posture. Take a deep breath. Hold it as long as you can hold it. Deep breath. Hold it as long as you can hold it. Just concentrate on the movement of the air through your nostrils. Repeat it. Take a deep breath. Concentrate on the air coming and going through your nostrils. Repeat it 5 times. Close your eyes. Don't open your eyes. Close the eyes. Sit comfortably. Just concentrate on the air coming and going through your nostrils. And all of you can keep your hands on your thighs. That will be comfortable. Repeat it 5 times. Take a deep breath. Hold it as long as you can hold it. Slowly exhale it. Repeat it. Repeat it 2 times more. Take a deep breath. Hold it as long as you can hold. Slowly exhale. Repeat once again. Now you just listen what all sounds you are listening. Listen all the sounds coming to you and enjoy it. Listen all the sounds you are hearing and enjoy it. Now you smell what all smells coming to your nostrils. Just smell it and enjoy it. Enjoy the smell that is coming to your nostrils. The newcomers can close their eyes and attend the program. Now you enjoy the taste that you are tasting in your mouth. Now you enjoy all the sensation from your head to foot. Enjoy all the sensations from head to foot. Now just imagine your body posture sitting in a very calm and comfortable way. Just imagine you are sitting very comfortable way, your body posture. Newcomers can close their eyes and participate in the program. They have to switch off their phone. Just imagine your body, you are sitting very comfortably. Now you just concentrate on your head. All the muscles of your head is going to a deep relaxation. And beware not going to sleep. Now you concentrate on your eyelids. The eyelids are becoming heavier and heavier. The weight of your eyelids are increasing. Eyelids are becoming heavier and heavier. Heavier and heavier. Heavier and heavier. Now just concentrate on your neck. All the muscles of your neck is going to very deep relaxation. And you beware that you are not going to sleep. Now you concentrate on your hands, all the muscles of your hands, from shoulder to the fingers. There's going to be deep relaxation. The weight is coming down and down. The weight of your hands are coming down and down. Like a feather in the air, the hands are becoming weightless and weightless. Now you just concentrate on your chest, all the organs of your chest, your respiration. Just concentrate on your breathing. All the muscles of your chest is going to very deep relaxation. Now just concentrate on your heartbeat and enjoy the heartbeat. The music of your heart, you just listen and enjoy. Now you concentrate on your abdomen, all the muscles of your abdomen, all the organs, the intestine, the liver, the spleen, all the organs are going to very deep relaxation. And you beware that you are not going to sleep. Now you concentrate on your waist. All the muscles of your waist are going to very deep relaxation. Now you concentrate on your thighs. All the muscles of your thighs are going to very deep relaxation. Now your legs, your toes, all the muscles of your legs are going to very deep relaxation. Very deep relaxation. Now the weight of your legs are coming down and down. Like a feather in the air, the legs are becoming weightless and weightless. Weightless and weightless. Now your body completely relaxed. Just imagine your body sitting in a completely relaxed posture. Once again, you relax from your head, and your eyelids are completely relaxed. Your neck, your hand, your chest, your abdomen, your waist, your thighs, your legs, your foot, completely relaxed. Once again, your head completely relaxed, your eyelids, hands, chest, abdomen, going to very deep relaxation, your waist, thighs, legs, and foot is going to very deep relaxation. Now I am counting from 5 to 1. When I count 1, you will be completely relaxed. Like you are getting down each step from a ladder, by counting from 5 to 10, you will be completely going to a deep relaxation. 5, you are going to a deep relaxation. When I reach 1, you will be completely relaxing. 4, going to a deep relaxation. 3, 2, you are going to very deep relaxation. When I count 1, you will be completely relaxed. 1. Now you are completely relaxed. Completely relaxed. Your mind and body completely relaxed. Now you just imagine a seashore where you are sitting. Just imagine a seashore. And you are sitting at the seashore. You look at the sea. See the boats, the ships, the waves, and the breeze. Enjoy the breeze that is coming and blowing on your body. Enjoy the sunset. Look at the sea and enjoy the sunset. You can enjoy the seashore now. The sunset you can see, enjoy it. The boats, the ships you can see, look at that and enjoy the waves, the blue sea, and the people around you. So many people are there. you can see them and enjoy it in a comfortable way. More than where you're really sitting now, you can enjoy it better than that. Enjoy it. Now you just concentrate on your body. You imagine your body from your head to foot and imagine it's completely healthy. You imagine your body completely healthy from head to foot. Your head is so healthy. Your neck, hands, chest, abdomen, legs, all the organs are completely healthy and you are leading very healthy, active life. Just imagine you are leading a very healthy, very active life like you were in your adolescent age. Imagine that your body is completely healthy and you are leading a very healthy and very happy life. And just tell in your mind without moving your lips or your tongue, you just tell in your mind, I am completely happy and healthy. Just tell in your mind, I am completely happy, I am completely healthy. And once again, you just imagine your body from head to foot and imagine it completely healthy and leading a life which you had experienced in your adolescence. Now you are completely relaxed. You are completely happy now. You are very much healthy now. Now I am going to take you back. I will be counting 1 to 3. When I count 3, you can massage your hands. Then you can massage your cheeks and open your eyes when I count 3. So I will be counting from 1 to 3. When I count 3, you can massage your hands. Then you can massage your cheeks. Then open your eyes. When I count 3. 1, your body is coming to the normal state. Now you can move your fingers and toes and eyelids a little bit. Now the body is coming to the normal state. 2, you are able to move more than earlier. You are able to move your fingers and toes and your eyelids a little bit more than that. Now I will be counting 3, then you can massage your hands and massage your cheeks. 3. So hope many are relaxed, many have slept, and few people couldn't close their eyes. Anyway, majority I think they have gone to a very good relaxation. If you are going still more deeper, you will go to the hypnosis. Then we can elicit so many things, as hypnoanalysis, where you will get, especially in the factitious dermatitis and all. We can ask them what's your problem, they will tell us this is my problem, then if you are understanding, then we can solve it very easily. So any one of two, you can just share your experience of relaxation. So the other thing is the imaginary things. I think suppose better than you are sitting in a seashore, now you may have enjoyed more than that, no? And the body, I have given you that image that your body is completely okay. So that distorted and unhealthy image is completely gone from your mind, and the importance of our subconscious mind. Whatever image we are giving to the subconscious mind, the body will accept it without any questions. Our conscious mind, if you are telling something, that will argue and that will question, but unconscious mind will not argue, that will directly perceive it. Accordingly, the psychoneuroimmunology will change and we will become more healthy. So any one or two person can just share their experience.
I felt totally relaxed. My muscles was totally relaxed, and I was just slept at that moment. I was not thinking anything coming to my mind, and as soon I was only following the command which was coming to me. That's all. And the imagination was just blank in my mind. Yeah. Yeah. That experiences, that the calm and the sound of sea shore that I found. It's yeah. That's what. Thank you.
Jaydev sir? Anybody? One person?
So it was really relaxing. I was like going to sleep. I was feeling that you will put us in hypnosis. I was a little bit afraid. That's why I was recollecting my thoughts. I thought you are gonna give us a hypnosis session, and we all will be under your control. Yes, so it was really nice, son. Really nice experience. I have been to hostelic medicine, and they also do the same thing for the reducing of the stress. So really nice talk. Thank you, sir.
I just stopped at the level of relaxation. If you go still more deeper, then you will go to hypnosis.
At home? That?
You can use for this sleep induction, but we have to start from the legs to the head.
Oh.
So last you just imagine that my eyelids are closing, I'm going to sleep. Eyelids are closing, then you will go to sleep, not from the head to foot.
Yeah, but here also I think almost about a trance thing was there.
It was really relaxing. I was just sleeping, and Dr. Abhishek just wanted me to just wake up. I was about in that trance period. So much of tired in last 2 days, and now I'm feeling very refreshed. Thank you so much, sir.
Okay, thank you for nice.
Thank you, sir, for more elaborative and informative talk on psychodermatology, and the most important part was the relaxing class, practicals, which made all of us relaxed. Thank you, sir, once again.
Thank you so much, sir, for this, I don't know, mind-numbing session, I would say. Moving on to the next session, we have pediatric dermatology. I would like to call upon the stage Dr. Vivekananda Mahapatra and Dr. Satyadarshi Patnaik to kindly chair the session.
Now I would request Dr. Prabhat Kumar to give his lecture on pediatric dermatology.
Good evening to everyone. Because before I start the lecture, I will like to thank the organizers, the scientific committee and all of the Clinicon, and my special thank to Dr. Latif. He really made us relaxed and composed after whole day of the sessions. So my topic is the pediatric dermatosis. These are the physiological skin lesions, that is the vernix curiosa. This is the acrocyanosis, this is the Harlequin color changes. These are the cases of the Herculean caseosa, Herculean color changes, and this is the case of the Vernix caseosa. Then the cutis marmota, this the cold exposure causes this, and the reticulate blue vascular pattern is seen. Then the suckling blisters, non-inflammatory bullae or the erosions at the site of the neonate suckling. And the third is the milia. It's a minute follicular epidermal cyst. The 1 to 3 mm white globular papular pearly lesions. This is the transient benign neonatal rashes. It start onset of 22, 42, 72 hours of the birth and resolves usually in 2 weeks' time. It is a looks erythematous macules with the central vesicles and pustules are there. No treatment required. It's resolved itself. This is the seborrheic dermatitis. Start during the life of the 2 to 4 weeks post-birth, and it looks like irregular salmon pink patches with waxy scaling. In seborrheic dermatitis, the distribution is mainly involved. The scalp, the forehead, the chest, eyebrows, ears, and interdigenous areas. This is the miliaria. It is the different types of miliaria. It's a miliaria castellana, miliaria rubra, miliaria pustulosis, and miliaria rubra profunda. And it is due to the occluded eccrine duct. This is a diaperdermatitis. There are many causes for this. There is irritant dermatitis, candidal dermatitis, seborrheic dermatitis, allergic contract dermatitis, and atopic dermatitis also causes dermatitis. Then come the congenital infection. The rubella, it is the present as a cranberry muffin or blueberry muffin. There is 3 part, that is there is the congenital rubella syndrome, there is a deafness, then the congenital cataract and the cardiac defects. There is some neurological involvement, coronary retinitis might become, and the most severe in the first trimester. Then the herpes simplex virus infection. There are the vesicles and the pustules on the erythematous base with the scarring often favor the scalp, and there is a majority caused by the HSB2. And it's usually acquired by during the birth. Then the cytomegalovirus infection is the blueberry muffin. Lesions are seen. Then the microcephaly will be there, and then pneumonitis, and the greatest risk with the infection is the first trimester. Then toxoplasmosis, it's a particular rashes is there, and neurological sequelae might be seen. Then they acquired usually from the cats. Then the SSS, this is the Ritter disease. It is a diffuse tender erythema and the superficial blistering. There is excessive fluid loss, fever is there, conjunctivitis, rhinitis, and pneumonia, and the mortality due to the sepsis may come. Then the disorder of the hyperpigmentation found in the pediatric age group. This is the congenital dermal melanocytosis. It is a Mongolian spot, commonly we call. Then there is a nevus of Ota and there is the nevus of Ito. And other condition is the incontinental pigmenta and then negative Frankenstein-Jansson syndrome. Then the hypopigmentation and the depigmentation. These are the vitiligo, albinism, then the ptosis alba, and the Waterberg, and the platism. Then the vascular disorder of the infancy and the childhood. It's an infantile hemangioma seen within the first week of life, involute over the several years, usually 3 years, it disappear. We can use the ocular drop, that is timolol we usually use. Then the vascular malformation, the nevus simplex, then port wine stain, and the Sturge-Weber syndrome. Other is the vessel malformation, there is a Marfovy syndrome, then the arteriovenous malformation. Lymphatic malformation is the cystic hygroma, lymphangioma circumscriptum, and lymphangioma simplex. Hereditary lymphedema can be seen as the lymphatic malformation. These are the pictures showing malformations. Then the bullous disorder of the childhood. There is epidermolysis bullosa. There are 3 main types are there. Epidermolysis bullosa simplex, then the junctional epidermolysis bullosa, and the dystrophic epidermolysis bullosa. collagen type 7 is mutations causes blisters in the sublamina densa. Then the chronic bullous disorder of the childhood, CBDC. This is the blisters in the circular arrangement on the groin or the lower extremities usually seen, and the perioral and the scalp area are sometimes involved, and there must be severe pruritus. Histological subepidermal bulla with the neutrophil at the dermoepidermal junction. And in DIF, we can get the linear IgA pattern. Treatment includes the dapsone, sulfonamide, and the steroids. These are the case of the CBDC. Then the varicella, these are the examples, disease of the childhood. This is varicella or the chickenpox, teardrop. It's caused by the dsDNA herpes virus. There will be fever, malaise, pneumonia will be there, and congenital varicella can be occur. Then the measles, it is also called the rubella. It is a morbilliform rashes usually, and the Koplik is the diagnostic thing. It's a blue-gray speck on the erythematous buccal mucosa. It's caused by the single strain RNA paramyxoviruses. There will be the three main cardinal signs will be the cough, coryza, and the congenital that suggests the and presence of the Koplik spot confirm the measles. Then the rubella. It's a germinal measles. There will be the confluent rose papules which begin centrally on the face and spread acrally. Petechia on the soft palate can be seen, and it is also caused by the RNA taugovirus. Then there is a respiratory transmission for the rubella. In rubella, we can get the fever, adenopathy, arthralgia, suboccipital, and the posterior auricular. Then the erythema infection, that is the slapstick. It's caused by the parvovirus DNA virus. Respiratory involvement is there. Some vertical transmission can be caused from the mother to fetus. Then roseola infantum, it is remembered rose pink macules with the halo, and papules on the trunk, red macules and the streak on the soft palate known as the Naga Yama spots. Then hand, foot, mouth disease, there will be vesicles and on the red base on the dorsum of the hand and feet and the groin. And vesicles on the oral mucosa, oral laceration can be seen in the heart, usually seen in the hand, foot, mouth disease. And coccidiosis virus is the cause of this HFM disease. Then the harness solin purpura, it's a palpable purpuric papules, macules over the lower extremities and the buttocks. Suspected post-infectious hypersensitivity reaction usually seen, and the joint pain will be there, might be there, abdominal pain, nephritis, and with the hematuria, glomerulonephritis, IgA vasculitis, and general supportive treatment. Mainstay of the treatment is the corticosteroid. Then the Kawasaki disease, there will be the red, dry cheek, cracked lips, then red eye, then the peeling of the skin on the fingernails and toenails, as well as in the toes, and then the coronary artery aneurysm might be there. And widespread rashes all over the body can be seen. Then the molluscum contagiosum. Molluscum contagiosum is caused by the molluscum contagiosum virus. MCV is a pox virus characterized by the pearly white, shiny, umbilicated papules. If symptomatic, destructive therapies or the topical immunomodulator therapies can be done. And imicomod 5% cream can be used. Then the bacterial infection is the impetigo. The main cause is the Staphylococcus aureus. It's a group A beta hemolytic streptococcus. Most common infection is the childhood. And the toxic target is the desmoglein 1. Then the cellulitis. It is due to the Staph aureus or can be due to the streptococcal infection. It's a polymicrobial inflammation in the deep dermis and the subcutaneous tissue. Then a scarlet fever, it's group A streptococcal infection. Usually tonsillitis or pharyngitis will be there, and the diffuse erythematous eruption on the neck, chest, intergenous area 12 to 48 hours after the sore throat. There is the sandpaper texture of the rash will be appear on the body. Then the leprosy. It's common to find leprosy patients in the childhood time. It's PB is the most common we usually get. Then the indeterminate leprosy, usually solitary lesion, no sensory loss, can progress into lepromatous or the tuberculoid or the borderline leprosy. Then the sclerophleboderma, that is the cutaneous TB. It's a subcutaneous nodule will be the purulent or the caseous drainage. May develop the sinuses and the ulcers with the granulating basis. Occurs most commonly over the cervical lymph node. Then the parasitic infection. This is the scabies caused by the Sarcoptes scabiei and transmission of the direct personal contact. In the childhood, we can get lesions over the face and neck also in the scabies. And the head lice is the pediculosis capitis, is the spread via the direct contact and the fomite. Intense pruritic and the secondary pyoderma is there. Then ichthyosis. There are the different types of ichthyosis we find in the childhood. That is the ichthyosis vulgaris, that is X-linked ichthyosis, collodion body. Then the autosomal recessive congenital ichthyosis, congenital ichthyosiform erythroderma, Harklin ichthyosis, and the syndromic ichthyosis we can see. These are the cases of the ichthyosis. Then the vitamin nutritional deficiency. It gives the many different types of the lesions over the skin. This is pharyngoderma. It is due to the vitamin A deficiency. There will be the keratotic follicular papules on the extensor surfaces of the body. There is xerosis cutis, xerothalmia can be occur, night blindness and the keratomalacia can be seen with the vitamin A deficiency. Then with the vitamin D deficiency, we can find alopecia, rickets, and osteomalacia. And with the vitamin C deficiency, there is scurvy, there will be the hemorrhagic gingivitis, there is polyfluor petechia, corpuscle hair, epistaxis, and delayed wound healing. Then it's very common to find the zinc deficiency in the childhood. There is periorificial and the acral erosive eruption. There were three things, that is the dermatitis, diarrhea, and depression. Usually we find acrodermatitis in enteropathica. There is a lot of diarrhea and dermatitis around the all oral area and the anal area. So its serum alkaline phosphatase is low, that is the zinc dependent enzyme. Risk factor for the acquired deficiency include the Vesan diet, malabsorption, streets. Then the additional disorders. These are the common things we call in the adolescent area age group, that is the acne vulgaris seen in the adolescent children. Onset is the puberty and the sebum production is start at the adrenarche. Rosacea we can see, it's not much common, but we can find it. Then hidradenitis suppurativa also we can see in childhood and around the 5 or 6 or 7 years old. Then hyperhidrosis is very common in the early childhood and due to the stress or some physiological conditions. Then the psoriasis, it's a very uncommon to find the psoriasis lesion in the childhood, but HLA-B7 are associated of the earlier onset and the more serious disease. Gutated psoriasis we can we find in the childhood cases. A small discrete lesions over the upper trunk and the proximal extremities. So streptococcal throat infection usually precede the eruption. Then the lichen planus. This is the inflammatory disorder affecting the skin and mucosal nail, and coagulation phenomena can be seen. Then the atopic dermatitis is a very common thing we usually encounter in day-to-day practice and OPD basis. Cheek and neck sensors are involved, more chronic with the lichen infection, and there will be some association with the family or the personal history of the atopy. Then this is the case of the atopic dermatitis. This is the case of the contact dermatitis, and this is the case of the seborrheic dermatitis. Then this is the case of lupus erythematosus. This is a connective disorder. This is an immunological disorder with the anti-DNA or the SM positivity. Then systemic sclerosis, vascular dysfunction and endothelial injury, fibrosis and immune activation. Thank you.
So that was a very elaborate presentation on pediatric dermatosis. Any questions from the audience? So, but I have a few proposals and suggestions. You talked about pediatric dermatosis. It was very elaborate. We are all enlightened. Suppose you find cicatricial scars in a newborn baby. What do you suspect? What is your provisional diagnosis? Cicatricial scars in a newborn baby.
In newborn baby.
Can anyone from the audience?
Congenital syphilis.
Congenital varicella, that is the correct answer. Suppose you find alternate red and white bands in the nail plate in a newborn child. Alternate red and white bands in a nail plate of a newborn child.
Sir, so sorry to interrupt. We are running a bit late on
Okay,
time.
okay,
Can
just
we-
1 minute, just a minute. Because yoga you took around 20 minutes. You cannot expert for academics. So, can anyone from the audience alternate red and white bands in a newborn child? Suggestive of Darier's disease. So, when do you suspect subglottic hemangioma? Subglottic hemangioma in a newborn?
Sepsis. Sepsis.
Subglottic hemangioma in a newborn baby. When do you suspect? Can anybody, Dr. Kumar or anybody from the audience? Professor Sitaraman? So if you find facial cutaneous hemangiomas over the beard area, chin, lower face, and neck, and then you suspect subglottic hemangioma in a newborn baby. You talked about atopic dermatitis also. Now it is a hot topic. Atopic dermatitis, very difficult to manage. And newer modalities of topical and systemic therapies are coming up. And CME seminars, all the international symposias, they are going on all over the globally. So can you say newer biologicals in atopic dermatitis?
We are very less experienced with the biologicals.
But can anyone
probiotic can help in the atopic dermatitis.
Can anyone from the learned audience suggest the latest biologicals to reach the global market in atopic dermatitis? Atopic dermatitis.
Abrocitinib.
Not exactly. I have the list. That is nowadays outdated. Now is nemolizumab, which is mainly anti-itching agent. Nemolizumab, and another is tralokinumab. These are the latest. Then another is lebrikizumab, which is an interleukin 13 inhibitor.
Okay, thank you for reaching us.
And the last, this is the last.
Nice, okay, go on.
Juvenile, these are all
Yes,
suggestions
yes,
to
yes.
enlighten the audience. Juvenile xanthogranuloma associated with which malignancy? Juvenile xanthogranuloma associated with which malignancy? Pardon? Full form?
Chronic myeloid monogenous leukemia.
No, in a newborn. It is JMML, juvenile myelomelanocytic leukemia. So thank you, Dr. Prabhat Kumar, and thank you, the organizing, a scientific chairperson, organizing chairperson, to give opportunity to chair the session. Thank you.
Thank you.
Thank you, sir, for such a wonderful session. I request our respected chairperson and speaker to kindly collect their mementos. For the next session, I would like to invite the panelists, Dr. Kalolini Shamal ma'am, Dr. Kshitij Saxena sir, Dr. Vanshika Rai, Dr. Vartika, and Dr. Rakesh to come on the stage.
So warm good evening. So we have come to the last session of the day before the oration and other activities. Since we are running short of time and we have very short time, we'll make it very short and sweet. I sincerely thank the organizers, Dr. Abhishek Jha, Dr. Vikas Shankar, and the entire team for giving me this opportunity to moderate an allied panel. Today we have esteemed panelists, well-balanced in experience and youth and dynamic entrepreneurs. Dr. Kalonili Shamal from Bhubaneswar, Dr. Kshitij Saxena from Uttar Pradesh, Dr. Vartika from Patna, and Dr. Rakesh SV from Calicut, Kerala. A warm welcome to all the panelists, and it's an honor for me to moderate such an elite panel. Thank you. So we'll go straight into the business. We'll have some small case discussions and few questions from real-life dilemmas. We don't expect much of textbook answers. We'll have your practical experience and which you have come across. The first case is an 8-year-old boy who suddenly developed scaly lesions, history of sore throat 2 weeks ago, mild pruritus, and parents are very anxious. So
good.
the diagnosis, it's very clear. Dr. Saxena.
Yeah, as you mentioned, it's a past throat infection. It's more suggestive of a gutted psoriasis. And there is a mild itching. I will proceed with the azithromycin and with the topical application of the the differential between gutted and pityriasis rosea. In the pityriasis rosea, we will see the herbal patch and a Christmas tree pattern. And it won't be present in the gutted psoriasis. Gutted psoriasis will be small droplets like seasons all over the body. And it will go away with a small azithromycin course along with the topical application of the lubrications and along with the mild application of a mometasone with the salicylic acid over the spots. And I would like to have a hydration cream to the patient so that he can recover so fast, as patients are more concerned about the look of the disease. So we have to go early and so that the patient's parents are really satisfied. Thank you.
Dr. Rakesh, the history of streptococcal throat infection, would you need ASO or anti-DNAs as investigations?
Clinically, not always. If it is very obvious clinically, if there is a history of pharyngitis and if you see tonsillar infection, yes, I would think of gutted psoriasis, especially if the lesions are scaly plaques or the trunk. ASO, I mean, I would not routinely do it because it doesn't call for an investigation as such. dsDNA, I don't think I would think of anti-dsDNA at this particular point of time. Maybe you want to rule out subacute cutaneous LE.
Yes, sir.
Okay, subacute cutaneous LE is you can think of if there are other systemic symptoms, and they are more psoriasiform than psoriatic in subacute. And if you suspect there are other systemic, there's history of fever or any joint pain history, then history of any photosensitivity, then probably yes, I would do maybe I'll do an ANA screening first and then think of an anti-dsDNA, if at all.
Yeah. Dr. Vartika, role of antibiotics, or you will just treat the skin? Vartika.
If the patient is having active pharyngitis or tonsillitis, then I would like to give azithromycin or oxythromycin. Otherwise, I will treat with when to escalate.
No, I'll ask her. When will you escalate the treatment from topicals and maybe antibiotic?
If patient is having severe disease, more than 10 involvement body surface area is high involvement and rapid involvement of the disease, along with not responding to topical therapy, will escalate the treatment. I will treat a patient with phototherapy, or sometimes if needed, we may give methotrexate in this case.
Not related to this case, Dr. Rakesh, would you suggest biologics in pediatric patients?
Not at all in this patient presently. Especially, I would think of gutted escalation when it persists more than 2 months or 3 months. Maybe we'll think of, as he said, we'll immediately followed by antibiotic and topicals. then there will be other, in my case, if it is the lesions are progressive, the lesions are on the scalp lesions. Nowadays, I must put patients on apremilast first. And apremilast is an oral biologic. So yes, in that respect, an oral biologic would be my choice.
What dose, apremilast, what dose?
Apremilast, it's around, in a pediatric, it will be like 10 to 30 milligrams per day. And the children who tolerate it well, they respond excellently.
Thank you.
Sir, I would like to add something. The apremilast is not recommended in the children age group as per the latest guidelines. I have read about it. We can go for if child is more than 4 years, we can give him etanercept. Or if his patients are more concerned and he's having a severe scaling, so then we can go for a scunimab. That's CAFO. That can be given, but the patient should be ruled out with any tubercular history, any liver, any strong ESR high levels, and I would go for a methotrexate. That would be a safer side in replacing for biologicals.
The problem with biologics in a child is, you have to give what the dosage. But the dosage, the problem is the minimum, the scaffold dosage is around, if you have to give even 150 milligram, you can give up to 150 milligram but less than that, it is, I think the dosage is 300 milligram, no one.
Its dosage is around 0.5 to 1 mg. I think I'm not recollecting it correctly, but in the starting we have to give it weekly for a month, and then we have to go it monthly, and it shows a really great response. And adalimumab can also be given, but it's recommended only on the above 6 years, and etanercept is recommended only above 4 years. But the first thing I would go for is a topical management along with methotrexate oral. That would be the safer, and we have a good exposure of methotrexate, so we can manage its side effects.
We'll go to the second case, a 3-year-old child, not responding, non-responder, and they have a severe itching, steroid phobia obviously there, and poor adherence. Atopic dermatitis, we all know it's a very common disease, but the management varies widely. How do you break the itch-scratch cycle? Dr. Rakesh.
See, the primary thing is atopic dermatitis, I like to believe that it is an itch that rashes. So the primary thing you have to address is the itch always. And a sedative antihistaminic like hydroxyzine, if it doesn't interfere with the child tolerates, it would be my first choice to break the itch scratch cycle, antihistamines. Then if I don't know the extent of lesions, if it is localized, a topical steroid and if indicated, an antibiotic can also be given. And if it is extensive lesion, the child is unable to sleep, it disturbs the sleep cycle, then sometimes we have to resort to techniques like wet trap techniques, which is sometimes very soothing and breaks the itch scratch cycle.
Dr. Vartika, how will you handle the steroid fear of the parents?
First of all, I'll counsel the patient's attendants and parents regarding the steroid fear. And then I'll ask the patient to don't apply it liberally, apply in a thin film and only apply over the affected areas.
Limited.
Wash hands after applying.
Dr. Shamal.
Food allergy testing in atopic dermatitis, we usually don't advise in all cases. But when you will get a clear-cut history of food allergy in the patient, after taking any food, he or she will develop allergy after 2 hours of intake. There we can go for food allergy testing.
And Dr. Saxena, when will you consider to escalate beyond systemics or even biologics?
Adalimumab is, I think pronunciation is correct. I would prefer for that, but
At what stage? At what stage will you plan?
When the patient is not recovering back from a steroid, topical steroid, sometimes I give oral steroid for a week, and the parents are not afraid of steroid. then we can go for it. And when, in case of biologicals in a patient, we have to counsel a lot. We have to go for a long investigation. They will say, why are you investigating so much of my child? And they won't adhere to the biologicals. So better would be the steroid topical, consult them. And regarding the, you talked about the diet, we have to take a diet history, whichever food is aggravating that disease, and we have to transfer the patient to the pediatrician, pediatric dietitian.
So the fear of steroid is more dangerous than the steroid as such.
If the extensive lesions patient is recalcitrant to is unresponsive to most conventional topicals and antihistamines, then probably the extensive lesions, then I would think of cyclosporin in children, cyclosporin. Then azathioprine used to be a favorite of drug, but now they have taken it off the guidelines, so now you're not sure whether you use it or not. And if more than 10 to 12 years old, excellent response have been seen with tofacitinib also. And I think that is one drug which you should use it judiciously, but it's a wonderful drug if used judiciously. Biologics, our patients are dupilumab, abrocitinib, all of this are really expensive. Dupilumab is a very safe drug.
It's not available.
But it's very expensive. It costs about 60,000. I think it's 60,000 for
1 lakh
for 15 days. Yeah, price is reduced now. Dupilumab.
Yeah. Okay. Now, third case, we'll go fast so that we can cover the entire topic. It's clear case of vitiligo in a 10-year-old with facial lesions and a lot of psychosocial concern. We just had an excellent talk on psychological aspects of various skin diseases. So which patients will you prefer for thyroid and other autoimmune screening? Dr. Shamal.
If patient is having any family history of autoimmune disease, we can screen for autoimmune disease. And even if in all pediatric cases, we should screen for autoimmune diseases. Basically, we should screen for autoimmune thyroid diseases and pernicious anemia and autoimmune type 1 diabetes mellitus. We should screen these diseases.
How often would you suggest, Dr. Vartika, how often would you suggest screening?
As ma'am said, whenever there is a positive family history of any autoimmune disease, autoimmune thyroiditis, pernicious anemia, Addison's disease, I would like to screen the patient.
How frequently? How frequently?
Annually, if there is a history, or and monitor it every 2 years if there is no history.
How do you set realistic repigmentation expectations in patients with vitiligo, especially in exposed areas? Dr. Rakesh.
See, we have to be very clear. The counseling is a big part of vitiligo because the patients don't tend to stick. And we have to tell them that the first 6 to 1 year is the golden period for intervention. That you have to impose upon the patients, and you have to tell them that the response rate is not less than 6 months. This is what you have to tell the patients. And if the patient is a rapidly progressive child, then probably yes, we would have to go in for systemic therapy. If it's a localized topical calcineurin inhibitors are excellent, especially if the face lesions you can safely say within 3 to 6 months. But other than that, probably area-wise, so the acral aspect, you have to tell them the response is going to be very slow. And hair-bearing areas, the response will be better. Otherwise, the acral areas, the mucosal, the response is going to be very slow. But the most important thing is you have to tell them it is going to time. You have to stick around. Otherwise, if that golden period goes off, then it becomes more and more difficult to treat.
And Dr. Shitish, how you will handle the psychosocial impact of the disease?
Psychosocial impact is quite large. The patient is quite tensed regarding that. If there's a female patient, female girl child, they would be really sad, and they would say, if it's white spot or not, is it epistaxis alba or something else or something in the eye and all. So we have to counsel about that. And regarding you told about the investigations. Topoisomerase, I think I used to deserve. And in my college, I did a study on the vitiligo patients along with thyroid. It was quite associated. Association was seen in more than 50% of the patients. The pediatric age group had the thyroid disease, and topoisomerase was not done in my study. And I would like to add that tofanosib, I have made a study. Tofanosib topical gets a good study, good results in cases of vitiligo. In a topic application, it is ready to replace tacrolimus. It's very good ointment, but it is not recommended by the FDA. We can use it in above 4 years case, non-FDA approval. And another one is Binopromast 0.03, that is Leishman. You must be properly knowing. It also gives a beautiful results in the pigmentation, and the patient adheres to you. And as the patient have been vitiligo, he have been visited long on many of the doctors. If you give him a really new medications, he will quite adhere to you. Thank you.
Another case, a 2-year-old child, patchy hair loss with scaling, few pustules and cervical lymphadenopathy. What would be your top differentials, Dr. Rakesh?
Scalp scaling, or patchy hair scaling.
Patchy
right?
hair scaling.
I would get a KOH down.
What will be differentials?
I would think of a tinea capitis. If it's a scaly type or the gray type, or if you have broken off hair shaft, it could be a black dot. But now you're referring to the scaly type. So yes, gray patch alopecia areata. Gray patch tinea capitis.
So what would you do to prevent scarring alopecia, Dr. Vartika?
Since it is a very inflammatory type of tinea capitis leading to scarring alopecia, we can give a short course of steroids along with griseofulvin at 20 to 25 mg per kg.
And would you suggest any public health angle family screening or anything, Dr. Shamal?
Yes, sir. We should examine all the contacts, household contacts and siblings for any inflammatory patchy lesions over there. We should also check whether their pets are present in households or not. Then we should treat even if we get them infected. If they are infected, we should treat them.
We'll come to the last case. This refractory eczema in an infant. Extensive erythroderma. It's not responsive to treatment. Patient is failure to thrive. A history of recurrent infections. What would be the probable diagnosis apart from refractory eczema, Dr. Vartika?
Infant failure to thrive can lead to a lot of differentials. Hyper IgE syndrome or Job syndrome, Netherton syndrome, Wiskott-Aldrich syndrome. All of them can be in differentials. We will have to rule out by further history and examination.
Okay.
So, when to suspect Netherton? Netherton will present as congenital erythroderma. It has it right, atopic dermatitis, bamboo hair, and ichthyosis linearis circumflexa. So, if these features are there, we can suspect Netherton.
Which investigations will you prefer, Dr. Rakesh?
One is serum Ig, high serum Ig is suggestive of Netherton syndrome. A hair shaft examination for this, that can give you some clue about the diagnostic part. Other than that,
any genetic study, anything?
Yeah, of course. All the genetic studies and all will come. Will have to be completed.
Fine. So you should think beyond atopic dermatitis when it is a case of refractory eczema. Now we'll go to a rapid fire round. I expect short and sweet answers, one-liners. Your time starts now. Common neonatal rash, which the parents are very worried, but it's nothing to be done. Dr. Saxena.
Neonatal rash, it can be neonatal acne, milia, ethma toxitorum, and one more was that.
Yeah, Mongolian spots.
Most common is probably erythema toxicum neonatorum, but it's very self-limiting. Malaria, especially in the neonatal period in a country where the culture is to apply oil. So malaria, occlusion malaria, folliculitis, occlusion malaria is a common
rash we get in.
In a school going child, would you prefer, will you choose to treat molluscum or what, or you'll just leave it for time?
If it is very localized, maybe I'll try KOH or something. But if there is, if it's not extensive, then it depends on the age of the child also. And if the child is not atopic, maybe sometimes I leave it alone, but always I make it a point to tell them that it is better to treat because it can spread, it can lead to newer lesions, and especially if atopic, then it can lead to eczematization also. I prefer, if a slightly older child, I prefer either phenol application, or if it's very few, or electrocautery, mild electrocautery after topical Prilox.
Dr. Vartika, sunscreen, now every other patient would ask you, which sunscreen should I use, at what age I can use? How early can a sunscreen be used in children?
Sunscreen advice, for ideal sunscreen, there is a checklist in book. It should be broad spectrum, SPF 30+, PA 3 or 4+, should be sweat resistant, water resistant.
At what
and
age?
A child less than 2 years, I think above 2 years sunscreen is advised.
Any other opinion?
You can use physical sunscreen in children. Physical sunscreens are quite safe. Nowadays, even the physical sunscreens come in some the ultra micronized forms. They are as good as chemical sunscreens.
Now we see a lot of acne in pre-teenagers. So at what point will you escalate the treatment, and what counseling would you suggest? Dr. Vanshi.
If patient is having severe acne, like having nodular cystic pattern and having severe scarring, then we can treat other acne in that patient. And not responding to conventional therapy, topical acne treatment, benzyl peroxide for 4 weeks or more, we can.
Any counseling?
In preteen, I think counseling is important, because sometimes if it's between 9 and 11 years, the other children in the schoolmates may not have acne. So sometimes they feel. So you have to take it case by case whether to treat or not. So if the child seems to be bothered by it, probably you can start with mild topical benzyl peroxide or clindamycin combinations, or even adapalene, mild acne. That's what I would, in preteen, you have to address it if the child is bothered.
Treatment options in lichen planus in a child, Dr. Saxena.
Well, I would like to give steroid, mometasone salicylic acid, for a short duration, and along with a syrup containing lycopene, it's giving antioxidant effects. It also helps in reducing. And usually, lichen planus treatment lasts for 2 years, so we have to be cautious. The child is bigger in elder in age, I would like to prefer to give him an oral steroid and a pulse dosage.
Mucosal.
Mucosal, it's a topical trichomonas is available, but in the elder peoples, I used to give isofil, that's isotretinoin topical. It gives a good result along with the lycopene supplement.
What are the ethical concerns in cosmetic procedures in adolescents?
My favorite in lichen planus in children is Dapsone, and it gives, because steroids, you have, when it is very eruptive lichen planus, you can sometimes start with the steroids, but you have to remember that you cannot give it, especially between the age of 9 to 12 years, so it's better to avoid steroids for more than a month. So Dapsone would be my number one choice in children with lichen planus.
Yeah, we'll come to the last slide. Most challenging case you have come across in your practice? Most challenging pediatric case, pediatric dermatology case.
Yeah, I got a case of child having herpes neonatal. I was like a bit confused. I went for a Tanzang smear. Then we got the diagnosis confirmed. Earlier it was what we are talking about, erythema toxitorum neonatum, and we gave him topical lotions, calamine lotions. But later on, when we found out the Zang smear containing multinucleated cells, then I was really shocked. And common mistake is that we have to rethink about our diagnosis. As the patient is a child is small, the parents are more concerned. They are not concerned for themselves, but in the case of the child, they will eat your head out. So we have to rethink for the diagnosis, and we should try to give them better response early as possible.
Others, panelists, Anything to add?
My most common challenging on pediatric dermatology, mostly I've struggled with acute generalized pustular psoriasis
On
in
time.
children.
Fine.
So,
Others, we have time up.
Okay.
Others, exactly, we have finished the time. In time. Anything to add? Common mistake or?
Recently, we come across a case of Down syndrome with pustular psoriasis and not responding to conventional treatment in a 16-year-old boy. Then we added, treated with biologics, secukinumab in that case.
So, as you all know, we have come to the end. Pediatric dermatology is very important because of the age-specific presentations, the challenges in communication, parental anxiety, and it's important to have early diagnosis and holistic management. I thank all my panelists for active participation, and I thank the organizers, Dr. Abhishek Jha, Dr. Anupam Das, Dr. Vikas, Dr. Punkesh, Dr. Svetalina, Dr. Sri Parma, and the entire team for such a wonderful conference. We had excellent talks. Thank you all. Thank you.
Thank you, sir, for such a wonderful session. I request our respected panelist and speaker to kindly collect their mementos.
A very warm good evening to all of you. We have come almost at the end of this scientific feast with the most prestigious and important session of this scientific feast, Dr. Professor Amar Kanja Amar Oration. Dr. Professor Amar Kanja Amar was born in 21st June 1949 when India was just celebrating her second independence. Since his early days, he was very laborious and meritorious. Born in a small village of Bihar, at that time, nobody knows that this little boy will one day become the synonyms of dermatologists in Bihar. After completing his MBBS from Darbhanga Medical College in Hospital Darbhanga, he completed his MD from Patna Medical College, Hospital Patna. In 1997, he became the first person in Bihar to do the PhD in dermatology, serving for more than 34 years. As a UG and PG teacher, he guided more than 140 PG students and did NCI inspection in different parts of the country for more than 16 times as a coordinator inspector. He served as a HOD in the dermatology department of Patna Medical College and Hospital Patna, as a superintendent, principal and dean of Faculty of Medicine of Patna Medical College and Hospital Patna. He was awarded many awards, but most promising was Guinness Book of World Record, Lifetime Achievement Award by the American Academy of Dermatology, IADVL Glaxo Oration Award, IADVL Best Teacher Award. He published more than 100 articles in the national and international journal. He contributed 3 chapters in dermatology textbook. He was author of 5 dermatological books, 4 Mathli books, and 3 Hindi literature books. His contribution to IADVL is unparalleled. He served almost all posts of the state branch of IADVL and state of Bihar and in state journal conferences. Not only state, he also served and contributed to national IADVL as a honorary secretary general 2 times, national vice president and member of the Constitution Committee and IADVL CC members since 1987. He was also organizing secretary of Dermacon 1991. An able IADVL member, he attended almost all national conferences meeting prepared by IADVL. He also prepared IADVL National Directory, increased the membership during his tenure as his honorary general secretary, gave IADVL the live membership numbering system, started IADVL newsletter, raised the central fund at that time, and many more. He was also interested in social services and free medical and dermatological camps. The national program IADVL Chala Gaon Ki Or was the brainchild of Dr. Professor Amar Kanja Amar. He organized countless rural medical camps along with the IADVL Awareness Day. He was the brainchild of this association, the Association of Clinical Dermatologists of India. He was the first to work and last to leave the venue of any scientific or program of any kind of dermatological. He was very humble, kind-hearted, and always helping person. And the award, and this Professor Amar Kanja Amar Oration Award goes to Dr. Bhumesh Kumar Katkam. It is my distinct privilege and honor to introduce a personality whose name resonates with the excellence, dedication, and visionary leadership in the field of dermatology. Today, we are graced with the presence of Dr. Professor Bhumesh Kumar Katkam, an eminent academician, clinician, researcher, and mentor, currently serving as a professor and head of the Department of the Dermatology, Venereology, and Leprosy Department of Osmania Medical College and Hospital, Hyderabad. He is also a program director of the Pediatric Dermatology Training Center of Osmania Medical College, Hospital, Telangana. Dr. Katkam academic journey is nothing short of exemplary. A gold standard achiever, he has been recognized as the best outgoing student of both the diploma and MD degree of dermatology, an early reflection of the brilliance that would define her career. With an extraordinary academic footprint, he was authored over 36 publications and contributed around 16 books chapter, while also serving as associate editor of the illustrated textbook of dermatology and STD. His academic voice has reached far and wide, with over 115 scientific papers and more than 450 guest lectures delivered across national and international platforms. His list of accolades is both extensive and inspiring. He is a recipient of multiple prestigious honors, including IIDVL Presidential Award, IASSTN AIDS Presidential Award, Andhra Pradesh, Abdul Kalam Lifetime Achievement Award, and numerous recognition as Dermatologist of the Year and Man of the Year. His contribution has also earned him international appreciation, including recognition from the ILDS in the SAARC East area region. A distinguished orator himself, Dr. Cartwin has been invited to deliver several prestigious orations, including Dr. B.G. Ranade Memorial Oration, IIDVL Presidential Oration, and the IASTD and AIDS Endowment Oration, each reflecting his authority and influence in this specialty. Beyond academics, his leadership in the professional organization is remarkable. From serving as Honorary General Secretary of the National IIDVL to holding a key point in IASSTD and AIDS and IAL, and organizing the landmark conferences like STCon, Dermocon, he has constantly shaped the direction of dermatology, both national and international level. His clinical and research interests, particularly in pediatric dermatology, allergy, and infectious dermatosis, and HIV-related skin disorder, reflecting his commitment to both science and services. As a principal and co-investigator in the multiple clinical research projects, he continues to contribute meaningfully to advancing evidence-based dermatology. But beyond the accolades and achievements like mentor, guide, and a passionate educator, someone who inspired the generation not just through knowledge but through example. Ladies and gentlemen, it is truly a moment of pride and privilege for all of us to have such a towering figure amidst us today. Please join me in extending a warm and heartfelt welcome to Dr. Professor Bhumesh Kumar Katkam. Please, sir.
Yeah, namaste to everyone. At the outset, I thank the team Clinicon and the Association of Clinical ACDAC to stand in front of you to give the prestigious oration on Professor Dr. Amar Kanja Amar oration. It's my honor, I am humble to give this oration. Whatever the little experience, clinical experience in my pediatric dermatology, I'll try to share the clinical aspects, mainly focusing on the pediatric inflammatory dermatosis, from clinical clues to comprehensive, the confident management. I won't go in detail about the management, but whenever it is required, I'll touch. So as a orator, so big thanks to the Association of Clinical Dermatologists of India, especially Dr. Abhishek Jha, Dr. Vikas, Dr. Svetalina, and Stephen, and all the team, always going to partnerize like a family. So always we love to go over there at any time. So, but this time, and today is a very prestigious day, especially for me. Of course, health is not everything, but without health, everything is nothing. But that health It has to be started from skin and genital health awareness, which has been started from the pediatric age group for healthy skin and healthy child and subsequently healthy nation. This is the motto. Of course, the children are not just small adults. The inflammatory dermatosis behave differently in pediatric age groups. If you see, we can learn two things from children. Always they are happy and always they are busy. These two are missing in us. So we can learn these two things from the children's. Let us have always busy and whatever the situation, let us be happy. Of course, the pediatric dermatosis broadly, the infective dermatosis as an inflammatory dermatosis. I won't touch upon the infective part. The inflammatory dermatosis, we know the two scientists are involved. There are 5 signs of inflammation. The Celsus and Virchow, at least for the PGs, this may be useful. Pediatric 3 decades back, as per OP Guy, pediatric dermatology contribute 20%. But now, after 3 decades, now it is 30 to almost 40, it is crossing 50%. Of various regions, the westernization and hygiene hypothesis, the pollution and limited families and the vaccination, multiple factors which will come into the picture. The pediatric inflammatory dermatosis constitutes a large proportion of dermatology OPD visit in children. So now the inflammatory dermatosis is in the rise. The Th1 milieu as shifting towards the Th2, subsequently inflammatory dermatosis. I would say the managing the inflammatory dermatosis is the antidote for the ego of the dermatologist. So if you keep the ego, if you leave the ego, the management will be easy. So just now, Betkarur sir said these words. The clinical morphology, distribution, and age of onset provides the crucial diagnostic clues. The early recognition prevents chronic disease, systemic complications, psychological impact, and misuse of topical steroids. The management are different in different age groups, from neonate to infantile, preschool, pre-adolescent, and adolescents. So to manage this, we can simply follow the formula of M square. What is that formula of M square? I'll tell at the last slide of my take-home message. So what is that formula of M square? If we implement that, we can learn. And unique features of pediatric skin is a thin epidermis, the higher skin hydration, immature barrier function, increased percutaneous absorption, and greater susceptibility to irritants and infections, gives rise to rapid spread of dermatosis, higher drug absorption, and different morphology compared to our adults. The treatment, as I said, assurance, always touch the baby. If you touch the baby, it is an important aspect in the management of childhood dermatosis. And then, shall we go with a 2S approach or 3S approach? Whereas supportive and symptomatic, where it is required, and specific therapy with a 3S, where it is required. It is the discretion of the healthcare provider. Are we going with a 2S approach or a 3S approach? And the clinical approach to pediatric inflammatory dermatosis, remember the 4 steps like Charminar, where I am staying. The age of onset, the morphology, distribution, and associated symptoms. So that's why these are the clinical clues. So always I used to tell to my PGs, history and examination is the king in the field of medicine. Spend time with the patient. Patient will give number of clues. And be a patient-centric approach rather than paper-centric approach. Especially in the children's, doing investigations is very, very difficult. So morphology, as I said, primary lesions, always look for the primary lesions and the distribution of lesions and associated features, symptomatic or asymptomatic. So these are the 4 areas. If you focus, generally we won't miss the clinical clues. So the pearl is morphology of lesions, the distribution of lesions based on the age will give a diagnosis in most pediatric inflammatory dermatosis. The three, like our beautiful tricolor flag, remember these three almost will get the clinical clues. Let us see the vesicles. If you see the vesicles around the lesions, so the diagnosis is not a problem. It is the string of pearls. But is it a diagnostic or a pathognomonic? What is the clinical clue to? So the diagnostic means it is confined to the one condition, but pathognomonic may be seen in more than two conditions. So we could see here the vesicle and bullae around the old lesion. So it's a clue for the CBDC. And it is here, see, the plaque surrounded by the vesicle and bullae. The plaque, again, it's a paired orange. So that is another important clue. Along with that, let us see some associated features. See, this is the old lesion associated with itching, child predominantly on the extremities. So the clinical clues we got, it is a CBDC. Once if you diagnose, so anti-inflammatory dose of steroids with a dapsone, because dapsone lag period is 4 to 6 weeks it will take. So that's why control with the anti-inflammatory dose less than 1 mg per kg, because not immunosuppressive dose is not required, because when the child grows there is HPA axis suppression here. So you could see after 10 days all lesions are subsided and the itching is decreased within 24 to 48 hours. This is another child, 6 months female infant. The lesions started with a vesicle and healing with the plaque which is a paired orange. So it's a mastocytosis. When it is diffuse, it's a diffuse cutaneous mastocytosis. So you could do simple test, the Darrier sign which is positive. Once if it is diffuse, and another important step is the serum tryptase levels, we have to get it done. If the serum tryptase level is less than 20, we can think confined to the skin. But if it is, the literature says if it is more than 20, may be associated with a systemic involvement. So what we have done ultrasound abdomen, no organomegaly, and we have done all investigations. The serum tryptase levels which has raised almost more than 170. But all investigations came normal. So what we have raising of all tryptase levels doesn't mean that they are associated with systemic involvement. Here again we have given the anti-inflammatory dose less than 1 mg per kg of the steroids. Over a period of 4 to 6 months all lesions were subsided. Now this child is going to the school. So that is the clinical clue with a simple the treatment. And this linear vesicular lesions. So when you see linear vesicular lesions, and onset is very important. So all linear vesicular lesions not herpes zoster, or linear vesicular lesions are not linear herpes simplex. So the onset is very important, and sex is also very important. Actually this case has referred to me and they have given antiviral therapy, the acyclovir, and no response that came to me. And once if you see the detailed examination, whole examination of the body, and the female child, you could see all the lesions, and the diagnosis is clear, incontinentia pigmenti. Once if you diagnose incontinentia pigmenti, as a dermatologist, our vision, though our medicine is a surface medicine, but our vision should be beyond the surface medicine. When you see this, whether it is confined to the skin or maybe associated with any syndromes, look for ocular complications, look for the CNS complications, look for the dental anomalies. These are the three areas mostly associated. May be associated, may not be associated. But so fortunately, we have seen the series of cases, all cases confined to the skin, and they run in stages, vesicular followed by verrucous, then hyperpigmented, then hypopigmented. You could see here. So this we have published the series of cases in IDAJ. And the rash on the cheeks, If you see the rash on the cheeks, again, the age, the onset, associated features. So always remember all three amalgamation will give clue. So just presence of malar rash in the malar area, it won't be a malar rash. So don't jump into go for investigations for ANA profile, all those things. It may take a lot of budget. So if you see the first one, associated with low-grade fever, there is a family history. So that is the infective focus. So no need to go for just 2S therapy is sufficient, supportive and symptomatic therapy with assurance. And this second child, well-defined erythematous plaques, unilateral. So again, this is also infective focus. Again, the third one, you could see, along with the rash, you could see other supportive evidence, the glossitis, cheilitis, angular cheilitis, something related to the nutritional. And again, this child, there is again malar rash, but photosensitivity associated with other features. So put together, so we can come to a conclusion. If you take all 4 clues, so most of the time we can diagnose clinically. So one is erythema infectiosum, 2S therapy is sufficient. Erysipelas, so streptococcal. Here, the streptococcal, the dose and duration is very important. 30 to 50 mg per kg per dose 3 times in a day over a period of 7 to 10 days. Otherwise, it leads to complications. It opens the nephrology, it opens like psoriasis, it opens the rheumatology. So as a dermatologist, so we have to close the doors to prevent the complications. So the third one is a nutritional pellagra, 4th one is SLA. So this is a 14-year child. You could see all clear-cut, well-demarcated, hyperpigmented. The burnt out, the features is the key. Diaper rash, always it's a diagnostic dilemma. Even if you are a senior most dermatologist, we may miss the diagnosis. So if you see on the convex areas, mostly it's the irritant dermatitis. If you well-defined the ulcers or erosions, so it could be infective focus, streptococcal perianal dermatitis. And well-defined plaques without any symptoms, you could think of something, the psoriasis or inverse psoriasis. But here, the irritant diaper dermatitis, if the diaper barrier damage which is persisting, if you won't address more than 48 hours, then the candida which is normal commensal, which will multiply and responsible for involvement of the flexors. That is the secondary, the primary irritant dermatitis with secondary complications of candida. And if that barrier damage which is persisting more than 96 hours, the staph aureus again, which is also commensal, which will come into the picture, and then the secondary bacterial infection. So the first 48 hours of primary irritant diaper dermatitis is the golden period to address the barrier repair and prevent the complications of either candidiasis or the bacterial infection. Whereas the streptococcal perianal dermatitis, once if you diagnose child is irritable, refusal of feeds, and topical therapy will not sufficient. We need to go for anti-streptococcal systemic therapy. The syrups is available, 30 to 50 mg per kg, 7 to 10 days. Full dose with complete duration is the key to prevent complications. Whereas the inverse psoriasis, the third one is the napkin psoriasis, well defined. Now we are seeing so many cases, even inverse psoriasis. So we are in Usmania, we are planning to do the natural history of inverse psoriasis, how many they are progressing into the chronic plaque psoriasis, because there is literature is very scanty. So we may in future, we may come with what is the natural history of inverse psoriasis, how many will resolve completely, how many will progress into chronic plaque psoriasis. So this child, again you could see, well defined. So inverse psoriasis, but what is the trigger? You could see some lesions on the site, that is the satellite lesions. So here, the candida, which is the triggering for this inverse psoriasis. So if you see that, first to treat the trigger. So what we have to do, what we have given, put on the moisturizers and miconazole, antifungal therapy. Once if you control the trigger, then the topical steroids. Then after 1 week of treatment, all lesions are subsided. So always if you find out the trigger, and treat the trigger. And atopic dermatitis, a lot of discussion everywhere. I won't go in detail, but atopic there is a genetic susceptibility. But the genetic susceptibility is not sufficient to produce the clinical manifestations until the environmental triggers which will come in contact with this atopic child, then the activation of immune system and which will release the pro-inflammatory mediators and responsible for the dermatitis. The triggers again remember for the irritants, allergens and infections and the stress. Stress is another important area we won't address. Even the children, stress is one of the important culprit trigger the atopic dermatitis that has to be addressed. So when a child has AD, the entire family may be affected. We are not treating the child, we are supposed to treat the family. And of course the diagnosis is the clinical, but there is no gold standard diagnosis for atopic dermatitis. That's why we have a criteria of Anifin Rajka, UK diagnostic, but American Academy, whatever it may be. So clinical clues. So as I said, the atopic dermatitis itch that rashes, not that rash itches. So that's why the xerosis, addressing the xerosis is the important area with a proper moisturizers. So this is the criteria, the 4 and 23. Out of 4, 3 is mandatory, either major, and 3 major and 3 minor criteria. And all the 23 which is there depicted in the book, every day we can see. So you could see the pruritus, the typical morphological distribution of lesions in dermatology. So is confined to the atopic dermatitis, confined to the scabies, confined to the leprosy. But even in the atopic dermatitis, typical morphological distribution is a major criteria. First 6 months you will see in the cheeks, because of xerosis, the child scratches with the mother's breast, that gives rise to the erythema. And after the 6 months, the baby crawls. Then the contact period is the earth. So then the lesions over there. And after that, the flexors. So that's why the typical morphological disorder. The personal and family history also is a significant, because the atopy it will march into atopy, atopic march. So the gateway for atopic march is atopic dermatitis. So these are all the minor criteria what we can see when you see such type of lesions, whether they are either atopic associated, non-atopic associated. For example, if you say P. alba, it is a component of atopy, but it can be non-atopic. But the features in atopic P. alba, so they're long-lasting, the relapses are frequent, and the response is compared to non-atopic is poor. And what is the important, I won't go in the therapeutic, but the skin care is the key. Because what is the skin care? What we are going to do, the bath water, use soft water, lukewarm, and better to use the Syndates in atopic child. The layman, they can't understand what is Syndate. The soap which will come less foam, that is suitable for atopic child. And the cloths, use cotton cloths, and sweat, avoid sweat. And the heat, avoid, the temperature should be 18 degree and humidity will be 50%. That is the ideal condition for the atopic skin. So to put together the emollients, the follow rule of 3. What is that follow rule of 3 in the management of atopic dermatitis? So the bathing for 3 minutes, within 3 minutes apply moisturizers. So what type of moisturizers, it's again debate. The patient friendly, the patient pocket friendly moisturizers is the best way to address the atopic child. So and then 3 times in a day. So that maximum it will prevent the itch scratch cycle. The best way to prevent or treat the itch scratch cycle, keep the child in non-dry form. So by taking care of the skin. So that's why the atopic, the scratch, sneeze, wheeze. So the sneeze and wheeze will be prevented or postponed by scratch. So atopic march, you could see all these points. I won't go in detail, but now it is on the rise. As I said, the westernization, the isolated families, and the lifestyle, hygiene hypothesis, all these will increase shifting of Th1 into Th2. So these are the poor prognostic factors. And prevention of scratch leads to prevention of sneeze and wheeze. So that's why the atopic, what is the significant? It is a first step in allergic march. 75 to 80% of AD patients develop allergic rhinitis. So more than 50% of AD patients develop asthma. So that's why we, the dermatologists, we are the custodian for skin health. And food allergies, 40% in children, whereas 50% in adults, were moderate to severe atopic dermatitis. Don't think of food is a culprit in mild AD. So this one study shows risk of developing. For example, if in general population, the risk of AD develop into asthma is only 8%. Whereas in mild AD, 30%, severe atopic dermatitis, there is 70% of progressing to asthma. So as a dermatologist, so keep the atopic child in atopic form or at least mild AD form. And another important, psoriasis. As I said, psoriasis, it all the phenotypes to genotypes to phenotypes, all manifestations which will affect eating habits, if effects on the palms and soles, impact on the whole family, and affecting the schooling and impact on the marriages. And it could be a primary, the acute or subacute. Gutted psoriasis could be acute with a genetically susceptible individual. Any infections, especially streptococcal, may present it with a small papules on the trunk. If you scrape it, you will see the scales. So that is gutted. So how do you manage this? Psoriatic child is, again, we need to treat the family, not the child. Child is a small component in the family. So this child, almost the verge of going for suicide. So what we have done, what we have started is, we put on cyclosporin A, 3 mg per kg. After 2 weeks, you could see almost more than 60 to 70% improvement. And after 4 weeks, everything is clear. Now this child is married. She got 2 children, and those children are also going to the school. And the management, the maintenance is very, very important, counseling, because the goal of a psoriasis is to clear the symptoms, not to cure. So we cannot cure the psoriasis, we cannot cure atopic dermatitis, but we can clear the symptoms, and we can keep in mild form, and we can prevent the complications. And the another child, first class psoriasis, is very, very painful in the whole family. Again, we started cyclosporin here. Again, minimum dose is more than 2.5. We have given 3 mg per kg. And after 5 days, you could see the excellent, the beauty. So the beauty of initiating the response in child is excellent if you give a proper dose with a proper counseling. And after 1 month, all lesions were subsided. That is the beauty of pediatric dermatology. And gutted psoriasis, as I said, the diagnosis is not a problem. But the thing is, who are going to recur? Recurrence, the risk of recurrence, the natural history of gutted psoriasis. Even the study shows, the Mercy et al. Suggested that the risk of chronic plaque psoriasis is higher, 1/3, 2/3 in a recurrent persistent gutted psoriasis. That's why addressing the streptococcal infection with a proper dose and duration is the key to prevent recurrences and to prevent the carrier stage of this infection. So that's why the psoriatic march, psoriasis is no more a cutaneous disease, is the cutaneous manifestation of systemic disorder. So which gives us the chronic and severe psoriasis, that gives us metabolic syndromes, insulin resistance, endothelial dysfunction, atherosclerosis, ultimately myocardial infection. So we are the custodian to manage the psoriasis, to keep the psoriasis in mild form and prevent the march of the psoriasis. So it is the chronicity and our severity, the risk factor for psoriatic. So even mild psoriasis, always it is our responsibility to look for the metabolic syndromes. So how to? These are the features. In obese child, the presence of metabolic syndrome is an issue in pediatric psoriasis. So these are all, out of these 3, more than 3 is required. So easy to assess the metabolic syndromes, even if it's mild, moderate, or severe. And the psoriasis, it licks the skin but bites the body organs. We dermatologists, when it is licking, address it and prevent the biting of body organs. And common diagnostic pitfalls. What are the diagnostic pitfalls? Tinea versus eczema, psoriasis versus seborrheic dermatitis, pityriasis alba versus these are the small pitfalls, but if you have some clinical clues, we can easily eliminate those pitfalls. You could see this is diagnosed as a atopic dermatitis and potent topical steroid was initiated. And if you see, it is unilateral, not bilateral. So that will give a clue. Borders will give a clue, but it is a topical steroid modified tinea. Then what we have done, KYH done, it became positive. After 2 weeks of treatment, all lesions were subsided. Hypopigmented patch on face in children is the high risk of misdiagnosis. Always if you see the patch on the face, the parent concern is, doctor, whether it is vitiligo or not. Doctor, whether it is a leprosy or not. If these two are not there, so happily they will give our consultation, happily they'll go. But to say it is not a vitiligo, to say it is not a Hansen's disease, we should have a guts. Confidently, based on the clinical features, to say this is not a Hansen's disease, this is not a vitiligo. So let us see some clinical clues. These are all the different manifestations we'll see. But white patch, how the skin speaks. If you see the white patches, scaling, non-milky white patch. So P. alba and tinea. If scaling is there, you can rule out Hansen's, you can rule out vitiligo. Whereas no scaling, again, milky white, vitiligo. No milky white, look for the sensations. Rule out Hansen's disease. This is easy way to rule out, simple way, scaling and the type of patches. So that's what is that just 5S formula for the diagnosis of white patches on face in a child. Since birth, rule out vitiligo, rule out Hansen's. Symptomatic, rule out vitiligo, rule out Hansen's. Scaling, rule out vitiligo, rule out Hansen's. And seasonal variations, rule out vitiligo and rule out Hansen's. And sensations present, rule out vitiligo, so think of Hansen's disease. Just 5 features if you think, so mostly it will give a number of clues. And what are the red flags? The considered systemic disease, the severe eczema in infants, recurrent infections, these are the red flags. Always the pediatric dermatology is a beauty, but if you won't address, that landed into complications. Severe, suddenly it progressed into this. So this child, 5 years old male child, dry skin, severe xerosis, severe eczema since birth with a recurrent pyodermas. That is a cold abscesses generally since 6 months of age. And we did a serum Ig levels, it is 4,429. So considering atopic dermatitis at birth, 99% of our diagnosis would go in a negative way. Because IgE antibodies till 8 weeks, it is premature, mostly atopy is unlikely. So hyper IgE syndrome, the job syndrome is entertained, so based on that we have to address. So dermatitis appears very soon after birth and severe, complicated by severe infections, think of beyond atopic dermatitis. This another child, 16 months old, the erythema and scaling all over the body. We thought of Netherton syndrome or erythrokeratoderma variables. And dermoscopy we have done, this double-edged scales, that has given the clues. So dermoscopy is the dermatologist stethoscope. Without dermoscopy, so examining the patient is off examination. And microscopy, you could see the bamboo hair. Simple investigations which will give diagnosis of Netherton syndrome. It has a triad. I won't go everything is this care. And what we have given, some cases, we have series of Netherton cases. The mild cases, supportive and symptomatic. In severe cases, we have given low dose, the acetretin. So it responded. And we have published this Netherton syndrome. And whenever you see the severe eczema with recurrent infections with hyper IgE, think of hyper IgE. Eczema, bleeding, infection, think of Viscotol-Ridge. Severe eczema with air changes, think of Netherton syndrome. So think beyond atopic dermatitis. So steroid misuse in children, so the worsening of infections. Actually, this child, the diagnosis of severe atopic dermatitis, they put severe potent topical steroids, and you could see the whole erythrodermic dermatophytic infections. Whole family, the erythroderma secondary to dermatitis. Very rarely we'll see erythroderma secondary to the dermatophytic infections. So here the culprit is the potent topical steroids. So what we have done, so we have given oral itraconazole 10 mg per kg divided 3 to 6 mg per kg. So each 1 ml contains 10 mg. After 3 weeks, you could see all the clearance along with the emollient is the key. Here the topical antifungal is very difficult to put everywhere. So give systemic antifungal. The quackery. So quackery, unqualified practitioners, it's the ever-ending subject. It is the responsibility of every dermatologist. As on 31st March, We have 19,012 dermatologists. Let us take the responsibility, be the custodian for the skin health. So let us, unless until we sensitize the community, so this quackery will not go. So what is the role of dermatologists? Advocate skin health awareness in the community. So I would appreciate the partner Bihar. So all aspects of awareness which has been initiated. Last 2 world records has been taken place, initiated from partner. So where I am happy to be a part of as a Secretary General. So we worked together and we achieved, and it has reached the Parliament first time, the word of IADL which has reached the Parliament, and they have asked for all the records. We have submitted all the records, and they are working for the skin awareness. Let us see their response. The challenges, these are the challenges. And finally, take home is pediatric inflammatory dermatitis are common but often misdiagnosed. So let us use the clinical clues. The clinical clues are the cornerstone for the diagnosis. Let us have the patient-centric approach. Early intervention prevents chronic disease. Emollients, education, rational therapy are essential. The qualified dermatologists are the custodian for skin health. So until we sensitize the community, how the community will going to. So if you have an ophthalmic problem, how they'll go to ophthalmologist. If they have cardiac problem, how they'll go to cardiac specialist. Like that, if they have skin, hair, nail, genital problems, let them come to the qualified dermatologist. It is our responsibility. Let us sensitize at least each member, sensitize 10 members, let them sensitize another 10 members that may reach the community. We are the custodian for skin health and managing all. So, to all this, as I said in the first line, implement formula of M square. Children's, so pre-adolescents, they are totally dependent on the parents. So as a healthcare provider, my role is 50% with medication. But involve the mothers or caretakers, your role is 50% by proper medication. Because pre-adolescent, they won't take medications. Preschool, they won't follow anything. So it is a responsibility. Whereas adolescents, neither they are children nor they are adults. They won't follow instructions of anybody. Teacher, parents, doctor, whoever it may be. Unless until you involve the minds of the adolescents along with the medications, with that the formula of M square, you practice, I am practicing, I am succeeding. So why can't you? You practice the formula of M square, definitely you are going to get good results. So practice healthy skin habits, feed the skin from the inside, whereas feed the skin from outside. And life is not just a pre-planned script. So it has to be balanced with the professional life to the family life. So we need to give equal importance to the profession as well as the family. And I salute, at the end, I salute my parents because they are my hero. In fact, they are our heroes. Always let us salute our parents, because don't say he is my hero, our parents are our heroes. Because of them we are here. Without them we are nowhere. So our heroes are our parents. So these are my parents, they are real my heroes. And my teachers, because they are the guiding lights. Without teacher, so there is no guiding lights. Always respect the teachers. If you respect the teacher, you will connect with the teacher and they will become a guiding light for your growth. And my well-wishers and my soulmates. So always they are there inside, so many are soulmates are there. Always they will encourage in a critical situation, in a difficult situation. Whatever the difficulties which we will face, that God will give to strengthen us to do more and more activities. And my family, so they are my energy and they are my enthusiasm and they are my entertainment. So without them, so I am nothing. And this is my better half, Lakshmi, and she is my happiness, and she is my smile, and she is my success, and she is my health. Without that, this will not reach us. And final acknowledgements to my all colleagues, residents, and young patients where I am working in Usmania. So always they will help to learn more and more. So always knowledge shared is knowledge gain. So thank you very much for all your patient hearing. Thank you.
And to confer this award, may I request Dr. Professor P.K. Roy, sir, to please come on the stage, Dr. Abhishek Jha, sir. And may I request Shivani and Madhukar, sir, to please call Neelam auntie on the stage.
It's a real proud moment. I would request everyone to kindly stand up and give a big round of applause for the very prestigious Dr. Amarkant Jha Amar Oration being conferred to Dr. Bhumesh Kumar Katkam sir by our very own president, Dr. P.K. Roy sir, and Mrs. Neelam Jha, wife of late Dr. Amarkant Jha sir.
Sir, could request all the person who is getting the FACDI to please go in the outside portico. Rest of then sitting here and please empty the first row.
Now we come to the very final and prestigious session of Fellowship of Association of Clinical Dermatology, FACDI. Those who have been informed about receiving this very prestigious fellowship, I would request those doctors to kindly go outside at the portico and collect their gowns. And for us, we are inside. Let me just introduce you briefly to the fellowship of ACDI. The Fellowship of ACDI was instituted in 2024 by the Association of Clinical Dermatologists of India. It stands as a mark of exceptional distinction for the professional excellence within the field of dermatology. Further elevating its academic stature, FACDI is recognized by the Al Karim University. The university itself is rooted in the legacy of educational advancement, founds its roots back in 1986. FACDI is not merely a tutorial honor, but a testament of years of rigorous clinical experience, evidence-based expertise, and deep commitment. By conferring this fellowship, ACDI acknowledges the clinicians and dermatologists who have embodied the highest standard of clinical judgment, ethical integrity, and continuous learning. FACDI thus emerges as a symbol of peer recognition, academic validation, and lifelong dedication to advancing the science and art of dermatology in India. I would request everyone to keep the first row of empty for our fellowship awardees. Give us a 40 minutes.
ये चलेगा।
हटाने बोला ना। ये खड़े रहेंगे क्या? such a josh in the air. So with this, let's start the ceremony of Fellowship of ACDI, for which we already have on the stage our President, Dr. Professor P.K. Roy sir, our organizing chairperson, Dr. Abhishek Kumar Jha sir, and our organizing secretary, Dr. Scientific chairperson, Dr. Vikas Shankar sir. To start the ceremony with, first, I would like to call upon stage Dr. Sitaram K sir to kindly come forward and receive his fellowship. A big round of applause for Dr. Sitaram K sir. Next, I would like to call upon Dr. Sudeep Das sir to please join us on the stage and receive this prestigious fellowship. Thank you, sir. Next, I would like to invite on the stage Dr. Siba Hussain ma'am to kindly collect her prestigious fellowship of FACDI. Thank you so much, ma'am. Next, I would like to call upon Dr. C.S. Sirka sir to kindly come forward and receive his fellowship. A big round of applause.